Good day to you all. I would like to thank you all for coming to this venue, which is quite out of the city. And the fact that the metro rail repairs are happening in the road doesn't make the travel any easier. So without much further delay, I think we will get the first session started. So could I call upon the moderators, Dr. Dhaval Nayak, and Dr. Sridhar, my colleague and friend, to talk on surgery in cardiogenic shock.
Good morning, and let me begin my talk by thanking Dr. Sundar for inviting me. And it's nice to catch up with a lot of old friends here. It's always nice to be the opening batsman for any session because that gives you the whole day for yourself. And the talk I'm going to give is about the role of surgery, if any, in the setting of a cardiogenic shock. See, this is a difficult group of patients, and also there is a feeling, and it's also a reality, that the role of surgery in this sick group of patients is diminishing, mainly because PCI has made such rapid inroads in managing the acute phase of acute myocardial failure and cardiogenic shock. And also, this is a very small subset of patients where it's really difficult to conduct any controlled randomized trials. And so there is also a paucity of information on what is the right approach to this group. Even fewer, we have studies on the role of CABG as a primary procedure, because most of these studies are focused on interventions, which includes both PCI and CABG, but very few or almost none at all which has focused on CABG as the primary option in this group of patients. So as a result of this paucity of information, there are clearly no specific guidelines, and most of these things have been observational. And I would like to share what is the current thinking on this group of patients and what is the role of CABG, if any, in this group of patients. And finally, and most important, it's not just in India, but across the world, where there is a general reluctance both on the part of the cardiologists and the surgeons to offer CABG or even suggest CABG because of its very high morbidity and mortality to the patients. So I will just be talking to you about the role of CABG in acute MI, which will also include cardiogenic shock and failure, but I will be staying clear of including mechanical complications like VSR, acute MR, or free wall rupture, because there is no confusion regarding the role of surgery. So this effectively confines our discussion to CABG in acute failures, which will also include cardiogenic shock. Right. So for the purposes of this talk, I will say that acute MI, I'm including both STEMI, non-STEMI, and the extended spectrum, which will include failure, which is basically pulmonary edema and fluid load status, which all and progressing on to cardiogenic shock. So what is the literature say about CABG and the mortality of CABG in this small subset of patients? I have borrowed liberally from what the STS has to offer. They looked at their extensive databases, Pan-American from 2003 to 2009, And out of this vast database, they said that patients with post-operative cardiogenic shock contributes only to 2.1% of the CABG cases, but they accounted for 14% of all the mortality, which is a huge step up. The operative mortality for CABG and cardiogenic shock is around 20%, and the mortality goes up to 33% if there's a concomitant valve procedure, and 58% if the patients have VSR. And also from the STS database, they also found out that the mortality for CABG for non-cardiogenic shock or non-acute failure cases has shown a significant downward trend, but it has remained flat when it comes to reductions in mortality in a setting of cardiogenic shock. Now, is there a role for CABG in acute MI is what we are going to discuss. Also, the effectiveness of CABG if there is a role. And this again brings into question, what is the appropriate timings and the role of IABP and mechanical circulatory assist devices in these patients when they are in a state of shock. This was probably the first trial which studied the role of interventions in a setting of acute failure and cardiogenic shock. This was in 1999, and shock trial literally is, should we emergently revascularize acute occluded coronaries for cardiogenic shock? I will just summarize the findings of this trial. It just said that medical management alone resulted in 70 to 80% in hospital mortality. And there was significant improvement in survival from interventions, both PCI and CABG. And with these findings, the American College of Cardiology upgraded the role of interventions to class 1A recommendations. It was initially class 2 before this trial. And shockingly, there is not very many trials after the shock trial. There was one more study that came out in 2006, which studied the shock trial patients. They didn't do any new study. And that established the comparable results of both CABG and PCI. But then there was a flaw because PCI was effectively given for single vessel interventions and for patients with less extensive disease and less comorbidities as compared to CABG, it was effectively offered only to patients whom they thought were not easily salvageable. And but then that we know has been the status of PCI with CABG in practically all the trials, and it should come as no surprise to us that this equivalence is misplaced. And apart from that, I could only find one more reference in 2002. This was a single center study from Germany where they had over a period of 10 years, they could get only 80 cases which they operated in patients with acute cardiogenic shock, which they offered surgery in less than 48 hours. Their 30-day mortality was 32%, and 15% of the patients persisted to continue having low cardiac output. 12% had CVAs, but the completeness of revascularization was achieved in 80%, and the usage of internal mammary artery was in around 50% of the cases. Not too bad. And they found out that patients who survived, their 5-year survival was in the region of 40%. So what are the current practices in a patient with cardiogenic shock? Predominantly, it is PCA and medical management. CABG is performed in less than 3% of the cases with patients in cardiogenic shock. And today, the thinking has veered down to a consultative approach where, because of the high mortality and morbidity, a cardiac team approach is strongly recommended because that also takes into consideration the patient's fears and needs. Basically, these are all to avoid the unpleasantness following a problem. So effectively, these are the only indications where CABG is currently offered in patients with cardiogenic shock. One, it's a multi-vessel disease where PCI is deemed not feasible. And of course, patients who are not amenable to PCI, a failed PCI or a complications following PCI. And the other situation is, but this is not strictly speaking offered in the immediate setup, but a post-culprit lesion PCI, which will be followed up with CABG rather than just medical management alone, which is generally the case in a vast majority of situations. This this thing was the culmination of some of the studies which showed that patients survive long-term better with CABG following a culprit lesion PCA than just with medical management alone. So that comes us to the timing of surgery, because as such, till now, one thing is clear, there are no solid recommendations for CABG. It is basically anecdotal and observational. There are no clear-cut studies which have shown that one procedure is superior to the other. And however, the timing of surgery has been influenced by all these factors: ongoing ischemia, critical left main disease, the state of cardiogenic shock, and also the use of antiplatelet drugs. The mortality is roughly around 14% for CABG if it is done within 6 hours, but it drops to 2% if the CABG is taken up after 2 weeks. So these are the consensus recommendations which will address all those previous points which I've raised in the last slide. The ACC, AHA, and even the ECS and ESETS guidelines suggest cessation of clopidogrel or ticagrelol for at least 5 days prior to surgery. And in cardiogenic shock, CABG is reasonable despite a higher risk of postoperative low cardiac output and end organ dysfunction. The role of IABP, this is controversial because following the shock trial, IABP was downgraded to class 2A by the ACC because they didn't find that there's any survival benefit. But however, anecdotally and observationally, IABP continues to have a very significant role in these patients. And this is also the consensus opinions. Conduits. This is a controversial topic, not the least because of the setting in which we are operating. And there's a general reluctance to use arterial grafts. But apart from the extremes of opinions, many surgeons believe that if the patient is relatively young with the possibility of a good runoff, and there is even a role for internal mammary harvesting when the patient is on pump, you offer whatever is possible, but this is generally left to the discretion of the surgeons. Again, on pump, off pump, this is truly a debate only in India. Rest of the world does most of these cases on pump alone. And there, many of them feel a role of off pump is only when the aorta is considered to be heavily calcified, and which is, I think, quite a tricky situation anyway to offer off pump in a case where you are not familiar with off pump surgery. But in India, I think I personally prefer to do it on pump for most of these cases in these situations, though on an elective basis, I think we are all preferring off pump procedures alone. So I will just share my last year's experience alone for sake of completion. And the main focus is not on offering early surgery. And we want to optimize the patients to the extent it is possible. And we monitor the patients once it is referred to us, strict fluid restrictions, titration of diuretics, which is again based on renal function tests. We look at the elevation of urea as a very important marker on titrating the doses of diuretics. Troponin levels, we wait for the troponins to come down to at least or show a downward trend. Most of these patients have, when they initially present to us a troponin over 10, we generally wait for it to come down to 1 or preferably 0. And of course, we monitor BNP. We wait for the BNP to settle down with very aggressive use of diuretics, and we find that the patients do much better when the BNP has shown a significant downward trend. And of course, fluid monitoring is also helped with repeated echo. We are very generous in using echo, at least 4 to 6 times a day, even to ensure that the fluid replacement therapy is appropriate to our needs. And also for managing inotropes and vasopressors. IABP, we use IABP in around 3 to 5% of the cases overall. And I think the same thing holds true. We do not put patients on IABP as a prophylactic support system. And of course, the role of BiPAP and oxygen therapy, we prefer if the patient is able to be weaned off, but otherwise we do accept patients with BiPAP and CABG. And coming to intraoperative management, it's the same story, which is an extension of what we follow in the pre-op. Swan-Ganz catheter and TE guided the fluid for both fluid and inotropic management, arterial conduits wherever feasible, on pump or off pump depending on hemodynamic stability, and a very low threshold for initiating IABP. We rather prefer IABP than to jacked up inotropic supports. In the post-op management, again, there's nothing much to speak of. And to summarize, we did 326 CABG cases last year, amongst which 14 of them were in acute heart failure, that is 4.3% of the cases. Arterial graft was done only in 42% of these cases. And nearly 70% of them, we did do them only on pump, compared to over 95% of the cases which we do off pump for our elective cases. And IABP was placed in 21% of the cases. But we are also very happy to say that because of probably this conservative approach, there was no mortality amongst these 14 patients. To conclude, CABG should be considered in select patients. And this I believe very strongly today, because knowing the natural history of a patient in cardiogenic shock is close to 80%. Here, even with a 20% mortality, it is probably a very effective tool, which I think we should propagate very aggressively. But I think the goal is take patients into confidence and explain things very clearly so that you have the full buy-in of the patients and their relatives, even for an adverse outcome. Thank you so much.
And they had a midterm study actually of around 5,000, 6,000 patients comparing primary PCI versus CABG in acute condition. And they had a follow-up of 4 years. So overall, median term survival is better with CABG.
Correct.
So that is one thing. Second thing is now 70% of the primary PCA, what they do in acute for STEMI or non-STEMI, 70% patient, they have a single vessel disease. So that was another reason, like, we don't come in the picture. And so the 30% they learned actually, just to do a POBA or a primary PCI to culprit vessel, and then further either CABG or stage plasty. And the last thing, the problem with like surgery, patient relatives or patient, it's an acute condition. For any surgery to get assembled actually takes 4 hours, including reports and everything, to just, so that 4 hours would be a little bit of like that slip from the golden
because that
hour.
is one of the reasons why surgery was not popular, because in the popular mind, we have the golden period. So they thought that, you can salvage the myocardium with PCI, which will probably not be possible in CABG for reasons enumerated by Dhaval. But now, in spite of this mindset, surgery has really been shown to be useful. And as I told you initially, this equivalence of PCI to CABG was a myth, because single vessel culprit lesion PCI cannot really be compared to CABG in acute cardiogenic shock situations, because the outcomes were similar, probably even slightly better in CABG. But definitely there's no question, long-term results over 5 years patients do far better with CABG. And that is also one of the reasons why they do advocate, if the patient is young and with relatively good targets, even to harvest mammaries, even though the patient is in failure, in shock, the patient is on pump, take some time, because these patients generally do well. There's also one more thought process that goes on, which says, don't offer any interventions, just put them on to mechanical circulatory support, bite them over, and then, those patients also do well. But I'm not very certain how much it's applicable in a huge patient subset of population. But yes, definitely centers which have the facility, that's a fantastic option to consider. Where's a small group?
See, there is shock and there is shock. So if you're looking at the classification, you have A to E. If you're looking at some people who are, at the bottom end of the pyramid of shock, these are nice things to do. But if you're on the amount of medications which can make their toes turn blue, we probably should just
Absolutely.
yeah,
There's no question.
correct. Now the question is, there is no doubt that revascularization helps one way or the other, either by PCI or CABG. Unloading the LV is probably a very important part of this whole treatment, and MCS in that situation is going to help you a lot. You can put somebody on a ECMO with unloading of the LV through one way or the other, or some kind of assist device, and then do PCI if possible, or is that something which you would consider?
Definitely. Where you are, see, the idea is not to promote surgery as an endpoint destination. The point is just to highlight the fact that we need not be so defensive about considering or offering surgery in this group. See, that is, I think, the main thrust of my talk was, because in a bad situation, many of us feel that, will the patient make it or not? Should we offer surgery? And I think that's a very valid point.
Correct.
But I think we need to remove that baggage and then say, yes, even in this very sick group of patients, surgery has shown to do wonderful things in spite of this high mortality. So don't shy away from offering surgery if it is possible, but that doesn't exclude the use of mechanical circulatory and other devices, because definitely they have a role. But unfortunately, not many centers are comfortable using a circulatory device because of lack of access and availability. That is the only challenge.
We've also just been trying to encourage our cardiologists to use more ECMOs, because percutaneous cannulations, they are very good at it.
Correct.
And they can easily put a cannula into the LA from the femoral vein.
I think Sundar has probably the largest experience with ECMO, because we have managed to put only 3 patients on ECMO. For us to break into the acceptance mode is, I think, the biggest challenge, not managing an ECMO. And I'm happy to say that we did get a lot of input from Sundar and team for the cases which we managed. And we did manage to pull off 2 of them out of the 3. And I think the credit goes probably to these guys who were helpful to us. But then the biggest factor is neither of the intensivists, neither the cardiologists are willing to broach the topic of ECMO to the patient, because the high cost comes into the access blinker.
It's very underused.
It's very underused, because ECMO has got no contraindications except bleeding. And of course, brain death.
I mean, just to carry on from what Julia said, yes, I entirely agree. The LV has to be vented. So once you put the support on LV, then most often it's PCI, but we have gone on, and then even coronary artery bypass valves.
Correct. Because that is one of the drawbacks of ECMO per se, because they say once you are not able to unload the LV completely. And yeah, but then a general, you cannot use it as a standalone. You need to unload the LV, which Impala probably does better. See. Okay, fantastic. And the puncture, yes, correct. But still, you may not get 100% decompression of the LV if it fibrillates. That is a problem.
The only problem with Impella is it cannot be offered for long periods of time,
Correct.
which, ECMO.
Thank you, Dr. Sridhar. First of all, congratulations on having zero mortality in some 14 cases out of 3.
But let me be clear, not all of them were in stage 4 cardiogenic shock.
Yeah, that part you never
So-
mentioned. You said zero mortality, so I congratulate for that. So the next thing is the very fact that.
I accept your congratulations.
Thank you so much, Sridhar.
Thank you so much.
Yeah, I mean, the very fact that we have so many studies, first came stitch, then came stitch extensions. The fact remains that there is still confusion. Unfortunately, when 56 months passed away with a stitch, and unfortunate, my classmate was there in that.
Can
study.
you speak into the mic, please?
Yeah, that time when we saw that stitch, finally after 56 months concluded, yeah, medical management seems to be little better, not much, than the surgical. But therefore, probably there was some confusion. They said none of the panel was not having sufficient surgeons to tell us that it is, and then they extended it to the stitch X. And then finally, when the study comes out, they says, no, surgery has got a better option. So the very fact that I don't know whether after stitch X, it will go stitch XX, then XXX. I cannot say that. But the fact remains that still we are not sure, as you said very positively, that it's a gray area to see. But as far as we are concerned at this time, it is definitely surgery. If at all, you find the patient is suitable and you can accept it, whether at what stage it comes to you, it depends upon your capability of management.
See, let me put it this way. All these studies are done in an elective setting. So it's very difficult to extrapolate those findings onto this. But also please understand, CABG per se is always been under the microscope. In fact, the latest American College of Cardiology has downgraded CABG to class 2A recommendations, which the surgeons are, I think, contesting and debating. So I think it is up to us also to, marshal facts rather than just shout at each other.
Yeah, but unfortunately, we don't have any much large studies in this country. All that
No, this is the American College of Cardiology.
That's what I'm telling.
SPS.
And that subset of Indian patients with coronary artery disease has been proven since time enough and not the same as what the white skin is having. So having transpolated the same conclusion to Indian patients is something to be doubtful.
We'll take one more question. Just, I think, Doctor. Okay, please, we'll just move forward with another lecture.
Can I call upon Dr.
Thank
Pradeep Narayan? He is going to talk to us about multiple arterial grafts and LV dysfunction and what the current evidence is.
Can you just help me find my presentation here? It's loaded. This trackpad is not working. Okay, it's working now. Thank you. Okay, so good morning, everyone. I would like to start by thanking Dr. Sundar for this opportunity to be here this morning and have this interaction with all of you. I'm going to be discussing some of the evidence that exists for using multiple arterial grafts in presence of LV dysfunction. And normally, it's a very straightforward thing. You just look at the guidelines and you find the recommendations that exist of using multiple arterial grafts in presence of LV dysfunction. Unfortunately, when it comes to LV dysfunction, there are no clear-cut guidelines that exist either in the European or in the American society. The only guidelines that are available is the American Association guideline, where they have provided a class 2A recommendation for using beta in patients undergoing CABG. The European guidelines, they have only told us where not to use beta. And I have to stress here that both these guidelines, whatever little exists in the context of all patients undergoing CABG. They are not specific to patients with LV dysfunction. And therefore, we need to find out why is LV dysfunction different to rest of the patients who are undergoing CABG. And in my view, there are two reasons. First of all, there is an increased operative risk associated with patients with LV dysfunction. And these people have a worse long-term survival. And just to prove both these points, I'm going to just quickly show you some evidence. So this is, we have been talking about it earlier. This is data from the STITCH trial that shows that the 30-day mortality was 5.1%. Now, I'm sure we'll all agree this is high. Now, you could say that this is an old study and that is why it was high, but this study comes from India, one of those rare studies that comes from Amrita Institute of Medical Sciences, published in Journal of American Heart Association just 2 or 3 years ago, and shows that the operative mortality in these patients is very high, 11.6%. And it is not just the operative mortality, but it is also the risk of sudden death. So these patients are at increased risk of sudden death, almost 8.5%. Let's take a look at long-term outcomes. Again, we'll use the STITCH data. If you plot this line, what you'll find is that at 5 years' time, the mortality is about 36, 37%. Now, again, we could say that this is very old data, so I'll give you some new data. This paper was published in JAMA just 3-4 years ago, actually 2 years ago. And this compared PCI with CABG in patients with impaired left ventricle. Let's ignore the PCI bit today. Let's only focus on the graph that shows CABG. If we draw this line, what it tells us is at 5 years, the mortality is 23.3%. What it essentially means, if we operate on 4 patients today, in 5 years' time, one of them is definitely going to die. At 7 years, this mortality increases to about 31, 32%. So if we operate on 3 patients today, one of them is going to die in 7 years. So essentially, it is very obvious that LV dysfunction is a completely different subset of patients that we have to deal with. Now, what I have stressed so far is patients with LV dysfunction have a poor long-term outcome. And we all know that multiple arterial grafts are very good, but they're usually very effective in the longer term. So one could argue that if the patient is not going to survive for a long period of time, is there a rationale of using multiple arterial grafts in these patients? Now, I'm not going to answer that. I'll just show you some more evidence from studies which have examined this very question in those particular studies. So let's start with this study, which was published in the European Journal in 2014. This compared bilateral internal thoracic artery with single internal thoracic artery. And it showed that there was no difference in operative mortality. So it is very reassuring. Beta grafting can be carried out in these patients without increasing the operative risk. However, it also showed that there was no improvement in long-term outcomes. So even though it was possible to do beta grafting safely, it did not translate into any benefit in the longer term. Let's take a look at this another very powerful study. You can see that the follow-up is almost 30 years. And this was published in JTCVS. And the title reads, Beta grafting improves long-term survival in patients with reduced ejection fraction. Let us find out what the result was. So quite right, when the ejection fraction is between 30 to 50%, beta grafting was associated with significant improvement in survival. However, when the ejection fraction reduces to 30%, there is essentially zero difference between beta and zeta in the longer term. The study shows that at different time points, 7 years, 14 years, the survival is very different. And irrespective of what you have used, whether it's beta or theta, doesn't matter. The survival, the median survival in these patients is 7 years or less. That is something that we have to remember. This is again published a couple of years ago, and again it compared single mammary with bilateral mammary. And again, it showed the same thing. No difference in operative mortality, no difference in long-term outcomes. The median survival here was better, but even then, it was less than 10 years. Now, this is a very, very interesting study. This is a very powerful study that looked at long-term outcomes in multiple arterial grafting. Now, they did a subgroup analysis using LV function as the marker. Let's take a closer look at this. What we find is the same thing. So if the ejection fraction is more than 50% or it is between 30 to 50%, there is a significant advantage with multiple arterial. However, the moment the ejection fraction drops to less than 35%, there is absolutely no difference. In fact, if you look at the graph, you can probably tell that it is in favor of single mammary. Again, another paper that compared multi-vessel with single arterial grafting based on ejection fraction. And this is what it showed. So ejection fraction more than 50%, significant benefit with multiple arterial grafting. Ejection fraction between 36 to 50%, significant benefit. And the moment it drops to less than 35%, this difference becomes insignificant. So essentially, I mean, it almost feels like I'm repeating the same study again and again, but I tell you, it is not. Every single study shows the same thing. Ejection fraction less than 35%, there is no benefit in using multiple arterial grafts in the longer term. So what we have summarized so far is essentially that LV dysfunction carries a higher operative risk. We have established that LV dysfunction patients have a poor long-term outcome. It is possible to do multiple arterial grafting without increasing the operative risk. However, there is no benefit in the longer term by using multiple arterial grafts. Now let's take a look at the guidelines again. This time I'll give you a different perspective. Let's concentrate on the recommendation for beta grafting. The association has used two terms here, and we have to focus on these two terms. One is experienced operators, and the second one is appropriate patients. So let us look into this slightly more closely in the appropriateness and the expertise. So let's start with the expertise first. Now, expertise with multiple arterial grafting is very minimal. If you look at the STS database, only 11.4% patients get a second arterial graft. If you look at the Canadian data, it's 16.4%. In Europe, it varies between 20 to 30%, and in Japan, it is 22.7%. And I'm sure we all remember the ARTS trial. This was done by a group of experts. However, 1 in 7 patients, almost 15% of the patients who were randomized to a double mammary received a single mammary because they could not do it. So it's not an easy operation, contrary to what the experts might say. And this led to Mario Godino carry out this meta-analysis where he combined 34 studies and more than 27,000 patients. And he clearly demonstrated that long-term mortality was inversely associated with institutional and surgical experience. And he also said that we should build up centers of excellence for beta grafting. It should not be done by everybody. However, you might be an expert, but just because you can do an operation well does not mean that you should do it. And that is when the question of appropriateness comes in. So the European guidelines very clearly say that you should not be harvesting both the mammaries in presence of poorly controlled diabetes, COPD, and obesity. But more importantly, I want to quote this paper from one of the pioneers and the great proponents of arterial grafting, the late Professor Brian Buxton. In this review, he clearly said that if the stenosis on the left coronary territory is less than 70%, and if it's less than 90% on the right coronary, arterial grafts should not be used. Right, so I'm coming to the end of my presentation, and to summarize, what we have shown so far is multiple arterial grafting has similar risk to single arterial grafting, so it can be safely done, no doubts about that. However, there is definitely no long-term benefit, especially in poor left ventricle with ejection fraction less than 35%. The importance of expertise and appropriateness of cases cannot be undermined. And I'll leave you with this space. I would say that watch this space, because a paper has been published which will be available in the March edition of the JTCVS that will show you this picture. And this has the potential to change the discussion on multiple arterial grafting forever. I said the potential. It is the post hoc analysis of the COMPASS trial, and it shows that the graft failure at 1 year was highest in REMA. With that, I would like to thank you all. Thank you very much.
Thank you very much, Dr. Pradeep. It was in-depth analysis, I believe. But one thing I just want to discuss with you and everyone, actually, in fact. So we discuss mostly, single memory versus bilateral memory. But in guidelines, even the recent SCCHA guidelines, radial artery is always preferable over the saphenous vein graft. And that class of recommendation is one now. Though the data is from the single center or that's available, but now the radial artery is a second arterial graft. Actually, we should prefer over the vein graft. So many institute or individual practitioners, actually, they have still conflict either to use radial artery as a second arterial conduit or just go for the vein graft only. So what is your opinion?
Yeah.
So how frequently use radial artery?
Thank you. So first of all, I would like to say that there is no evidence of using radial artery in poor left ventricular dysfunction. So when there is LV dysfunction, we don't know what happens.
In guidelines now, ACCHA guidelines now, the class of recommended is one. Even if you just go back to your slides, actually it's there.
Yeah, but that is not for LV dysfunction patient. That is for all CABGs. Now, radial artery, I have used a lot of radial arteries in the past. I have to admit, I don't use it as much. And radial artery, in my view, has gone through different phases. There are phases when it has been told that it is even better than REMA. There are phases when it has been shown that it is worse than vein grafts. So I don't really know. But in my practice, I would never use a radial artery unless the stenosis was very tight, because I am really worried about that radial graft failing. I know people who use it routinely, and I don't understand that, quite frankly, because if your stenosis is 60% or 70% and you are using radial artery, I would be very surprised if it does not fail.
Yeah, I agree that. So that is very standard. So there was, I think 2013 or 14, there was a big paper actually came from Melbourne. I think Dr. Tackle
The
is
RAPCO trial.
Yeah, exactly. And they suggested like radial artery is second, not first one. Okay, second choice of conduit as arterial conduit over the vein graft.
Yeah, see, it's very interesting now. So if you look at the RAPCO trial data that was published in 2020, it had two arms. In one of the arms, radial artery was compared with RITA, and the other arm, radial artery was compared with saphenous vein grafts. Now, surprisingly, radial artery was superior to RITA, but there was no difference between radial and saphenous vein graft. Now, I'm not saying that it means that saphenous vein grafts are as good as radial artery. It just did not show the difference because the sample size was very, very small. It was not powered to show a difference. They could not do the angiography. So see, I think that radial artery is a very good conduit, but I think it cannot be applied to every patient. It cannot be applied to every target. We have to just tailor it to the need of the patient. If the stenosis is high, I don't see no reason why the radial artery cannot be used effectively.
Yeah, totally agree. So like so many times like Indian practice is slightly different than what is the recommendation actually. That's what one morning we were discussing. Yes, sir. Dr. Sridhar, sir, is.
I have no idea, sir. I have not read the paper. I saw it this morning in a mail from JTCVS. So, yeah, again, that is very controversial because there are a lot of studies that have shown that there is no difference between in situ RITA and composite grafting of RITA and LITA.
Most of the places they mentioned as a composite graft as a Y.
Yeah.
So there is a very less percentage where they use as a in situ.
So I have a
Memory
feeling that
artery.
there are a lot of composite grafts here. These are not uniquely sort of in situ grafts. So I'm not saying that this, what I've shown you on the last slide, that this is sacrosanct. I know we will have to read it and analyze it. So that is why I use the term that it has the potential for changing the scenario, but it may not be.
As per the
The role of Lima was established, but they said that the role of Rima or even Lima to conduits other grafts other than LAD don't fare well. So this is a very old study. I think this came out in 93, 94. And I think you just corroborated those trials. So I think there's definitely an issue with Rima.
Yeah, no,
Probably.
So I'm not very sure, to be honest. Even though I've shown this slide, I do not necessarily agree with that findings, because the largest angiographic series comes from James Tatuli's group in Australia, and they have shown that the Rita has got very good patency. And I mean, they have advocated using Rita. It is very difficult to comment on this, without really reading it. And I, again, don't think that Rita is a bad conduit. I think it is a very good conduit. But again, the question is appropriateness. If you are using as a pedicle graft on a right coronary artery with a stenosis that is about 75%, I'm not surprised if it fails. But if it is used in a tight lesion, I don't see why it should behave differently. I mean, the Lima to LAD is sacrosanct. There is no doubt about it. That is the best conduit for the best target. And everything else, as you said quite rightly, is less than that. But I'm not sure if this is this bad. And I'm pretty sure that there must be some problem why this has come through. Because this study was carried out not to look at grafts. The COMPASS study was a comparison of rivaroxaban with or without aspirin. So there must be some confounder here.
Yeah, the fact remains that, as you told at the first beginning, the LRA graft fell out of grace after Dr. Alan Carr's introduction to that, and because many of the times we found, even in our experience and many people's experience, that within 2-3 years it just got stenotic and closed. Maybe because of its media little larger than that of the internal mammaries, but of late, as per our experience, after Dr. Arun joined with the department, I myself has used about 50-60 patients with LRA. And we have, as you said very correctly, it's not a very large group. But over the period of 3 years, at least, we have been pounding their patent. I cannot say why they are patent. The only difference may be in the medication that we have got the Nicorandil now, and we put them under any patients, every patient. First few days in the ICU, we started with either Nicorand drip or with amiodarone drip. Amlodipine. Then we come back to the Nicorans once they are extubated. So that could be one of the reasons, but I'm not sure. So definitely there is the role for LRA over a period of longer period, and that needs to be studied.
I agree. I think radial arteries are good grafts. So is Rita. I'm not personally very convinced about the role of calcium channel blockers. There are a lot of people, especially in Australia, who do, probably do routine radial artery grafting, and they don't use calcium channel blockers, and they have got good results. So there is still something that, biology of the radial arteries, which we probably do not understand.
I think just bit of a short of schedule. We'll just move ahead with another very interesting topic with Dr. Alef Sridhar. The surgical strategy in ischemic cardiomyopathy.
Thank you.
Myopathy with poor targets, actually. So Dr. Alef Sridhar, please.
Can I also just call on Dr. Dilip Mishra, sir, and Dr. Dheeraj Reddy to moderate this session along with Dr. Dhaval Naik, sir? Thank you.
Good morning. First of all, I'd like to thank Dr. Sundar and the organizers for the invitation. I'm going to talk about the surgical new strategy for, it's not a new strategy. Dr. Pradeep has already spoken. I've just extended on to the patients with very, very poor coronary targets in ischemic cardiomyopathy. As you all know, it's a difficult group to start with because first, most of them are younger patients with a strong family history of sudden death, diabetic smokers, and they are still not yet ready for transplant. They have not reached the stage for transplantation, and they are carried a very poor surgical results in the conventional way. And yeah, thank you. So finally, most of them are left with medical management. And maybe 10% of them go through surgery with poor surgical results, or they go with incomplete revascularization. Say, for example, if the coronary anatomy shows one vessel which is graftable or stentable, that is done, and the rest of the arteries are left alone, which makes it incomplete. First of all, I don't. I like to thank Dr. Pradeep for showing us a lot of papers to justify arterial grafting and poor LV dysfunction. I've just extended on to people with very poor coronary targets. Little bit of theory, not much of theory. Hang on. As you are aware of this, CABG is just wanted to re-emphasize that CABG is among the most important surgical procedure in the history of medicine. No other operation has prolonged more lives, provided symptomatic relief, and has been thoroughly studied, and still remains most durable means of revascularization for patients with CAD. My talk is not based on any scientific papers. It's based purely on my observation, experience, and also root cause analysis with surgical evolution of arterial grafting, and finally the excellent clinical outcomes. Well, ischemic cardiomyopathy represents an important cardiovascular condition associated with substantially increased morbidity and mortality. This diagnosis is based on the demonstration of significant left ventricular dysfunction in the context of significant epicardial coronary artery disease. What is the pathophysiology of ischemic cardiomyopathy? In the setting of unremitting myocardial ischemia with impaired coronary flow, a series of events take place which alters the structure of, which leads to structural alterations of LV myocardium, leading to adverse remodeling and eventually contractile dysfunction and mechanical pump failure. There are three basic pathophysiological concepts underlying ischemic LV myocardium, which include stunning, hibernating, and scarred myocardium. I'm talking about this because it's very useful when I make decisions about the surgical strategy. Hibernating myocardium refers to a chronically dysfunctional hypocontractile state, but viable myocardium characterized by reduced blood flow at rest. Stunned myocardium is characterized by prolonged and reversible contractile dysfunction, which usually results from abrupt, transient, severe ischemia that persists even after normal epicardial blood flow is restored. Of course, these two conditions, they do improve, unlike the patients with non-viable and scarred myocardium. Well, the commonly used methods to detect myocardial viability, we all must be aware of it. I just want to stress upon a few things. Echocardiographic, magnetic MRI. I'm not a great fan of MRI. A lot of people go with MRI, but I'm not a great fan of MRI. SPECT, of course, PET is a useful tool for me. But the most important tool for me is echo. I personally look at all these echoes, especially in patients with severe LV dysfunction, with poor coronary targets, whether I can do something better for them. I look at basically the preserved muscle thickness, the dilatation of the LV. If the LV is dilated with good muscle thickness, I'm not worried. But if the LV is dilated with a lot of fibrosis, I get worried a bit. The fibrosis can be easily detected in echo. It is typically echo image, white glistening surface. You can see it. Thinned out white glistening image is what you get in the echo. That shows that this part of the LV is fibrosed and thin. So I do get worried. That's when I put them through PET. Of course, the next important thing I look at echo is the RV function. Because for me, impaired RV function is a no-go for surgery. At that time, I stabilize them. Sometimes I even put them on pre-op dovitamin and Lasix to stabilize them and get them better for surgery. I optimize them before surgery because RV dysfunction in the post-op, most of them succumb. So I do prepare them before surgery. And of course, PET scan is, I want to see how much is the scar burden. If I feel there's a lot of scarring in the echo. Scar burden is very important to me, but that does not, I don't shy away because there's a lot of scar burden. Even if there's a 5% or 8% viability, I go ahead with surgery because, like I said, most of these patients are in younger age group. So I would like to do something for these patients instead of just dumping them in medical management. Well, I don't have to repeat it. It's been told time and again. Patients with coronary artery disease, severe LV dysfunction have a poor long-term prognosis. Results with medical therapy have been uniformly poor, and the 2-year mortality ranges between 38 to 96%. It's been demonstrated by the CAS group that CABG is superior to medical therapy alone. Of course, it carried a very high mortality in the past. For patients with viable myocardium, the annual mortality was 16% in the conservatively treated group, as compared to only 3% in the revascularized group. Innumerable number of papers, we can mention so many papers supporting the role of CABG in ischemic cardiomyopathy. The most important, which has already been discussed, is the STITCH trial, which definitely says that surgery is as a better option than leaving the patient with medical therapy alone. And like Mishra said, the extension of STITCH trial, which is a 10-year follow-up, again proves that surgery is definitely has an edge over medical therapy. Now, I don't have papers to substantiate and justify the role of arterial grafting, which has already been discussed by Dr. Narayan. It's when conventionally, when vein graft and mammary were done for poor LV with poor coronary targets, the surgical results were very, very poor. So people started looking at other arterial grafting, and even generally for normal ventricles and with LV dysfunction, they started applying this for a better long-term outcomes. And this cohort study of 49,000, which definitely proved that single mammary and vein graft, as compared to total arterial revascularization, improved long-term freedom from major adverse cardiac and cerebrovascular events, death, and myocardial infarction. Well, my journey started with arterial grafting way back in 2004. I was doing few cases a year, very selective at that time. Good critically blocked targets with younger patients, in older patients with unforgiving aorta. And slowly, I went on to extend this surgery to the younger patient with significant LV dysfunction, but with, again, good targets and good viability. Later on, when these patients came for follow-up, I found the results were excellent, with very good clinical improvement and good recovery of LV function. That encouraged me a lot. So then I thought I should probably carry this forward with patients with very poor coronary targets in normal ventricles or a mild LV dysfunction. Because earlier, it was arterial grafting was a taboo when someone says he's got very poor coronary targets. In fact, the choice even for LAD, if it was small and diffuse, was SVG, just because LAD was small and diffuse. But most of the patients whom we deal with, especially with normal ventricles, most of the patients were younger patients who come with this kind of vessels. They're again smokers with a background of strong family history and diabetes. So when I gained more experience, especially with the importance of light, with the sequential grafting and the placement of white, I got a little bit of more courage to venture on to doing small, very poor coronary targets with diffuse disease, especially younger patients with normal ventricles. And what did I find when they came for follow-up? They did extremely well, with very good clinical outcomes, with negative treadmill tests and with excellent effort tolerance. Well, of course, the method of harvesting initially was skeletonized, because for some reason, when you take a skeletonized mammary, it always looked bigger to me. It became surgeon friendly, so it was skeletonized. But slowly I switched over to semi-skeletonized. I'll explain the reason why. If I find good mammary takers, because all the mammaries we don't take us as a teaching institute. If we find good mammary takers, I insist on extrapleural. I'll tell you the reason why. Now, I wanted this strategy to be adapted to patients with severe LV dysfunction, with very poor coronary targets. Because like I said, these patients, 95% of the patients were left with medical management alone. Even if they are operated, they didn't do well. Their immediate post-op mortality was very high, and short-term and long-term was not good. And generally, they didn't do well. This, I started thinking, why should this happen only in this group of patients? Poor targets with severe LV dysfunction. Why this very high mortality? When the patients arrested in the ICU, when you do an open massage to resuscitate, I found the mammaries invariably were pink, probably it's flowing, but I found a lot of vein grafts to be thrombus. So this got me thinking that there must be some other reason why the vein grafts are closing down. Graft closure, it doesn't mean that graft closure don't occur in normal ventricles. It does occur. But normal ventricles can take all these things, even if it's a graft closes for an insignificant vessel, nothing happens. Sometimes there'll be some hemodynamic instability, but not like the bad ventricles. Bad ventricles behave very badly. Even if the graft for a very insignificant vessel closes down, they sometimes go, the pressures drop, they even have a cardiac arrest. Then I seriously thought, I use the same surgical technique, same anastomotic technique for all the vessels. In fact, when it comes to a small vessel, I'm even more careful taking every bite. Why do these grafts close? It occurs with more experienced surgeons too. So I was seriously thinking there must be an answer for that. And why do these poor ventricles don't take up this nonsense of graft closure, even for a small arteries? Whereas normal ventricles, I have seen while in reopenings for bleeding, one or grafts sometimes get closed. Nothing happens. The patient is okay. We don't do anything. We just close and come out. Whereas these things in poor ventricle, they don't tolerate. They arrest. So this got me thinking, and I was thinking when I opened all these people that there must be something attached to the gross mismatch between the conduit and the native coronaries. Imagine a 3 millimeter conduit, a vein, going to a 1 millimeter vessel. It doesn't work that way. There has to be resistance, and SVG is more prone for resistance. Whereas lima, I see a lot of arteries, small arteries, pulsatile arteries flowing to small vascular bed where there's a lot of resistance, but they still continue to flow. So it's a pulsatile flow. It doesn't depend on a thing. So I decided that this must be one of the reasons why the grafts close. So then I decided that I must offer this sort of strategy for a poor coronary targets, especially in patients with sick LVs. This I wanted to talk about later, but probably I can talk about it. The pedicle graft have less chances of thermal injury, especially if a junior surgeon is taking down the mammary. But they have more chances of sternal wound infection. Paresthesia is common when you take a bulky pedicle because this annoys the patients for months together. They keep on complaining, I have this heavy feeling, even though we sort of reassure them your treadmill is negative, it's nothing to do with cardiac, but they keep on complaining. And now, of course, nowadays we have some medications for this neuritic pain, but it's annoying for the patients. So bulky pedicles can cause this. But there are papers to indicate that pedicle grafts work better than skeletonized grafts. Skeletonized graft, the advantage, like I said earlier, they always look bigger. They're surgeon friendly, longer length, but less chances of wound infection, but more chances of thermal injury, which you can see blotches of hematoma on the branch sides, which I get worried always because I don't know whether it's intraluminal or just adventitial hematoma. So as a trade-off, I sort of like semi-skeletonized. Well, there's a lot of talk about radial. Dr. Dawal was talking about radial. We started way back in 1995 when I came down from Australia. We have done close to 3,000 to 4,000 radials, or even more. I don't remember. I did a 1-year follow-up angiogram for 50 patients, not a big number, but 50 patients, which I presented along with Christopher Ekar in Sydney. What I found was the patency was slightly inferior to SVG, and also noted very inferior patency in small and poor pulmonary targets. But we do use on and off Lima radial Y when for some reasons we are not able to do both the mammaries. My intra-op strategy is always beating on. In dilated and fibrous ventricles, I electively go on pump and do it on pump beating heart or with IABP support. The patients whom I do IABP support is when they have comorbidities like chronic kidney disease or liver disease. I don't want to put them on cardiopulmonary bypass. LAD is always after the Y, LAD comes first. If the diagonal is there, I do the LAD diagonal sequence first. And you can ask me why let me show you the angiograms. Probably question will arise why you're not doing endarterectomy for this vessel. I have a reason for not doing endarterectomy. I can explain that later. The suture length, I'm very careful about suture length. I don't have a long suture length because I worry about suture length getting entangled with other instruments or other things and cutting off of the, sometimes the memories get torn off by entangling, and that compromises the entire procedure. And also I believe in telling my junior colleague to be less aggressive. I don't want them to be too active, too enthusiastic in help. I tell them is to just follow the thread, keep the loops away. I don't even allow them to touch the mammary when I'm doing the sequence because it's very important. Small error can jeopardize the entire operation. Well, these are some of the angiograms. They've all been coming up with follow-ups. Huh? No, I don't have the video. This particular patient I did 2 years ago. Incidentally, came to me for follow-up after 2 years, day before yesterday. His EF was 25 at the time of surgery. And when he left the hospital, it was 30, but now it is 45. And I put him to a treadmill. He went up to stage 5 with no ST changes. And 10 minutes he has done with very good effort tolerance, absolutely asymptomatic with normal life. This guy had received 4 Lima. You can ask me, why didn't you endarterectomize? No, I don't do endarterectomy. We have done in the past, in the early 90s, close to 3,000 or 4,000. But when these patients came back for follow-up and when we did angiograms, we found that endarterectomized vessels had closed down. Of course, those days we were using venous graft for those patients, but they're closed down. So I don't endarterectomize. My plan always is wherever I find a soft spot, I just graft. I don't care whether there's a distal disease, wherever I find all the vessels, whether it's 1 millimeter or 1.25, or it takes only just a 1 millimeter vessel, I just do the grafting. And sometimes I use skip grafting, especially in LAD, where it's small and multiple disease. I always skip, I don't endarterectomize. I just want to, excuse me. Just a couple of videos which was done recently. In presentation. ಇದೆ. Open. This patient had 4 graphs. I'll just show in the last video the targets. This is what I meant by semi-skeletonized. I don't take bulky pericles. I'm just, it's muted. I'm just trying to show that LED target and the diagonal before I started grafting. There's hardly any LED there, just a 1 millimeter vessel with a diagonal. So 30. The same patient who had this after the grafting. Just wanted to show you about the semi-skeletonized mammary. It's not completely skeletonized. A little bit of well, the downside of lima is especially in skeletonized or semi-skeletonized bulky pericle is more chances, like I've already mentioned, in paresthesia. So what I do is to avoid too much, to avoid wound infection, especially the lower end wound infection is common. So I leave the bifurcation on both the sides intact. Very rarely I take up to the bifurcation, and try and do extrapleural dissection, because these patients sometimes end up with pleural effusions, recurrent sometimes, or even late pleural effusions. So you can get over that by just doing extrapleural dissection. Well, over a period of time, I've done about 120 cases of ischemic cardiomyopathy with poor targets, very poor targets, like the ones I showed you. And I've lost one patient in that group. This patient, 74-year-old gentleman who recovered from COVID pneumonia, got readmitted to the emergency with pulmonary edema and chest discomfort. We also had, incidentally, had other comorbidities like chronic renal disease and liver disease. Was in the ICU with recurrent problems despite medical treatment. Treated, again shifted to the ward, but continued to have problems, chest discomfort and orthopnea. So I had to operate on it because he was under great pressure. He did not do well. He continued to be in renal dysfunction and liver, and finally succumbed to multi-organ. So, and 3 cases in this group had AICD, elective AICD, because these 3 patients presented with ventricular arrhythmias, mainly VTAC, and one of them had VFib in the ICU. So I primed them for AICD before operating on them, because the PETs showed a lot of scar burden. And incidentally, the person who came 2 days ago, his scar burden was about 28% with a viability of 6%. He did extremely well. His EF has improved to 45 now. So these patients with AICD had extremely large scar burden with about 5% or 6% viability, and also presented with VTAC and one of them with VF. So I primed them for AICD electively, put them on AICD on the 4th day after surgery. And to my surprise, one patient, when he came for follow-up, when we studied the AICD, he had used it 4 months after surgery and one after 1.5 years. They're all doing well, but they did use it had delivered a shock 4 months, one patient after 4 months, one patient after 1.5 years. Well, these patients, like I said, the guy who came 2 days ago had overall excellent results with good clinical outcomes in the 3rd month review, asymptomatic with very good effort tolerance. Most of them also showed good improvement in LV function. To conclude, CABG is superior to medical therapy in patients with ischemic cardiomyopathy. Excellent early outcome with improved EF and functional state. More arterial as compared to one artery in SVG was associated with improved long-term freedom from major adverse cardiac and cerebrovascular event and death. Ischemic cardiomyopathy with poor coronary targets, but with viability should be offered surgery. SVG grafts are more prone to graft closures and early mortality. Probable reason, I may be wrong, I don't have any papers to substantiate. Probably the gross mismatch and SVG more sensitive to resistance. IMAs, especially sequential grafting, are more suitable because there's not much of a gross mismatch and also they're all pulsatile flow. Thank you for your attention.
Thank you, Dr. Caesar, for an extensive study, and probably contrary to the presented papers by Dr. Pradeep, it is an Indian study which he has done an extensive his own experience, and he has already shown it. So there are two things from that, apart from this presentation. First of all, we had a doubt, the scanning procedures to know which part is viable and which part is not. I had a personal discussions with the nuclear medicine people. The gadolinium uptake in PET scan has got its own doubt. So the viability study of a PET scan, which Dr. Sridhar was very crystal clear that he depends upon that and not an MRI. It's quite feasible. Most of us do that, but that's gadolinium uptake itself is a doubtful thing. So far, probably some of the radiologists say that the MRI is the best part of it, but more importantly, the person who can really study the MRI, that's more important. And secondly, I think if I remember way back in the 80s when we were in Italy, Calafiore used to come to us and say, take memory, which enlarges over a period of time. Probably that has been proven by Sridhar now, that is better graft. Over a period of time, the diameter enlarges and so the flow increases. So these are all, I mean, to tell me all this, that this is presented in our experience. We never had a large study. I told Dr. Pradeep also, India never had a large study of its own to show which is beneficial and which is not. And I am still crystal clear, anatomically, Indian subset is totally different from the European subset. I can't say about Australians who have got a training there, but European subset is totally different. What we call as ectatic coronary is probably normal for them. So maybe that's anatomical difference in that. That's another important thing. So however, thank you, Dr. Sridhar, for a nice presentation. And one thing I must tell you, because Dr. Sundar has just reminded, he came in and pipped out and told us that we are 1 hour back than the schedule. So that indicates that we are also short from our lunch time. So we would request all of you to complete within the time and tell us.
So it was wonderful presentation. I just have a couple of summary points actually. Whenever we talk about CLV with the poor targets, one is papers has proven do not hesitate to do it on pump because the complete revascularization matters actually. So for the sake of doing off pump, putting lace grafts, actually it is not a good idea at all. Chances of acute renal impairment is slightly higher with on pump, but long-term results with on pump studies are comparable to the off pump. Second thing is use of bilateral internal memory artery, particularly when the EF is 20-25% should be avoided. This is what this paper is. I agree with that, Pradeep Kumar. Certainly individual experience is always there. But then multiple arterial grafts are welcome, but bilateral memory artery If it is 20-25% severe LV dysfunction, and this and atractomy doesn't have any long-term good outcomes actually. So that is, as I totally agree with you. Most of the time we should avoid actually, just find a good spot and do that. Anastomosis. So complete revascularization is most important that talk about poor.
What I found is if the arteries are good size, big, clean arteries, I think any conduit will work. But if the arteries are small, diffusely diseased, I feel the bigger conduits may not work because of the gross mismatch. That is why I thought that I should mash these arteries. Whereas big arteries critically blocked, any conduit I think will work. Like so many times when you do angiograms, so many SVG on LAD works. It's nice because especially SVG to LAD. LAD being good and right on surface, it works. So that's what my assumption is.
Sir, only one thing which I wanted to think is whether we are doing complete vascularization or not. How do we come to the conclusion, have we completely vascularized or not, based on the viability?
Well, you go by the walls and the vessels.
Yeah, so the only
I
documented,
will cover all the walls if there are vessels.
that's what, sir.
So whatever vessel
To
size.
complete that,
Yeah.
either we need to do an MRI.
I'm not a great fan of
No,
MRI.
it's
I
not,
personally look
it's
at
not
the
about,
echoes.
personally, even I'm, but that's the only documented evidence where we can show that this has viability and it requires a graft. That is one. Echo does not show much of viability. It is only observer dependent and it changes from center to center, person to person, surgeon to surgeon.
No. Echo should be seen by the surgeon.
I understand, sir, but
Especially
again,
this-
it's observer dependent.
I see the echo personally, right from the basal segment. I keep looking at the muscle thickness, where the walls, whether thin, papery, scarred. And then I always put them to PET, collaborate my findings with that, and then I plan my strategy.
So what I'm suggesting is any patient who has a lower EF less than 30, do an viability and graft for only the viable territories, which says that we have done complete revascularization to the heart, rather than saying that I felt it, rather than, that's the only proof saying that it is viable.
See, if a lot of times you come across, there's no viability in the anterior wall, scarring in the anterior wall. That does not mean that you should avoid doing LAD. I always do LAD because LAD is a big territory. There'll be some viability there. And clinically, when they come back after 3 weeks, why should the echo function improve? Obviously, some viable muscle has started working. So even if they say the entire anterior wall is scarred, I don't believe. Anterior wall includes anterior wall, anterolateral, and septum. It's a huge territory. So there must be some viability there, especially in the basal segment. So I always, even if the proximal LAD is there, I just graft it because I know the septals will cover the basal segment.
Endarterectomy, I'm with you, sir. So better to avoid endarterectomy. Unless you're pushed to it, don't do it. The mic is not on. Take this mic.
So if there is no viability, then yes, I agree. It should be targeted approach, which I'll talk about in the next session as well. And I don't believe in grafting that territory, but that's my view. I go with what Dheeraj has been trying to say, because we do, and I rely on PET
Especially
viability
LAD
more than
LAD, if I find a target, I
MR.
always graft it. I never leave it.
I think the outcome shown by you is a testimony to an excellent surgical skills, which we are all aware of, Sridhar. But I think to put it in a very simple perspective, we can only graft if there is a vessel. You cannot make chicken soup with chicken shed. So graft all the vessels that are there, and then the choice of conduits based on your skills. If you're as good as LFS, you can get away with anything. But I think preparation and also assessing the viability are very useful in planning your surgery. LFS, again, congratulations. Thank you.
Yeah, so we'll just move to the last lecture of this session.
Thank you, ladies and gentlemen. We are at fault to have this venue so far out of the city, and we had this big metro which delayed all of us, and we did start off about 30 minutes later. I'm aware. Nonetheless, we are running far behind time, and that's going to affect the future speakers. May I do a little bit of housekeeping? May I request, please, may I request all of you to stick to your time of 10 to 12 minutes and have the discussion for about 3 to 4 minutes so that, we can fix all within 1 hour. Over to you, Yusuf. Thank you.
Thank you.
In the laptop. Yeah, can you take this one? Hello, please. Good morning, everyone. Thank Dr. Sundar and team for this opportunity. I think lots been spoken about CABG in heart failure, treatment of heart failure. My role is about minimal invasive CABG in this group of patients, which is a very small targeted group. Generally, minimal invasive CABG in heart failure, treatment of heart failure is less. Mitral valve repair procedures, targeted small group of coronary artery bypass grafts procedures, and now placement of ventricular assist device is being increasingly used. So just to summarize the advantages of minimal invasive, it's mainly because of the reduced tissue trauma. And in this group of heart failure patients, the SIRS response does matter with the sternotomy. So it is less, of course, with reduced risk of infection and pain, less blood loss, less use of blood products, which also has a significant advantage. Of course, reduce hospital stay and early return to normal activity, with other advantages such as cosmetic appeal, better visualization and training in mitral valve procedures, and good in patient in turnover to the units. CABG, we know, has moved a long way from on pump to off pump, minimal invasive, and now robotic assist, total arterial as well, which we do increasingly. So robotic assist procedures have been on the increasing trend over the last decade. This is a study from Europe over just before COVID, over a 4 years period. Centers that's been routinely practicing then have been 27 and just over 2,500 patients. And they noticed in Europe, it's changed their practice from predominantly robotic mitral procedures to 2/3 being CABG, robotic assist CABG procedures. But if you look at the numbers, less than 5% were bilateral mammary usage in Europe. And that graph shows the trend of increasing numbers from 300 to 700 over those 4 years period in a year, and double the centers over those 4 years period as well. So it's increasing over the decade. Observed mortality with use of robotic assist procedures is lot less than Euroscore mortality. Of course, Euroscore mortality is higher even in the open procedures compared to observed. And when they broke down to CABG alone, it was a lot less. So the recent, couple of years ago, a review article in JACC showed not only does robotic assist procedures reduce hospital stay and reduce recovery time, but with surgeons coming off learning curve and more centers with more numbers of procedures being reviewed, complications and mortality is less compared to sternotomy procedures. The patient sits comfortably and with 3 or 4 ports, but still most of us do direct coronary anastomosis, but we are working towards totally endoscopic procedures. That's what the patient goes home with, whether it be bilateral or single. So it does reduce the stay and the overall surge response. Because early extubation and they get discharged home in 3 to 4 days. Advantages, better vision, and it's 3D vision, just like a magnified operating field. Extended arms, negligible pain. There's hardly any retraction even compared to minimal invasive. But disadvantage is cost and learning curve. I'm grateful to my mentor. So there are certain contraindications. Previous lung surgery, adhesions, poor lung capacity, unstable patients is still a no-no. Relative contraindications, we move on with expertise. So this was a meta-analysis published in the European Journal of Pharmacological Surgery, Pharmacological Sciences. They looked at compared CABG versus robotic assist and TCAB. More than 2,000, close to 2,300 patients, 16 studies. They showed incidence of MACE was half as much as open procedures. So they concluded reduced infection rates, no increase in graft occlusion with reduced incidence of MACE. So overall, it is even more advantageous than minimal invasive because we can provide total arterial revascularization. We can get good length of mammaries from origin to beyond bifurcation by use of robo, both sides, shorter incision, quicker recovery. Not only is it kinder to the patient, but to the surgeon as well. We don't have to break our backs taking mammaries like minimal invasive. And this is a typical first day post-op X-ray, which we don't see in robotic or in open or minimal invasive patients. There's hardly any collapse because there's less retraction and less pain. You can combine this in robotic as a hybrid procedure, robotic or minimal invasive, in diffuse disease diabetics as well as patients with high uroscope. This is a study shown about 10 years ago in Annals of Thoracic Surgery. You can see one of the groups that really benefits by hybrid is the poor LV patients, where the Lima to LAD and the rest, if they require 1 or 2 stents, can be stented, or left-sided vessels being done by surgery and then stent to the right. It's a 2-stage approach. I won't go much into detail. Day 2, we do usually the stenting and always check the patency of the grafts. Advantages we don't need to go through. This was a review article published in, again, Journal of American College of Cardiology, JAMA, in 2020. They showed hybrid procedures reduce the incidence of MACE in the short term and long term, which is the other way around. In CABG, shorter incidence of MACE is higher, whereas in multivessel PCI for multivessel disease, incidence of MACE was longer, higher after a year. In our group of patients, close to 3.5 years ago, over 3.5 years now, close to 300 patients with high age group, more than 70 is 25%. You can see patients with left ventricular ejection fraction were 25% of the group. So some of these outliers are this group of patients. It's more comfortable. And I want to just show 3 cases before I finish, where we did targeted approach. This was a 67-year-old hypertensive with LV function around 25%. All these patients, we did viability studies and then went on to graft. And I prefer PET viability as Dr. Sridhar. And now FDG PET is more accurate than gadolinium. So this patient was going in and out of another quaternary center because they could not stent these. They tried once, could not pass the wire. Then this patient was referred to us. We did offer a hybrid approach. I'll show you why, because it was a circumflex alone, apart from this poor LAD. So we did Lima LAD and checked the patency as well. You can see that horrible LAD still flows well. And I don't believe in, I'm try to avoid endarterectomy unless I'm caught into it, which I think most of us do. And then this circumflex, which has proximal and OM1 disease, was stented 2 days later when that LAD was checked as well. This patient is doing well now, more than 2 years, and his LV function is improved as well. This is another case where we did a targeted approach, 48-year-old a 46-year-old patient. He had orthopnea. He was quite active otherwise, but has been significantly reducing in activity over 6 months period prior to surgery. So it's within about 6 months ago now. Angio showed triple vessel coronary artery disease, but completely non-viable territory in the other two except LAD. So we went on with mild renal impairment. I just did Lima LAD alone through robotic assist. He was optimized with guidelines derived medical therapy and optimization of renal function as well. Now he is doing well. His most recent echo 2 weeks ago showed 38% ejection fraction, still non-viable territory in the other two. So he is asymptomatic now, unable to lead his normal life. This was another patient, 72-year-old, on dialysis, CKD. On presentation, she had deranged liver function because she presented with ACS and was in ICU for about 10 days, in and out of acute pulmonary edema every other day. We tried to stabilize. In fact, we were not keen on operating, but she was not getting off anywhere. So Euroscore mortality was 26%. Again, we gave a targeted approach, just Lima to LAD to get her off. We did the procedure, optimized liver function to near normal, pre-op, dialysis as usual the day before surgery. She was extubated day 1, but day 2, again, the liver functions deranged. She was done off pump. She was not done on pump. She was on IABP, CRRT done in ICU as soon as she came out. INR went up to 4. She kept bleeding. Again, multi-organ failure. Day 3, she passed away. So again, these patients are a small group. We can provide a targeted approach, but we have to be highly selective and optimize them as best as we can. Always, and this is for patients who are not suitable for transplant or not suitable for LVAD procedures. So we have to be highly selective in choosing these procedures. I put this patient particularly to get that message through. It's not for everybody. It's for a small group of patients, highly selective and optimized prior to surgery. So I have a video, but in the interest of time, I won't run it through. There's a robotic video which may not be relevant here. Thank you. Are you okay? Well, in background, I'll show you the video of how we harvest mammary, but we can take questions.
Thank you, Dr. Yusuf, for an extensive presentation mix. And now, because we are running short of time, and as Dr. Sundar has already reminded us, we will take only one question. And after this session will be over. The next session about the aortic valves will start after that, but I will take just one question from the audience. Anybody there? Yeah, doctor, can you come here? We have a mic here. Please give him a mic. Somebody to give him a mic, please.
Yeah.
You can take this mic if you like.
For the robot, yeah, it's the mid port is usually 4th or 5th space where the incision would be later, because currently we do direct anastomosis.
The midpipe line, or you cross to the
No, it is lateral is always better
later. Okay.
for approach later for the LAD,
Okay.
as well as for the camera. It's a 30-degree camera looking up.
Okay.
So if you go closer, we cannot look up.
How many ports you use? Three.
Three.
Or three ports.
Second space, it's usually 2 spaces above the incision, 2 spaces
Is
below
it
the
straight line
incision.
ports you are going to put, or angle?
I do a slight
Triangle.
triangle, but a lot of surgeons do straight line.
XI, yours is model say XI. Da Vinci
XI,
XI,
yeah,
XI model. One doubt is there. Why do you want to do the stenting before? Why not you do stenting before the day of surgery, so that
No,
probably you may.
The stenting before surgery has 2 major problems. One is dual antiplatelet therapy.
Okay.
And the second thing is we can assess the patency as well.
Can we put
of the
on
graft.
put on a heparin and then maintain that patient?
Why do
Instead
we
of-
have to do that when we don't have to struggle with this way?
Okay.
Because this we have done, we have a series which we are presenting in IACTS, 180 patients.
Okay.
So we didn't have problems with.
One more last question. Do you stop any situation where you have to give cardioplegia? What's your, in case if you have to convert You are doing op-cap most of the
Yes,
cases.
that's right.
In case you have to
So
go
I
into a
have
situation where
less
heart
threshold
arrest.
to, yes, I have less threshold to convert.
Okay.
If there is, and I tell all my patients 2 to 3% conversion. Our overall conversion rate is just over 2.8%.
Okay.
If there is any hiccups, even arrhythmias for once, then I convert.
Okay.
So if I do convert, then it's on, usually on pump beating.
Okay.
Rarely, I
So
think one occasion we had to give.
the suturing
Plegia.
through the mini thoracotomy
Yes.
you are doing.
The incision is much smaller than minimally invasive surgery.
Okay.
It is just about 5 centimeters, unlike 7.
Okay. Thank you. Thank you so much.
And the
Thanks.
thoracotomy pain post-op, we hardly see after robotic.
Okay.
But with minimal invasive, they persist for about a month in 50% patients.
Ah, yes. Thank you.
Okay, thanks, everybody.
Thank you.
Once again, I thank all the speakers, starting
Sorry,
from
I'll
Dr.
stop the
Sridhar,
video.
2 Sridhars, 1 V, 1 LF, and then Dr. Yusuf and Dr. Pradeep. Thank you so much. This session comes to an end, and the next session in aortic will start. Dr. Sundar, coordinate.
Thank you.
Thank you, sir. Thank you so much. It was a very informative session. I'm Dr. Sen. I'm pursuing my training in cardiothoracic surgery in Apollo, Chennai. And this meet is extremely informative for us registrars who are present. So thank you to all our professors for giving us this opportunity. One thing I would just like to say before I proceed to the next session, to make up for time, lunch will be served on our tables. So you don't have to go anywhere. Please be seated, and it will be served around 1 o'clock at our tables itself. So the next session is going to be on aortic valve and aorta in heart failure. And I would like to call on the moderators for this session, Dr. Anbarasu sir, Dr. Sai Chandran sir, Dr. Shivan Rajan sir, and Dr. LF Sridhar sir. Can I please have you on stage for the next session? The first talk is going to be on conventional surgical aortic valve replacement in heart failure, and Dr. S. Vijay Shankar sir will be speaking on it. So can I please ask him to come up on stage and take over? Thank you.
Hello. Thanks, the heart transplant team, for giving me this opportunity to talk. Just few seconds. Can I? This is my mentor, Dr. H.T. Virare, an eminent vascular surgeon of the yesteryears. He's not moving, man. Babu, it's not moving. Oh, I got to play. Oh, where's the space? Yeah. And this is Dr. Solomon Victor, a brilliant cardiac surgeon. Both had one thing in common: keep it simple and safe, both in life and in surgery. They called it the KISS technique. I think I think in cardiac surgery, everything should be kept simple and safe. Can I have my video, please? The light off. Tambi. And the light off. Yeah. Double. No, man. Or can the next doctor? Not this. No, you're far again, man. Wait. Let me start from the beginning. Start from the beginning. I think you have to improve on the clarity. Tanvi. No, I think from the beginning. One of the commonest problems I have severe aortic stenosis is in our adult population. Symptomatic aortic stenosis, the lease of life is only 3 years. If it is associated with failure, is only 1 year. The greatest invention of 19th century is the prosthetic valve, be it tissue or mechanical. It gave a lease of life for many millions of patients. We have come a long way from 1954, where Hufnagel inserted a ball valve in the descending aorta without bypass for severe aortic regurg successfully. Acute cardiac heart failure is a syndrome in which is caused by multiple etiologies. One important cause is the aortic stenosis with mismatch between the left ventricle and the aorta. The other important cause is severe aortic regurg resulting in left ventricular diastolic overload. Lastly, ischemic cardiomyopathy due to multiple infarcts. Now it's up to us to identify which is the cause, and putting a valve in ischemic cardiomyopathy would be an exercise in futility. Just a few words about aortic stenosis. Left ventricular hypertrophy, which is more than 15 millimeters, is due to after mismatch. Now, this is because of the increase in the size of the cell due to a growth factor, not because of multiplication. Now, what happens once the compensating mechanism fails due to the infiltration of fibrosis, patient starts developing symptoms. These symptoms, one of the earliest symptoms seems to be dyspnea. Now, you see the next picture is a young lady is probably suffering from dyspnea, and she's in class 2. Now, if this symptom is ignored, or if she doesn't comply with proper treatment, they go into class 3 and class 4, where multiple forms of support is necessary. Here, this lady needs a balloon because she became hypertensive before surgery. It is now the pro-BNP increases, the EF falls to 30%, the left ventricular systolic volume increases. Now, here is a lady with class 2. We offer her the conventional aortic surgery, which may be very elementary for you people, many of you people, may be useful for post routine cardiac aortic cannulation, routine SVC cannulation, routine IVC cannulation, coronary sinus cardioplegia, continuous TEE, ascending aortic for cardioplegia, and a must left ventricular event, aortic cross clamp, and complementary I-slash to protect the myocardium much better. Now, we also dissect the left part of the aorta so that we can see the left-sided incision before closing. Identify the right coronary artery, and usually the incision 15 millimeters from the origin of the right coronary artery. Sometimes incision goes close to the right coronary artery. While suturing the aorta, it can produce a stretch and produce ischemia. Our incision is usually hockey-shaped incision. After incising, we lift the upper border, we look at the left coronary artery, and then incise so that our incision doesn't go near the left coronary artery. Sometimes we face this problem. After opening, we are not able to see the aortic valve. Then we completely excise the aortic valve. We have an enormous, fantastic exposure. Small tips about better exposure. We cut the aorta in the anterior aspect, and then put a couple of stay sutures in the upper part of the incision. And similarly, we put a couple of stay sutures in the upper part of the incision. Now, this exposes the artery, the underlying structures very well. Stay sutures on the commissures exposes the valve much better. Now, examination of the anatomy. We look at the relationship of the coronary artery to the valve, see the valve, whether it's bicuspid and tricuspid, look below for subaortic membrane. Now, having done that, we have an idea of what's going on. Now, sometimes you see by early division. So only one, the cardioplegia goes into only into one branch, and that is evidenced by the black blood coming out. Sometimes we are not able to see the right coronary artery origin. We lift it up and ask the assistant to push it forward, and the orifice comes into view very easily. Sometimes we don't see the coronary arteries at all. Then we give the cardioplegia, coronary sinus cardioplegia. And once we give the cardioplegia, the coronary artery starts filling up with blood. We can identify the branch by identify it, but sometimes we don't identify it in spite of this. Now, if we follow a technique which is done by Dr. Girinath, he closes the aortic valve completely and then closes the aorta. Then afterwards, he gives the ascending aortic cannula, gives antegrade custodial cardioplegic infusion, and then opens it and does the aortic valve replacement with much ease. Now, this may not be the situation quite often. Now, our method of removing the valve is that of Kirkland. We hold the right coronary cusp, cut the center part of it, and move towards the left up to the commissure and use a knife to cut it. And then you hold the left coronary cusp, the left part of it, cut it by means of a knife. Cut it by means, sorry, knife. Then the right part of it is cut by means of a scissors to avoid injury to the aortic valve. The non-coronary cusp is removed, then the right coronary cusp is removed. This is our method of doing it, and we found it very useful. Now, sometimes we are faced with such a situation where the aortic valve is severely sclerosed and stenosed and calcified. Now, in these patients, we are not able to see the annulus at all. We use the endarterectomy lymphosis Cooley's technique to see the annulus. We also have the suction ready with us so that any debris could be sucked up and prevented from going into the coronary arteries, giving us a perioperative problem or ischemia. Once this is removed, we look at the annulus, and with a sharp knife, 11 blade or 15 blade, cut the remnants of the annulus so that the annulus is completely devoid of any unnecessary tissue. A larger size valve can be inserted. Sometimes there will be calcium on the top of the mitral valve, which has to be removed so that it doesn't impinge on the disc of the prosthetic valve. You may make a hole, just put a few stitches, that sorts the problem out. Calcium underneath the right coronary commissure should be carefully removed to prevent a block, as it is immediately beneath the right commissure. Sometimes these accidents do happen when you remove calcium from the non-coronary commissure, it gets separated. All we need to do is put a patch between the annulus and the mitral valve, or you can take a couple of stitches, interpret sutures between the annulus and the mitral valve, and suture it. That solves the problem. Once having done that, you see the tip of the left ventricular vent, and now we wash the left ventricle by means of about 500 cc of cold water to remove all the debris. And this also cools the endocardium. And we have already removed the cut piece of gauze. Then we size the valve. The cylinder should go inside completely. And now, once the cylinder goes inside, we now use the replica to know where the coronaries are. Now, this tells you where the coronaries are and where the struts are and where the sinotubular junction is. Our suturing technique is very simple. The use of suture organizers made it very simple for us. We always use the interpreted suture technique with or without pleasure. The first suture which we tie corresponds to the black mark, which corresponds to the middle of the sinus, the deepest part of the sinus, and it also usually corresponds to the origin of the coronary arteries. If it is a pledget, we do the rock and then tie it with compression of the annulus against the patient's annulus. We also use simple suture technique for small annulus so that we can push in a larger size valve. Sometimes we are faced, a note of caution, with a small annulus which is around 17 to 18. But this should be enlarged because by the technique which you know, and put a larger size valve. Now recommended valve is more than 21. This could avoid postoperative low cardiac output, which could be a deterrent for your outcomes. A new techniques which has been developed, of course, my friend Dr. Yusuf does this quite often, exposure of the aortic valve through the small mini thoracotomy. and removal of the valve through the right mini thoracotomy. They feel, and these doctors feel that the recovery rate in this type of surgery is much faster than the conventional surgery. This is probably due the intensity of the whole body inflammation secondary to cardiopulmonary bypass is less in minimally invasive than in the conventional surgery. Well, some strange situations. Some patients become very sick in the floors. They are in class 3, but they become class 4. They need urgent surgery. So they're shifted downwards into the operating room. Now, we learned this from the tracheal surgeon Santosham and Dr. Bhaskar anesthetist. They are not able to lie down. What we do is we cannulate the femoral artery and femoral vein either percutaneously or expose it. These cannulas are inserted. This is just to support the circulation. It may not be huge cannulas, it may be just small size cannulas and connected to the cardiopulmonary bypass. Now, once these patients are bypassed and once the circulation is under control, we are safe, the patient is safe. Many times we have faced this problem. The cannula, the femoral cannula does not go further, so the anesthetist takes care of it. He puts in another cannula from the interjugular vein and leaves it in the SVC. This helps us to go on total bypass, and this is connected to the cardiopulmonary bypass and circulation. Circulation is bigger. Now, once this is done, the patient can lie flat and he is able to breathe, or he's conscious, but he's not aware of what's happening. Now, the anesthetist can safely intubate this patient without any difficulty and also pass a rise to people if necessary. And once we got control of the respiration and the circulation, it is usually conventional surgery. There are certain situations, but paramount here is how do you protect the heart? Now, we follow the techniques developed by the Japanese seems to be interesting. After the cross clamp, cross clamp, a 5-size cannula is inserted to the left coronary and the right coronary artery. This is connected to the pump, and continuous blood is given into these patients continuously, and the heart is beating always. Now, with the heart beating, now the valve is excised completely, and an appropriate size valve is inserted. This technique definitely favorable because there is no anaerobic metabolism. Now, the other technique that is also followed is cross clamp. A small incision is made in the right atrium. The coronary sinus cardioplegia is inserted. This is connected to the pump. A cross clamp is done. We expose the aortic valve after incising the aorta, and the coronary sinus cannula is attached to the pump, and cardioplegia is given. You see the blood coming out of the coronary arteries. This is stopped by passing two 5-size coronary sinus catheters and connected to a suction device which prevents blood spillage into the aorta. Now the valve can be excised safely without any problem. These techniques just help because the amount of cardiac depression is very minimal because there is no anaerobic metabolism, and so the outcomes should be better. Now, the new sutureless valve has come and said this should be used in such critical situations. This definitely saves time. Unfortunately, we had a cross clamp. The one problem with this is the heart block and the periprosthetic leak, but definitely it should be given a try. I'll be damned if I don't, or I'll be damned if I did. Sorry, this is an elderly man, 92-year-old man, who 20 years back, he had a coronary artery surgery. All the grafts are patent. He comes with severe aortic stenosis with class 4. He was referred to the surgeon, but he refused. He was referred to Dr. Sengutubel. He did a TAVI. During TAVI, he arrested 2 times, but he recovered. Now look here, on the 3rd day, he goes to the voting booth from the permission of the cardiologist, walks there, votes for his favorite candidate. The people there know his attitude. And they give him a standing ovation for his effort and attitude. I don't think surgery can reproduce this.
Before the procedure, I was very ill. My quality of life was very, very poor. I could not walk.
Now here you see this gentleman, 94-year-old gentleman, walking out on the 4th day in the company of our nurses. Lastly, let me show you this. When we were students, 50 years back, we used to see this is a common sight. The parts of the aortic valve, prosthetic valve flying into the abdominal aorta. Now, 4 days back or a week back, Dr. Yusuf removes a TAVI valve from the ascending aorta, which is symbolized. Thank you, ladies and gentlemen.
Thank you, sir. That was a very illustrated and informative session. Next, I would like to call on Aorta and Heart Failure, a Phenomena of Newton's 3 Laws by Dr. Mohammed Atheris, sir. Can you please come on stage?
Yeah. For want of time, I think we'll just quickly rush through the session and have a couple of questions for the whole session at the end of Dr. Idris' presentation.
Babu.
Okay. As the presentation is getting prepared, Dr. SVS, is sir here? Okay, sir, an elegant presentation as usual, sir. Now, in terms of LV dysfunction, when would you say no for a severe LV dysfunction aortic valve replacement patient?
I've not done such bad LV. I think Alex Peter has done about this. He'll be able to give you a much better history. Huh? Yeah. But I think we should offer. We should be able to offer.
Yeah.
Doctor who had a severe aortic leakage with a EF around 10 or 15% with a pro BNP of 14,000. They waited for 2 days. They offered him a valve replacement. Now he's flying all over the world.
Yes. Yeah, Dr. Idris.
Good afternoon and all present here. I thank the organizing committee and Dr. Sundar for giving me this opportunity. The topic given to me is aorta and heart failure. So when Dr. Sundar told this topic, I was just wondering what to talk on this. So I have no financial disclosure. Before starting on the topic, so most of them are married here. Okay, we have a spouse whom we all depend upon. And most of the times, they trouble us and cause some failures. I call this phenomena as a spouse mechanism failure. And sometimes there is a different mechanism where the in-laws will try to trigger the spouse and they cause failures. And I call this as the in-law mechanism of failure. This is very true in relation to my topic, where the aorta itself can be a direct cause for heart failure, or sometimes it can trigger the valves or the myocardium or the coronaries and cause an heart failure, which I call the in-law mechanism. So moving on, these are different sections here. Aortic ectasia with aortic regurgitation. This is a very common thing which we all recognize. And because of the dilatation of the aortic root, there is a severe AR and dilated LV is there. And the patient will have an severe AR and dilated LV, which cause heart failure. These patients will require a Bentall's operation or a David's operations, or in most of the cases, aortic arch pathology as well. And these patients, when they present with dissections, then we have to tailor-made. I'm not going to dwell into this topic. So the most important is already the previous Dr. Vijay Shankar mentioned, myocardial protection is very, very important. We use a lot of custodial in these kind of dilated LV patients, which will protect the heart. And when they go for more than 2.5 hours around, so custodial is a very good option here. This is one of the cases which we published during my residentship in Chitra. So this was a large LV, almost like 70 mm was there. And this patient also had a VSD with aorta and ectasia. So we had to close the VSD, and this was published in Annals. So the move on to next topic is like the stenotic lesions. There are a lot of stenotic lesions which lot of stenotic lesions. One such lesion is the bicuspid aortic valve causing aortic stenosis. Then moving on forward is the supraortic stenosis. Then we have a coarctation of aorta. All these will cause diastolic and a systolic dysfunction. So a stenotic lesion is there, a mechanical obstruction, there is a left ventricle overload, and these patients will have cardiac myocyte hypertrophy. Then they might have a mismatch between the oxygen supply and the demand. Then these are replaced with fibrosis, which will cause a fibroelastic mechanism alteration and also a defect in the compliance of the left ventricle, leading to a diastolic dysfunction in these patients. This is a similar mechanism in all the patients, supraortic stenosis, or severe AS patients, or coarctation of aorta. So coarctation of aorta, how does this cause an LV dysfunction and heart failure? So I've already mentioned about the diastolic dysfunction. So there are different options of treatment, like we can do a bypass graft is there, or we can do aortic to ascending aorta to descending aorta bypass, or a stenting can be done. So we have elaborated all the techniques in our paper in Journal of Visualized Surgery. This is a discrete aortic coarctation of aorta in young female whom we have done bypass with the Dacron graft. So when we are coming to hypertension with coarctation of aorta, so over 3 decades, only 1/3 of the patients remain hypertensive, normotensive, even after a good repair. The most important predictor of this is the age of the initial repair. So in this study, which was published, which shows that the patients who have undergone the repair well in infancy, that is less than 1 year, have a good survivorship and the lowest rate of late hypertension. So there are multiple theories which was put forward. So why does this hypertension, late hypertension, is in these patients of coarctation of aorta? So one is that they have reduced baroreceptors, and other they have more collagen and less of smooth muscles, making the aorta more less compliant and more rigid, causing hypertension or abnormal structure in the pre-aortic coarctation segment. Then these are the in-law mechanism of causing heart failure in coarctation of aorta. One is the aneurysm, other is the bicuspid aortic valve, which are related to this topic. The bicuspid aortic valve, already Dr. Vijay Shankar has mentioned about this one. So nearly 2/3 of these patients of coarctation of aorta have a bicuspid aortic valve, and bicuspid aortic valve as such is a separate disease entity, which will also have an aortopathy. So more than nearly 1/3 of these patients have serious complication, and a report says that bicuspid aortic valve causes more deaths and morbidity combined when we put combined of all the congenital heart disease. And you all know bicuspid aortic valve can lead to stenotic lesion, regurgitation, aneurysms, or dissections. All of these are their own mechanisms of heart failure. So this is a patient who had a coarctation of aorta and severe aortic stenosis with severe LV dysfunctions. So the patient presented with dyspnea and heart failure. We did a stenting of the coarctation of aorta, and then within the 3 days time, then what we did was we went and did the Bentals with hemiarch replacement for this patient. And then in regards to aneurysm, this is one of the largest study published in Journal of Vascular Surgery. We are one of those which was published. It is here 74 patients who had a post-coarctation repair aneurysm were examined, and almost 5% of these patients had a heart failure. So which was 3 in open repair and 1 in endovascular. This is one of our patients who had multiple surgeries after coarctation of aorta. So when he had interposition graft, later after 7 years of his initial repair, he had an ascending aortic dilatation and hemoptysis, for which he underwent ascending aorta abdominal aorta bypass. Later, another around 14-15 years again he came back with heart failure with severe aortic dilatation and severe AR, for which a Bentals procedure was done for this particular patient, and this was published in Annals way back in 2009. So this coarctation of aorta not only causes an LV dysfunction, it also causes a right heart failure, which was recently published in Circulation 2021. So they have examined over 820 patients in 820 patients who had a prior coarctation repair. And they found almost 1/5 of these patients, 20%, nearly 20%, 15 to 20% of these patients have RA dysfunction, RV dysfunction, and pulmonary hypertension. So the authors came up with a separate scoring system, having a 7-point scoring system, assessing the right atrium, right ventricle, and the pulmonary hypertension. And they proposed that this system, where each unit increase in this system, in this scoring system, when there is each unit increase, there is an increase of 64% in the cardiovascular death. The next morbidity, which in aorta, is the supravalvular aortic stenosis, one of the rarest form of LV outflow obstruction, which has a focal narrowing or a diffuse narrowing just at the ST and this is because of the reduction of disorganized elastin fibrins in the medium. So if this is left untreated, they will move on to heart failure or death. So the different surgeries which have been proposed here, a single sinus, double sinus, or a triple sinus to repair this and dilate the root. This is one of our patients, but a severe calcific supraaortic stenosis for which Bental was done. We were not able to reimplant the coronary arteries. So coronary arteries were severely calcific. Cabrals also was not possible. So we had to close off and do a Bentals for this particular patient. So this was a series of 117 patients which was examined outcome after a supravalvular aortic stenosis. So of this, 96 patients had some amount of cardiovascular events, of which 2 patients died because of heart failure. 7 had a new onset heart failure. So most of them are only a valve regurgitation or aortic valve or mitral valve regurgitation, and one is a supravalvular aortic restenosis. Then the porcelain aorta, the calcific aorta, is another pathology which always causes heart failure. The most important thing is the diastolic dysfunction because of the stiffened aorta, because of the loss of elastic tissue. And this is more common in diabetic patients or the renal failure patients, where there are a lot of calcific deposits causing a stiff aorta, and they are independent risk factor for LV dysfunction. These are the spouse mechanism for causing heart failure. If you move on to this is one of our paper, which I published in when I was a resident in Chitram. So when you go to the in-laws mechanism, what is like when these particular patients also come for other surgeries, like a patient with a porcelain aorta can have a bicuspid aortic valve, and those patients can come for a surgery. So we have a difficult time already. These patients with LV dysfunction, a bicuspid aortic valve, a high incidence of stroke or myocardial protection is always a difficult thing. These patients with porcelain aorta had more morbidity, like cross clamp, and the increased rate of stroke is also present. So we published this technique where we use a coda balloon intraoperatively and tried to occlude instead of a cross clamp, and did an aortic valve replacement in this patient. And this was an interesting thing where a patient with the porcelain aorta had to undergo for heart transplant. So the surgeons over there, what happened was they had to replace the ascending aorta. After that, they have to do a transplant. So this patient also incidentally had a TAVI, the recipient heart. So the TAVI can be shown in the other mechanism is aorta arthritis, which can cause a heart failure. So this is a well-recognized mechanism, and this is a leading cause of heart failure in Takayu's arthritis patient. It can be multifactorial, which can be inflammation or hemodynamic factor. See, the factors can be renal artery stenosis leading to hypertension, or an aortic obstruction with multiple aortic obstructions, or a coronary obstruction, or a regurgitation lesion of the aorta, or the myositis as such can cause heart failure in these patients. When they examined 87 patients with diagnosed patients of Takayu's arthritis, they found nearly 20% of these patients had systolic dysfunction, and almost all the patients had a diastolic dysfunction. And all these patients are active disease. And Takayu's patients with, there have been reports where heart failure is present in these patients, even without hypertension or coronary artery disease or any valvular regurgitations. So when they examined when the autopsy examined the heart, they are found to have interstitial fibrosis and myonecrosis of the myocardium in these patients. There are different lesions in Takayu's arthritis, where the stenotic lesions or the regurgitation lesions, or a stenotic lesions of the branch vessels, which can accelerate the hypertension and cause heart failure. The therapeutic management can be interventional or medical in these patients. Depending, it can be a immunomodulator, a decongestive or surgical or catheter-based treatment for these Takayasu arthritis patients. This is one of a patient who was a very young female, 22 years female, who had a severe coronary artery stenosis. So then the cardiologist put a stent and immediately re-stenosed within 3 months' time. So then we have to take her for CABG, and a Lima LAD graft was done, and this patient is doing well. This is another patient who had a severe stenosis of the mesenteric and the renal arteries, and this patient is still on 3 antihypertensives, and surgery is very difficult, and the patients also refused the surgery, and the patient is moving in for diastolic dysfunction right now. And these patients, many of these patients who present an active disease of Takayasu arthritis, also on heart failure. So we had one patient which was 26 years old. I had a critical stenosis of the left carotid and the left subclavian artery. She was in active disease process, and she also had a severe regurgitation, acute AR with congestive cardiac failure. So she has to taken up for emergency surgery. We prepared this patient with 2 weeks of IV steroids, and then was taken up for surgery, and we did a Bentals with debranching for this particular patient. And these are the patients who can have active disease and heart failure. And when there is an encroachment, we have two mechanisms. One, if there is an Alauddin Khilji-like person who can encroach with a solid muscular thing, or if you are a superstar, you can resist the encroachment. Our aorta is something which can encroach on the cardiac structure and causes heart failure. This is our own patient which was published, which is a huge aneurysm which compresses the myocardium and has caused heart failure. There are multiple reports where one of the large aortic aneurysm, ascending aortic aneurysm, compresses the coronary artery and has caused heart failure. Then here there is a descending thoracic aortic aneurysm causing an heart failure by compression of the left atrium. This is a large aortic aneurysm compressing the right pulmonary artery, causing a thrombosis, which is leading on to a right heart failure. And here there is a patient which is aneurysm, which is causing compression of the pulmonary artery and left atrium, causing a heart failure. So this is from our own country, where this patient had a heart failure because of the compression of the left ventricle. So Newton's third law says every action is an opposite and equal reaction. So likewise, when the aorta, because of the vascular rigidity or a hemodynamic alteration or any compression of the left heart structures causes it reacts, the heart reacts with a systolic or a diastolic dysfunction. I thank the organizing committee for giving this opportunity. Thank you, Anna.
Thank you, Dr. Indres. Now, there's more and more emphasis on severe LV dysfunction, aortic stenosis. You've covered extensive aortic dysfunctions, severe LV dysfunctions. Now, one test which differentiates a patient who will benefit and not benefit from surgery from severe LV dysfunction, aortic stenosis, maybe an MRI. And I think we should try to follow it and document at least who will benefit from surgery.
I totally agree with it. I totally agree.
Like he said, like, do you have any scoring system before the procedure, like which patient will be getting benefited and which requires surgery and which does not require surgery, or put the patient on medical management? Do you have any?
We have quite a lot of patients who had stenotic lesions and regurgitation lesions who with LV dysfunction. We have taken up for surgery. So most of these patients always recover. You know, when even though I agree with Dr. Anbarasu, but personally, we have not done any thallium scan or viability scan for these patients to assess. So most important, because any patient compared to regurgitation lesions, the stenotic lesions, once the stenosis is relieved, most of these patients recover very well as compared to.
They said like stenotic lesion will recover faster, but regurgitation, if the LV size is becoming more than 7 or 8 across 6, then did you take a call on it? Like you wait for the patient or straight away and replace it?
Question of waiting is always There's
But
no choice of
outcome,
it.
like
We
how-
have to
I
take
mean,
it up. They take it.
Yeah,
Take up.
but outcome, like outcome is, how is the outcome?
So
Your
they
experience.
have a bit of STOMI post-operative. But the most important thing is that myocardial protection in these patients. So we found that del nido in these patients have a lot of arrhythmias. These dilated LV patients. We try to use a custodial in these type of patients, or we use a blood cardioplegia. Blood cardioplegia increases the cross clamp time because we need to give repeatedly. So custodial, even though custodial is, they say use it for 3 hours. What we do is after 1.5 hours or 3 hours, we give another half dose. Initially, we give around, if we give 20 ml per kg and later repeat with 10 ml per kg, we repeat the dose.
Thank you, Dr. Edris. I think for
Thank you.
want of time, we'll close the session and
Thank you.
invite for the next session.
Thank you so much. The illustrations and animations definitely made this session very interesting. Before I move on to the next session, I would just like to request that everybody can be seated in their seats. We don't need to go anywhere. Lunch will be served at 1 o'clock without delay. So moving on to the next session, now that we are done with aortic valve and aorta, we move on to the left ventricle and heart failure. I would like to call on the moderators first, Dr. Periasamy sir, Dr. Jacob James Raj sir, and Dr. Vijay Shankar sir on stage to moderate this session. The first topic will be discussed by Dr. Janardhan Reddy sir, and it will be on surgery for LV aneurysm. Sir, can I please ask you to take over? Thank you.
Ladies and gentlemen, this is Dr. Janardhan Reddy. He needs no introduction. He must have done about 1,500 cases of LV aneurysm resection. 1,000. So you must be able to, you'll be able to give us a lot of information.
Good evening, afternoon. So we are going to present a ventricular aneurysm and its repair. So I used to do from 1997, 98, we used to do the LV restoration. Okay. Okay. LV aneurysm, if everybody talks about one procedure, that is endoventricular patchplasty by a DOR. So I attended the session in the 2002 on Monte Carlo. So I presented a last session for 5 minutes. I presented that. So he was really liked my technique and then asked him to present one of the papers so that it will be included in of the book, but I never presented anything. So this is the interesting development of the ventricular aneurysm. That is a patch. Okay. This is the technique which Dr. Dorr in 1984. There is a purse string at the neck of the aneurysm, and it's make it smaller, and then we'll put a circular patch suture onto the segment to the neck of the, and then we suture the suture. That is you open it vertical inside the aneurysm, then we'll put a purse string at the neck, and then we'll put a patch so that it will become a aneurysm is closed. The anterior one is a linear closure, either with a felt or directly. This is the schematic diagram of the scar, the apical small scar. And then there is a bigger scar, it will become a scar and produce a dyskinase. The larger scar can produce an aneurysm. This is what you have seen, the anterior wall scar. See, the vent is cross clamp, clears dimpling of the anterior wall. You can see the entire scar is dimpled in because when you cross clamp it, open the vent, you can see that anyway. This is the classical anterior wall aneurysm. One and a half years ago infarcted. This is the dimpling of the anterior wall is aneurysm. And then I can open the lateral edge of the infarction. Now, the endoventricular Gore-Tex patch plasty. This is the technique which I practice. We call it my name because everybody has got the doors or modification, but finally I have done this. We are to name it only yesterday. Okay. And then we can see various types of aneurysms, which a lot of aneurysms which draw the diagrams. It can be a 40% to 25% ejection fraction. Because all of these are drawn it and then did the surgery and then we got the findings. Now this is the classical methodology of which we have done. This is the anterior wall septal area. Is yellow is seen. The outer edge of the scar, the anterior wall, outer edge of the scar, lateral whatever, there will be a scar and then you open it up and then put a Gore-Tex patch into the septum and then suture it back together in the lateral wall. This is on long axis. We can see the incision between the diagonal and the LAD. And then we did the vertical incision and then we did a patch and then we did the restoration. This is the one of the echocardiograms which we have. You can see that cone is immediately postoperatively will have a cone, but slightly dilates over the months. It will become a different type of a, right now it is not nice cone, but it will become a slightly bigger. And this is the one of the ultrafront CT scan, which is showed the pictures, and then we see the patch. Don't have it. Okay, pointer is not working anyway. That's how this, you can see the white patch seen in the LV restoration. The LV size is reduced and then now, one of the questions they asked, I said, are you at the end of the lateral edge of the, are you sure that you are in the a scar or in a muscle. Then we took a study, edge of the scar, which we had taken out the biopsy, we'll get the slice at the edge of the scar, and then we send it for the histopathology, and then we studied there is no viable muscle in the scar. This is we wanted to. There, one question they asked, I said, "Are you sure that they are not in the edge of the scar?" Yes. This is how we have done a 1 year, 72 cases which we have done. So now acute, there is a 1 death. Intermediate, there is a 2 deaths. Chronic cases, which are 2 deaths. There is a 75% of them are diabetics. This is the tabulated. This is the acute MI, that is in a VSR and acute infarction. Then we can see the intermediate type of, we have got studied by the pathologists, and then we did that. And then we find out the VTs were there in 2 cases, preoperative, that they have got converted back to normal. Technique of aneurysm. That is a standard my technique which you have done, because it's not DORS. DORS is a different type of methodology. Of course, we use a blood cardiopesia. LV restoration, endoventricular patchplasty, is done in a beating heart. Now, stitch trial is a very small sample, which is not really extrapolate to the number of thousands of cases with a LV restoration, LV failure. So this is not a very valuable study. And then this is the one which Dr. Dorr has done a lot of work. And then Vincent Dorr cautions that explorating the stitch trial results in a too widely will deny any effective treatment for the like SVR for many diverse deserving states. Lot of deserving patients which have a large aneurysm, they require surgery. Classical LV aneurysm, which I did it in 2002, presented in the Monaco. Same thing, I'm presenting it again. 3 years after the infarction. This is the entire lateral edge, apex to the full. And then you can see the probe, which is on the septal side of the infarction. This is a complete incision of the lateral wall. And then we do that, mitral valve regurgitation will repair it through the LV. You can see the diagrammatic representation of the flagellated sutures to the annulus sutured into the LA side. This is a conjunct difficult to understand, but it is possible to do it. We have done it. They do very well. This is all the anterior, because you can see that anterior posterior papillary muscles are widely dilated. That's the reason why there is a mitral regurgitation. Then the Gore-Tex suture is sutured to the left septum, and then we can trim it according to the patch, and then we suture it back to the. Now this is the lateral mattress suture. When the Gore-Tex suture is sutured a lateral wall, the mattress suture, so that it will not cut through. It will be nicely anchored. Now this is the completion of the suture. Usually it is 3 centimeters to 4 centimeters, maybe whatever is the suture which is sutured to the left LV. Now finally the redundant sac is excised and completed the suture. Lateral wall is reconstructed. Follow up, this patient has 11 years after surgery. I don't know, he lived for further. Asymptomatic, never seen a doctor after the operation. He's never taken to that means they're very good operation. Now, what is called LV aneurysm, which is very commonly you come across, that is 2 weeks after the infarction, thrombolized, and then you had an aneurysm, acute LV aneurysm with the strengthened free wall rupture. This is the angiogram. This is the LV angiogram. You can see the rupture of the anterior wall. This is the echocardiogram. This is the diagrammatically I presented it. You can see the anterior wall is fully infarcted. We can see that. You can see the edge of the infarction incision. There is a different type of color. That's called border zone. You can see the lot of clot, and then you can see the dehiscence of the anterior wall. And then you can see the trabeculations in the apex. We can see the difference in the edge of the incision. You call it a border zone. Septum suture with a continuous and then interrupted in between. At the edge of the lateral wall is a mattress suture again. You can see the difference. The sutures go through the normal myocardium and then mattress. Completed suture, never plageted sutures, never plageted were used for the suturing. No strip of a Teflon is used because it will produce this stiffness of the LV. So always use a Gore-Tex continuous suture, and with a very rarely we can use a plageted stitches. This is the one of the CT scan 9 months ago. We can see the Gore-Tex, and then patient is doing well. Now this patient are 4 times to US and 1 trip to Europe, asymptomatic, 10 years really, underwent angiograms elsewhere. They recommended LAD graft to the LAD marginal. So because they don't know what is the operation was done, they don't know idea. Because endoventricular patch plasty, they don't know about the operation. And the echocardiogram did not recognize the patch. Ejection fraction is 42. That's very good. Okay. This is another patient which LV aneurysm. Feature of ASMI and 100% LAD and all that. This is the echocardiogram. Huge aneurysm. This is after the surgery, and then 19 months after the surgery. So the LV looks beautiful now compared to what you have seen it before. And this is the total amount of cases which I have done. Ventricular restoration was done 1,000 cases, out of which the mitral valve repair through the LV is and ventricular septal rupture, 81 cases. And then if you see that mitral valve repair through the LV, 10% of the cases are mortality. And then regular cases has got 5%, and VSR is 24%. Off pump CABG is 0.47. Thank you very much.
Any questions from the audience?
Excuse me, sir, I'm Dr. Perez. Sir, regarding the post LV aneurysm repair, how come that the post-operative, any arrhythmia you encounter, how will you treat that?
See, in a immediate VSR and an acute cases, it'll never have an ectopic. And then intermediate, they say, where it is a biopsy showed intermediate type, also don't have arrhythmia. Only the patients with a fibrosis and then scar, they have ectopics. And then also 2 cases which they had VT. So we converted into.
One angiogram you shown that is proximal LAD block, distal is LAD is good. After aneurysm repair, you do the graft or you
Of course,
neglect?
always there is a graft has to be done. There is no need to leave it off unless if you have a VSR, you go, suture will go through the LAD. That you can't do anything with it.
I think one of the few peoples with such a tremendous experience is Dr. Janathan Reddy. So if any of you want to ask him anything, I think now is the
Of course, I
time.
can ask. All problems I faced. All problems.
Good. Okay, sir. Lovely. Thank you so much. Okay. Yeah, sure. Shoot.
CAD is present in most of the cases, aneurysm. Do you face any particular case in which there was no significant coronary disease was present, but still there was a giant aneurysm of the LV?
Repeat again.
He's asking if you had aneurysm without coronary artery disease.
Yes, there are cases where there is one case where the patient got infarcted, recanalized normal vessels. We did the LV restoration.
So in that case, what was the cause? It was basically the connective tissue disorder or something else?
No, it's a regular case. We developed an infarction. There is a huge aneurysm anterior wall. After 8 years, nearly 5-6 years later, he developed a 25% ejection fraction breathlessness. We have to do surgery.
So basically, because we have recently faced a particular case in which there was no coronary artery disease, significant coronary disease. LAD was hardly 30-40% lesions.
No, he's saying it was a recanalized coronary artery.
Okay.
No, his question is, have you faced any situation where it is not a atherosclerosis, non-atherosclerotic disease, any other etiology wise, have you faced any aneurysm? He's asking.
No, I have not seen. And
Most of the aneurysm is like that only, that recanalized.
We recently faced that kind of particular case in which there was no significant coronary disease, LAD hardly 30-40% lesions, circumflex was absolutely normal. So, but still the patient got the large giant aneurysm of the LV.
Yeah, we accept that because that is recanalized coronary. If you do the angiogram, it shows the coronaries will be normal, even though dilated, but the LV aneurysm is there. So definitely has to correct that is LV volume reduction.
Actually, that patient recanalized is, what is the volume of the LV? 250 ml. That's quite big. So we have to reduce that. And as it is, if we got an anterior wall MI, aneurysm, circumflex and RCA normal, don't do a hurry to do the surgery. You wait till you get the symptoms.
Okay. So most of the time, the temporary thrombus can be present, which could dissolve after giving the heparin or thrombolytics. So it has already done its job. It's already infarcted the LV and caused the aneurysm to form. So because we have thrombolized it, so it has got cleared. So that might be a cause, or otherwise there might be a connective tissue disorder which has caused.
Most of the time, connective disorder uniformly dilated. This is like a LV dysfunction, CCF.
Yeah.
So congestive cardiac failure. It won't be this isolated, that's local aneurysm. Sir is telling about all those things what you asked. The post angio, if you see the normal coronary, that's previous must be that is some amount of myocardial insufficiency due to the coronary. That's development. That's it. Okay. Thank you for this.
Thank you. Thank you
Next,
so
we'll
much,
go
sir.
for that.
Yes, sir.
We'll call
move on
Dr.
to the
V.
next.
Arun.
Yes.
For the.
He'll be talking on free wall LV rupture. Can I please have him on stage, sir?
pages? I don't know.
Good afternoon. Respected teachers and friends. First of all, thanks to Dr. Sundar for giving me this opportunity. And as I promised him, I'll try to keep it as simple and sweet. And my topic is left ventricle free wall rupture, just an overview. The free wall ruptures involve, of course, the anterior wall, the lateral, and the posterior lateral wall, posterior inferior wall. And this is usually follows a complete occlusion of subcritical lesion. And there's no time for collateral formation. And if the patient is hypertensive in the immediate acute MI period, and if it's an elderly gentleman, usually that's when this rupture occurs. This holds good for either ventricular septal ruptures or free wall ruptures or papillary muscle ruptures. And that's pathophysiology. Following the transmural MI, there is an expansion and thinning of the infarcted wall. And when the elastic strength of that free wall is exceeded by the left ventricle systolic forces, that's when the rupture occurs. And these are some of the risk factors, like I mentioned: elderly person, female gender, no previous MI. That means there's no chance for any fibrosis to occur to support it. If the patient has been hypertensive in the immediate post-MI situation, if the patient was on corticosteroids, and if there is late use of fibrinolytics. So there has been a classification that's by Becker, but this is basically an autopsy-based classification. What is important for us as clinicians is to understand that this LV rupture can occur as an acute, subacute, and a chronic. The acute is when there is an immediate rupture which occurs within 24 hours of MI, and there's a linear macroscopic tear, and there will be a large amount of pericardial effusion, with the resulting going in for pericardial tamponade, electromechanical dissociation, circulatory collapse. That's the acute situation. Whereas the other variety is subacute, where there's a smaller microscopic tear. It's partly sealed off by clots and some of the pericardial adhesion. And that is what is called as, that is the subacute variety. The chronic variety is what we see about 2 weeks post-MI, where there is pericardial adhesions, which will restrict the rupture. And that is what is called as a pseudoaneurysm. There's another way to classify the acute. It's called blowout type. And the subacute is also called as the oozing type. Because this particular reference is for us as surgeons. When we look at the patient in the theater, we should know which variety, so that we know what type of operative strategy can be used. So what is the principles of treatment here is: one, we have to remove the pericardial fluid and therefore relieve the tamponade. Number two, we go for hemostasis. And number three, we should not, during our course of trying to repair the defect, we should not worsen the LV function, and geometry should be preserved. And apart from that, we also should make sure there's no question of re-rupture, or we should prevent any pseudoaneurysm formation in the long term. So I'll go through the operative strategies. One of the simplest thing you can do is a linear closure using pledgeted proline mattress sutures can be taken. And but the issue here is we have to go through the infarcted area, and again the sutures might cut through. But this will be the only option if you are dealing with a case of a blowout type of left ventricular rupture. The other variety is this is not much used. This is called infarctectomy, where you excise all the infarcted area and then you close it with a Gore-Tex patch. Again, this distorts the ventricle a lot, and there will be definitely worsening of the LV function in the post-operative period. But you could reserve this for the chronic variety when there is a pseudoaneurysm of the pseudoaneurysm has formed after the rupture. Then the ones that we are using more often is especially in the oozing type. This type of patch closure technique is the ideal one, where there is a partial seal of the rupture because of the clot. And all that you have to do is put bioglue in that area and cover it up with a bovine pericardial patch. So as to avoid the pericardial patch from moving around, we suture it to the healthy epicardium all around, well away from the infarcted zone. And of course, bovine pericardial patch. And what the bioglue that we use is, of course, as you know, it's made up of the glutaraldehyde, which is 10%, and about 25% or 45% of the albumin, and that forms cross-linking of this, and it links with the tissue. So that's why that integrity is there. But one of the most important thing with BioGlue is it should be a bloodless feel for it to really stick onto that area well. And yeah, this is how we apply it. And the other, which is more popular now, is a sutureless repair, because even in the previous one, as you can see, to prevent the pericardium from moving around, we do put a continuous suture. But in a sutureless method, what we are using here is called the TacoSeal. The TacoSeal is equine collagen, and on one surface, you have coated it with the human fibrinogen and human thrombin. And to understand which is the active surface, riboflavin has been put, so that's why it is yellow in color. So that particular active portion is to be compressed onto the rent and hold it for about 5 minutes of manual compression. And what happens is that the thrombin reacts with the fibrinogen, converts it to fibrin, polymerization, and then there's a linking with the tissues. So that's how it seals. And here you don't have to put any sutures to hold it in place. Obviously, these two methods which I mentioned will be more useful in the oozing type rather than the blowout type. So here you can see a sutureless repair that's been done for a lateral wall rupture. There's no sutures, it's just 2 layers of this TacoSeal has been put. And this is one of our cases. Patient had a lateral wall MI when he was waiting for surgery. He crashed, and we had to open up the chest. Like I said, the first step is to relieve the tamponade. We're removing all the clots. We're able to identify the area of the rupture. As you can see, it is more of a oozing type, partly sealed off by the clots. And if you, of course, we usually prefer to do it on pump. And we have an aortic and a single double stage venous cannula. And for mobilization, we could use a starfish, and you can see the rent in that area. And that part is now covered with the bovine pericardial patch, and with, of course, BioGlue has been put. A few sutures have to be taken on the sides. This is one of my cases. And recently also we had another case of, I think, where we had a lateral wall rupture. Sir helped me in that case. We put TacoSeal and we didn't put any sutures in that case. So yeah, that's about it. So thank you.
Thank you, Arun. Nice, elegant presentation. I said it's a great presentation, you know. It's very clear and crisp. Any questions, ladies?
Yeah. No, it's available.
TacoSeal is not available now. They have removed it, but they have come out with another new material with a lot of spots. It's available in our hospital.
Yeah, there's no apoprotein in that. They have avoided the bovine fraction in that, right? The original TacoSeal had bovine material. The one that is coming now is only human fibrinogen and thrombin, but you don't have the apoprotein. That's why it will not be refrigerated. Yeah,
Arun, you mentioned risk factor is 70 years.
elderly people.
Okay.
Anyway, thanks, Arun. I think we'll go on to the next talk. We'll call Dr. Shiv Muthukumar to talk about ischemic
Surgery for
BSRs.
ischemic BSR. Yes, sir. Can I please have you on stage, sir?
Yeah. The point. I leave the laptop.
Good afternoon, friends, respected chairpersons. Thank you, Dr. Sundar, Dr. Paul Ramesh, and Dr. Madan for this opportunity. And I'm going to discuss about this, the most dreaded mechanical complication after acute MI, the post-infarction ventricular rupture or the post-infarction VSD. Can I have the next slide, please? Let's not change.
You can just click it from here.
Yeah, thanks. I'll use both, yeah, it's fine. And so it's called, some people call it as post-infarction VSD, some people address it post-infarction rupture, ventricular septal rupture, and some say ischemic VSR, and the Japanese group says ventricular septal perforation, VSP. So I thank Dr. K.R. Balakrishnan, Dr. Richard, and my friends, Dr. Perisami and Dr. Ranjit, from whom I learned a few tips and tricks of this most dreaded complication of acute MI, and which is devastating for the family, for the surgeon, for the entire team. And we're going to discuss about the decision making, which is as important as the surgical technique and the timing of surgery, whether you're going to use MCS as a bridge to surgery, like IABP or ECMO or VAD, or any other mechanically supplementary MCS, or and we're going to discuss about the heart team approach, a few scenarios in which heart team approach is really mandatory. As we all know, it carries very high risk mortality, and it presents with a bimodal pattern where you have the high incidence of mortality in the first 24 hours, and then later we see a peak in the third to fifth day. And most common cause is usually the LAD, sudden occlusion of LAD. So this registry, GRACE registry, which is a global registry for the acute coronary events, says the incidence is around 2% before the thrombolytic and Perkinis intervention era. And now with the advent of effective thrombolysis and shortened door to needle time with early revascularization, it's come down to 0.31% on average. But it's the high incidence is high with the STEMI population, which is 0.9%, and the NSTEMI, which is a very less, 0.17%. And in unstable angina group, we see as 0.25%. And just to brush through the history, we all know Latham described in an autopsy, finding the ventricular septal rupture in 1845, and a lot of people have contributed to the evolution of surgical technique. And it's still evolving. The surgical technique is still evolving. We have publications, publications and modifications every once in few months from different corners of the world to address ventricular septal rupture. And the incidence is definitely decreased with early revascularization, but still the mortality is still high, even with definitive repair and closures, and is extremely high without any intervention. So we need to think about intervention at the right time. So we have some perfusion friends. So I thought I should talk about the blood supply of the septum also, which is good to know, to decide understand the pathology and then decide the patch locations and the techniques in surgery. So as we all know, it's majority supply comes from the LAD with the anterior from the anterior interventricular groove through septal branches. And then you have a posterior descending artery from the right coronary and sometimes from circumflex, supplying the posterior 1/3 of the septum. So when you talk about the infarct-related artery, usually it is LAD, which contributes to the anterior and anterior apical VSRs. And you have right coronary artery contributing to 30 to 45%, which results in posterior or basal VSRs. And if you look at the angiographic findings, the coronary artery disease pattern in VSR patients, you often see double vessel pattern in 40 to 45% and a triple vessel pattern in next group 30 to 35. And in 25-30%, you see only LAD occlusion, and ejection fraction is usually reduced to 30. So anatomical classification of ventricular septal rupture will be either simple or a complex one. Simple is just a transmural infarct, which is through and through, located usually in the anterior portion of the septum and with a clear margin. And the complex one has a serpiginous route which tracks into the septum Most of the time, we find it difficult to find the entry and exit points on either sides of the ventricle, on either side of the septum. So we have this Becker and Dr. Mancham classification, which is originally described as Dr. Arun mentioned during the autopsy. It's an autopsy classification for the free wall rupture, but it can be used or correlated for VSR also. When you look at the type 1 rupture, there is an abrupt tear with a thinning of without thinning, and which occurs usually in the first 24 hours, and it is associated with acute infarcts and the full thickness rupture. And the type 2 is the erosion of myocardium at the site of infarction. Usually it is like a few days later and covered with a thrombus and subacute infarcts. Type 3 is a rupture from the previous aneurysm. It's a late one, and it's a chronic infarct which is located between normal and the infarct myocardium. Usually patients are stable in this subsect. When you look at the distribution in the septum, anatomical distribution, you like we all usually see in the anterior part or the anterior apical part. Very rarely we see a posterior basal septal rupture. So the anterior apical septal rupture is about 60 to 80% of the cases which due to LAD occlusion, and the posterior rupture is usually due to the RCA infarct, right? RV infarct, and sometimes we see multiple defects in 5 to 10% of the patients where you have multiple sieve like ventricular septal defects where you cannot identify the exact point of entry and exit. So the surgical margins or the healthy margins will be difficult to identify, and it becomes surgically difficult to address this scenario. This pathology in ventricular septal rupture is quick, but there is hyaline degeneration and leading on to fragmentation of the myocytes, and with enzymatic digestion of the myocytes, which leads to fragmentation and septal rupture finally. The pathophysiology, you have a sudden rupture with shunting of left to right and with the right ventricle overloading, and you have sometimes when you have on right ventricular infarct, it complicates the scenario. So these things, the heart failure, size of infarction, the magnitude or shunting, the quantity of shunting, and the QPQ's ratio, and anterior septal ruptures with LV dysfunction, posterior septal with RV dysfunction complicates the decision making. So these are the risk factors which will affect the timing of surgery, and we need to consider and take a decision based on all these risk factors. As we all know, pre-op stabilization is very, very important in patients with VSR, and we start with SPR, addressing SPR to reduce SVR and then reduce left to right shunting, thereby reduce the QPQS ratio using either pressors or vasodilators or mechanical circulatory support like IBP or ECMO. And role of IABP is we need to consider in all patients, either elective or when you are forced to do it when you're not able to maintain with the vasopressors, and it definitely helps in reducing the afterload with reduction of the QPQS ratio, and we'll have time to make a decision to take the patient with a good outcome and reduced perioperative mortality. And management strategy, you have a patient with VSR and the patient is unstable, straight away go for surgery, or think about a bridge to surgery. When you talk about bridge to surgery, you can do when you have a center, when you are in a center with device closure abilities and manpower, then you can go ahead with a percutaneous device closure, or think about a hybrid procedure where you do mini thoracotomy or use VATS technique to get the device into the ventricle, percutaneous or transventricular deployment of the device, or think about an IABP or Impella or an ECMO as a bridge to decision making. And the patient is stable, please hold on, don't go ahead with surgery. When you don't have significant risk factors, the patient is stable, please hold on, you have time to operate. When the patient has significant risk factors like a large VSD or posterior location or with the right ventricular dysfunction, then you'll have to change your strategy. Think about bridging to decision making and then go for a repair at the right time. Or think about the heart transplant as a last resort. So when not to operate is the most important thing. All of us should, as a surgeon, we need to know when not to operate immediately in these patients. When you have adequate cardiac output, with no evidence of cardiogenic shock or absence of signs of failure with minimal pressures and no fluid retention or good renal output, then think about like not to say not to operate. So in any surgical technique, the goal should be exclusion or removal of the infarct septum, the myocardium, and the elimination of the shunt with minimal or no residual leak. The surgical principle, as we all know, good myocardial protection is a key to outcome. And then trans-infarction approach in most of the patients, trimming of the infarct edges around the VSR, and then close the VSR with a patch without tension, and close the ventricular defect, the LV or RV, with the buttress sutures, either with Teflon felt or Dacron patch. And safe timing of surgery will be usually in a stable patient 2 to 3 weeks from the onset of from the instance of MI. And the edges would have become firmer and thicker so that you can have secure sutures. And you can either go for a classical Daggett's direct closure with a single patch, or a David technique where you have infarct exclusion with double or triple patch techniques. So this is a classical approach where you have a single patch or a double patch. We put the patch on one side of the ventricle and then reconstruct the septum with usually a Dacron patch or sometimes bovine pericardial patch. This is a classical Daggett's procedure where you anchor the edge to one end of the healthy septum, the other edge towards the ventricular wall with a Teflon felts. For the posterior rupture, we approach like this and lift the heart as we do, like how we do for PDA anastomosis. And ventriculotomy can be right or left ventriculotomy. Usually it's left ventriculotomy, and reconstruct the wall with the Dacron patches. Additional procedures are usually CABG, and most of the time we don't grab the LAD. Sometimes mitral valve replacement, we are forced when you have papillary muscle dysfunction or caudal ruptures. And then think like consider LV aneurysm repair if it is there. We have a thinning of LV wall. So there are a lot of publications on modifications of techniques with the double patch, a single patch, double patch, triple patch, modified or extended patch techniques. This is proposed by Kenji Lino from Japanese group, published in JTCVS, where you have a 2 patch. You can either have 2 separate patches, or you can have a tongue-like folder patch, usually bovine pericardium, anchored with the healthy myocardium, and then take it to the free wall of the ventricle and anchor it with the felt. When you have a necrosed LV wall where you need to trim it and you have a defect in the LV wall, you need to reconstruct with an additional Dacron patch or a Teflon felt or patch over that, and then anchor it like that. A patch, like another technique called sandwich technique, where which is proposed by Isada from again Japanese group. But this is a right ventricular approach where you do a right ventriculotomy and insert a patch or place a patch to the left ventricular side, anchored with a suture across the septum, and then use the same suture to anchor the right ventricular side patch also. So you have a 2 patch, and some people inject glue between the patches into the defect, and then suture it, anchor it on either sides, and then anchor it to the left ventricular wall and then right ventricular wall, and top of it buttress with a Teflon felt. Then you have a David Passini's triple patch technique, where this is a left ventriculotomy approach, where he combined both Daggett's and David's procedure, used advantage of both the procedures. So he used both a single patch to close it, and then additionally he used 2 patches to close, and then additionally he had a middle layer of Dacron to give internal support, and then reinforce with a glue, bio-glue. So this is a technique, and it's LV approach. First repair the RV side, anchor a patch, and then come to the LV side and place a Dacron patch in between the 2 layers, and then finally anchor it with the wall. This is another technique, it's called modified double patch technique by Emma Shaki. And again, like LV approach, you do LV ventriculotomy, left ventriculotomy, you have 2 patches. The first one goes into the right ventricle, anchor it with sutures, and then bring it again, second patch, like both are Dacron patches, and bring it and anchor it. These are small minor modifications where how you place and what kind of patch you use, but they've published as their innovations in these patients. So another technique where you have a bovine pericardial patch from the LV side, you do left ventriculotomy, place a patch on the LV side, and then have another patch which is folded and then anchored to the left ventricular healthy wall. When you have a weak or thinned out left ventricular wall in apical or mid septum, this technique can be used. So you have a space between the patch and the thinned out left ventricular wall where the bioglue or fibrin glue can be injected and filled, and which will give additional support. And this is called extended sandwich technique by Tuvira Asai, where he is for the posterior basal ruptures, where like he opens the ventricle and then again like same anchor with two patches and bring it out. Small minor modifications compared to the previous one, but they call it as extended sandwich. Is pictures of extended sandwich where the ventriculotomy and place the right ventricular patch and then anchor it through the ventricle with the felts, Teflon felts, and then you have another patch, a Dacron patch. The first one can be bovine pericardium, second one can be a Dacron patch, and then anchor it with the free wall, and finally you buttress it and close it outside. And we have another technique we used to do at Ramstra Hospital. I learned it from Dr. Perisamy, where we used to stitch two patches together like a dumbbell, like a ASD device, one larger patch and a smaller patch. The one patch can be, we do left ventriculotomy, and the larger one can be pushed into the right ventricle and need not be anchored all the time. And the left ventricular patch will be anchored like with the multiple interrupted Prolin sutures, and then we buttress with the left ventricular felt outside. So I don't have a picture of that technique. And device closures are being done nowadays with aggression and hybrid approach with a mini thoracotomy or VATS assisted per ventricular deployment of the devices should be considered in very sick patients, in an unstable patient. And we surgeons should take the lead and get the cardiologist involved, and we can do it with good outcomes. So when you talk about outcomes, you have a patient with shock and the mortality is very high, and a patient without shock or good stable hemodynamics, the mortality is only 48, and then you have a good outcome in those patients. So this caution study looked at the mechanical complications of acute MI. It's a retrospective multicentric trial from 2001 to 19. And they said cardiogenic shock was found in 44%, and then salvage surgery was done in 44% of the patients. Early mortality rate was very high, 40, and did not improve over 20 years, it remained the same. And we see recurrent VSR patients in 12% of the patients in this study. So finally, when you have a patient with acute MI patient with VSR, the mortality is very high, 94%. Immediate surgery, when you have within 24 hours, again, the mortality is 60%. And you could do a percutaneous closure with the device in these patients. Mortality is slightly, again, high with this publication. And the surgery on a third or fourth day or a week later, you have slightly reduced mortality, which is 47. And then surgery deferred, again, like you have still again around 50%. And percutaneous closure after a week or 10 days, the mortality is slightly low. If they survive for a week and then stabilize, you do surgery after 3 weeks, then the outcome is good comparatively. It's 30%. And you can go for a device closure also at that time. And if they survive for more than 3 weeks, elective surgery, and you can achieve a very good outcome with mortality of only 10%. To summarize, management strategy is still evolving, and you might have another paper in today, tomorrow from different groups across the world. So this post-infarction VSR, which has a very high mortality, in spite of all these advances, should be dealt with careful, meticulous planning and timing of surgery. And transcatheter device closure should be considered because it's an expanding technology with a good promising one. And we need to think about hybrid ones in these patients. Though these patients carry a very high risk mortality, surgery is still the gold standard. So we should look at operating on the patients and achieve a good outcome. Thank you so much for the opportunity.
Excellent presentation, Shiva. Especially you completed, you covered the different techniques very nicely with a lot of very good illustrations. Any questions for, yeah, Julius?
No, I don't have a personal experience with LVAD, but not dealt with the LVADs being done for this VSR patients. Yeah. Yeah.
He said
So you
that
don't- you don't-
criteria, close the VSR and put a impeller.
No. They had
On
mentioned in a
LVAD.
publication, they had mentioned they use LVADs without to bridge.
Okay, without anything. You can't use it because shunting is there. The transcatheter thing, once scar formed properly, that's later. That's why he said that's later. Acute is anyway, no question about that.
But when the patient is unstable, humanly unstable, when you want to intervene,
That what they use, sometimes they'll do, they'll occlude with the balloon. They won't put device. That acute management, want to manage cardiogenic shock. If high risk for the surgery, we can occlude with the percutaneous balloon instead of device. We can manage little bit, then we can proceed.
now I've seen a report with percutaneous mini thoracotomy, transventricular device deployment, anchored with sutures on the ventricle from outside.
Okay, thank you. Thank you.
Thank you.
Thank you so much, sir. That was a very informative session. I hope everybody enjoyed the lunch as much as they did the session. Okay, so just a note, the forgotten right ventricle, as ironical as it sounds, will need to be recalled just a little while later, because due to our a little bit lag in time, we are running a little late, and the time difference in UK, we already have Dr. Nicholas Barrett online with us to discuss about the VA ECMO as the initial therapy in cardiogenic shock in ICU. So I would just request everybody to go through his session first. And I would like to call on Dr. Sundar sir right now to just give a small introduction for Dr. Nick Barrett. Thank you, sir.
Yes, thank you, Polami. As Dr. Polami said, we have been running a little late, and just to keep in time with the time across in the UK, we are just getting Professor Nick Barrett's lecture via Zoom now. After that, we'll go back to the usual session it was, which is on the forgotten ventricle. So Dr. Nick Barrett, he is the Director of Critical Care Services in St. Thomas's Hospital, London. And he did help our team with ECMO during the second COVID wave. And we are all delighted. He was here 2 weeks ago, and he graciously accepted our invitation. He couldn't come in person, and so he's agreed to do it online. So thank you, Dr. Barrett. And we look forward to hearing your presentation.
Lovely. Thank you very much, Sundar, and thank you so much for inviting me, and my sincere apologies for not being able to join you in person, but it's in a good cause, as I'm taking my wife and children on holidays first thing tomorrow morning in London. Let me just try and share the screen. And hopefully you can see that. Is that projecting? Oh yes, it looks like it is. Okay. Hopefully you can see and hear me. I shall try to keep time, and my sincere apologies for upsetting the right ventricle, because I do agree that it's quite an important, rather important part. I have no particular conflicts of interests. I'm currently chair of Euro also, and I am representing both King's College London and Guy's and St Thomas's. So what are we really talking about here? Well, we're talking about severe acute cardiogenic shock. So we're looking at effectively thinking about the SKY criteria D and E, so deteriorating and in extremis, with significant hypotension and signs of end organ failure, along with the hemodynamic criteria that we know so well. And I think this is quite important to be thinking about the end organ failure and getting in there relatively early. And if we think a lot about the sorts of patients that we really need to be offering VA ECMO to, they are patients with organ impairment and not necessarily frank organ failure. We want patients with oliguria, not anuric renal failure, small rises in transaminases, not transaminases in the thousands. We know that this is a little old, this data, but we know that by and large, acute heart failure and cardiogenic shock is particularly prominent in the 60s and 70s. But we do see significant numbers of patients in cardiogenic shock below the age of 60. And we know that for heart failure, acute heart failure, the majority of presentations are not cardiogenic shock. Cardiogenic shock is the small group in the paler color there. And so the cardiogenic shock population only form a relatively small number of the patients that we see in critical care. However, they have a disproportionately high mortality, and this mortality has been stubbornly resistant to improving over the last 15 to 20 years. So what can we say that helps? Well, really, not a lot. I think for ischemic cardiogenic shock, the primary thing to do is to get early revascularization. That absolutely assists in outcomes. And if we look at the rise of PAMI centers dealing with acute percutaneous interventions, that's really driven, particularly in the UK, the development of specialized centers able to urgently unblock arteries 24/7. Unfortunately, in terms of looking for areas of benefit beyond that, we're a bit limited. And so we have a lot of things that don't. The first thing is inotropes. So anything here to the left of the line of one is helpful, and anything else to the right is harmful. So we have drugs such as levosimendan, plus or minus vasopressors, that probably don't provide substantial benefit for patients with acute cardiogenic shock, but don't appear to be particularly harmful. However, the remainder of inotropic support tends to increase mortality. Now, we are slightly in a bind because we don't have medications that can definitively improve outcome. And we know that the patient who has persisting hypotension and inadequate organ perfusion will also die. So it's a very difficult position that we're in. Balloon pumps have been well studied in the acute myocardial infarct population in particular, and with disappointing results, both out to 30 days and out to 180 days, with no particular improvement in mortality. Devices such as Impeller, similarly, when used alone, although people are increasingly using them for peri-procedural work, where I think they certainly do some of their best work, there is limited data to support the Impeller as a sole therapy in this population. So what can we do? Well, Firstly, we need to think about a cardiogenic shock system. So we need to think about the early diagnosis and recognition of cardiogenic shock. We need to think about it in the ED, in our wards, in our coronary care units, and in our intensive cares. We need a fairly structured approach. Certainly in the UK, we struggle across the whole of the NHS to deliver echo 24/7, but clearly echoes, ECGs, basic bloods are crucial, and then an ongoing assessment. We need to think about the early assessment, the early resuscitation, starting our medications as early as possible, continuing with advanced monitoring, and revascularizing as early as possible. For those patients with a refractory shock, who particularly are going into organ impairment or are going down in the SKY criteria from B to C to D, we need to think early about a clear multidisciplinary approach using a shock team. And then we need to think about the devices. The different devices provide different levels of support. And here's one suggestion, starting with potentially balloons and then impellers, with VA ECMO being able to provide a higher level of support. Who do we need to think about? So if we look at this, so in the black, we see the ECMO usage over the last really 20 years. And in the blue, we see the mortality. So we can see that over time, usage has steadily increased and global mortality has progressively fallen. Although we seem stuck still at around the 50% mortality mark for patients with cardiogenic shock. We can think about the sorts of patients. So here we have some data looking at the Intermax 1 category, and you can see in the blue and the brown lines at the top, you've got a very similar outcome between the Intermax groupings, where you've got those with ECMO and those without ECMO, unfortunately, still have a relatively similar outcome. Although the Intermax 1 does, with ECMO, the outcomes do improve to that with Intermax 3 to 4, which I think is an excellent outcome, although not statistically significant in this particular study. So who do we think about? Well, we've got patients with particularly ischemic problems and non-ischemic cardiogenic shock. We've got patients who would be more, thinking more around the lines of potentially bridging to transplant, so exacerbations of chronic heart failure. You've certainly got drugs, arrhythmias, both good groups because both groups tend to get better. And then clearly post-cardiotomy, although I shan't be talking about post-cardiotomies, I think there's another talk about that. The contraindications, we need to think about patients who can't recover. And that's either can't recover because of their underlying disease or can't recover because of the cardiac dysfunction. And particularly if they cannot access LVADs or transplant. We do need to think about those who can't be anticoagulated or severe aortic regurgitation because of the impact upon the left ventricle and distending the left ventricle, as well as clearly aortic dissections and multiple organ failure. If we think about the groups that do relatively well, then we've got groups such as those with myocarditis, whether that's an autoimmune or a septic myocarditis. PEs, provided they haven't arrested, do very well. Cardiomyopathies, particularly acute cardiomyopathies, can do extremely well. And that group with the non-ischemic myocarditis, cardiomyopathies leading to cardiogenic shock are the patients who do the best with VA ECMO. After that comes the patients with ischemic heart disease, and acute myocardial infarction. Then after that are those with post-cardiotomy, particularly those if they don't have transplant or VAD as a way out. Septic shock, this came out last year and showed a clear benefit for patients who were offered ECMO in the setting of septic shock. We commonly use both VA ECMO as well as hybrid forms of ECMO because many of our patients in septic shock have primary respiratory failure with secondary cardiac failure. But septic shock is one of the clearer indications now for VA ECMO. And this was quite a nice study from the French group that came out last year. I'm just going to share a quick case with you. So this was a young lady who had an acute illness. She had very non-specific symptoms and a rapid progression, and she was very difficult to ventilate. She had significant respiratory failure, as you can see there, so PO2 of 5 kilopascals, which is what, about 40 millimeters of mercury, and a 4-quadrant infiltrate in the lungs. She also had a significant mixed acidosis, a high noradrenaline requirement, and very poor cardiac function. This was her CT of her chest, so really very little in the way of aeration, and this was her echo. So very, very poor left ventricular function for a young lady. So we used for her, we used a hybrid form of ECMO. So you can see the access cannula there going through the left femoral. And then we had a femoral venous return, which you can see just coming up to the top of the screen. And then we also had a femoral arterial return. You can see that lower down there in the right femoral artery going up into with its tip, probably in the common iliac. So we commonly use this form of VA support for patients who have dominant respiratory problems on the basis that the heart failure tends to resolve over 3 to 5 days, whereas the respiratory component tends to resolve over 10 days to 2 weeks. We could easily start with just going straight onto VA and then add in the respiratory, the venous return when we start to see Harlequin syndrome. However, we've found over time, it's simpler just to start both at the beginning and have a small amount of blood running through the oxygenated blood running through the venous side, and then steadily increase that as we get heart recovery. Otherwise, we found we tend to end up recannulating at 3 in the morning, which is never an ideal time to do such things. So what happened with her? So initially she had a small pulse pressure. We had a predominantly arterial flow, small amount of venous flow. The fact that she had no native respiratory function was very helpful because we were able to manage that, give her oxygenated blood coming out of her heart using the venous return. We were able to actually come off the noradrenaline very quickly, and we aimed for a low mean arterial pressure in a young lady. She had Haemophilus in her blood. We gave her antimicrobials, and all the shock resolved. And this was a couple of days later as she was starting to come off VA ECMO, and then that was at day 10, by which time she was starting to come off the VV component as well. So septic cardiomyopathy definitely does extraordinarily well. So do all the other non-ischemic cardiomyopathies, provided you can treat them. So adult Still's disease and some of the other autoimmune problems that respond very well to steroid therapy do extremely well. With ischemics, slightly less. When should we commence ECMO? I think this is a really, really important question. what we can see here is we've got a number of markers. So we've got lactate. Patients with a higher lactate do worse than patients with a lower lactate. We've got pH. So those with a higher pH do better than a lower pH. And we've got creatinine. So those with a higher creatinine do worse than with a lower creatinine. Functionally, all of these markers are a combination of both severity and time. Time is quite important. And if we look at the SAVE score, which was developed by colleagues in Paris a few years ago using data from the ELSO registry, we can see here that we've got, this is designed to try to help to predict outcome for patients. So the higher the score, the better in this case. So we've got diagnostic groups with myocarditis doing better than other diseases. We've got age is an important indicator. As you get older, the outcome is progressively worse. We've got underweight or overweight individuals doing worse than normal weighted individuals. ECMO organ failures as opposed to organ impairments are really important. And then up on the top right of the screen, duration of intubation. So that amount of time spent in the intensive care. And it's not necessarily just about the amount of time you're ventilating the patient, it's how long you're managing the patient's cardiogenic shock for. And the longer you have prior to the initiation of ECMO, the worse the outcome. Then clearly, if you've arrested or if you don't have a pulse pressure before ECMO, then things get substantially worse. That gives you a mortality reading here. So if you have a patient who's young with a potentially reversible cause that you have onto ECMO within the first 6 to 10 hours of their intensive care stay in organ impairment but not failure, you can expect 60, 70, 80, 90% survival in that group. If, on the other hand, you have patients who have, you've waited a day, 2 days, 3 days, they're in frank organ failure with deranged liver, renal function, significant acidosis, very high lactates, then you can expect a 10, 20, 30% survival. So it really is about time to getting onto ECMO. So that leads to this sort of concept that we want to be really looking at a population where the blood pressure is falling, there's end organ injury and you're getting organ dysfunction, but not at the point where you've got progressive acidosis and irreversible organ failure. And it's that time, which is probably in the first 0 to 12 hours of their stay after they've presented, that ECMO is going to be of greatest benefit. This was looked at in greater detail in a study that's only just come out in circulation by the Czech group. And they looked at the current management of cardiogenic shock with where you've got staged approach, oxygen and ventilation with inotropes and vasopressors, and then later mechanical cardiac support. And it compared going onto ECMO very early within the first few hours, or sticking with inotropes and vasopressors and ventilation and general supportive therapy for the first few hours. Both groups could get access to ECMO later as well. And these were the indications that they used. So they were effectively SCI-D patients. They had about 60 patients in each group who got randomized. And they found that actually the outcomes were generally the same. So if you went on to ECMO within a few hours, you could afford to delay. You couldn't afford to delay a long time, but you could certainly afford to delay a little bit, but still 50, 60% mortality. So immediate access to ECMO wasn't that important. However, even in the delayed group, was still looking at about a 6 to 12 hour window prior to the commencement of ECMO. So you can afford to delay a little. You can't afford to delay too long, but you can, and you can provide ECMO sort of within that first 12 hours without being too concerned. So initial therapy, resuscitation, and then think about ECMO. We tend to provide ECMO via the femoral vessels. It's certainly much more convenient within the intensive care to provide it percutaneously rather than via sternotomy. However, none of us are surgeons, so we provide intensivist delivered cannulation with percutaneous approaches. We do always provide a backflow cannula, and I think that's quite important. The other thing that's really important that we need just to briefly touch upon, because I'm sure it's covered elsewhere, is unloading. And there's some growing data around unloading with ECMO. And so this is ECMO added to the balloon pump with a clear improvement in survival. This is impeller added to VA ECMO. And of course, the theory is that ECMO supports the body extremely well by providing high volumes of oxygenated blood into the arterial tree, but it impacts the ability of the heart because it increases the afterload on the heart, and it increases the likelihood of left ventricular wall distension, LV cavity distension, and increased LVEDP, all of which deteriorate the function of the heart. This was a nice little review just looking at outcomes of ECMO plus impeller, showing that really you want to actively consider unloading in all VA ECMO cases. And this again showed that you could certainly improve your mortality with mechanical unloading without a particularly large increase in complications, although there was a little bit more bleeding, and particularly with the impeller, a little bit more hemolysis than was otherwise the case. So in conclusion, really, we're looking at, the only other thing, sorry, is we do need to think about destination therapy and providing VA ECMO without access to a VAD and transplant program is difficult. So you do need to think about a way out. As soon as you're on to ECMO, what's the strategy for the way out? Is this a condition that will reverse and improve, or is this a condition that we need to end up in VAD and transplant? So for patients that you're placing on VA ECMO, I would strongly encourage you to discuss with your local VAD and transplant center. We tend to discuss around days sort of 5 to 7, because by then you've got a clear idea of the trajectory of the patient, and you can start thinking about whether that patient will get better or will deteriorate. So in conclusion, we've got patients who will potentially benefit from VA ECMO. We need to think about applying ECMO early, but it doesn't have to be immediately on arrival. And we need to think about patients who have reversible diseases. I would very much like to welcome you to come and join us in Lisbon in late April. Thank you very much.
For your excellent presentation and also systemic analysis of patients with cardiogenic shock and their appropriate management using VA ECMO. And I like the point what you have stressed, like
managing the patient on ECMO is not the time to relax. We have to aggressively treat them and get them out of the ECMO as quickly as possible. So the weaning plan should start as soon as we initiate the ECMO. That's a very valid point. Also, I'd like to ask you, like, is there any data on Impella with isolated VA ECMO?
So there isn't good data in terms of comparison data, no. What people are really doing, and we're doing a study on it at the moment, is looking at the ways that we can offload. I think that ECMO gives such excellent support for the body, and particularly for kidneys, liver, gut, that it's difficult to see that being improved upon. But the negative impact upon the heart is substantial. So I think the way that many centers now are going is VA ECMO combined with a form of unloading in order to try to improve the outcomes that way.
Thank you very much. Audience, any questions? Yeah, please. Mic to him, please. Dr. Nick, there is a question from the audience.
Yeah, I had one question about your configuration of VA-V ECMO. I noticed you had one drainage cannula in the femoral vein and another outflow cannula from the femoral vein into the right atrium. Do you ever experience recirculation because of that configuration?
So we do. Whenever you access and return blood on the venous side, whether it's VV ECMO or hybrid ECMO, you absolutely get recirculation. However, it's very relatively rare for us to have it as problematic recirculation. So it's usually in the order of about 15% or so of total flow. It usually doesn't impact our ability to provide systemic oxygenation for the patient. What's more important is matching the venous flow with the cardiac output. So if we have a low cardiac output state, actually providing a liter of oxygenated blood into the right atrium can provide adequate oxygen for blood that's ejecting from the heart. As the cardiac output improves, clearly you need to increase that total net flow in order to match the cardiac output. But in essence, yes, we see recirculation, but it's not usually a big problem. It's occasionally a big problem when we need to manipulate the cannula tips.
Is there any distance that you would keep between the two cannulas for, say, the outflow cannula closer to the tricuspid valve and the inflow cannula lower down below the right atrium?
It's interesting actually, because we've sort of put cannulae all over the place. So generally we start with having the access cannula around the level of the confluence of the hepatic veins. However, with many patients, particularly patients if they've got abdominal pathology or abdominal distension, it can be very difficult to access blood from the IVC within the abdomen. The other thing is that IVC blood is not as desaturated as SVC blood. So, and this is going to sound very counterintuitive, we will often place the access cannula up into the right atrium and sometimes even up into the SVC in order to access that more deoxygenated blood, then having the return still within the right atrium. And even then, the benefit that you get from accessing good flows, good volumes of deoxygenated blood exceeds the problems that you have with recirculation. It is very interesting. Important thing is to look at your flow and see where your oxygen delivery is optimal, because you will find that just pushing the flows up and up and up and up doesn't necessarily enhance your ability to provide systemic oxygenation using that approach. But we've had cannulae all over the place.
You also mentioned a finite way of measuring recirculation. You said 1 liter. How do you measure that? Do you put a flow sensor on the line?
So you certainly can provide. There's an ultrasound technique where you can measure get a measurement for recirculation directly.
Thank you.
Any other questions? There is no questions. Thanks a lot, Nick, for your time and knowledge. Much appreciated.
My pleasure. Enjoy your Congress.
Thank you.
All right, so now we can make the right ventricle smile again. And for that, I call on Dr. Paul Ramesh, sir, to speak about mechanical circulatory support for the right ventricle. And I would like to call on Dr. Selvi ma'am, Dr. Jyoti sir, Dr. Purna Pushkala ma'am, and Dr. Satish Javali sir to moderate the session, please. Thank you.
Everybody, I think just following Nick's talk, which is full of data and analysis as to when you're supposed to do. My focus is going to be on the right ventricle, which is very, very important as cardiac surgeons. All of us, even in the old days, when you try to come off bypass, you'd find that the RV is struggling, and then there'd be a combination of starting inotropes and giving some volume. There are a few more things that have been added on, but the essential problem is that the right ventricle is a very complex ventricle. Its adaptations are quite complex. So my focus is going to be on how does the right ventricle fail, in what situations do they fail, and with some clinical scenarios from our own practice. When I say our own, it's Dr. Sundar, Madan, and myself over the years, to try to show you where the right ventricle could go wrong and some of the ways in which mechanical support could help. I also want to say that this is a very heavily interdisciplinary teamwork. In our immediate team, we have 3 surgeons, and we also have some young talent, Dr. Sriram, who's joined us recently, as well as Dr. Purna and Dr. Selvi, who's a pulmonologist, who's there on the chair here. Okay, start it. Yeah, and while we wait for it to start, Purna is a cardiologist. So it really takes all of these people plus nephrologists who have a handle on acute care, the ID in our country especially, in order to transition these people. I think Nick mentioned a shock team. I think we have progressed beyond a shock team. We have a really robust interdisciplinary team, and it's also testament to it that some of our own colleagues refer and get our advice during this. So the right ventricle and mechanical circulatory support. The right ventricle is very, very different than the left ventricle. It's quite clear. And the reason is that the way it's shaped and the fact that it has to push the same amount of blood through a very compliant circulation that branches very quickly makes it very different in function, although it's trying to do the same kind of things, but very different in function from the left ventricle. From this particular graph, you can see that both the preload and the afterload for the right and left ventricles make the ventricle behave very differently. The left ventricle is more robust over a wider range of pressures, but the right ventricle begins to fail or works within a very narrow range of pressures. I don't want to emphasize too much on the various aspects of how you assess the right ventricle, but I will say this, both in the acute situation as well as in the chronic situation, and I come to the clinical scenarios where I differentiate the two. We have found, and we have an excellent anesthetic team. I think Balaji is here today, but Minnal, Balaji, and Karthik. So we have access to somebody who can put in a swan. We can do the measurements and the outputs. We also have a method of delivering nitric oxide to these patients, even if they're not intubated, and do a simultaneous echocardiogram, for which we have Dr. Chandrasekhar when he's here, and Dr. Purna. This is very, very useful. The reason being, you can get some amount of information from the SWAN, which you can't really get from as well from an echo, and vice versa. So putting all of this together will help you know where exactly the problem lies, and which is, even if there is a problem in the preload contractility and afterload of the right ventricle, you can pinpoint quite exactly where the problem is, or which is the most predominant problem. And this is quite important, because if you start doing too many things at the same time, you'll actually end up worsening things. One of the easiest ways is the ratio between the right atrial pressure and the left atrial pressure. Usually you're going to measure the left atrial pressure as a wedge. If these two are more or less normalizing, you want one to be closer to 5, the RAP, and the wedge to be closer to 10 or further down. If they start beginning to narrow, then you have a significant problem. I'm not going to talk too much about the pulsatility index. We can discuss it if you want to, but that's another one that's emerging as a useful tool. So you can have failures in the preload, contractility, and afterload, and I think most of you are quite familiar with that. One of the commonest things with the preload is somebody has had a right ventricular infarct, or someone's right ventricle has been failing, and usually they have been treated in an outside hospital or in an intensive care where they've given a bit of volume, they've seen some response, and they've gone on doing that again and again and again. But in fact, what it has done is it has pushed it. This is because the right ventricle works within a very narrow preload range. Beyond that, you overdistend the ventricle and it really begins to fail quite a lot. And this is one of the most important ways in which an excessive preload can fail the right ventricle. I'll give examples of this in my talk a little bit later. Contractility, quite common. We've seen RV infarcts, myocarditis, sepsis was just mentioned. And one of the reasons why VA ECMOs may have some level of an impact, I was privy only to that French study which came out last year right now, showing that even in sepsis, this is quite useful, is because sepsis can affect both ventricles, but seems to predominantly affect the right ventricle quite fast and quite early. As far as the afterload is concerned, I want to bring another concept of the VA coupling. This is quite important because as the right ventricle contracts and it generates the systolic wave, this wave goes, but on the pulmonary circulation, the pulmonary artery branches very, very quickly. And so these waves hit multiple junctions or kind of crossroads, or I would say junctions where they branch out. And so the wave coming back is a complex cumulative wave that comes back towards the right ventricle. So you can imagine that the right ventricle's contraction generating the maximum pressure should be fairly accurate to kind of understand this impedance wave that's coming back. Any kind of disconnection and the RV will begin to struggle. And this is also a very important thing. And one of the reasons why rhythm is very important in the right ventricle is because of this. And this VA coupling is also a very important factor if you don't take into account why the right ventricle may fail. The other things which as cardiologist or cardiac surgeon, we may not be aware, but which is overemphasized in routine medical ICUs by critical care people as well as intensivists and anesthetists, but not so much by cardiologists in their own ICU, is the fact that the intrathoracic pressure plays a big role. So you have somebody, you're ventilating and they're having a bit of pulmonary edema, someone's given them PEEP, the intrathoracic pressure rises. The moment your intrathoracic pressure rises, the venous return to the right ventricle goes down. More importantly, during spontaneous breathing, what happens is in the first bit of the inspiration, the afterload against the right ventricle begins to go up. And that is the time at which the right ventricle has got to do its best work. The infundibulum is usually the last bit of the ventricle that is beginning to see this high pressure coming at it. And if at that point in time it begins to fail, there's going to be a problem. Towards the end of inspiration, is most of this blood in the capillaries are running off into the LA, and so the afterload begins to fall. This is even during spontaneous breathing. But on a ventilator, this is exaggerated. And another important thing is bronchodilators. An independent study has shown that irrespective of whether the presence or absence of V's, bronchodilators have helped improve RV function in this subgroup of patients in whom there is RV dysfunction. I think most of the cardiac surgeons are aware of pericardial limitations. We've worked with constrictive pericarditis, but this is an issue even in patients who have not been operated on. There's some Dressler syndrome. The RV doesn't kind of get out quite easily. And the reason I said all of these things is if you're going to talk about shock teams, you're going to talk about heart teams, you're going to talk about interdisciplinary care. This is very, very important that this is not a linear algorithm. No right ventricle comes in and says, okay, now I'll have a little bit of ventilation. Now my RV is going to fail, start some inotropes. Now it's time for mechanical circle. It doesn't work like that. Everything may have to happen simultaneously. As you can see, I deliberately put a mishmash of lines. Surgeons have to be involved very early on. They may be required later. You may require intensivists. And as I said, nephrologists with a handle on acute kind of failure, because we have to use the CRRT a lot in some of these patients just to get the volume down. You cannot wait for conventional nephrology endpoints like pH, lactate, potassium and things like that to go up. So everyone's got to kind of be involved as soon as a patient comes in with cardiogenic shock RV. You may not require a surgical intervention. You may not require a mechanical circulatory support, but it's important for the team to be aware, especially anesthetists and cardiac surgeons who kind of do ECMOs and VADs. I'm going to give you a series of examples. So I won't take up too much of your time. It's very nice to talk about all of that physiology. What does that really mean? So these are all our own patients. And this is a patient who had right ventricular failure from LV failure. Here you can see this patient had severe aortic regurgitation by the wide pulse pressure, not treated for a long time, heavily volume overloaded. And so his CVP has gone up because the RV is also beginning to fail. Here, the important assessment should be, is the LV going to take a good aortic valve replacement? There have been a variety of things that are being talked about, cardiac MR, fibrosis index, so on and so forth. This patient had a straightforward AVR and the right ventricle improved straight away. And the next one is a patient who had a right ventricular infarct. He came in cardiogenic shock. You can kind of see that the RV is struggling a bit. And because of that, the RV is not pushing enough blood to the left side and the LV is quite empty. So here, because of rising lactates, you looked at the criteria that Nick was showing about lactate of 2 and a pH of 7.2 or 7.1. So this patient presented with a pH of 6.9 with lactates 20. What I have seen mostly in ICUs is the intensivists tend to keep cranking up the adrenaline or noradrenaline, especially the noradrenaline, to significantly high levels. And this is really counterproductive because what you're really doing is already there's an empty preload on the LV. You increase the afterload, you increase the lactates, and this is actually setting up the failure even more than you would. And by the time you've lost the liver and the kidney and it's too late to do anything, and then you put them on ECMO and then they die and everybody says ECMO is useless. So I think the point taking from what Nick said is not just early, but before multi-organ failure sets in. And this is important. So this patient was kind of referred in time. He had a peripheral VA ECMO, was taken to the angiogram room because this is important. The next step of the decision making can be done under stable conditions. You want to do a PCI, you want to do EP work, anything, you're just really comfortable on the ECMO because all the acid base settle, your kidney, liver is fine. The patient can be ventilated at a lower level and get the pulmonary edema down. So it's definitely safer than just taking him to cath lab. And here you see this patient has a balloon. We talked about ischemia and offloading the LV. The balloons are particularly useful, not just for offloading the LV, but in these kind of ischemic situations because they do improve coronary flow and they help quite a lot. So this patient had a VA ECMO. You can see the venous cannula there. He's also had to be paced. So you get the rhythm right. You've got the venous draining the RA. So then there's the preload has gone off the RV. You've done a balloon to improve the ischemia and improve the coronary flow, as well as offload the LV. And this angio showed triple vessel disease. So this patient went on to have a CABG. And you can see once you've done the CABG, there's not much pulmonary edema. The gases are fine. You can downgrade to an RVAD. Now, there's a lot of talk about Impella, RP, and Duotech. I'll come to that in a minute. But if you have an ECMO machine, the rotor flow is more than sufficient. We've used it. It's an off-label use of it as an RVAD, but we've used it quite a few times, and it's quite good. You can also use the CentriMag if you have that as well. But in India, because of costs, and you have only one machine, the RVAD with the rotor flow is more than enough. We've used it up to 7 or 8 days. I think Madan might correct me if I'm wrong. And it's worked quite well. So here we've brought it out subcostally after the CABG, and it's the same patient. So they're quite comfortable while the RV infarct tends to heal over the next few days and the lungs clear up and we can take them off. Now, you can get an RV failure if you inadequately offload the LV. There was a lot of talk about Impella earlier on. So this is a patient of ours who had a myocardial infarction outside hospital. He went into cardiogenic shock. I think he was taken to the cath lab and Impella was done. Here an angiogram showed coronary artery disease. But the problem, although the impeller on the left side, I think now they have 5 liters, but this was done about 4 or 5 years ago. The impeller only 2.5 was then. Although it says 2.5, it rarely gives a flow of 2.5. It's usually more like in the range of around 1.8. And so this did not offload the LV enough. The patient had increasing pulmonary edema, and this brought on a new onset RV failure, cardiac arrest. We had to do a peripheral VA ECMO, and then we bridged him to a durable VAD. I think he had a HeartMate 3. I cannot remember. I think it was a HeartMate 3. So sometimes you can excessively do it. So you put in an LVAD, and this is what happens. So this patient has got an LVAD. Here you can see if you suck too much on the left, on the VAD, the interventricular septum begins to move that side. So two things are happening here. It makes it more global. More fluid comes onto that RV, as well as the contractile force of that interventricular septum goes, and the RV begins to struggle. Now, this can happen because of 2 reasons, not necessarily just because you're pulling on this, but because prior to this patient, he's an ischemic cardiomyopathy patient. So his right ventricle is used to just a flow of about 1.8 liters at most. Now, suddenly with the VAD, you start giving around 3-4 liters, that right ventricle begins to actually show what it can truly do. And that's when you get stuck in these patients. So this is the same patient. So in this situation, what we did is we supported the RVAD, one subcostally and other to the second intercostal space, because it's just a little bit easier. Sometimes you don't have to take out open the sternotomy again. So these again, they take some time, but they get better. So same patient. I just want to show you here that even though you may put in a VAD, and even though you might have assessed the right ventricle very, very well, you may end up that the right ventricle is struggling in the immediate postoperative period. And here you can see that those pressures have not really come down. The CVP is not, it's got better, but it's not really come down. It makes much better sense when you look at it as on the flow monitor. Anything more than 3 liters, that RV began to fail. However, within about 3 days, the RV adapts. You can get flows up to 5.4, CVPs down from level 12 to 5, and those PA pressures are nicely down. So it does get better. And this, again, you've got to assess the RV contractility and make sure that it can pick up the slack. If you've got a fibrotic RV that's just hanging loose, it's also involved in the myocarditis, it's also involved in the cardiomyopathy, you may have a dreadful failure of the RV, and you may not be able to get these patients out. And last but not the least, and COVID has been a real master about this, is and our own practice, which is quite heavy on lung transplantation, is this kind of patient is a very common cause of RV failure. So this is a patient with COVID lungs. You can see here as the patient is desaturating, you can see where the ECG is going into VTAC at the same time. And this kind of RV failure is also quite important. It may be tempting initially to just put on VV ECMO, and we do try that, but sometimes that may not be enough. Some other causes, pneumothorax, megacolon, sometimes in the same patient, Bull's disease, which exacerbations. These patients may have exacerbations of the original disease while waiting on the list. They may have a new onset pneumonia. They may have RV, they may have a pulmonary embolism, all of which again focuses on the RV beginning to fail. The RV beginning to fail is usually a sign of poor prognosis, because it means that very little can be done unless you're going to be transplanting this patient soon. So this is the, just to give you a view, this patient has a carbon dioxide 249, which is about the highest I've seen. This is in spite of a well-compensated 54. All of this, the hypoxia, hypercarbia causes worsening pulmonary hypertension, RV ischemia, and all of this can lead to quite precipitous failure of the right ventricle. Someone asked questions about the VAV. So you go in a peripheral VA ECMO, either an eCPR or even as a part of cardiogenic shock, then suddenly you find the lungs fill up, or the lung has developed a pneumonia on day 2, day 3. The heart is now ejecting a little bit better because you've offloaded it. Now it's ejecting more blood into a bad set of lungs, and you start getting cerebral ischemia and coronary ischemia, and the heart then begins to start failing, both the LV and the RV. So in these situations, you just put an additional jugular venous line in here, and you control the flow into the femoral artery as well as into this thing, as well as into the internal jugular. This is a VAV. For those of you who are kind of unfamiliar with this, anything in front of the hyphen is what is draining the blood to the pump. Anything after the hyphen is the blood going back to the patient. And the reason we do this, as we've had, we are obviously very passionate about this as a team, but you can see even as these patients are waiting for their transplants, they really have a very high quality of life. They can comply with physiotherapy, and these two things, improved quality of life, better nutrition, more physiotherapy, all have impact on outcomes in transplant patients. We'll be discussing about this tomorrow in the panel discussion. Just a quick through and I'll be finished. The therapies, there are patients who, there is availability of things like Impella RP. So this is nothing but you entirely put it through the femoral vein. It goes up through the tricuspid. One port remains in the RA, other goes via the tricuspid into the pulmonary valve, into the main PA, and you can switch it on much like you do with an Impella. The only thing is the possibility of clot and the possibility of distracting the tricuspid and the pulmonary veins. We have had no experience. I don't think this is available in India at the moment, at least not commercially. So tandem RVAD, kind of similar as is the Protect Duo. So these are all, the Protect Duo has got very, very big, 31 French. A lot of our Indian patients, especially women, do not have sizes of internal jugular of that size. All of them distract the two valves. So they do have potential for the future. But right now, I think a actual implantable RVAD, either a durable or a temporary, or not a durable, sorry, a temporary one, or the use of VA ECMO is probably a far easier option and a cheaper option. And I'll finish with these two kind of rare rare patients that we've seen in our practice. So this is somebody whose right ventricle is fully replaced by fat, who had a transplant. And this is somebody with Epstein's anomaly, a very hypoplastic right ventricle with cardiac cirrhosis, who had a heart liver transplant. This is somebody with very, very advanced pulmonary hypertension with pulmonary aneurysm and RA, who required a heart lung transplant. And I'm going to leave you again with this, just to say that I think it's time to develop an interdisciplinary team that comes in for every case of cardiogenic shock, whether it's from poisoning, whether it's from sepsis, whether it's from not just post-cardiotomy. We tend to focus a lot on these post-cardiotomy patients, but there's a whole world of patients out there who do require our help. And so I think some of it is really the future of cardiothoracic surgery. Thanks very much to my team. Thank you.
Thank you, Dr. Paul. I have two questions. I'm Dr. Jyoti. I'm the senior consultant, pediatric cardiac surgeon from Apollo, Delhi. See, when you put an LVAD, what percentage of patients will eventually need an RVAD also? And how do you predict that an RVAD is going to be needed, which is not very clear when we investigate or when we do echoes and stuff? How do we know that? How can we predict that this RVAD also is probably needed?
That's an excellent question. I kind of briefly touched upon it. If you have biventricular failure, for example, ischemic cardiomyopathy, and you can be fooled into thinking with your echocardiogram that RV is quite all right at the moment. But yet when you put in remember the LVAD is only going to support the left side, but it's going to push far more blood into the right side and it begins to fail. So the two things that are being used is this RAP is to wedge index. So if you have a ratio that is 0.85, 0.6 to 0.8, those patients have a potential to have RV failure postoperatively. And the other thing is a pulmonary, what they call the pulsatility index. Again, that around 1.85 has a higher prediction rate. But quite simply, I think when you do your right heart cath and you have anything over 3 Woods unit that does not appear to respond to pulmonary vasodilators, we use inhaled nitric oxide, but whether using milrinone or nitric oxide or whatever pulmonary vasodilators, if there's a lot of kind of flexibility in the pulmonary vasculature, so you're able to increase the cardiac output with, say, dobutamine or something, and the pulmonary pressures seem to react to that quite well, then you're quite okay with an RVAD. I'm going to touch upon a little bit more on exactly this point in my third talk today on is it going to be a heart lung, same kind of questions. Are you going to do a heart transplant or are you going to do a heart lung transplant in these patients? And there are some numbers which are quite useful. A transpulmonary gradient of around 10 to 12, which is quite good. You're very likely going to get away with it. Something over 15 that's fixed. If you put in an LVAD, you're most likely that RV may begin to struggle. If you have ischemic heart disease, especially if it's a right dominant system with significant coronary artery disease, then if you're not grafted it, then there may be a problem. If the right ventricle is extremely thinned out on your echo, and I think there are some cardiac MR indications, which I'm not very familiar with. Dr. Purna is our transplant heart failure cardiologist. She could add to this. All of these would indicate that, yes, you have to be a bit careful with the RVAD. The number of people, to answer your first bit of the question, the number of people who require durable RVADs after an LVAD is extremely small. And I looked at the literature a few years ago, it's just a handful of patients and the outcomes are not very good. One particular group in Norway seems to have the most kind of experience with it. But yes, to answer your question, if you have to put in a durable RVAD in patients, then the prognosis is quite bad. The alternative to that is a total artificial heart, and even that doesn't really have the same kind of outcomes as an LVAD. But there are patients like that. There are some of these are smokers who have pulmonary hypertension, which is unmasked once you get more blood going through that right side.
Thank you. Any more questions from the audience?
Do you want to add to that, Purna, about right ventricle cardiac MR?
Right ventricle is, predicting RV failure post LVAD is one of the most difficult things. And I think we have to use multiple parameters, like a right heart cath, echocardiogram. So there are 3D RV ejection fractions that are similar and comparable to cardiac MR based RV volumes. So if everybody is not able to get a cardiac MRI, and if we have good 2D images by transthoracic echo, we can implement 3D RV ejection fractions. So all of these are very good, but then we do have to optimize the RV prior to surgery for LVAD something, or for a LVAD implantation surgery. And it may come at the cost of minor minor renal dysfunction, like say when we get somebody really dry and put them on inotropes and get them to the driest weight possible, their creatinine is going to be a little bit on the rise, but we take that because at least the RV will not suffer as bad post-operatively. And identifying post-operative RV failure earlier and instituting therapies like CRRT or nitric oxide or pulmonary vasodilators is very crucial. So multitude of factors preoperatively will suggest whether the patient can fly away with LVAD with some difficulties or not. And that also depends on how long they've been waiting with LV failure. If somebody is waiting with LV failure, chronic hypoperfusion and increased left ventricular filling pressures, not able to tolerate guideline-directed medical therapy, their RV has much higher chances of failing post-operatively.
I'm asking what, I deal with kids. So we've had many kids with viral myocarditis with severe LV dysfunction. And on heavy inotropic support, the PICU will start straight away on adrenaline, noradrenaline, and vasopressin. That's it. So in these patients, they are too sick to be, she was saying about doing a cardiac cath or a cardiac MR. It's not possible to shift these kids to. So that is what I'm asking. Is there any specific things in 2D echo that you can predict that this RV is going to give you trouble?
The thing with viral myocarditis, we had a couple of cases, I think 1 or 2 were pediatric, a couple of adults. So this is the problem, because the myocarditis is so diffuse, the RV is also. In those kind of acute situations where there's no background ischemia, I think you can go ahead first with the VA ECMO, not with a VAD, because most of these patients, about 5 or 6 days down the line, the ventricles will improve. If you're having a problem whereby the myocarditis has transitioned into like a cardiomyopathy and the RV is looking good, and you're thinking of a VAD, and that's a very, very rare thing. I've not come across that personally. Then I think you may have to assess. But if your ventricle is stiff, and if it's still showing inflammation, and NT-proBNP is very high, and your pressures, I would not go with an LVAD. I would try to persist with the bridge to recovery with the VA ECMO.
Thank you.
That was a very explanatory session. That was a really interesting talk. I would now like to call on Dr. Prashant Bhupate, sir, to speak on the interventions for idiopathic pulmonary hypertension. Thank you, sir.
Good evening, everybody. First of all, I would like to thank Dr. Sundar and the entire organizing team for inviting us and allowing us to present our interventions in pulmonary hypertension. So as we all know, pulmonary hypertension is rare but a debilitating disease, and thorough workup is necessary to identify the cause of pulmonary hypertension before labeling as idiopathic pulmonary hypertension. And any intervention in pulmonary hypertension, by the very virtue of the disease by itself, is associated with significant risk. And interventions in pulmonary hypertension could be therapeutic and palliative as well. So we had a 14-year-old boy who had dyspnea on exertion, easy fatigue, had an episode of syncope. Echo was showing suprasystemic PA pressures, was labeled as idiopathic pulmonary hypertension, had improvement in symptoms, and came for a second opinion. However, on workup over here with us, we saw that PA pressures were systemic with a near normal RV function, and an ultrasound abdomen, which we are doing regularly for all patients with who are pulmonary hypertension, and especially a portal venous Doppler to look at extrahepatic portal cable anomalies. And this child had that, and the diagnosis was confirmed on echocardiogram. And you can see there is a huge communicating vein there, which is communicating from the inferior mesenteric vein, and it is going into the IVC. Now, what happens is, because the systemic vascular resistance is low as compared to the hepatic vascular resistance, most of the blood is flowing from this into the systemic vascular resistance and is bypassing the hepatic circulation, which results in severe pulmonary hypertension. So his PA pressures were near systemic with the cardiac index was very, very high. It's a high cardiac output state. PVRI was nevertheless also very high. And you see this is that same vein over here, which is communicating into the IVC. We managed to close this vein with a device there. And this is a final injection. And you can see now the portal circulation is filling up very well after closure of that shunt. So 1 year post procedure, the child was doing well, was in functional class 1 to 2. We slowly weaned off pulmonary vasodilators. Echo was showing only mild pulmonary hypertension with normal RV function. We did a cardiac cath at the end of 1 year, and PA pressures were mean of 26, cardiac index was 3. So near normal PA pressures. Post this case, this was an index case. We found 11 other patients who were wrongly labeled as idiopathic pulmonary hypertension, but had this kind of abnormality. Various shunts you can see, and we publish in the Indian Heart Journal. And most of these patients have normal PA pressures now. So this is one of a very rewarding diagnosis to find in a debilitating disease like pulmonary hypertension. Then coming to palliative procedures in pulmonary hypertension is usually performed in drug refractory pulmonary hypertension. And as we know, patients with Eisenmenger with PH are much better as compared to those with congenital heart disease, as compared to those with idiopathic pulmonary arterial hypertension. And hence there is a way to create make this idiopathic pulmonary hypertension patient into an Eisenmenger patient by either creating an interatrial communication or creating an communication at the great vessel levels. So interatrial communication is an age-old technique in which an AASD would be created, and communication would be created between the left atrium and the right atrium, which would result in the decrease in the right atrial pressures, improves in the left atrial filling, left ventricular filling, and improvement in the cardiac output. However, there are certain disadvantages because it will decompress the right ventricle only in diastole. It has a chance to decrease over a period of time, the size to decrease over a period of time. And it results in desaturated blood, which is going to both the coronaries as well as the brain, as well as the, so upper part and the lower part of the body both get desaturated. Dr. Shiv Kumar and his team has excellently demonstrated the use of atrial flow regulators in pulmonary arterial hypertension, which has mitigated one of the drawbacks of an atrial septal stenting or an balloon atrial septostomy. It does not decrease over a period of time. And they have shown beautifully that there is increase in the 6-minute walk test. There is a decrease in the NT-proBNP and cardiac index in these patients. However, this atrial flow regulator is no longer commercially available in India. Then coming to the next or the more important part is creating communication at the great artery level, which we call as the reverse spot shunt, which was first described by Blank et al. In 2004 as a letter and editor to NEGM. It converts idiopathic pulmonary hypertension to a PDA with Eisenmenger physiology. It decompresses both in systole as well as diastole, and there is desaturated blood only in the lower part of the body. The coronaries and the brain get saturated blood. It improves the right ventricular function, and more importantly, there is decrease in the need of medication. So all the papers in which port shunt has been done, they have been successfully able to decrease the pulmonary vasodilators, especially the prostacyclin analogs. So this is a first detailed paper, again by the same unit, published by Diamond Bonnet et al., in which they had 19 surgical patients and 5 transcatheter ports patients. And as I said, most of the patients had improvement in functional class, and there was weaning of epiprostenol in all patients. One patient, however, required a double lung transplant 6 years after the procedure. Now, since the first publications, there have been multiple publications about port shunts in pulmonary hypertension, including our own in 2021 in Indian Heart Journal, when we had described 16 patients from our hospital who had benefited from doing port shunt. A multicentric study was again published early last year, which showed a similar benefit in patients, in children with pulmonary arterial hypertension. So what are the advantages of a port shunt over an intraradial communication? It decompresses in systole as well as diastole. Desaturated blood is only to the lower half of the body. It's unlikely to decrease in size over time, and improvement in the clinical, echocardiographic, and biochemical parameters allow decrease in need of medications. There are ways of creating a port shunt. There is a surgical port shunt and a transcatheter port shunt, and Dr. Mohanty after me is going to describe about the surgical aspects of port shunt. What I'm going to talk about is a transcatheter approach to creating a port shunt. So if you have a pro-patent PDA, it's very easy. You can just go and stent that PDA. However, the more important part is what do you do if you don't have a pro-patent PDA? So I think the details of this, Dr. Mohanty will go across our surgical port shunt data. But more importantly, what we need to see is, this is the publication in which we had shown that there is improvement. The green one is the one in patients who had undergone port shunt. So there is survival benefit in the patients of port shunt. However, the surgical risk is higher if the patient is little older and if there is a severe RV dysfunction. And that is predominantly because of the clamping of the pulmonary artery is very difficult. And sometimes there is intraparenchymal bleed. And especially in older patients, when we are not doing it off pump, it might be challenging to reach up to the pulmonary artery. So PDA stenting can be done if you have a pro-patent PDA. So here we had a child with severe pulmonary hypertension and a pro-patent PDA. We can see that PDA is shunting predominantly right to left. Echo was suggestive of severe RV dysfunction with suprasystemic RV pressure. You can see the interventricular septum going into the left ventricle. That is a angiogram in which we can see that's a very, very tiny PDA that's a stent across it. And there is a good flow across the stent once we stented the duct. This is a flow. This is the RV function. You can see the interventricular septum has gone back into the center because of the equalization of the RV and the LV pressures, and the RV function looks better as compared to the preoperative status. Then coming to transcatheter port shunt in absence of PDA. As I said, it's a high-risk procedure. Surgical port shunt is a high-risk procedure in older patients. So we did 4 patients of transcatheter port shunt in absence of a PDA, age ranging from 27 to 42 years. All of them were in functional class 3 and 4, despite maximal therapy. All of them had suprasystemic PA pressures, and they were not willing to go for a lung transplant. So we can see this is a simultaneous angiogram between this is one catheter is in the aorta, another catheter is in the pulmonary artery. And there is a simultaneous injection, which is showing that the aorta and the pulmonary artery are very close to each other. This is an RAO view, and this is a lateral view of the same patient. We take a snare across from the RV side into the pulmonary artery. And this is the Achilles sheath. And with the Achilles sheath, through the Achilles sheath, we have a Bailey's microcatheter. And through the microcatheter, we have a Bailey's wire. And then by using a surgical cautery, which we apply to the distal end of the wire, we are able to cross from the aorta into the pulmonary artery. And then this wire is snared into this snare, creating a AV loop. Once an AV loop is created, the sheath is crossed from the pulmonary artery to the aortic end, and then we place a covered stent across it. So this is the stent which is ready to be deployed, and this is the deployment of the stent. there. And this is a final angiogram, which is showing a good communication between the pulmonary artery and between the pulmonary artery and the aorta. There is no leakage, and there was equalization of the aortic and the pulmonary artery pressures. So basically, we have created a communication between the aorta and the pulmonary artery. We were successful in 3 patients. In 1 patient, after we crossed from the aorta and the pulmonary artery, we were not able to snare that wire through the pulmonary artery, and that resulted in a catastrophe in the cath lab. The other palliative procedures which can be done is pulmonary artery denervation. It is noted that PH patients have increased sympathetic activity, which is associated with poor outcomes, and radiofrequency ablation of the pulmonary artery near the bifurcation has been done in 66 patients till now, and it has been published, I think, in 2019 or 2020. And they have shown that there is improvement in the improvement in the PA pressures, improvement in the systolic as well as diastolic, and improvement in the right atrial pressures as well. So to conclude, selected patients of pulmonary hypertension and amenable to interventions in the cath lab as well as the OR. Finding the cause of pulmonary hypertension, especially something like an Abernethy malformation, is key to successfully treat pulmonary hypertension. And pod shunt, pulmonary artery denervation, and atrial flow regulator offer exciting new avenues for the palliation as a bridge to transplant in these extremely sick patients. Thank you.
Okay, I have a question for you. You see, you said you create intra-atrial communication for idiopathic primary pulmonary hypertension. See, we had a patient now, Algerian kid, 4 years old, came as a diagnosis of VSD. There's no VSD. There's a very tiny apical VSD, which is non-existent, but suprasystemic PA pressures. But the saturation is 98 to 99%. She's a fair kid. She's very, so she's very pink. So we discussed the options of creating an intra-atrial communication. And we said that there could be possibility that the child will become a little blue. So they got very rattled and they went away. So how do you justify, and how much, how much is the kind of intra-atrial communication in terms of size that you need to, and how would you do all that?
So it would all depend upon what the hemodynamic data shows. What is the right atrial pressure versus what is the pulmonary artery wedge pressure? If the right atrial pressure is more than 18 or 20, it's an absolute contraindication. We cannot create an intra-atrial communication because the child will become very blue. If it is less than that, then we titrate the size of the interatrial communication till we get the saturations to about 85 to 90. We don't go less than 85.
But for somebody who's got saturation of 98, if they come down to 85, it will be very visible in a very fair child.
Right.
And it is very difficult to justify the procedure that we're doing.
I completely agree, but it is a question of life and death.
But this child is asymptomatic, and we asked she's having any episodes of dizziness or unconscious, nothing. So in that situation, we were also stepping back.
In that situation, the first treatment would be drugs, medications.
We have started drugs anyway, but we were thinking about a little more being aggressive to create this intra-atrial communication, and it didn't look.
So only when the patient is not doing well on medications is the role of interventions.
Okay.
So only when the patient is not doing well of medications, even on medications, the patient is having right heart failure, having syncopal episodes, that's the time when we chip in with the interventions. First therapy, even if it is a suprasystemic PA pressures, is going to be medications. And right now we have, in addition to phosphodiesterase 5 inhibitors and endothelin receptor antagonists, we also have selexipag as a prostacyclin receptor agonist, which is available in the country. And we have around 50 patients who are on selexipag, who are taking selexipag and are doing well on selexipag. We also have around 8 patients who are taking subcutaneous treprostinil now, which is manufactured in the country, but unfortunately not marketed in the country. But yes, so first therapy in pulmonary hypertension is always going to be medications. And if the patient is not doing well on medications, having symptoms on medications.
What symptoms?
So if the patient is having symptoms of right heart failure or syncope, these are the two extremely important symptoms which the patient has, is only the role of interventions will come.
Thank you. Yes, sir.
Prashant, that was a very nice presentation. Do you do a CT scan for assessing the location of the pulmonary artery and the aorta and how close it is and where it is closed?
Yes.
Before you do a
Yes.
puncture?
So the distance has to be less than 2 millimeter between the aorta and the pulmonary artery, and we identify our potential site for interventions on the CT scan.
You didn't mention that.
So I need to know about the subcutaneous treprostinil, where they are manufacturing.
So it is manufactured by Dr. Reddy's in Andhra Pradesh, and also manufactured by MCure Pharma in Pune, Maharashtra.
Okay.
But it is not available for marketing in India.
Only for you people, huh?
No. The patients have to import it. So they export. So these medications are exported either to UK or to Europe,
Okay.
and the patients import it for their personal use.
Okay.
However, if the patient is very resourceful, Dr. Reddy's is also giving some of our patients free of cost.
Thank you.
It's the surgical portion is with graft. Most of our surgical portion is graft. I think Dr. Mohanty will talk about the surgical portions with the graft. In the intervention, we put a covered stent in between the aorta and the pulmonary.
Yeah, I had one question. In your selection criteria for the patients who you had chosen for a pot shunt, were there any RV parameters you considered after which you that they would become a contraindicated for a pot shunt?
Yes. So this is true for both surgical as well as transcatheter portion. So what we do if the patient is not doing well on medications, we get the patient into our ICU. We start the patients on all the pulmonary vasodilators which are available, including inhaled iloprost, because that's a little cheaper one and it is not oral. And we demonstrate that there is a decrease in the NT-proBNP, improvement in the right heart function, and improvement in the patient's overall hemodynamic conditions. Only when this is happening is we subject them for pot shunt. It decreases the risk of the procedure by itself. Also, it is an indirect way which would tell us that the procedure will be beneficial for the patient, because not all patients with pot shunt whom we have done pot shunts have benefited from the procedure. We have had certain deaths, acute deaths as well as late deaths, and most of these patients, I think Dr. Mohanty will talk in detail about what is the difference between the patients who benefited and who did not benefit from the pot shunt.
So were all your patients in end-stage disease with fulminant right ventricular failure and you had to start them on this, or were there some patients who were in, let's say, class 2 and you put them?
So most of the patients in class 3 or 4. Class 2 patients won't agree for a high-risk procedure.
When will you refer this patient for lung transplantation?
So our first approach to these patients is to counsel them and tell them about all the treatment options which are available, including the availability of subcutaneous treprostinil and also lung transplant. Counsel them about the risks and the benefits of each of the procedure, and then let the patient take the choice as to which pathway they have to go. So yes, so I mean, but if you have a death, then there is no bridge to transplant. So we have to tell them that a lung transplant option exists before we take them for a pot shunt, because even if it is it is told as a bridge to transplant, but as I said, if we lose the patient, then there is no bridge. Thank you.
Thank you so much, sir. That was very informative. I would now like to call on Dr. Smriti Ranjan Mohanty, sir, to elaborate more on the POTS shunt for idiopathic pulmonary artery hypertension. Thank you.
Yes, sir. I didn't take it. Forward, backward. Forward. So, very good afternoon.
And I really thank Dr. Sundar for this opportunity. So I dedicate this talk to one of our patients. I think she was operated in 2021, Renuka. You can see clearly the PA pressures, which is 133/74 against the systemic pressure of 126/65. So this is what you get in the operating theater. So we have been into this business from 2016 onwards, and I'm here to express that it is just like riding a bullet in a road that is at all, it's created virtually. Let me tell you as a surgeon, this is the experience. So it's not that simple as, the subsequent slide will show the outcomes. But all that I can say, those who want to get into this business have to be fully prepared for it. So for the just basic background, the normal mean pulmonary artery pressure is 14 plus minus 3.3. And if you have anything above 25, it is called PAH. So the background is PAH is a progressive disease, and 5-year survival rate after diagnosis, mind you, is 80%. And those who are in class 4, they live less than 2 years. So the mortality and morbidity is secondary to RV to PA coupling. And as compared to PH without congenital heart disease, the Eisenmenger syndromes, they have got better outcomes. So this particular paper is an old one, 2019, but it shows clearly that the outcomes after diagnosis of PH, especially in idiopathic variety, is very bad. Now, in World Symposium, which was in 2013, if you see the extreme right side, the options surgically available for dealing with severe PAH is only arterial septicectomy or lung transplant. So the concept of Potsons was not available at that point of time. And you have the hordes of, medications that will take care of the PAH. So the possible therapies after that have been that creating an intraarterial septum, as Dr. Prasant, mentioned, with the possible benefits, what he elaborated, or classical is a bilateral or single lung transplant. Now, the single lung transplant or the bilateral lung transplant is not that well developed in our country. Dr. Paul Ramesh and Dr. Sundar have been excellent results from this city itself, but few people have been able to replicate that in this country. And of course, as India and Indians, we have to take the cost into the calculation. So keeping this, and of course, if you see the IC-HLT data, the outcome after the lung transplant is not that rosy, especially in patients with PAH. So if you have a patient who is of other spectrum for lung transplant, the outcomes are much better as compared to PAH. So one has to really practically focus on either arterial septicectomy and Potson. Now the world experience of arterial septicectomy is not that great, with a quite high early mortality of close to 6.8 to 7%. But the most important thing is that you can achieve arterial septicectomy. The benefit do not last. That is where the problem is. And of course, this particular slide will tell you that the patients of Eisenmenger syndrome, instead of having a higher PA pressures, they are better off as compared to the normal IAPH because of low arterial pressure and better cardiac index. So keeping that in view, this was Ajit described in a letter to the editor from the Paris Pascal Boy and Montblanc group. They proposed a creation of shunt between the left pulmonary artery and aorta, which was actually way back used for palliation of cyanotic disease. So the flow is reversed, but they proposed this. And as you see in this particular diagram, you will have a circulation which will be desaturated beyond the left subclavian. So you have got the gut and the lower limb getting the desaturated blood. However, the coronaries and the brain, they do not get it. That is the major advantage of this procedure, the end result, if you can accomplish that. So when you kind of contemplate to do this procedure, your target should be your lower limb saturation should be 10 to 15% lower than the upper limb. So let's say you have got 95 to 100% in the upper limb, you should reach around 80 to 85% in the lower limb. by the time the patient is discharged from the hospital. That will definitely improve the RV function. There will be less pancaking of the LV, and the cardiac, most important is the CVP will drop and cardiac output will improve. So just for the non-surgeons, I'm just taking you through few pictorial slides, which I have borrowed from the Firoz Edgasi group. So you go through the left lateral thoracotomy. We enter in the fourth space, and what you have to do is try to mobilize the branches of the left pulmonary artery and the descending aorta. Then one by one, a clamp has to be placed into the pulmonary artery, which is the most difficult and most dangerous part of the operation, because you are clamping somebody with a PA pressure of 130, or in one patient, actually for our patient it was 164. So you got to clamp that, and then you got to do a arteriotomy. Arteriotomy will match that we decide preoperatively. So then you sew in a Gore-Tex. We have modified not going around the pulmonary artery, because it is many times not possible to go around. It is so huge and so tense that you'll land up injuring it. So we do partial clamping, and we loop the branch pH distal to the clamp, and we keep it for any adverse situation. And then you got to just sew in a Gore-Tex graft in a end to side fashion. And just after you finish sewing, the next step is sooner you have to release the clamp and put the clamp on the graft, because you do not, the patient, and this will give you 15 to 20 minutes to do this particular part of the operation. And then you can take a breath for some time. Then you can size the graft, and then the target is to clamp the aorta partially. That is not a big deal. So we have been doing coarctations and others. So you can clamp the aorta and do a longitudinal incision. And in that, beveling the graft end of the PTFE, you again do the final anastomosis. So that is pretty easy. You can just DR it prior to that, apply the sealants, and then this will be the exact way the patient will be looking at the end of the operation. So I'll show you a picture of that in our theater. So we use normally the descending aortic diameter, less 15% of that as the proposed, you can choose that Gore-Tex graft, and you can interpose that between the LPA and the descending aorta. And this is the PA pressures in the theater just after releasing the clamp. So, there is a standard thing that if we really we do CT scans in all of these patients. So the LPA and aorta are actually pretty close. Then people will say, why can't you try to directly, create it as it is being done by the Paris group? But the thing is not that easy to do it. The reason is to, let's say you choose a size of 12. Now to do a 12 size arteriotomy, exactly, it is not easy. And again, to replicate that on the aortic side, it is not easy. The second most important point is when you want to do a direct anastomosis, you are clamping both the LPA and descending aorta together. So that causes a serious hemodynamic compromise, which is not easy to keep it like that for almost 20 to 25 minutes. So I will always personally advise to go for a interposition graft, sequentially doing the LPA followed by the aorta. Now, these people, the Pascal Paris group, they published their first article in 2012. And after that, as Prashant has shown this slide, there have been multiple publications of series ranging from 4 cases to 24 cases all over the globe. And from 2017 onwards, in the treatment protocol for the pulmonary arterial hypertension, pot shunt is taken as a destination therapy or a substitute to lung transplant or a bridge to lung transplant. So in our hospital experience, out of the 52 patients who were counseled in the OPD and worked up, only 25 they agreed to go through any of these procedures. And the median age was 10 years, and we had a median weight of 10 kg with a body surface area of 0.9. 7 patients were in WHO class 4, class 3, and 10 were in WHO class 4. So we had 17 kids and 8 adult patients. 23 of our population were IAPH, and 2 kids, they had significant CSD operated. So one was a arterial switch operated who persisted to have pulmonary arterial hypertension, and one was a VSD closure who continued to have again pulmonary hypertension. Now, all of these kits, as Dr. Prasad mentioned, they were started off with pulmonary vasculitis, single drug, dual drug, triple drug, along with inhaled iloprost and treprostinil. So after the failure to the medical therapy, only the interventions are considered. All these patients except two, they had suprasystemic PA pressures by echocardiogram. We had cath almost half of our patients. And the two patients who did not have or who had subsystemic PA pressures, they had history of repeated syncope and they are already on maximum medical therapy. And all of them, they had moderate to severe right ventricular systolic function. We have a set of parameters for the RV. Dr. Prasad does that very pretty well. We go for all TAPC, RV, FSC, and all the parameters that fits into the criteria. Now, as I told, we also do cath for all of these patients, most of these patients, and this was the cath data or hemodynamic data prior to the surgery. Now, out of the 17 surgical ports by interposition, and I had tried one unidirectional ports which didn't make it finally. Out of this 18 and 3 PDA stenting and 4 transcatheter ports, which of late Dr. Prasad is doing himself in the cath lab, making my life easier. So this is the total experience of 25 patients. Out of that, we have lost 4 surgical in the theater or immediately after the theater. I have lost the unidirectional ports, which was done on bypass in the conventional way, but still the patient didn't make it. He had an accident in the cath lab. I tried taking that patient to the theater. I could not proceed beyond sternotomy because everything was totally in a mess. And it was just a salvage, trying to do something if possible. Now, apart from this early mortality, we have followed up all these patients judiciously in our department, and we lost 3 more patients in the follow-up period. 2 of them, they were lost because of progressive right heart failure, and though they are candidates for lung transplant, finance was a big issue. And one of them, we're not sure because he died in outside hospital. This is the same arterial switch kid who was doing very well. Even he was seen in our clinic 15-20 days before, and apparently he had a lower respiratory infection and in the hospital. We don't know the exact cause of death, but we lost this kid. So our survival after 1, 3, and 5 years of our series is 85, 76, and 76% respectively. The other gratifying part is all of these patients, after the port shunts, their medication has decreased drastically. So the people who are on prostacyclin, they are not on prostacyclin, and those who are on triple therapy, they have come down to single therapy or no therapy. So these are the graphs showing the survival function of our series, and we have published that. The change in the NT-proBNP, TAPC, as well as the RVFAC. And if you see this, those patients we have lost versus those patients we have successfully treated them. The patients whom we have lost had bad RV functions from the beginning when we retrospectively analyze, and they had got very high RA pressures as well as the cardiac index was less. So if I compare the group 1, that means the successful port shunts of 17 versus the 9 death, then you see the same thing. The functional class is little better in the group 1, 3 versus 4. The TAPC score is also less in the group 1. RV function is better. RV mean pressures are better. Cardiac index is better. So finally, what we have figured out that when you are also subjecting them to this procedure, we need to ensure that RV function is maintained. Otherwise, they are not going to do well. So this graph shows the same thing in a pictorial form. So as I told this, there is a good paper in recent 2021 by this multi-registry group. They have analyzed from multi-centers of the world, 110 patients, and shown significant advantage of survival with port shunt. And they have compared this group with lung transplant, showing an advantage with the port shunt as compared to the lung transplant. And this is a new concept. It is going on pump like a regular surgery and trying to do a unidirectional pumps. We tried doing what? The group in New York, I think Emil Vasa et al., they have reported 5 cases. But the problem over here, what I found is, it's not that easy as you see in the picture because of two things: sizing of the graft and trying to put a contiguous graft inside the Gotex. So, I mean, I may be wrong. I have not actually watched this. I corresponded to Emil Basa group. They gave some tips, but I have to see them how they do it to really, make it work. But it is not that difficult performing because you are doing it on bypass as compared to the usual portion. So finally, RV decompression can be taken care both in systole and diastole by the portion, and you don't channelize any desaturated blood to the coronaries as well as the upper part of the body. There will be always improvement in the clinical, echocardiographic and biochemical parameters. So it's probably a better option at the moment for Indian setting as compared to lung transplant. It's a feasible and it can be performed in drug refractory pH. It provides and sustains effective palliation. And if you want to send these patients for lung transplant, it is possible. It is not that they're ruled out from lung transplant. In fact, once they come into this pathway and the family benefits, there is some option of arranging finance for lung transplant and going for it. But most important is it should be done before there is a RV deterioration. So that is the catch point of this whole process. So in our unit now, the protocol is we assess these people, and once we decide about doing an intervention, we look for a small PDA. If there is a PDA, then the things are much simpler. Stent the PDA. If there are no PDA, then if they are adult patients, more than 16 years, it's much better to try it in the cath lab first. And if you don't succeed in the cath lab, maybe this set of patients doing a unidirectional pons with a valved conduit is much better. And if there's less than 16%, we're pretty confident of doing them through the regular thoracotomy with the interposition graft. Thank you for your patience.
Okay, I have a question.
No, less than 15% the descending aortic cells. 15. 85% of the descending aortic cells.
The size of the shunt.
Yeah.
Okay, I have a question. See, when you clamp the left pulmonary artery, even if you clamp partially because of the high suprasystemic pressures, have you had problems in the right lung, like increased flow or ET bleed because of parenchymal bleed and such?
First thing that the patients who have lost, they had fibrillated.
Fibrillated.
Bradycardia, low cardiac output. So, I have now started being immune to the anesthetist. You do whatever you want to do. I'll take 10 minutes, finish this. But one thing, once you release it, it's totally dramatic, situation. The storage is totally different. So 15 minutes of torture, you have to tolerate and, go for it.
So it looks like between creating an intra-atrial communication and port shunt, it looks like port shunt is a better option.
Much more high risk.
But
it will help always.
It will help. And number two, it is also it is accepted. It will be accepted by the patients because the desaturation will be only in the lower half of the body.
First, you have to accept it.
We have to accept. I'm saying the parents also will accept that the upper limbs and the lips will be okay, so they may not be finding it too
that's
difficult
a
to
very
accept.
small price to pay.
Yes,
I agree. It's important.
It is difficult to convince them.
And to be very honest, since we are following these patients very regularly, it's very gratifying. Let me tell you that. 7 years into the business and 7 years follow.
So should we decrease the pressure before applying the clamp? Yes. Should we decrease the systemic pressures also?
No. You got to maintain it.
Okay.
So you actually jack up the inotropes to maintain the systemic pressure.
Okay. You have to apply on the higher pressure only.
Yeah. No, but for the adults also, personally, I think using heparin in these patients is a big problem. So in fact, the one we do while doing the PA side, we do not give heparin. So I give 1 mg per kg heparin for doing the aortic side only. Because heparin and PH, there is some problem. They bleed. Basically, they bleed. That is the whole story. Well,
most of the urologists while doing kidney transplant surgery, they don't give any heparin.
no, but here, being a vascular thing, then, we have that thing to give
And
heparin.
in aortic
They
surgery-
bleed basically,
in aortic surgery-
these lungs, they bleed and they're washed by heparin and then nothing can be done after that.
Why can't we do it without heparin?
Well,
So
that's why I said we have reduced that to the, minimum acceptable dose. No, as he said, as Muthu said, they bleed everywhere. I mean, both the lungs. It's not only localized.
So if you do, rather than thoracotomy, if you do it centrally, midline sternotomy, then
Centrally,
you
you'll not reach only.
will not reach.
You'll not reach only unless you decompress the heart on bypass.
So you have to go on bypass in that.
Sorry.
Heart into the right pleura, so we get the DTA, and then we put an interposition graft from the pulmonary artery to the descending thoracic aorta. So we don't have the intraoperative thing, but like you said, they have other.
Thank you. Sir. Right. No, sir. The indication is always with the suprasystemic PA pressure.
Forward flow, and how much is the flow into the descending thoracic aorta?
It will be always from the PA to the aorta.
It will be from right to left. That's
Right.
correct.
Right.
But quantity wise, how much flow it is going? Have you ever calculated it?
No, we have not done any CFD.
Okay. And if you have seen what is the oxygen saturation into the pulmonary veins or the LA afterwards?
Pulmonary veins, the pulmonary veins are
100% saturation.
100%.
Now you said that it can be used as destination therapy, right?
Yeah.
So there was paper where the results are compared between the lung transplant and the port shunt. How long it was followed up and what were the results in both of them comparatively? How long it is followed up? You think that definitely it can be taken as a destination therapy compared to the lung
No,
transplant?
it is not declared as a destination therapy, though it is in the chart.
Right.
Because the problem is the outcome of lung transplant for PAH is very bad. Okay.
No, sir, it's better.
No, I'm talking about IAPH.
IAPH is better. No, sir, actually compared to other group undergoing lung transplant like ILD, COPD, idiopathic pulmonary hypertension.
I thought
good
the
results.
ILD is the best.
No, ILD is a poor outcome compared to other groups.
Any more questions? Thank you so much.
Thank you so much, sir. That was a very explanatory talk. And I would now like to call on Dr. Julius, sir, to shed some light on chronic thromboembolic pulmonary hypertension.
We still have Mountie stock there. The slides are. Good afternoon, and thank you very much for giving us the opportunity to talk about this interesting aspect of surgery. Regardless of how many times it's been said, it is customary to define your topic. So there goes a definition. So to call some patient to have CTEPH, you need to have symptoms which are like dyspnea on exertion, and on these investigations which image the lungs, you should be able to demonstrate mismatched perfusion defects and typical signs on CT or MRI with 3 months of anticoagulation, supervised anticoagulation. And this is a precapillary pulmonary hypertension, which was earlier defined as more than or equal to 25 millimeters of mercury with a mean or with a wedge pressure of 15. In the World Symposium, which happened in 2018, which was published in 2019, precapillary pulmonary hypertension was redefined to, or the threshold was brought down to 20, and 3 Wood units of PVR was added as part of the definition. Then again in 2000, it was also found that there are some patients who are symptomatic and have similar perfusion defects and did not have pulmonary hypertension at rest. So they were referred to as another disease entity called chronic thromboembolic disease, or CTED. And in CTED, in the nomenclature, it doesn't refer to the pulmonary circulation at all. So there was some confusion in that. And the nomenclature was subsequently suggested in 2021 to include both the diseases as chronic thromboembolic pulmonary disease, or CTE-PD, with or without pulmonary hypertension. So the ones with pulmonary hypertension was still continued to call CTEPH, and you could also have CTE-PD without pulmonary hypertension. Then again in 2022, the threshold for PVR was brought down to 2 Wood units. So precapillary hypertension now requires only 2 Wood units and 20 millimeters of mercury as wedge pressure. In the diagnostic workup of a person with pulmonary hypertension, you must always look for CTEPH, because that is probably one of the only curative situations where you can surgically or medically, not so much medically, but surgically certainly, cure them of the disease to a large extent. I wouldn't say 100% cure, but to a large extent. So in the workup, what is most important is to do a perfusion scan or a VQ scan as the first screening method. So if you find that there is no perfusion defects, it is extremely unlikely. You can pretty much say that there is no CTEPH. And if this is the 2022 ESC guidelines, so what they say is, if you find that there is high probability of CTEPH and VQ shows mismatch, you must refer them to a center which is a CTEPH center. So subsequently, you will have a CTPA or other imaging modalities and a right heart catheterization. And once they are confirmed to have CTEPH, then an MDT would decide how to proceed next. So this is an example of imaging with VQ. VQ is probably the first screening technique to use in order to make or exclude diagnosis of this. Now, what we usually take as a go-to investigation is the CT scan. And one drawback you must understand in CT is that very peripheral lesions are completely missed out in CT sometimes. So it is sometimes useful to use one of the other modalities like the cone beam CT and dual energy CT. Dual energy CT has also got the advantage of giving you some idea of what the perfusion is. So MRI is also another tool which can be used for, in addition to getting some anatomical details, you can also get some idea on the perfusion. DSA was always thought of as the gold standard, and you can get the very specific findings which you see, which are described there in this disease on a DSA. But CT is fairly good in assessing, even if you do not do a DSA all the time. So this is what I was mentioning about. Very peripheral diseases sometimes can be completely missed. There's a correlation between CT and the DSA. You can see the, not sure if I can use a pointer. Oh. So again, you can see these large areas which are completely missed from CT, but there is disease there. So DSA can give you much better delineation anatomically for this disease. And usually a multidisciplinary team approach is used in planning the treatment. So the first question to ask is there pulmonary hypertension? If there is pulmonary hypertension, is CTEPH the cause of the pulmonary hypertension? The answer to both these questions should be yes, in order for you to treat this disease as CTEPH. Now, you must use multiple imaging modalities. That is what is recommended. And in order to assess the operability, which is probably the most important part which you need to address in the MDT, first you have to see if the disease is surgically accessible. The accessibility is very sort of subjective. What is accessible to some people may not be accessible to others. So as we go distally, based on the experience of the unit, it may become more accessible as you gain more experience. The other important thing is most of the patients have a certain amount of distal pulmonary arteriopathy. It is extremely hard to differentiate based on, part of the disease is having arteriopathy of vessels which are less than 500 microns in diameter. It is extremely hard to tell how much is caused by the fibrotic clots and how much is caused by the distal arteriopathy. And also we must look for other, the general fitness and comorbidities. The only absolute contraindication to doing this operation is if there is parenchymal lung disease with destruction of the parenchyma. You're not going to benefit by removing the clots from that. You're probably going to increase the VQ mismatch. And the next one would be, which is a relative contraindication, is severe LV dysfunction. Because once you improve the blood flow into the LA, you might unmask an LV failure there. So patients who've got indwelling catheters, shunts, and other apparatus going through and splenectomy tend to have a more difficult outcome. And one thing to always be warned about is the in situ thrombosis, which happens in pulmonary hypertension from other causes. It cannot be differentiated with certainty, but there are a lot of ways of telling one from the other. One of them is the presence of systemic pulmonary collaterals. If you have collaterals which are from the systemic to the pulmonary artery, it tells you that there is a low pressure area beyond the level of obstruction. In the absence of collaterals, you may not find the low pressure area. That means there is distal disease, either from non-thrombotic disease or there is distal vasculopathy by itself. So we'll come to the management options later. Lung transplant is very, very rarely done for this disease today. So in terms of management, once you make a diagnosis of CTEPH, they have to have lifelong anticoagulation, and the treatment decisions is made by an MDT. If they are operable, there is no further questions. You send them for surgery, and PT is the mainstay of therapy in this situation. And either if they are not operable or if there is persistent pulmonary hypertension after PTE, then you can consider other options like BPA, and sometimes they will need medical therapy in addition to that. And long-term follow-up in a CTEPH center is recommended for all these patients. So just to show the options and where they stand, the proximal obstructions are best treated by addressing them surgically. And the segmental and subsegmental areas can be addressed surgically, or they can also be addressed by balloon angioplasty. What is beyond subsegmental area can only be addressed by medicines. So you may need a combination of these at times. So when you're doing the operation, the most important part is to ascertain the correct plane of operation. Once you get the correct plane of surgery, which is indicated by having a pearly white tissue on what is remaining, then it is a question of tracing that into the branches and removing them. Generally, you will be dissecting the walls of the PA away from the fibrous clot and not pulling on the clot too much. So you have to see the ends of these fibrous clots. Only then you'll know that it has come out fully. So this is an example of balloon angioplasty. You can see there's a stenosis there. It's getting dilated and there is good flow after that. So sometimes when you do a balloon angioplasty, it may not be apparent that it is successful at that time. Over a period of time, they may open up also. There is also the option of medical treatment, which is basically recommended only for inoperable patients for either because of access, or there is comorbidities which is making the patient inoperable. Or you could always argue that the patient is not willing for surgery is something the way you tell the patient. If you give them an option, nobody will be willing for surgery. But then the surgery is way ahead of medicines or anything else in this condition. So if there is right ventricular dysfunction or a high peer pressure after surgery, they may benefit from further medical treatment or sometimes PT or in recurrent disease. So the question of having bridging therapy from the time of diagnosis to surgery is not very clearly answered. Some people say that it changes the quality of the clot, so it makes it harder to handle during surgery. So there is anyway no evidence to suggest that it helps or medical treatment helps as primary treatment in this. So I thought there may be some medical audience also, so I had all these level of recommendations, but since it's a surgical audience, it just needs to tell that surgery is the thing to be done. And if that is not possible or if it doesn't work, then other options such as medicines or BPA. And for bridging therapy and patients who are for BPA, there may be some benefit from doing some bridging therapy for a bit. So in summary, we must, it is sort of an underdiagnosed disease. And one thing to understand here is it's a combination of fibrotic intravascular material and secondary microvasculopathy. So it is kind of hard to differentiate which part is more in a particular patient. So it is under-recognized not just in India. It is wherever you go to, you'll find them complaining that it is not recognized adequately. So if it is untreated like any other pulmonary hypertension, it has got very high mortality. Now, surgery is the first, second, and third option. All the other ones come afterwards. Okay, and once you have a good surgery, they have excellent quality of life and all the hemodynamic parameters come back to normal. Will BPAs replace surgery? At least for the distal part, eventually it will, is what I think. Because right now we don't have a lot of specific hardware. Once all that is developed, for distal disease, there is a good chance that that will replace surgery. But then if you've seen the kind of clots which you have in the proximal tissues, I don't see anything other than catheter held dynamites will help. So this is the only pulmonary hypertension subset which has got some chance of a cure if treated appropriately with surgery. So that is the main importance of diagnosing this. If you look at the hemodynamic parameters in the above and before and after pictures, you will see the kind of difference you have. You have a PVR of 899 before, and it is 113 after the operation. Same thing with the difference in the PA pressure, which was systemic there, which is 80. I can't read that quite well. But anyway, it comes back to normal at the end of the operation. If anyone is looking at starting a program, I would recommend that you get a specific set for the operation, which really helps in the procedure. So thank you very much.
So I have a question. So do you encounter RV dysfunction after the surgery? Because I guess you have to do it on bypass.
Yeah, RV dysfunction is very unusual after surgery. We just had one occasion or two occasions where we've had severe RV dysfunction. So RV dysfunction in this situation is diagnosed by having normal PA pressures, but very high CVP. So initially you'll be very glad that the PA pressures came down without quite realizing. But then since you're looking at the RV, you can easily tell it's not contracting. And that is why there is no peer pressure which is developed. So usually, once you had a good endarterectomy, if you had an RV dysfunction, if you put them on ECMO for a few days, they recover completely.
Thank you.
It is generally from some myocardial protection issue, something like that. Because all RVs, regardless of how bad they are, will recover once you remove the afterload. The RV dysfunction is purely effect of the afterload. So, that is the physiology of it.
Hi, Julius. Yes, I'm wondering actually, do you find unilateral disease?
Unilateral disease is rare, but it is possible.
It is possible. Huh? And how frequently the patients are symptomatic, with unilateral disease?
You will be symptomatic.
You will be symptomatic.
So one thing which is recommended when you're treating, when you're operating on unilateral disease is to patch the PA. I do not know how that changes things, but that is what is recommended. I can't quite answer if you ask me why.
So if patient is symptomatic, is having just perfusion mismatch, the other lung is absolutely normal, then do you recommend surgery?
Yes.
Yes.
If there is pulmonary, if there is symptoms and pulmonary hypertension.
Okay. Thank you.
So one more question, sir. After the COVID, did you observe any extra cases added to that, sir? It's a question from government general hospital. After the COVID, did you get an extra case? The number of cases increased after COVID. Are any correlation with the COVID? Because pulmonary associated disease. Yeah. Because you got a highest census of the cases in Narayana, that's what I know that. Okay.
As in, the numbers have been going up from the time we started the program. So I don't know if COVID alone has made a.
Yes, after the COVID, we received approximately 5 cases we received, and 4 cases we operated, 1 case we lost.
You may have a higher incidence of acute PE in COVID, but the chances of acute PE is turning chronic is under 5%.
Okay, thank you.
Julius, for the BPA cases, I take it that there is no stenting there.
No,
So what are the chances of restenosis there?
it is not really very high.
Not high.
No. So we had some difficulties in opening them if you are trying to do them post-operative. Like if you've done sometimes they come after surgery from elsewhere. So we try BPA first. But a lot of them don't do it.
Okay. And secondly, which are the patients which you will refer for the lung transplant in this disease?
In this, unless it is not accessible. See, sometimes the disease is beyond subsegmental arteries.
Right.
They have to be transplanted. If they fail medical care. Riociguat is the drug which is recommended. So subcutaneous treprostinil also seems to work, which we don't have.
Okay, thank you.
Yeah, the role of TCA in during the procedure, the total circulatory arrest.
Always on TCA.
Always on TCA, must.
Yes.
Okay, so and the post-op anticoagulant after the surgery, like how many? Lifelong, even after complete removal of.
Once you have a diagnosis of CTEP, you will have lifelong anticoagulation.
And the use of IVC filters in certain conditions.
We do not use IVC filters.
If it is a proven DVT which has been showering from, there is no role of IVC filter for this.
Lifelong anticoagulation.
Yes.
If you cannot anticoagulate them for other reasons, then we would sometimes do that.
IVC filter. Thank you.
If somebody can be anticoagulated therapeutically, then we do not use an IVC.
Okay.
And again, there is a lot of confusion about what anticoagulant to use. Most of the CTEP centers have been using only vitamin A antibodies for anticoagulation. Even though NOACs, like everywhere else, is coming into this also, there have been some non-inferiority studies and all of that which have been done. But one thing is clear: if you are APLA positive, nobody recommends NOACs. You must be on VKs. But if you are not APLA positive, I do not know. We don't use NOACs, but some people.
Sir, what is the incidence of APLA and the patients?
I think it should be 15%.
Oh, 15%.
Do you see pulmonary hyperperfusion syndrome, sir? How frequent it is?
one side getting overperfused because of uneven spread of disease or uneven addressing of the issue. And if it is there,
Edema happens to some extent in a large number of patients. So we keep them very dry. We filter them during surgery. We do a mop at the end of the operation for all of them. We try to get the CVP as low as possible. And most of also, even at the expense of creatinine going up a little bit, we keep them very dry. And in spite of all of this, some of them develop deposition edema. So a few days on VD ECMO, that should be good.
take care of that.
So, sometimes we cannot use a peripheral cannulation because of DVT and IVC thrombus and all. Then we don't have to use a cannulation.
Okay, so that's precisely next question. So you go for a VV or VA, sir? You try to keep the lung.
If it's purely reposition edema, VVs.
VVs.
Yeah.
So you're not
If it is-
concerned.
if it is other like RSA or sometimes with PD. See, sometimes you have boundary average, which is not responding to the usual basis. Sometimes we have to keep them on ECMO and reverse all your heparin and everything else. So that time we might use use VA. But what you must remember in a VA is that if you have full flow VA post VTE, you're taking away blood flow from the lung, and you have an endarterized surface, which will lead to the entire pulmonary artery thrombosis. So if you are doing VA, you mustn't exceed, say, 70-80% flow. You must maintain some pulmonary blood flow in order to, like you have no endothelium and you have stagnation. That is good recipe for thrombus formation, regardless of, you can keep your ACT to 1000, if these two are there, thrombus.
Yes, precisely what you said. So with the hyperperfusion with a normal RV function, if you have a hyperperfusion with a normal RV function, if you have to make a choice between VV and a partial VA, is partial VA better, sir? Because partial VA will decrease your QP and whatever the edema and all, make that get better.
Try to avoid doing a full VA in all these treatments if possible. So if it is a oxygenation issue, it's only
VV only.
So once the oxygen, the PA pressure increase is because of low oxygenation of the vasoconstriction. Then the RV will get better. In the absence of that,
Done. Thank you.
So one last question. Do you face any recurrence in your cases or recurrence in your cases, redo surgery? Because there are a lot of chances that the patient might again come with a thrombus. So what you do in the case?
See, one of the things we do is we repeat imaging after about 3 months when they come for follow-up. So we have a baseline image either in VQ or CT. Then we know where they stand at the end of the operation. And we also have the peer pressure measurement by echo. We don't repeat the cap usually. So sometimes people come back 10 years after surgery with disease again. When someone comes back with increased peer pressure, we work them up like it was the first time. And if it is operable disease, at that time, do a redo operation. If it is not operable, then you offer probably other operations. In all redos, you must look at them like you are examining them for the first time. Yeah. So supervised anticoagulation is the key. A lot of people will go somewhere and then say, let's change to NOAC. We have no idea what happens. In NOAC, they say you don't need to measure anything. Basically, you can't measure it. Thank you.
Thank you so much, sir. That was quite a riveting session. Now we move on to our next session, which is also a difficult problem again that we have to face as cardiac surgeons, and that is cardiogenic shock. So in order to moderate this session, I would like to call on Dr. Sandeep Seth, sir, Dr. Julius, sir, and Dr. Varun Shetty, sir, on stage. And the first topic we are going to be talking about is IABP as the first therapy of cardiogenic shock in ICU by Dr. Murali Krishna, sir. Can I please ask you to come on stage? Thank you, sir.
Very good afternoon, everyone. I'm Dr. Murali from MGM Healthcare, and over the next 15 minutes, I'll be dealing about IABP as the first therapy when you deal a cardiogenic shock in ICU. First, my sincere thanks to the organizing team for giving me this opportunity. I don't have any relevant disclosures to this one, and this is a brief outline on which I'll be dealing with this talk. To start with, if you look at the definition of cardiogenic shock that's been defined variously by various trials or by the societies, this is what it constitutes. You have a hypotension in spite of volume resuscitation, probably requiring an MCS or an inotropes. Along with that, you have signs of a poor perfusion with laboratory parameters deranged, that is a lactates or an acidosis. So our talk mainly is to look at IABP as the first therapy. So with that, we presume that all these patients whom we are going to consider are already on an inotrope. We're not talking about IABP being coming even before the inotrope. Second, when we are looking at, we are probably looking at escalating to a mechanical circulatory support. So when we are looking at mechanical circulatory support, whether IABP can be considered as first support as a blanket in all these patients, that will be the focus of this talk. If we look at the common causes, what we deal in an ICU for cardiogenic shock, these may be the ones. You may deal in an acute myocardial infarction or a myocarditis for varied causes, an acute and chronic failure in a patients of variable reasons, ischemic, dilated, restrictive, pulmonary embolisms, or sometimes a septic cardiomyopathy. So these are your common causes. And in these cases, whatever it is, when we go for a balloon as an option, this is how it predominantly helps you by decreasing the afterload to the left ventricle, thereby decreasing your LVEDP, increasing your coronary perfusion pressure. Apart from that, what it is shown, the commonly used balloon, which is used in multiple studies, is a 40 cc balloon that has shown to have a very minimal increase in the cardiac output to the extent of 0.5 to maximum of 0.8 liters per minute. That is a very marginal increase in the cardiac output. So looking at the advantages, this may not be anything new for us, but when we deal with a situation where you have a patient who is in the cardiogenic shock and practically you're looking at escalating it to a mechanical circulatory support. So the very simple facts like the ease of insertion can be done by anyone, can be done bedside, and the cost being not high when compared to the other forms of support like your Impella, ECMO, or a ventricular assist device, and the complications being significantly less, comes in a very big way. So these are very significant advantages with this sort of IABP modality when you compare with anything else. Apart from that, for the patients whom it makes a difference, that is a responders, it really makes a miracle where you can keep this patient on this support till you come out of this either by recovery or by some other pathway in these patients. The main disadvantages or limitations will be you do have certain set of patients who will be the non-responders who don't respond to the balloon, or what the evidence we have from literature, though it is not very convincing or some of them being conflicting, then you don't have this option, particularly for pediatric patients who have a cardiogenic shock, or if your patient is having any of the contraindication for putting a balloon. So with this basic view, let us look at what is there in the literature in different scenarios for IBP as a first therapy in a cardiogenic shock. To go into that, let us divide the cardiogenic shock, what we commonly face, into these scenarios. An acute MI cardiogenic shock, and all acute MIs, definitely we cannot equalize them. In that acute MI also, probably we need to divide them into some cases where you have an adequate revascularization, whether it is by a PTCA or it is by surgical revascularization, or cases where you don't have an inadequate revascularization. Second, MI with mechanical complications, where you have a VSR or a papillary muscle rupture leading to severe mitral regurgitation. Then finally, a non-acute ACS cause of an acute cardiogenic shock. This encompasses a wide variety of situations: a dilated cardiomyopathy, restrictive cardiomyopathy, ischemic cardiomyopathy, myocarditis, or any other fulminant myocardial failure. So let us look at these scenarios, what is there in the literature one by one. To start with, cardiogenic shock due to an acute MI. In the late till 2012, the IBP was very widely used for management of the cardiogenic shocks caused by the acute MI. Rather, in some of the studies, you find in uses of IBP up to the range of 60 to 70%. But this single trial changed the way it is practiced. This was the SHOCK 2 trial, which came in 2012, published in the NEGM. What they essentially did was, this was one of the only randomized prospective multi-center trial where they took 600 patients who had cardiogenic shock. They divided them equally into IBP group and into the control group. All the patients, they go for an early revascularization. They went for a full revascularization, and they did the best possible medical therapy in this patient. The primary endpoint, what they looked for was 30-day mortality for all causes in both the groups. Apart from that, they assessed a lot of other parameters, one of them being the safety parameters or the complications, like a bleeding, stroke and all. What are the results? It clearly showed that the IBP did not had any significant effect on the mortality on 30 days. It didn't make any difference when it compared to the control group who were medically managed. That was the main outcome that was shown. Apart from that, in a variety of secondary points, what they looked into and other process of care measures, that is the time taken for the lactates to settle down, all these things, and complications also. So all these things, there was no difference between the control group and IABP group. So this changed the way the IABP was used for acute myocardial infarction, especially the STMI, who are adequately revascularized. So after this, all the guidelines, whether it is a European or American, have downgraded the usage of IABP. The European has brought it down to the class 3 recommendation currently for a regular use of IABP in all patients with cardiogenic shock in an acute MI situation. And the American guidelines have brought it down to the class 2B recommendation. So it is not just this trial, but subsequently the analysis which came after that, whether this is this Cochrane analysis or a large registry meta-analysis which has been done, all of them have clearly shown that IABP does not have any survival benefits in acute MI patients who have been adequately revascularized. So that is one subset of patients. We do have another subset of patients, that is patients with acute MI who have cardiogenic shock, but who may not have been adequately revascularized. For some reason, you're not able to establish the flow well. So in these cases, still there is a role, as that is shown by this study, which is a prospective analysis of the registry data. So they have taken close to 7,200 patients and they analyzed. What they found was when the TIMI flow after an acute MI has been a TIMI 1 or TIMI 0, that is, it is an inadequate revascularization, their IABP is shown to have an improvement in the mortality. So IABP has a beneficial effects in patients who are having acute MI and cardiogenic shock who are undergoing PCI with a suboptimal results. In this subset of patients, it has shown to have an improvement in the mortality. Then coming to the third subset, patients who are having an MI and having a mechanical complications like VSR and MR. So in these patients, still IABP clearly has a role, rather it is a standard of care as suggested by the guidelines with the recommendation going by the 2A recommendation in these patients. Then let us come to the fourth category of the patients who are non-acute coronary syndrome cardiogenic shock. This group encompasses a wide category of patients who are dilated cardiomyopathies, ischemic cardiomyopathies, or restrictive cardiomyopathy, or any acute myocarditis patients who are presenting in cardiogenic shock. There are a lot of studies in the literature which shows the utility of the IABP. Most of them have favorable results. One of them, which is worth mentioning, is the one which I have shown there, because this is one of the randomized trial, which has done in a very small group of population, that is close to 32 people. In one group who presented with cardiogenic shock, they put a balloon. In second one, they try to manage with the inotropes. So what they clearly shown was that using a balloon has resulted in a better hemodynamic parameters and a decrease in the BNP in this patient. So in this category of patients, the cardiogenic shock in non-ACS category, the IABP certainly has a role in stabilizing them. To sum up all four, this is what it is now. Acute STMI with adequate revascularization, the routine use is not indicated. Whereas if we have an inadequate revascularization, it is probably useful based upon the studies. If you have a mechanical complications like VSR or MR, it certainly has to be used. It goes by the recommendation of 2A. If you have an acute or chronic failure or myocarditis, in this subset of patients, it is still indicated, though we don't have a large scale randomized trials, but it is still shown to be beneficial in these patients. So something which is not being considered, or rather a new development, this is not really new, this is there for last 10 years, uses of a 50 cc balloon. Why does it matter? Because the size of the balloon matters, because when the 50 cc balloon was used, it has been shown that it can cause a higher peak augmented diastolic pressure, and the fall from the peak augmented to the aortic diastolic pressure, the slope also is greater in this patient. So this translates into a better hemodynamic variables or better hemodynamic outcomes. So whatever the small studies on the hemodynamics have been done, it has shown that this can probably increase the cardiac output up to 1.4 to 2.4 liters. That is close to 40% of the native cardiac output. When you compare with the 40 cc balloon, which can increase only up to 18% of the cardiac output. So the initial trials, these are only hemodynamic trials or small comparative trials. They have shown favorable results, but we don't have any large scale randomized trial like a shock to trial. So this is something which probably a factor which may influence the way the IABP is practiced, going more pro by the way of balloon. So having looked at all the situations where it can be used, if other thing we need to see is the complications. If you compare with any of your other mechanical circulatory support device, this is the data which was compiled looking at all the complications in different mechanical circulatory support. It has shown that obviously the IBP has much lesser incidence of any of these complications when you compare with any other mechanical circulatory support devices. Similarly, the SHOCK 2 trial has clearly shown when you compare with even the medically managed group of patients, the incidence of any major complication, including bleeding or limb ischemia and all, were not significantly higher in the IABP group. So to sum up with our institutional experience of balloon, we still use in some cases of acute MI where the shock is refractory to inotropes before we proceed to an impeller or an ECMO option. In otherwise, it's considered as a first line of therapy when we handle any patients who are on acute and chronic heart failure deterioration in these patients, unless you're dealing a situation like a cardiac arrest or a severe hypotension. The response you see typically is much better in ischemic cardiomyopathies, followed by the dilated, probably lesser in the restrictive cardiomyopathy patients. Once we see that a patient needs to be for a longer time on balloon, we go for a subclavian balloon insertion. And the duration of support, like it is shown in many studies, we're not looking at the duration like 3 days or 4 days as a cap of the duration of support. If required, we do support them for weeks of them. Just want to end with this couple of cases which we had. They were both in 50 to 60-year-old and they were waiting for the heart transplant. That's when the COVID struck and it was a total lockdown. And these patients started deteriorating. In any other situation, probably we would have gone for ECMO. Since they were waiting for an organ, we could have got a transplant. Rather, we painted it for ECMO. To that ready, we were there. Then we put a balloon. Slowly, both of them improved. And we had to support them, one of them for 4 months, the other one was 6 months on balloon. We had to change the site. Eventually, we converted to subclavian and all, because all this time it was total lockdown and there was no organs available. Eventually, both of them got the organs and then they got discharged. This is a video of the patient with subclavian balloon walking around in the ICU. So to sum up, this certainly has a role in the cardiogenic shock. The main advantage is the cost, the ease, and the lesser complications. They certainly stand out when you compare with any of your mechanical circulatory support. If you have an adequately revascularized MI, probably won't be of any benefit. Whereas if you have an inadequately revascularized or you have a mechanical complications, or you are seeing a patient with acute and chronic heart failures, certainly this has a role in those patients. Only thing, we do have responders and non-responders. We need to identify very quickly who is a responder, who is not a responder, then escalate therapy based upon that in that particular patient. So, and should be considered for all of them before we look at any further aggressive mechanical circulatory supports. Thank you.
Thanks, Murli. That was very well presented. I think there was one other thing I would have probably have added was the auxiliary balloon which Dr. Jivanandam had developed.
Yes.
Where you could disconnect. So I was just thinking, if you had a metric like the increase in cardiac output, ml per rupee,
sure,
IABP would win hands down over everything else.
Yeah, true.
And certainly if you have a new balloon which is going to give 1.8 to 2.4 increase in cardiac output, that would be a really great thing. Because as Paul had mentioned earlier, impeller in reality 2.5 gives only 1.8. So this seems to give more than
doing
that.
the things. I mean, that's what practically is. The advantages, though they look very simple, but they do matter when you see a patient who is deteriorating, when you have to counsel them for an ECMO-induced cost or an impeller and that cost. On the other side, the amount or whatever the simplicity with the balloon, if it makes a difference, certainly it is a far better support than compared to all these things.
If you disregard the shock trial results, if we can have a show of hands as to how many people believe that balloon helps.
Certainly, I mean, without
I think
majority
I would
still
also join in that, because you know most people have experienced the goodness of
magic
the
of
balloon.
it.
Thank you. Any other?
What is your opinion of using IABP for unloading the left ventricle on ECMO?
unloading the left ventricle on ECMO. It is standardly practiced. It may or may not make a difference, but that is one of your modality. You have to go by your wedge pressure and start whether with your inodilators, inotropes, or decreasing flows, then balloon. If that doesn't work, probably escalate further to a vent or a septostomy, some way of doing it.
So if you had a patient in cardiogenic shock and you put him on a balloon first, and if you find that he's not improving, would you leave the balloon and put him on ECMO?
It depends upon the case. Given a choice, yes, that's a way. But if you have an access issues, you are in an emergency, you have to convert from ECMO to in IABP to ECMO, you may still use the same access and then dilate and do off the ECMO. Rather, to put it the other way, if the patient is already on balloon, you have done the ECMO, you'd like to keep it and use it for probable effect of decreasing your LVDP. On the other side, if you have a patient who is on ECMO, if you're having a trouble with high LVDP, pulmonary congestion and all, we may not consider putting a balloon de novo in that patient, rather go for a surgical venting or some form of venting in that patient.
Thank you.
Thank you.
Anyone else wants to ask questions? Can we, thank you, Murli. Sorry.
There was a recent study in Jack last year that compared balloon pumps and Impella for LV unloading, and there was actually no difference.
No difference.
So you can actually, I mean, we used to think that Impella was better, but then we started using balloon pumps mostly, and then we had similar results. So, and less limb ischemia and less bleeding and et cetera of the balloon pump compared to the Impella.
That's true. I mean, even if you see a patient who is acute MI first time, when you see him, you will not be very clear whether you're going to achieve 100% revascularization. You're not going to end up in a mechanical complication. So all that are foresight thoughts that, okay, revascularize, we should not have put a balloon, but still he's in trouble. Your inotropes are not making a difference, even with mild or moderate doses, then still it has a role, sir, where it makes.
I do have a couple of concerns about having peripheral ECMO with IABP, because in a peripheral ECMO, IABP is going to interrupt the flow half the time. And also we know that it will, if there is some amount of mixing, it's going to move the mixing cloud more distally. Yeah. So, I am not a big fan of that idea.
Both together, yes.
Peripheral ECMO and
IABP. Yes.
Thank you so much, sir. Ma'am, who is here to answer a very important question: to vent or not to vent the LV in patients on peripheral VA ECMO. Can I please have you on stage, ma'am? Thank you.
Very good afternoon to one and all present here. I'm here to attempt to give a talk about whether to vent or not to vent the LV in a peripheral VA ECMO. Yeah. So I think a lot of our practices are also based on what we have done when we were in training, or at least for younger faculty like me. I think it translates to what I have seen during training and what I am exposed to right now, and how we adjust with what we have available. So I'm just going to present a case, start with a couple of cases. So I saw a patient who was a 24-year-old male with recurrent cough, poor appetite, fatigue, weight loss, sleep disturbances over several months, and eventually he ended up to the emergency room one fine day. He's tachycardic in the 120s, tachypneic with respiratory range in the high 30s, saturating 90% on room air, unable to lie flat. Blood pressure initially was 90/70 and subsequently dropping to 80/60s. On examination, he has neck veins up to his ears in the semi-recumbent position. Heart auscultation reveals tachycardia with an S3 gallop, systolic murmur, lung with crackles, mildly palpable liver edge, cool lower extremities, and a distended abdomen, So labs reveal respiratory and metabolic acidosis with a lactate of 3. He has acute liver and kidney injury, elevated NT-proBNP, mild anemia, thrombocytosis. ECG shows some low voltages and intraventricular conduction delay. So this looks like maybe a subacute presentation of something that's been going on for a little bit, for a little while. X-ray shows significant pulmonary edema, and a Swan-Ganz catheter is placed in the hospital via the right IJ. His right atrial pressures are elevated, RV 45/20, PA is 45/35 with a narrow pulse pressure, and his PAPI is low. He has an elevated wedge, and his cardiac index is 1.5 liters per minute per meter square. And his urine output in the time since he has been in the emergency room has not been much at all. So, this is a patient who, would qualify for a VA ECMO in the right setting, and depending on what kind of resources you have. So if you can just take a look at the echocardiogram of this patient, his LV is quite dilated for his body surface area. He's a very thin male. And there is mitral regurgitation. And, this is to show the end diastolic dimension. And this is the Doppler profile of this patient who has a very high E and a very low A, suggestive of a restrictive filling pattern, and low TDIs and myocardial velocities in the medial aspect, suggesting elevated left atrial pressures. So this is one case scenario. And then I'm going to talk about another scenario where there was a 26-year-old female who was admitted for an elective procedure related to septate uterus and infertility. So she underwent general anesthesia, and after induction, she had uterine irrigation with glycine and saline, and then she suddenly became hypoxic, bradycardic, needed cardiac, went into cardiac arrest and had to be revived. Post-resuscitation, she went into a refractory shock and required multiple pressors with worsening acidosis and kind of going into anuria in the 3-4 hours she was in the ICU. And then she was, ECMO was initiated for this patient due to LV stunning. And this is her LV, and she's on, inopressors. Her LV volume here measured is around 82, and her LV end systolic volume is around 70 with an AF of around 13. And this is her LVOT VTI, something that we heart failure cardiologists like to look at to assess the stroke volume of the patient, and that is very low. So what I'm trying to infer here is one size does not fit all. So the first patient who had a very dilated LV, mitral regurgitation, pulmonary edema, and who has probably an underlying myocardial pathology definitely is going to require LV venting of some sort. And then the second patient who had an acute insult, she was totally normal without any prior medical condition. And when she goes into an acute cardiac arrest due to some intercurrent issue that's happened in the OR or some air embolism, probably of that sort, and that patient who gets onto VA ECMO may not necessarily need LV venting. So I think it depends on what the patient's presentation is, what their heart says, and what their hemodynamics say in order to decide what the right strategy is for them. So peripheral VA ECMO is very easily instituted at the bedside, like all of them have talked about. It has emerged as the established therapeutic option for patients with sustained cardiac arrest or cardiogenic shock. It provides temporary circulatory support until causative treatments are effective. Either the myocardium has to rest in the case of myocarditis, or the acute insult that has been instilled in the myocardium takes time to resolve, or like an MI that needs to be revascularized. Or so these patients can be bridged via a VA ECMO to recovery, to heart transplantation, or a surgically implanted ventricular assist device. So what happens in a peripheral VA ECMO are these huge cannulae that sit in the arteries, and then they push blood retrograde into the aorta. And so the potential drawback is that there is so much blood that's going retrograde, and it causes left ventricular distension. And if they don't have MR, mitral regurgitations, if they don't have like a severe mitral regurgitation, the LV kind of distends quite a bit. And when it distends, the myocardial recovery becomes very poor, and the aortic valve does not open, and there is risk for thrombus formation. And if there is a pop-off valve with the mitral regurgitation, they all develop pulmonary edema. And so that's when we have to think about LV venting strategies. So in the paper that I have presented here. They did VA ECMO plus intra-aortic balloon pump and VA ECMO plus microaxial pump like Impella. Currently, the most promising and best investigated strategies for LV venting, although there are definitely a lot of surgical venting strategies which are going to be talked about next. So we need more prospective RCTs on these venting strategies to figure out which one is the best, and that's the problem. We are devoid of data in this. So I trained at an institution where they did Impellas all the time, and in a patient with severe RV dysfunction, they would go on VA ECMO, and then with an Impella in place, and then once the RV improves, the ECMO would have been removed, and then they would wait on a Impella for either a bridge to recovery or transplant or VAD. So what I found with all these Impella patients was that the CP or 2.5, they all had a lot of hemolysis, and hemolysis in turn, not just hemolysis in the milder form, some would even go into acute renal failure requiring dialysis. And so we will be looking at a heart transplant kind of candidate. So the ones that were implanted percutaneously from the groin were so prone for movement with slightest of, the patients who are chronically in the hospital or in the ICU need to be moved, and, back care and all of these have to be given. So these patients had a lot of difficulties with the Impella cannula moving constantly or tearing on the mitral valve apparatus, that it was just a nightmare. But what we found was the axillary surgically cut down Impellas that were placed on some of these patients who, especially some of them are very big males who have a large body surface area, and the 5 or 5.5 that were surgically cut down axillary placements had a lot of stability, and it enabled the patients to eventually ambulate and gain their strength prior to plant, transplant, or a surgical VAD implantation. So, like I said, retrograde flow to the proximal aorta, increased LV afterload, which in turn increases the LV end diastolic pressure and decreases the stroke volume. So the LV distension causes pulmonary edema, thrombus formation in the left heart due to stasis, and myocardial ischemia from decreased transcoronary perfusion gradient. I really like this. The diastolic blood pressure minus the LV end diastolic pressure is the coronary perfusion. So when your LV end diastolic pressure increases, the coronary perfusion reduces. So it causes impaired myocardial recovery from myocardial ischemia. So this is one of the papers that I looked at, mechanical LV unloading in patients undergoing VA ECMO. So among adults receiving VA ECMO, mechanical unloading was associated with lower in-hospital mortality despite increased complications, including hemolysis and cannulation site bleeding. Compared to peripheral VAD, mechanical unloading with intra-aortic balloon pump was associated with similar mortality. So that was the findings from this paper. And there was another one that looked at it's a meta-analysis that looked at ECMO versus ECPella, meaning ECMO plus Impella in patients with non-post pericardiotomy cardiogenic shock. So the 30-day mortality of non-post cardiotomy shock remained high despite the use of mechanical circulatory support. Combined use of ECMO and Impella may have some protective effect, whereas IABP had no effect based on meta-regression analysis was the finding in this paper. Major bleeds are more frequent in patients with ECPella than with ECMO, as we all realized. Patients with ECPella, though, had lower rates of heart transplant or LVAD within 30 days as compared to ECMO alone. So there is a lot of talk about unloading, so much so that there are some trials that talk about it in an acute MI setting instead of directly going and opening up the culprit vessel. There are people talking about door to unloading time where they actually in a big anterior MI, they're talking about unloading with an Impella first to reduce the myocardial ischemia and the myocardial damage and then reopening the vessel. So I think a lot of trials are looking at this. So this is the controversy in extracorporeal membrane oxygenation, immediate versus watchful waiting for VA ECMO venting. So myocardial recovery can be impaired and inversely related to the degree of LV distension. An increased pulmonary congestion after VA ECMO is associated with poor prognosis. So I think it is very important that we look at the patient and look at their echocardiographic parameters and their clinical presentation to decide the timing and the strategy of LV venting. So as a cardiologist, what do I look at when there's a patient on VA ECMO? We look at the etiology of cardiogenic shock, whether it's from acute MI or acute and chronic decompensated heart failure, myocardial stunning, or whether it's congestive heart failure before the VA ECMO. A low systemic arterial pulsatility, meaning a pulse pressure less than 10 to 30. high mean arterial pressure without pressure. So this person is not on any pressors, but they have a high mean arterial pressure. High diastolic pulmonary artery pressure more than 20, high capillary wedge pressure more than 25, high left atrial pressure, high end diastolic LV pressure, and need for high flow support, more than 4 liters per minute. This is great. But we don't often get to put right heart caths all the time in our patients because of increased risk for infection or concern for sepsis. And so we have accommodated ourselves to look at all of these things by a transthoracic echocardiogram, provided they have some good windows. If not, we use TEE as a method to look at their intracardiac pressures. So if there is no aortic valve opening, so first of all, we look at the LV size, NV end diastolic volume, LV end systolic volume, at least in 2 windows, apical 4-chamber and apical 2-chamber, index to body surface area. And then we look at their filling pressures, E by A wave, and then the E by E prime, which is the myocardial tissue Doppler velocity. So we look at it and average the medial and lateral and see what the filling pressures are. We look at for the presence of mitral regurgitation, and if so, what is the regurgitant volume? And then we look at the pulmonary veins to see whether there is systolic flow reversal or systolic flow blunting in the pulmonary veins. And consequently, we also look at the RV pressures, where we look at the pulmonary artery systolic pressure. We have the tricuspid regurgitation signal. And a lot of times, if we are lucky enough, we can get a PR jet, then we are even able to look at the pulmonary artery diastolic pressure and the mean PA pressure by echo. And by this means, we can calculate a non-invasive pulmonary vascular resistance. However, there is no study that has shown that PVR by echo and PVR by invasive means have been, good correlation. So anyway, look at all of these things. We do a comprehensive RV echo, LV echo. And if we look at smoke or LV stagnation, stagnation in the left-sided cavities like left atrium and LV, and high filling pressure and significant MR. So we do a thorough echo, and then we kind of discuss with our surgeons or the ECMO team about what we could do. Pulmonary edema by radiographic means, and hypoxia under VA ECMO or high end tidal carbon dioxide, or anything like pink frothy sputum in their endotracheal secretions. So I guess this is similar to what I have talked about, in a non-pulsatile ECMO with a low pulse pressure, worsening pulmonary edema, we do echo or right heart cath. We kind of see that the LV is distended, there is stasis, there is no aortic valve opening. And, then we decide on what next to be done. So medically, how can we manage LV distension is by increasing LV contractility. So if somebody is not on any inotropes, we try to put them on some inotropes to cause LV ejection and make the heart a little pulsatile. When the arterial waveform blips a little bit more, we are a little happy. And we try to decrease the LV preload by PEEP, invasive or non-invasive. And we try to increase the extracorporeal blood flow to improve the RV drainage in patients with residual transpulmonary flow. Sometimes the drainage cannula position can be optimized, or a second drainage cannula can be added, although I've never seen this. This is just what I read, so I put it in the presentation. And we minimize the LV afterload. So in a patient who has a high blood pressure, we try to keep the lowest possible extracorporeal blood flow to maintain the least amount of transpulmonary blood flow. And we can add vasodilators like nitroprusside is my favorite all-time go-to medication in these patients. And we ensure that the perfusion markers like lactate or urine output is good when we do these things. So again, this is similar to what I've talked about. So these are more about venting and what kind of changes are present in different forms of venting. So the recent ISHLT guidelines have put this under their recommendations when considering VA ECMO. The last point, the need for LV venting or unloading, pharmacological or mechanical, should be considered. And it's a class 2 recommendation with level of evidence B. Thank you.
Thank you for that. So in the 2 cases you presented, in the young woman, you would not want to vent, is it?
Meaning, because she showed good recovery, her LV filling pressures were not high, and her LV was not distended, and we had a feeling that she was going to come off without we weaned the PA, the VA ECMO in a couple of days, so she did not receive any venting.
I mean, occasionally you will end up getting someone who recovers well without venting, but in general, it is thought that the the commonest cause for non-recovery of your LVs because of lack of unloading. Would you agree with that?
Yeah.
Uh,
No, but I'm just talking about the different scenarios where I have seen there are some patients here who we didn't vent and they did pretty okay and coming out of VA ECMO, especially these, if it's not a primary myocardial problem that is in place, if it's some secondary insult that the heart is a bystander, they're usually able to get off without any venting. But if in the first case, that man had myocarditis, it was very clear, it was a subacute presentation. So there was no way he could have done anything, even though he was the same age and all that. But the second person, she was totally fine. She walked into the OR and just went into cardiogenic shock from a lot of insults that happened in the, for some, unfortunate reason. So she did pretty good.
Before we started routine venting, some people have recovered. So, but now we try and vent everyone as much as possible.
So I don't think we do routine venting here. We look
So
at all these things.
If we are doing, you want to explain how we do the?
So our go-to strategy is to do a septostomy and direct the venous cannula across the septum. So we will be draining both the LA and RA through one cannula. And we do it very early. We have a very low threshold to vent the LV, primarily because of what we discussed.
Sometimes you can even place a second cannula like that. You already have got one drainage cannula. Then you think LV requires a vent. So you put from the other side, one more cannula which goes across the septum.
Yeah.
So that is the other thing which we have done.
Okay.
I mean, normally surgical venting is what we prefer, but
I have a question. I'm curious about your pharmacological methods of venting. How effective do you think it is? And also when you start the inotropes, how long do you wait before you say that, time's up and you need to try surgical venting?
I think dobutamine usually immediately should have some effect. We should see some change. We crank it up to a higher dose. The maximum tolerated, at least the maximum dose we have used is 7 micrograms per kilogram per minute. So if there is not much response within half an hour of starting or titration, then we usually say that that's not working. But whomever I have seen till now with my limited experience, they've had some response to dobutamine or, milrinone if their blood pressure allows, or epinephrine if we are using it, that we start seeing improvement in their pulsatility. And vasodilators, nitroprusside, in someone who's higher mean arterial pressure, we use nitroprusside, and that also helps.
You see pulsatility, but you still see a low VTI and some sec in the LV. Then what do you do?
Sorry?
No, you have some pulsations, maybe 1 in every 3 beats, but you still see some sec. You still see some, the LVOT VTI is low. Then do you consider?
No, if the LVOT VTI continues to be low, or if there is still smoke, or if the LV is still distended, then yes. But I think if you want to look at some echocardiographic change, you may have to give it at least a few hours, after starting the dobutamine. We look at pulsatility based on, the arterial waveform, but for some effect to be seen, at least we repeat an echo in a few hours. So we do a lot of echoes in these patients. And if we see there is some improvement in the LVOT VTI or in the size of the LV, then at least we are okay. If not, then,
So it's mostly the echo that guides you.
Echo and clinically, if they're making urine, or if, how are their end organs perfusing, how is their chest X-ray, how is their oxygenation? It's not just one thing, right? It's a multitude of things that we're looking at. So,
thank you.
Thank you, Dr. Purna. I've got a few announcements to make. One is about dinner. The dinner has been organized in Hall A, which is a venue which is about 10 kilometers from here in Hotel Taj, Wellington. So transport will be organized from here to have the dinner. Before I call upon my colleague Paul Ramesh to talk about eCPR, I have a small housekeeping announcement to make. We are running grossly behind time. I think we are about 3 or 4 hours behind time. And I think a lot of our senior colleagues have come, who've all prepared, come all the way. And we just need to keep that in mind and be a little more time conscious. Thank you. Thank you for your attention.
Thank you so much, sir. Thank you, ma'am. That was a very educative session. And now I call on Dr. Paul Ramesh, sir, to speak about eCPR. So can I please have you on stage?
Yeah, I hope it was just coincidence that Sundar made that announcement just before my talk. So, but I will try to keep things as. Okay. Yeah, so eCPR, I think this audience is quite used to most of the jargon that comes with it. So I'm going to skip over the first thing. Just one important thing to talk about here. Oh, I can see it, it's still not projecting, is what is actually meant by return of spontaneous circulation, and what is a no flow state and what is a low flow status. If you're not familiar with these, it's quite important because a lot of the literature related to eCPR is around about this. Return of spontaneous circulation implies a good rhythm, a reasonable mean arterial pressure, reasonable saturations that is maintained at least for 20 minutes without going back into a CPR situation again. And no flow is the definition of the time from when the patient is first arrested to any kind of CPR being started. And there is an important physiological reason to define this particular period of time. And low flow is arrest to the initiation of ECMO. We got that? Yeah. So when to do eCPR, age is an arbitrary factor. If it's a witness arrest, we have confined all our eCPRs to witness arrests either in our hospitals or in hospitals around the city. So we've gone to at least about 5 or 6 different hospitals, but it has been witnessed there and CPR has been started immediately. This is because the no flow time of less than 5 minutes and the low flow time of less than 60 minutes has been shown to improve outcomes or seems to indicate better outcomes than if it's much longer. That makes sense. The initial rhythm, whether it's VTAC or VF or pulseless VT, appears to have a better outcome. If you're doing conventional CPR and someone's massaging or defibrillating, and you are measuring the EtCO2 at that time, and if it is greater than 10 millimeters, it means that you have a reasonable level of flow, and that is associated with better outcomes. You're doing a massage, you're defibrillating, you get some rhythm back and forth, you get some blood pressure and it goes back. It's certainly better than not having asystole. If you come back into recurrent VF, which you have to keep shocking, that appears to be slightly better prognosis. You have to understand that this entire cohort of patients have a 100% mortality if nothing is done. Signs of life, they buckle, they cough, they turn around, they move their arms, anything. It's better than them not doing anything. And of course, you wouldn't do it if you have severe aortic regurgitation, dissection, or some terminal illness or severe neurodegenerative illness, or the family has talked about DNR before and someone's accidentally put out a call. You have to make sure these things, those are rare, but things you have to think about. So this is quite important in when a patient arrests, and this is something that we all know intuitively, but we may not have thought about in a detailed manner. This is important because all aspects of the ECMO is important. The first is the concept of a mean capillary filling pressure. I want to make this distinction from this being the mean pressure in the venous system or the mean circulating volume or the pressure driving the mean circulating volume. Mean capillary filling pressure actually refers to a concept of the blood that is in the venous, particularly in the venular system and in the capillaries, that cannot be drained out back into the heart with any amount of suction. So it doesn't matter how much suction you give, this will be the pressure in that circulating system when there is no flow. Even when there is flow, this will remain there. So what happens is the moment you arrest, your right atrial pressure and mean capillary pressure will equalize, so no flow happens. And why I say this is one of the important, people have this idea when you go on an ECMO, it's really that arterial flow, and sure, that is important, but it's also equal the suction that you apply on the right atrium or the venous drainage, because that re-established this gradient between the mean capillary filling pressure and the right atrial pressure. And that is shown to be as important, if not equally important, more important than the forward flow for these patients immediately. And the reason for this is because both the lack of forward flow and the high right atrial pressures or the equalization of pressures leads to a profoundly high pressure right through the circulating and the capillary system. This leads to leakage, interstitial edema. This is not the only pathophysiology that is happening. You have vaso and venodilation also because of systemic inflammatory response, which is the response of the body to anything catastrophic. Of course, in patients who are not used to a sudden exposure to low oxygen or high carbon dioxide, because they don't have any kind of disease previously, chronic lung or chronic heart disease, they develop a very rapid acid gradient. And of course, the fact that you're going to give back a lot of oxygenated blood to an essentially hypoxic system. In the hypoxic system, there's no oxygen for the electrons in the electron transport chain to go and latch on. So the moment you give some oxygen, a lot of electrons go on, reactive oxygen species, and that's a profound part. So people talk about some kind of antioxidant therapy that has to be concomitant with this. Acute pulmonary, just like you get edema right around the body, you can get it in the lungs also. This is also quite important. You won't be able to intubate the patient. So, and of course, the patient is hypoxic and the conduction system is also being bombarded. So the rhythm goes from something like VF, VT to an agonal rhythm. So all of these things can be offset by a multitude of things, not just the ECMO. You get the rhythm right, you defibrillate, maybe some kind of antioxidant therapy to recurse the or to reverse the profound oxidant injury that you're going to get, reduce the interstitial edema. So these patients are not passing urine and they're all bloated up, have a low threshold to stick a CRRT on this and start taking more volume out. So you may get these patients back, you may get a reasonable rhythm, you may get some SATs back and blood pressure. This is somebody with pulmonary hypertension who developed pulmonary embolism on top of that, came in fairly catastrophic. But here you're going to have this patient, but this patient is not going to kind of walk and get home just because you got them out of the recess. They're going to have a lot of inotropes, lactates are going to build up. So they can still make a case for going on ECMO to support it. I think there's been a lot said about the impeller. You do not use it as a first line very clearly. The go-to is a VA ECMO. If possible, if there's some rhythm, you go peripheral VA ECMO. If not, you do a central VA ECMO. And the reason is what I exactly said, a central VA ECMO or a peripheral VA ECMO. The moment you drain, the CVP comes down, you have some kind of mean arterial pressure. So you have established the pressure gradient. Then you worry about everything else. You can have a TE. We just talked about the various ways of monitoring this. So in that low flow state, make sure that you don't interrupt the CPR or the defibrillation too much. We have an extraordinarily great team put together by Dr. Madan and Sriram now with our anesthetist, who are all excellent. They can get in these lines very quickly. In addition, there is an interventional radiologist usually available and a vascular surgeon in case we need to get that peripheral distal cannula and there are problems with it. Use an ultrasound immediately out of the ECPR, check for cannula position. You don't know if this patient had a PE, check for clots. You can do that even before you go on, but make doubly sure. Make sure that the distal perfusion site's fine. So some of the things you need to watch out, if you're not getting an adequate preload, you're not able to get good venous return to the pump, it's going to be an inadequate flow, and that's not a good resus. So you have to see if you obviously, as I said, you got to try and mobilize some of that peripheral fluid. If you're unable to do it with just one cannula, you may have to insert an additional cannula. A peripheral VA ECMO especially is very, very sensitive to afterload. Remember, if it's usually in the femoral artery and the heart begins to eject a bit, or you've got your inotropes quite high, this will create a kind of narrowing between the afterload and preload across the pump head, and that's quite sensitive in centrifugal pumps. And then these last two can kind of illustrate, this is a patient who had CPR at that time. You can see the pH on the left-hand side is about 6.9, lactates around 10. We've got on ECMO. Things should have got better, but they really haven't. The lactate's gone up. The pH is not as well as you like. And the problem is the hemodilution that came at that time, the hemoglobin 6.4. Once you've corrected it, if you look at the timings, the first one's about 4 hours after the arrest, the second one's like a few hours after that. Once you've corrected the hemoglobin and you got better oxygen carrying capacity, it's an important thing. It's a simple thing, but these are quite important and easily missed in the kind of environment that surrounds these patients. And the next one is don't correct the carbon dioxide too quickly. So you got to control that sweet gas. So our experience with eCPR, out of the 296 odd ECMOs we've done over the last 12 years, we have done 13 eCPRs. It's about 4%. And about half of the ones we done got discharged. And this, in the literature, is anywhere between 15 to 50%, a very heterogeneous group of patients that undergo eCPR. The ELSO registry, even in that heterogeneous group, suggests around 29%. We are very careful. We don't give it to patients who've been resuscitated for over 90 minutes, agonal rhythm. So use some of those criteria I talked about. We were able to successfully wean patients off, but some of them succumbed to kind of infections later. One of them had a bridge to transplant. So when we talk about discharge, we're talking about bridge to recovery after an arrest. One is currently in hospital and he should be discharged soon. And about one out of 4 of them died on ECMO. With that, I'll finish, and I hope I kept time promise to Sundar. Thanks very much.
Thanks, Paul. That was wonderful. There is a lot of things which I had never heard of before. Thanks for enlightening us on that. I was just contrasting your talk with what Nicholas was saying before, where he, not about eCPR as such. It is okay to wait for a few hours.
Yes.
And then after a few hours, he's telling the lactate is going to go about 2 now.
Yes.
But on the other hand, we are seeing people with lactate of 6 to start with.
Exactly right.
Which is very different substrate, which we are.
Absolutely. I think this is a very important point. The time at which they refer to us and the kind of comorbidities we have is very different. There, the kind of way in which they quickly refer to the next level. He comes from an elite Guy's and Thomas's, and so their referral centers are also kind of honed in on that. I think if you, even in England, if you go to a district general hospital, you may not find what he's talking about. The lactates are going to be high comorbid. People don't really refer for ECMO. So he's in a very elite institute. I think the point he was trying to make was in cardiogenic shock, where he says maybe waiting for a bit and not waiting for a bit does not make that much of a difference on that study that he quoted. But I think as far as eCPR is concerned, the decision to quickly go and do something is, I think, there, because these patients have made a decision. And in India, once they've made a decision and maybe they've said okay to the money, which is the big issue, they want immediate action. They don't care. You can't tell them, look, but one study said we can wait for a little bit and see, and so on and so forth. So I think there is the cultural milieu in which we work, as well as the clinical milieu in which we work. So we've got to maybe look at our own data separately. So.
Sometimes we find somebody's toes are already blue before ECMO referral comes in.
Yes.
And lactates are high. And
yes.
pH is, like you said, low. So one of the meetings which Dr. Bartlett was here, he was mentioning when someone calls you for ECMO, if they have had a problem for longer than 30 minutes, you just go there and say, I won't put ECMO.
Yes.
You might eventually decide to put it, but at least next time they will call you a little earlier.
Yes, that's absolutely. I think Madan and his team and our team has now, we work a little bit more in sync with the intensive care, and people have seen outcomes. So they more, but you're absolutely right. I think earlier on, I think Madan has done somebody up to 90 minutes of massage and he's got them out, but you're right. But I think 60 minutes and 5 minutes for no flow and low flow is very reasonable, because that's what the data suggests is better.
So any questions from the audience? Thank you, Paul.
Thanks very much.
Thank you so much, sir, for an educative talk on eCPR. I would now like to call on Dr. Nikhil, sir, to shed some light on post-cardiotomy VA ECMO. Can I please request you to come on stage, sir?
Good evening. I'd like to thank the society and the organizers to give me the opportunity to present here today. My name is Nikhil Tekamparmbil, one of the cardiac surgeons at Apollo Chennai. So I'm talking about VA ECMO in post-cardiotomy patients. So we'll talk briefly about the current status, indications, timings, configurations that we use, usually the outcomes that we can expect, and what the particular barriers in this country are. So I use this paper for a lot of the initial information. This is by Sarat Chandra in the United States, 2019 data from the national inpatient sample. So this basically takes data from the insurance companies, and it includes 20% of the US population. So out of the 130,000 patients that got admitted with the diagnosis of post-cardiotomy cardiogenic shock, they were looking at the ECMO usage. So as you can say, over the last, or the 10 years that were reported, post-cardiotomy shock was increased, but use of mechanical circulatory support really hadn't increased as much. But what was key or was important to notice was that the use, the red line that you can see there is the use of intra-aortic balloon pump actually had come down over the 10 years, while the blue line in the small box, if I can get my arrow, I guess the arrow is not there. Anyway, so the blue line in the smaller box shows the use of ECMO, which is increased about 3 or 4 times from 2005 to 2014. And probably the SHOCK 2 trial was part of the reason why there's an increased uptake after 2012. The ELSO registry also shows an increase in the last 10 years in the use of ECMO in post-cardiotomy patients. So the incidence that is reported by most papers is between 2 and 6%. Indications are inability to separate from cardiopulmonary bypass or low cardiac output syndrome, despite maximal support, and usually an intra-aortic balloon pump. Interestingly, the post-cardiotomy ECMO is the most frequent indication for ECMO in the United States, and that's how I learned how to use ECMO. And a lot of the times it's a bridge to decision because the economics are not really involved when we have to put this in. So it's a bridge to decision. So if you can't come off bypass, if you have a catastrophic event post-op, then you put them on ECMO, and then you go from there. There are some prognostic tools like the Apache score, the SAVE score, but you know, and the most accurate of them supposedly is the Remember score coming out of China 2 years ago from Wang et al., which says the predicting mortality in patients undergoing veno-arterial ECMO membrane or ECMO after coronary artery bypass grafting, and supposed to be most sensitive for outcomes. So they look at 6 parameters: the age, left main disease, inotropic score, CKMB, serum creatinine, and the platelet count of the patients. They've assigned scores based on the retrospective data, and they separate people into 3 or 4 different categories. Class 1 with a 13% mortality, or a class 4, which is about 95% mortality. So usually, not sure if you really have time to sit and do all this. This is very useful in retrospective setting. Usually in a post-cardiotomy setting, these are more theoretical than actually practical. So according to the 2020 guidelines, essentially what they're saying is if you've had maximal pharmacological support with or without balloon pump, depending on how you're inclined, and if you're still having low cardiac output syndrome, you should probably put in the ECMO before or at the earliest signs of end organ damage or anaerobic metabolism. That takes us to the timing of when you would put an ECMO. So this is a study from Tom Fuchs, which actually looks at ECMO survival and the lactate level at the time of when the ECMO was placed. So was discussed here for eCPR. So if your lactate level is less than 10, your outcomes are better. It's very interesting that if you have coronary artery disease and your post-cardiotomy ECMO is after CABG, then your outcomes are worse. But still, if your lactate was less than 10, your survival was 33% as opposed to 10%. But if it is non-ischemic disease or for other cardiac surgery, then you have an 80% survival if you intervene early as opposed to late. So different configurations, I'm sure we've talked about a bunch of these. So the peripheral femoral veno-arterial ECMO is usually the commonest, especially if you're almost close to the patient or you're outside the operating room. This obviously the Harlequin syndrome or the watershed phenomenon is something that you would see. So one of the ways to avoid it is to do a 2-site veno-arterial ECMO. One is IJ venous drainage with the subclavian arterial infusion, Again, does not solve the coronary desaturation, but does cerebral desaturation. Central VA ECMO, again, if you're still open, this is probably one of the techniques that a lot of surgeons like to do. Commonly, the cannulas are tunneled under the xiphoid, but the key is to try to close the chest to reduce the amount of bleeding. The only problem, as you can see on the left side, is both your cannulas go on top of the RV. So as you are recovering and the RV starts to function, the cannulas tend to impede them. So if possible, you would want to tunnel the cannulas away from the RV, either go suprasternal or in the intercostal space on the right side. But the ELSO data is actually quite interesting, where in spite of central cannulation having its advantages, the survival or the in-hospital mortality is lesser for peripheral cannulation compared to central cannulation, and most of it was related to increased bleeding and blood products in people that were having central cannulation. After you've gone on, we had a talk earlier about venting or not venting. Well, if your ventricle looks like this after you've started ECMO, then you're not really necessarily helping the heart. So you should probably think of some way of venting. There is many different ways, as was previously explained. There's percutaneous ways and there is surgical ways, and you probably have to pick one of those. So when they looked at the different modalities of LV venting, the most common ones were obviously transaortic, which is Impella, which is used a lot in the United States, which we have done as well. Intra-aortic balloon pump was almost obligatory before, now it's plus minus. And then left atrial venting devices also have been used. Essentially, if you look at your ventricle and if you start seeing that your CVP is increasing, your ejection, your aortic valve is not opening and your ventricle is distending, you should do something about it. Otherwise, your ventricle is not going to recover, especially in the post-cardiotomy setting. So what are the special considerations for post-cardiotomy? One is to reverse anticoagulation. People are worried about giving protamine. I think you should give protamine. Meticulous hemostasis. 12, maybe even 48 hours of heparinless ECMO can be problematic when you have mechanical valves, but that would be the ideal way to reduce your bleeding. And then, of course, weaning from ECMO. There was a paper in 2011, which I thought had a very good way of assessing your patient on ECMO. So you reduce the flow to 1.5 liters and you see what their pulse pressure they're generating. If it's greater than 50, your EF at least 20 to 25%, PTI of greater than 10, and your lateral mitral annulus peak velocity of greater than 6. If you have all three criteria or four criteria, your chance of coming off ECMO is pretty good. If it's less, it's going to be more troublesome. And then the typical duration for post-cardiotomy ECMO, if they are going to recover, is usually 72 to 96 hours, which is typical time for stunned myocardium. So if you're unable to wean, then you have to look for reversible causes, pre-cardiac, intracardiac, post-cardiac. You have any cannula problems, you have aortic dissection, pneumothorax, pericardial effusion. So you have to go down the list. And if you have corrected those reversible reasons and you're still unable to wean, then you should think of your next steps. Is this going to be a bridge to VAD, bridge to transplant? Have difficult discussions with the family. Those are the things that need to be done. Going into the outcomes, in spite of the increasing use that we have seen in the last 5 to 10 years, the mortality seems to still be pretty high. About 60% of patients do not make it out if they go on ECMO. However, looking at the 5-year survival on patients that did make it through post-cardiotomy VA ECMO, they actually seem to be doing pretty fine. So about 60% of them, or 60 to 70% of them, didn't make it through the operating room or through the hospital stay. But if they did make it through the hospital stay, then their outcome seems to be pretty reasonable, or what could be expected of someone of their age. So if you look at someone younger, they tend to survive better than those that are older. But if they survive the event, then their mortality seems to be reasonable after that. Some of the barriers that I've noticed in this country, one is, of course, initiation costs, about 5 to 7 lakhs, not something that's easily affordable for most patients, and 1 to 2 lakhs per day, at least in this city, after the first 48 hours. Very resource intensive, 1:1 or sometimes 2:1 nurses to patient ratio. And then you need a perfusionist almost 24/7 to see or watch over the patient. and then high utilization of blood products. So might not be in the realm of many institutions, and then needs teamwork. So you might not have the same multidisciplinary team that you would need to get a patient through this, because it's not just the ECMO, but after that also. I was just briefly going through our database in Apollo for the last 10 years. We've seen about 12 patients that were purely post-cardiotomy, non-transplant, non-VAD patients, of which 4 of them were weaned successfully from the ECMO, which included one of my patients. And then, but only 2 of them were discharged alive. And my patient actually died 1 month after decannulation of ECMO from lung problems. So these are very, very sick patients, and outcomes are less than ideal. So key points, scores are helpful, but surgeon's assessment of reversibility is the best. So if you know why there's myocardial stunning, then you probably have a better chance of advising the family or the team to go ahead with the ECMO, especially when cost constraints are there and you can't just bridge to decision. Implant early before acidosis and end organ damage. Prophylactic ECMO placement in the OT, again, something that we did in the US, which might be harder to do here, which is better than having a crash in the CT-ICU. And then meticulous hemostasis and close the sternum whenever possible. Obviously, if your RV is dilated, you might not be able to, but if you can, you should. And then protamine and heparinless support for first 12 to maybe 48 hours. And if there's no recovery after 4 to 6 days, then you have to decide bridge to what. Thank you. Appreciate any questions.
Thank you for that excellent presentation. I have a question. What would your strategy be for venting the LV in a post mitral valve replacement with a mechanical valve or bioprosthetic valve?
So we were, yeah, so I've done that only once, and we were actually able to do it with an impeller. So we were high, like Purna was saying, we did use impeller a lot, but we usually made that decision 1 to 2 hours later. So almost all of them had a balloon pump. We didn't take the balloon pump out when we put the ECMO in. And on this particular patient, the LV continued to dilate. So we actually put in an impeller. And then, we were able to get him through with that. But that was the only experience I had.
Because impeller is usually not an option because of the cost. It's just,
correct. Yeah, here I think all the decisions are more complicated. Yes.
In our institution, we don't charge for post-cardiotomy ECMOs.
That's fantastic.
Because that goes as part of the, if complications happen, it is covered under the package. So that is not a concern. But impeller is just too much for that.
Yeah.
If you look at, so I've always wondered what is the best way to decompress the LV when you have a valve in place, because now the aortic valve is not opening, and since you're draining the LA, this may be sitting closed.
Correct. So we've had similar experience in training where the entire left atrium was clotted off.
So
and then
what
you have
we
to
have done so far is to go from the side and put a LV apex cannula, because we can no longer lift the heart because of the mitral valve.
Yes.
So you do a separate thoracotomy and then put in a cannula on the left side. So that's what we've done, and we've got a fairly large number of post-cardiotomy ECMOs. We don't.
Have you published? I was looking for studies from India. I didn't find. You should.
I think Varun himself must have done a large number. You want to see
About venting.
post-cardiotomy ECMO in general.
Yeah, like you described, we too have a low threshold for initiating ECMO on table itself. So usually our strategy would be to insert the cannulas. If we are not able to wean off CPB, we don't try to at all. We directly tunnel in the lines, correct the cannulas, go on ECMO, and give protamine, bring down the ACT to about 160 or 180. And then, like you said, for about 48 hours, no heparin. Try to close as much as possible because of the oozing of the sternum, and we don't this thing. And if we have to put in an LV, vent, it will usually be an left ventricular vent. Apex, LV apex.
You don't have bleeding from there?
No, because it's the drainage. It's the drainage vent. So it's been sucked down. So you never see bleeding around the cannula. Yeah. Suck, yeah.
Thank you. Or any other questions? Thank you.
I have a quick announcement. I bring good news this time. Dr. Madan Kumar and Dr. Sriraman have been kind enough to discuss these during the ECMO workshop on Sunday. So we are effectively canceling these two. And Dr. Aditi Singhvi will come and talk about evaluation of right ventricle disease in the next session, so that we can cancel the whole session there and these two talks and try to, come up to speed. And I think we will still be able to close in the correct time. Thank you. Well.
Yes, sir, we have. Yes. Just hold the type, please. Thank you.
I clicked on. Yeah. Good evening, everyone. Thank you so much to the committee for having me. So switching gears from cardiogenic shock, I'm going to be talking about evaluation of right ventricle in lung failure. And my disclosure is that I'm a cardiologist, not a transplant pulmonologist. So I'm really going to be focusing on the mechanics of the right ventricle, the contractility, and its importance in lung disease. So this is the outline of my talk. First, starting with the RV adaptation to lung disease. So the RV adaptation to lung disease is determined by the degree of pressure overload, volume overload, and alterations in intrinsic contractility. These three situations have distinct clinical causes, and the therapeutic approach, although commonly they coexist in various degrees as well. So this is the structure of a normal right ventricle, which we know is a thin-walled compliant structure. In pressure overload, we see hypertrophy, dilatation, systolic septal flattening, and extensive fibrosis. There's reduced myocardial deformation with dysynchrony and systolic shortening as well. In this condition, we see the highest increase in end systolic elastance as well as arterial elastance, which we will discuss later on, are key measurements of the intrinsic contractility of the right ventricle. In volume overload, we see dilatation and diastolic septal flattening. There's mild fibrosis and near normal and synchronous myocardial deformation and coupling of the right ventricle and pulmonary arteries preserved. The cardiomyopathic right ventricle is more about intrinsic myocardial diseases, so not really relevant to this topic, but this can be seen in conditions such as ARVD. So the right ventricle is very sensitive to loading conditions, preload as well as afterload. We're seeing over here that with increases in the pulmonary arterial pressure, there is a steep decline in the stroke volume of the right ventricle, and contrast that with the functioning of the left ventricle. There are certain additional changes with chronic lung disease that we see that also impact the RV function. So chronic hypoxemia, disruption of pulmonary vascular beds through parenchymal loss and fibrosis contribute to increased ventricular afterload. Certain lung diseases such as interstitial lung diseases associated with scleroderma inherently cause pulmonary hypertension as well by causing arterial remodeling. Generally, there is some degree of hypertrophy in all chronic lung diseases, but myocardial contractility and cardiac output are generally preserved. Development of pulmonary hypertension and RV dysfunction happens only in the late stages, and it does worsen survival in chronic lung disease. There is also alteration of the right ventricle and left ventricular function by changing intrathoracic pressure. So lung hyperinflation, like in COPD, increases right atrial pressure, which reduces venous return, which reduces RV preload, causes global RV dysfunction, and LV underfilling. Also, highly negative pleural pressures may be necessary to facilitate ventilation in COPD or during episodes of airway obstruction and sleep apnea. These highly negative pressures also reduce intrathoracic pressure and increase LV wall stress during ejection, potentially resulting in LA hypertension and increased afterload. So classically, the end result of RV dysfunction in lung diseases is called cor pulmonale. Generally, in lung disease alone, RV failure is rare except for in acute exacerbations. So why do we care so much about the RV in lung disease? What is the importance? So we know particularly in pulmonary arterial hypertension, where there is increased pulmonary vascular resistance, RV overload, eventually it leads to RV failure and death. Patient's clinical status and prognosis depends on the capability of the RV to adapt to the increased afterload, maintain function, and preserve cardiac output. Numerous studies have shown that when there is a preserved RV ejection fraction and it stays stable over time, patients have a better prognosis, as shown in black over here. And when the RV-EF declines over time, those patients have a poorer survival. Even in pulmonary fibrosis, the development of pulmonary hypertension has been shown to predict a poorer prognosis. So with increasing PA pressures, there is a decline in the PaO2, decline in DLCO, as well as poorer survival. The RV function also has prognostic value after lung transplantation. So after lung transplant, there is a significant improvement in pulmonary arterial pressure and RV strain. However, post-transplant, RV function correlates with outcomes. So it has been shown, so these are images of echoes pre-lung transplant and post-lung transplant, and we can see a significant improvement in the fractional area change, reduction in the tricuspid velocity, tricuspid regurgitation velocity, and improvement in the RV strain. However, patients who had RV dysfunction post-transplant, shown in green over here, these patients have the poorest survival. Interestingly, there are no pre-transplant RV parameters that have been shown to predict all-cause mortality in the case of chronic lung diseases. So this suggests that even though there is increased PASP and reduced RV function, it should not discourage clinicians from considering lung transplant, or that we need more sensitive markers to detect subclinical RV dysfunction. Next, coming to evaluation of the RV. So we should evaluate the RV in a holistic fashion. This consists of various components. First is obviously clinical examination that includes history, physical examination, as well as biomarkers, imaging like echo and MRI, which we'll go over in detail in the coming slides, hemodynamic evaluation, functional imaging as well with exercise, and metabolic imaging is currently mostly of research interests only, but metabolism of the RV can also be assessed with various modalities. So these are signs that you're all familiar with, so I don't have to go over with this audience, but on physical exam, your exam should be concentrated on signs of RV congestion as well as RV forward failure. It can be difficult to distinguish symptoms associated with lung disease from those associated with pulmonary hypertension and RV dysfunction, since dyspnea is a ubiquitous symptom in these patients. Also, certain auscultatory findings of RV failure can be limited by chest overinflation and chronic lung diseases. Other clinical markers include arrhythmias like atrial fibrillation, wide QRS duration can signify RV dyssynchrony, elevated BNP, and elevated troponin. You'll see ECG changes of P pulmonale, right axis deviation, RV hypertrophy, RV strain, and right bundle branch block suggesting dyssynchrony. Now coming to imaging, our imaging should focus on the structural characteristics of the RV as well as the functional characteristics. So the structural characteristics of the RV can be defined by several parameters, and these can be calculated on echo as well as MRI. So important parameters that should be evaluated include end diastolic volume and eccentricity index, which is the ratio of the diameter of the RV to the LV. So a diameter that's great, an index that's greater than 1 suggests RV pressure or volume overload, and delayed enhancement on MRI suggests fibrosis. So these are indices of RV contractility, which are important. It is important to also note that most of these indices that we commonly use in clinical practice are very dependent on the loading conditions. That means preload and afterload. So if you have a compensated patient, then these parameters will look better. If you have a decompensated patient, then these parameters will look worse. So none of these parameters are true measures of RV contractility, which is what we are really interested in. So RV ejection fraction, Normal range is around 60%. The best method to calculate this now is using MRI. 3D echocardiography can also be used, but is subject to good windows. RV fractional area change, TAPC, but TAPC also has several limitations, and it can also be impacted by movements of the heart within the chest. Post-surgery also, it is not going to be accurate. Then tissue Doppler imaging to calculate the S prime. RV strain is a newer index which is also being used now and is being shown to be quite a good correlate of RV function, though again, this is load dependent. So these are echo images that I'm sure you're all familiar with. And most of these features are very prominent in pulmonary hypertension, pulmonary arterial hypertension, and less so in chronic lung diseases by themselves, unless it is very advanced. So on echo, we'll see RV enlargement, pericardial effusion. These are the views that should be looked into based on the American Society of Echocardiography as well as European Society. So the long axis view, short axis view. In the 4-chamber view, you'll see dilated RV and with a basal RV to LV ratio that is increased. This is the view that we calculate fractional area change in, TAPC as well as S prime, and enlarged right atrium, increased tricuspid regurgitation velocity. Then in the RVOT view, you'll see dilated pulmonary artery and the RVOT acceleration time of pulmonary ejection. This will be reduced to less than 105 milliseconds when you have severe pulmonary hypertension. So this is this is the reduced pulmonary arterial acceleration time, which we can see in pulmonary hypertension along with a mid-systolic notch. And just for reference, this is what a normal ejection would look like. These are markers of function or contractility that we get on echocardiogram. So this is TAPC, RVS prime, fractional area change, which is basically the difference in the area between systole and diastole, and a newer marker, which is strain. So strain basically picks up the deformation of the RV in the longitudinal axis, transverse axis, and radial axis. Additional echo parameters are TAPC, to PA-SP ratio, early diastolic pulmonary regurgitation velocity, as well as dilated IVC. So it is important to note that Doppler echo is unreliable in 1/3 of the cases, at least, for estimating the pulmonary arterial systolic pressure. So this is not what should be used. A right heart cath should be done to evaluate the PA-SP. MRI is now the gold standard for assessment of the RV. So RV ejection fraction, RV volumes should be calculated based on MRI if feasible. So MRI is really good for delineating the morphology. Same features that we saw on echo, you'll see over here with an enlarged RV, the septal bowing as well, increased right atrial size. The MRI is very good for calculating RV volumes as well with extreme accuracy. And the measures of contractility that we looked at on echo can also be calculated using MRI now. So for instance, the TAPC, S prime, as well as fractional area shortening can all be calculated on MRI as well. All these MRI parameters have also been shown to correlate with outcomes. Stroke volume index derived by MRI, and diastolic volume indices and RV ejection fraction have all been shown to correlate with survival as well. Strain can also be calculated using MRI. Next, coming to hemodynamic assessment. So important hemodynamic parameters to assess the right heart function include RA pressure, and RA pressure of greater than 15 suggests significant right heart failure. PA pulsatility index, which is the PA systolic minus the diastolic pressure divided by the right atrial pressure. When it is low, it suggests right heart failure. RA pressure to wedge pressure ratio suggests right to left discordance of filling pressures. And if it is greater than 0.6, suggests right heart failure. RV stroke work index is not a parameter that we calculate very often, but again, it is a very good marker of RV function, calculated using the mean PA pressure minus the CVP times the stroke volume index. Pulmonary vascular resistance. PA compliance is another measure that we don't use very often, but this is a better measurement of the pulsatile load in the pulmonary arterial bed. So this is the true load that the RV is facing. And this can be calculated using stroke volume divided by the PA pulsatility. So challenges that we encounter in the assessment of RV contractility. On imaging, we know that RV has a complex geometry. The infundibulum itself is not well visualized, and about 30% of the RV volume is in the infundibulum. On echo, the heavily trabeculated RV endothelial border can obscure viewing. Again, on echo, the retrosternal position can sometimes obscure viewing. In patients with COPD with hyperinflated lungs, they can have poor acoustic windows. And then virtually all the indices that we use are load dependent. Invasive assessment of load independent contractility and physiological reserve is indirect and inexact right now. The dP by dt, which we can get on hemodynamic measurement, is also load dependent. And the only way to truly know the load independent contractility is using conductance catheter pressure volume loop analysis, which is limited to research. So in the last few slides, I'll just quickly go over RV-PA coupling, which is an important physiological concept, particularly in the context of pulmonary arterial hypertension. So this is a normal pressure volume loop of a right ventricle. And in the case of pulmonary hypertension, when there is preserved RV pulmonary arterial pressure coupling, then the end systolic elastance to the arterial elastance is in the normal range. So in this case, the pressures are increased, but the RV volume is preserved, stroke volume is preserved. So these are patients who are well adapted to the pulmonary hypertension. In advanced cases, when the RV truly starts failing, there is RV-PA uncoupling. So these are cases when the RV will be enlarged, there will be decline in the stroke volume, and the end systolic elastance to arterial elastance ratio will be reduced. It has been shown that end systolic elastance to arterial elastance is a much better method of calculating RV-PA coupling, and ejection fraction is not a good indicator of RV-PA coupling. So in clinical practice, how can we calculate this RV-PA coupling? So stroke volume divided by the end systolic volume. These are measurements that we can get based on echo, MRI, and right heart catheterization. This is not an exact way to get the RV-PA coupling, but it is probably good enough in the absence of using pressure volume loops. So this is something that we are interested in knowing when the RV has maladapted and it has truly started failing. RV-PA coupling is also related to RV reserve. So as we see, when you have a better end systolic elastance to arterial elastance ratio, there is increased stroke volume reserve. And this RV reserve also correlates with parameters that we can measure during exercise. So if PA pressures do not increase during exercise, shown in blue over here, you have the poorest survival. And if you have a low peak VO2 on CPET, then you have a poor survival as well. And combining both of these parameters gives you the best prediction of survival. Specifically, looking at RV function in the context of lung transplant, there is poorer outcomes in patients who have pre-existing moderate to severe PH, have pulmonary fibrosis, or do not show recovery of RV function after transplant. It is recommended that the pre-op right heart cath should be performed to assess pH and RV function in all patients. And a pragmatic approach is also to clinically assess hemodynamic changes and response to inotropes during transplant after clamping the PA, and to derive from this an appropriate risk stratification regarding the occurrence of RV failure. So to conclude, it's all about the RV. Poor prognostic signs by hemodynamics include high RA pressure, low cardiac index, low TAPC on echo, RV dysfunction by labs, for example, elevated BNP, impaired renal function, impaired liver function, and a patient who is functionally advanced. And importantly, high PA pressure alone is not a consistent predictor of poor outcomes. Thank you.
Thank you, Aditi. I just wanted to make a comment on the RV circulation in a hypertrophied RV, which some of us who are in the transplant or CTF space face. Pretty much like the left ventricle, the coronary blood flow in a hypertrophied RV happens predominantly during the diastolic phase. In a normal RV, it is continuous, as we know. So it is very important to maintain a good diastolic pressure when you are finishing an operation, coming off bypass, etc. And in order to do that, you have to maintain a good SVR. So a lot of times we tend to use milrinone and the SVR goes down. And then you get a coronary steal phenomena happening, and the right coronary doesn't get it supplied adequately. So in these, particularly in transplants and other areas where the RV is hypertrophied, it is very important to maintain a reasonably good SVR. The other comment I wanted to make is you had mentioned that Doppler measurement of peer pressure peer pressure by Doppler is very inaccurate. And before you, Dr. Purna also had said about PVR. What I have always thought is when a cardiac transplant surgeon is willing to accept a patient for heart transplant based on echo measurement of peer pressure and PVR, then I will agree that it is a good measurement. I don't think as of now that happens.
Absolutely. So those are important points that you've made.
Any other comments? All right, thank you.
Thank you so much, ma'am, for such an illustrative talk. The next session is, of course, going to be very enlightening for us registrars because it's a session on imaging in heart failure. And for that, I would like to call on Dr. Shelly Simon, Dr. Madan Kumar sir, and Dr. Indrani ma'am on stage to moderate. The first talk is going to be on nuclear medicine in heart failure, and it's going to be given by Dr. E. Prabhu sir. Can I please have you on stage?
I'll invite Dr. E. Prabhu to talk on nuclear medicine and heart failure. He's the head of the Department of Nuclear Medicine in Omandurar Medical College. He played a key role in developing the unit and successfully running the program in a government setup that have to be appreciated. Dr. E. Prabhu, over to you.
Thank you, Dr. Madan, for kind introduction. And thank you, chairpersons and my dear friends. This is going to be quite interesting in the sense, what is nuclear medicine has to say in heart failure? A lot of things that can be discussed in nuclear medicine, but due to time constraints, we will be as brief as possible. What really happens in a failing heart? The moment it is hypoxemic, it is not having adequate circulation, it switches over to glucose metabolism. In the sense that whatever remaining amount of oxygen, it tries to maximally utilize to make a lot of ATPs to generate adequate energy. It not only uses glucose, it burns as the fat, it burns as proteins, peptides, whatever is available, and the failure mechanism sets in. These are the various processes. Like hypertrophy sets in, then there'll be programmed cell death, non-programmed cell death, fibroblasts. Then we have a lot of immune system cells that come into play. The endothelium also has a lot of important chemicals, inflammatory mediators to be secreted, and the heart doesn't keep quiet. It has a lot of extracellular vesicles, microsomes, exomes, macrosomes. It throws out a lot of particles with containing RNA signals, communicates with the heart, communicates with the kidney, communicates with the lungs, liver, and a lot of whole dynamic orchestra happens in the metabolic milieu. If only we have an ability to introduce a tracer to all this mechanism, we'll be able to visualize what exactly is transpiring at the molecular level. Not only that we can visualize, we can quantify it, give a three-dimensional structure to it, and follow it up. What is the response to various treatment methods, whatever we adapt? For this, we need this equipment called as this is the SPECT CT. This is the one which is commonly available in most of the nuclear medicine establishments. And the PET CT has come a big way into our country, especially in the private sector. We have almost 38 PET CTs in Tamil Nadu alone, nothing in the government. And for this, these are the traces which we are using. The commonest we are using is the sestamine and tetraphosphine, which gets into the mitochondria. And this is thallium, which we were using in previous days. And it mimics the potassium ions. We were using rubidium-82, oxygen-15 labeled water, and so many other traces. We call this a traces. We don't call it as a dye because we're going to inject a very tiny microgram, nanogram level of substances. These are very safe. It can be introduced to whatever your level of serum creatine level, so that we'll be able to measure the various metabolic processes that is taking place. This study we performed a couple of days earlier. This is about 65-year-old man who is a diabetic, hypertensive, complaints of chest pain. And when we do a myocardial perfusion study, what we can see here, almost a uniform uptake into the ventricle walls. This is almost a normal study. On the other hand, a younger individual, 42 years, IT professional, diabetic, hypertension, and history of coronary artery disease. You can see the hugely dilated ventricle. You can see the perfusion defect here. Normal myocardium, it is rich in mitochondria, so it is almost a uniform uptake is seen. When there is myocardium is ischemic, there is decreased mitochondria, the myocardial the uptake will be slightly reduced. If it is infarcted, that means there's a dead tissue, no mitochondria, so the tracer will not be seen. This is how we are able to see in the nuclear images. This is another way of image processing, where we can see the ventricle here, and this is a generic coronary artery image that is being projected on the image on this ventricular reconstruction. This is how the normal ventricle looks like, and the ischemic, the dilated ventricle in the heart failure, this is how it looks like. The same patient, we did a CT, where we can see a near normal heart on the lung, whereas in heart failure, we do come across patients with pulmonary edema, pleural effusion. All these things can be seen when you do a correlated CT. This is now the modern trend. We just don't limit with the structural imaging like PET and SPECT. We correlate with SPECT and CT and MRI. So this is the fusion imaging or multimodality imaging. That's what is happening nowadays in almost all the centers. So the current trend is there are a lot of diabetic diagnostic challenges that are being thrown up to a physician in heart failure imaging. There are challenges in failure in the cardiomyopathies, in imaging the vascular and valvular diseases and arrhythmias. And these are the challenges. We use a lot of wide variety of tracers, whether it is tetraphosphine and the hypothetical tracer, which will be in future. I think Dr. Shelley will be able to see about the fluperidas. This is going to be more extensively used in myocardial perfusion imaging. And there are a lot of other tracers which mimic this catecholamines, and we will be able to understand the presympathetic, the adrenergic receptors that are present to the myocardium. When we were all thinking about the stress and rest imaging, because as a standard dictum, we have been administering stress by using pharmacological stress. Adenosine is what we have been using consistently in our setup. And then what happens is they found out it occupies plenty of time. There were certain situations where some of our workers, we felt that the stress alone is enough. The study in a myocardial perfusion stress imaging is adequate. We need not follow up with the rest images. So what happens is the patient is getting benefited. There is decreased steady time. We can administer very low dose of medications, and it also reduces the cost. What happens is then they compare in nuclear medicine. What happens is they compare the myocardial stress alone imaging with stress and rest imaging in various clinical conditions in diabetic heart disease, women with coronary artery disease, and if they found a good correlation in the sense that the studies are confirm that stress imaging alone is enough for determining the heart failure and ischemic heart disease. There was a meta-analysis which are done about 20,400 patients, and they electronically chose the images by artificial intelligence, and they found out these are the patients who will be maximally benefited by doing stress alone imaging. The same workers worked on yet another study where they evaluated around 35,000, more than 37,000 patients, and they confirmed just stress alone myocardial perfusion imaging is enough for evaluating in heart failure. So this is the algorithm. Whenever there is a strong clinical suspicion of heart failure, we do a stress myocardial perfusion study, classify it whether it is HPF or HRF. When there is extensive coronary artery disease, we go for a viability study and revascularize. If it is not viable, straight away send for guideline-directed medical therapy, ICD, CRT, LVADs, DVADs, or transplantation. And if there is no extensive coronary disease with varied florid clinical presentations, we do a atypical MIBG SPECT. When the MIBG SPECT is seen, we will be able to identify the neuronal distribution or the sympathetic innervation of the heart. And if there is, we can also use other modalities for identifying amyloidosis and sarcoidosis. This is what we were doing with 123 iodine MIBG SPECT. This is the planar imaging, where once the particular study is being done, we compare the heart to mediastinum uptake. When the heart to mediastinum uptake is very prominent, the sense that we are able to see the myocardium uptake prominently, these are the patients who are having good prognosis to whatever heart failure treatment we administer. On the other hand, with heart to mediastinal uptake, which will be less than 1.38 ratio, these are the patients who are likely to throw up a lot of arrhythmias, and it's going to be difficult prognosis. When there is literally no uptake in the myocardium in patients with heart failure, these are the patients who are found to have poor prognosis. And there was an ADMIRE HF study, which was done in about 965 patients, and it just confirmed the similar findings. When we did a cardiac SPECT with all the MIBA, that is myocardial perfusion imaging with MIBG, the adrenergic receptor imaging, and another about 961 patients, it helps us to quantify who are the patients who will be maximally benefited. There are other imaging, whenever there is a strong clinical suspicion, heart failure, bradyarrhythmias, we use technician level pyrophosphate imaging. We have been doing a lot of studies of late. And if when the studies are prominent, we think in terms of pyrophosphate, that is ATTR amyloid proteins uptake is prominent. And this is how the algorithm we work out. And this is how we stage it. And whenever we don't see the uptake in myocardium, in the heart, then we say it is almost, we compare with the tracer uptake in the ribs, we compare to the heart. When there is nothing, it is grade 0. When it is minimally present, less than that of ribs, it is grade 1. If it is almost equal, it is grade 2 and grade 3. These are the patients whenever we see a prominent tracer uptake with the technetium pyrophosphate. These are the patients who are rich in cardiac amyloid, predominantly ATTR amyloid. There are other questions like cardiac involvement and sarcoidosis. And whenever there is a strong clinical suspicion and extra cardiac incidence of sarcoid, like in this particular study, we can see the lymph nodes having sarcoids, and there is intense uptake in the lateral wall of the ventricle, and these are the inferior wall of the ventricle, and these are the areas which are prominent in cardiac sarcoid, and this helps us to follow up with immunotherapy. On the other hand, a similarly dilated heart where there is no uptake in the myocardium, this is negative for cardiac sarcoid. It is dilated cardiomyopathy. Nowadays, we have florid, a lot of lipid-lowering drugs that are available in our armamentarium, and we want to follow up what is the effect of the lipid-lowering drugs. We can use myocardial perfusion imaging, which is commonly available, and with SESTIMA-B, we can use this neuroreceptor imaging by MIBG, and we can also image the inflammation and fibroblasts by FAPI or gallium-68 pentoxifer. So now that we have come to gallium-68 pentoxifer, it helps us to image the CXCR4 transmembrane protein. That is a marker of inflammation. And it helps us to, if it is present in the infarcted area, these are pro-inflammatory cells. And when the intensity of uptake of gallium-68 is high, so the patients can develop less of scare, the response to treatment will be prominent. On the other hand, if there is less, there is increased incidence of scar tissue. Similarly, this is for the FAPI imaging that helps us to find out the distribution, to understand the distribution of fibroblast infiltration. And it helps us to understand whether the scar tissue level is prominent and due to the various inflammatory mediators that have been expressed. And these are the patients to what extent they'll be able to develop scar tissue and what will be the kind of ventricular remodeling we'll be experiencing. Another thing, what we can see is by evaluating apoptosis, we use a tracer called 99 technetium annexin 5. It was previously it was very exhaustively available, but then due to less of demand, the number of studies have come down drastically. But this, whenever we can see there is increased uptake of annexin 5 here in the system B, there is decreased perfusion in the anteroseptal region, whereas increased uptake of annexin 5. These are the areas where apoptosis is set in, and it helps us to plan accordingly.
It's a very good talk. I like to hear more and more, but pressure from the organizers regarding the time.
Just give me a minute.
Yeah, thank you very much. Sorry.
I'll give
Very
me a
sorry.
minute. So there are a lot of parallelly, lot of interesting technological developments that are happening. And so in nuclear medicine, we want to study the LV geometry, function, geometry, dysynchrony, and all those things. We use a conventional spec CT with ECG gating. We can study myocardial viability, myocardial perfusion with cardiac imaging PET. Then with sympathetic innervation, inflammation, apoptosis, amyloid deposit, heart transplant, almost every aspect of heart failure, you'll be able to visualize and quantify in nuclear imaging. Thank you.
Yeah, thank you, Dr. Prabhu. It was a very nice talk. And there is one small comment on this, that the most commonly used study now for the viability study, I think we use the FDG, and that is to identify the hibernating myocardium. So the faster we identify before the LV remodeling, if we intervene, then there are a lot of chances that patients can get revascularized.
That's true. That's a very important comment. Yeah. Whenever you do a myocardial perfusion study with FDG PET, it helps us to quantify the ischemic myocardium. And if only we'll be able to revascularize this particular area, we'll be able to restore the viability. Yeah. Thank you.
Thank you. Any questions from audience?
Nicely covered all the traces. Congratulations on it.
Thank you. Thank you.
I request Dr. Madan, consultant radiologist, to talk on the role of MRI in heart failure.
Thank you so much, sir, for such an illustrative discourse. Can I please have Dr. Madan on the stage, please? Yes, yes. Thank you.
Okay, by the time I'll just start. So I guess it's good evening, and I thank the organizing committee for the invite. May I have a show of hands, like how many of you have access to dedicated cardiac MRI services at your hospital or at your practice? Okay, thank you. So given the time constraint, I'll just try to keep it short. So as we all know, there are 4 common imaging modalities to image the heart in a heart failure. One is echo, which is the routinely and widely practiced one. And then comes the other 3 modalities, which are nuclear medicine, as Dr. Prabhu has detailed in the previous session. So out of these 4, echo and CMR obviously are non-ionizing radiation imaging modalities. So what is more special about the CMR is that unlike echo, it is independent of acoustic issues with windowing, and it offers an excellent contrast resolution. In addition to the, can I do this one? Either one. Pointer. Cursor won't work through. Cursor won't work through. Show it on the picture. Sorry for that.
You can go directly there and like use a remote exchange.
That's very difficult. Huh? Okay, I guess I'll just skip that because most of the slides does contain an images, so I just wanted to show that to you. So anyway, this is next now. Which one should I use? This one? So, okay. So with a good spatial resolution and temporal resolution, MR offers a wonderful imaging of the myocardium, and it is considered as a gold standard for quantification of the LV function and the RV function as well. So given the characteristics of MR in visualizing the myocardium directly, and also there are multiple parameters by which you can characterize the myocardium, we can identify specific etiologies and we can narrow down the causes of left ventricle failure. So when it comes to disadvantage, the major disadvantage is that the availability. The MR is not widely available, and even the MR is available, the cardiac sequences and dedicated radiologists, there is a kind of a limitation there. And of course, some of the scans are quite longer, and some analysis like a strain analysis as you do in echo, in MR it is quite time consuming once the scan is done, right? So heart failure, as you all know, it isn't. Okay, thanks. So it's a multi-faceted entity, and I'm not going to go into that. So I'll be talking about preserved ejection fraction and reduced ejection fraction, and most of the cases fall into the spectrum, and we end up imaging the patient at some point of time, right? And the role of MR has got two major things. One, you evaluate the patient, and then you look into the etiological factors, and you arrive at a diagnosis. And then there are multiple parameters that MR can offer you to prognosticate the patient with heart failure, right? And this is the guidelines that has been given by the ESC, where MR definitely plays a very vital role. And it is the recommendation by the society where MR plays a very important role in cardiomyopathies, infiltrative disorders, storage disorders, endomyocardial diseases, so on and so forth, right? So let's just quick word. So this is one of the bread and butter investigations that any of the cardiac radiologists would do. So diagnosing LV systolic impairment is pretty easy, but the problem comes only when do you like to diagnose the pathology or the underlying etiology of the LV dysfunction, because the phenotype, the end result of most of the cases which result in LV systolic dysfunction is a dilated phenotype, and you tend to have multiple scars in various patterns and forms. And this is a gross algorithm where the step one, as we all know, that you just exclude the major common diagnosable etiologies like CAD or a congenital heart disease or valvular heart disease and arterial hypertension that would have led to heart failure. And then MR plays a very vital role in step two, where you can identify some of the diagnosable etiological causes, which here you can look into the HCM, which has resulted in a DCM picture, a restrictive cardiomyopathy, which has resulted in a dilated cardiomyopathy, or peripartum, or any toxin-induced cardiomyopathy, or an acute conditions like a Takotsubo or an LV non-compaction. So finally, when you're not able to differentiate or put the patient in any of these categories, you just establish an undifferentiated dilated cardiomyopathy, which usually is because of a genetic or an autoimmunization pathology. And you have to understand that most of the cases, about 50% of the cases, it's just not possible to give an etiological diagnosis with MR as well. So when you talk about cardiac MRI, the talk is always about this one specific sequence, which is a late gadolinium enhancement. And for the junior residents here, I think it's something that you have to at least take home message. So unlike the other MRI, like brain MRI, where you do a T1 imaging and then you do a T1 post contrast to compare whether there is an enhancement or not. Whereas in myocardium, what we do is there is a sequence wherein you null the normal myocardium. So the normal myocardium will be like black. So if at all there is an enhancement, it is going to come and pop at your eyes and it's going to be white. So anything you see white in that particular sequence is abnormal. So based upon the pattern within the myocardial thickness, it's about like 10 mm of the myocardium. So if you see what kind of, how it is involved, that is number one. And what is the distribution over the entire left ventricle. So based upon these two things, we can fairly arrive at a reasonable diagnosis with cardiac MRI with this conventional imaging alone. So there's one of the major distinguishing factor for an ischemic cardiomyopathy is you see a subendocardial involvement, and from there, whatever, any length of transmural spread, it can be a full. But without the involvement of subendocardium, an involvement here or somewhere here does not correlate with ischemic pathologies. So anything apart from this is non-ischemic. And yeah, the ischemic one, this in addition has to follow the coronary arterial territory. So because there is one condition where you can get a global endocardial enhancement, which is seen in amyloidosis or systemic sclerosis or in post-transplant cases. However, the depth of penetration is quite varied. There are associated other findings as well. So this is a mid-wall enhancement, and this is the RV hinge point enhancement, and this is another mid-wall enhancement in the lateral wall. And this is, we call it as epicardial. So anything apart from this is categorized as non-ischemic etiology. So, here, so ischemic cardiomyopathy, you see a regional wall motion abnormality like you see in echo, and you can also see a myocardial thinning, and there is a corresponding enhancement in the post-gadolinium images. So you can just diagnose it as ischemic cardiomyopathy. But there are certain pitfalls, which I think it's more of a radiological issue. So there's one thing that you have to take home is, even though we see a classical subendocardial pattern, sometimes there might not be a coronary artery disease in an angiogram. So in about 15% of the cases this happens, and this is probably because there is an embolic phenomenon or a transient event that has happened. But there are, or in a cases where, say for example, a sarcoidosis or any other inflammatory pathology, the associated vasculitis component can lead to this kind of a picture, right? So this is a patient, 66-year-old male. Here you can see this is in cine images. Here there is a global hypokinesia, and here if you can appreciate, there is this part of the left ventricle dilates a little bit more hypokinetic. It's not moving. So anyway, okay, unfortunately these two scenes are not moving. But anyway, so here now you can appreciate that this is a delayed enhancement sequence, which I already told you. You can see that there is a subendocardial enhancement, and this is the normal myocardium, which is completely black. And this follows the LAD territory. This is the long axis view. We can see the anterior wall, LV apex, and this is a wraparound of the LV apex, which exactly corresponds to the LAD territory. And this is an ischemic pattern of cardiomyopathy. And this is another patient who is a 25-year-old male who had so I don't know if you can appreciate here. So this in the cine images, these compared to similar to the last picture, you can see that there is a relative thinning, and also this part is relatively hypokinetic, even though there is a global hypokinesia. And here, if you appreciate that there is an enhancement on the outer side of the myocardium, which is the epicardial enhancement, you can see that there is a normal myocardium inside. And in addition, if you can appreciate is there is a linear enhancement in the mid wall, and all these pictures correspond to non-ischemic entity, where in described cases, in a known case of Becker's muscular dystrophy, this is one of the signs which we see in dystrophinopathies. So this is another patient where you can appreciate there is a global hypokinesia. However, we don't see much of an thinning of the myocardium, and these additional sequences are called as STIR sequences. You might have heard about it, and these sequences identify edema. right? So here you can see, this is the normal reference myocardium. Here you can see there are some patchy involvement in the myocardium, and here, and a little bit here, and a little bit here. So this is a mid cavity because you're able to see the papillary muscles here, and this is the apical cavity. And correspondingly, there are corresponding as well as non-corresponding areas of patchy enhancement, which shows that there are varying stages of sarcoidosis, varying stages of inflammatory pathology in this particular patient. Here you can see this; these are all abnormal enhancements. So here, and here, this is a varying pattern, like mid-wall, subepicardial, and it's a little bit of mid-wall and subendocardial, so on. So this is a known patient with sarcoidosis, and this patient who had an apparently normal ejection fraction a few months back. And she presented to us on an acute failure and with acute pulmonary edema, and their troponin levels were also high. So she was subjected to an coronary angiogram, and the coronary angiograms were apparently normal. And in the cine images, you can appreciate that this is the basal LV, which tends to contract well compared to the apical. So there is what you call as an apical ballooning. And again, this is an edema image where you can see there is a diffuse high signal of the entire myocardium. So this indicates edema. So an edema with no signal. This is apparently normal looking LV myocardium. This is a very classical case of stress-induced cardiomyopathy. And later on, when we look into the history of the patient, she had a very unfortunate event in a close relative. So
When
moving
you
on
have
to the
2 minutes more.
Okay, so
If
then
you're able to cut short in 2 minutes, it will be appreciated.
Yeah,
Sorry
sure.
for that.
Yeah, sure. No, sure. So when you talk about the preserved ejection fraction heart failure, there are multiple modalities. There are various parameters that MR can offer, right? So we have many sequences like phase contrast, 4D flow, myocardial tagging, feature tracking, so on and so forth. And similar to your MR evaluation of diastolic dysfunction, MR can assess pulmonary vein flow. MR can assess and quantify left atrial enlargement, which is more accurate compared to the echo finding. And mitral valve inflow velocity, this can be assessed in MRI. And systolic function, obviously, you can measure. LV hypertrophy and fibrosis and ECV content are all because of the parametric mapping. And you can also analyze the strain analysis of the LV myocardium. So based upon these parameters, similar to your echo, we can categorize the patient of diastolic dysfunction, and you can also prognosticate. So with this, I would just like to add a few words that LV hypertrophy, when it comes to LV hypertrophy, MR is gold standard. And with respect to LA enlargement, MR and echo are comparable, right? And especially there is one study which says that the one of the technique in MR is much superior than the echo technique. Whereas when it comes to transmitral flow, the pulmonary vein flow, MR identifies almost all of the cases, whereas in echo, we are able to identify only half to 60 or 70% of the patients. And just get this. So this is the parametric imaging. So this is something that you have to just remember one word. So the LGE, late gadolinium enhancement sequences, are conventional imagings. So these are all bit advanced MR sequences where you need to have the machine, you need to have these sequences, you need to have the post-processing software analysis as well. So this is just whatever we are in the conventional imaging, we see visually. Here in these imagings, you give a number to it. And then the number, there are various applications for it. It can diagnose, it can categorize, it can prognosticate all the entities of etiology. So this is a case where you can see there is a diffuse subendocardial and complete enhancement seen all over the LV. And there is an increased T1 value throughout the myocardium. This is sampled in red. And this is an extra cellular volume expansion. This is a classical case of amyloidosis. So this is another patient where you can see that there is compared to the previous images, if you remember or not, this is much more darker myocardium. And here, this is a liver. In liver also, you can see that's much darker. So it's a case of thalassemia. Patient underwent multiple repeated transfusions, and the calculated, the calculated iron concentration is 3.52, which is very severe, right? So take home is MR offers. So MR is gold standard when it comes to LV and RV function. So, and it is one of the powerful and versatile tool to differentiate between ischemic and non-ischemic pathologies. And when it comes to non-ischemic pathologies, yes, we can categorize into multiple various etiological, which we can do. And after the diagnosis, there are multiple ways to prognosticate. And the one of the most important thing is the LGE. So presence of scar, identification of scar is prognostically very bad in MR. So that's something that you have to take on.
Thank you.
That's all.
Thank you, Dr. Madan.
Yeah.
It is an excellent depiction of how CMR, because of its inherent spatial resolution, differentiates between ischemic and non-ischemic, and nicely depicted. Thank you.
Thank you.
In the interest of time, I think we will avoid questions. If you want to ask, you can ask them individually. Thank you.
Thank you so much. That ends our session on imaging and heart failure. Now, as we know, anesthetists and cardiac surgeons have to work hand in hand in order to have maximal successful outcome. So our next session is basically anesthesia for heart failure patients. And the first topic we'll be talking about is anesthetic considerations during minimally invasive cardiac surgery. And I would like to call on Dr. Ganapathy sir to talk on this. I would like to ask Dr. Bhaskaran sir and Dr. Murali Krishna sir on stage to moderate the session, please. Thank you so much.
Good afternoon and welcome to the session. The first talk is by Dr. Ganapathy Armugam about anesthetic consideration during MICS. Request all the speakers to kindly stick to the timings.
Yeah, a very good evening, everyone. I'm Dr. Ganapathy from Apollo Hospital, Chennai. My topic is anesthetic considerations during mix. I discussed where this topic fits in heart failure conference with my surgeon. He told we can have this approach for targeted surgeries for specific heart issues, if anything that can benefit heart failure patients. Disclosures none. Mix. AHA defines mix as a cardiac surgery performed through a small chest incision that does not include full sternotomy. Not all patients are suitable for mix. Intraoperative TE is essential. Major benefits: reduced postoperative pain, shorter hospital stay, better cosmesis, quicker resumption to normal activities. The anesthesiologist who is anesthetizing mix should be able to handle regional anesthesia and analgesia techniques, thoracic anesthesia practice, one lung ventilation, cardiac anesthesia, and TE. All are needed in some part of mix anesthesia. Surgeries performed under mix are mid-cap, AF for ablation surgery, minimally invasive MVR, minimally invasive AVR, minimally invasive ASD, and PDA ligation, and also the robotic assisted cardiac surgery. And patient selection in mix is essential. Elderly, frail patients, though be afraid, may benefit from this minimally invasive surgeries. If aortic atheromas or potential length of cross-clamp time are expected, then don't go for mix. And cosmetics, younger patients prefer mixed surgery. And coming to pre-anesthetic evaluation, there are pretty much contraindications, relative and absolute for mix. Pleural adhesions and peripheral vascular disease are relative contraindications, while any contraindications for TE, especially for minimally invasive MVRs and minimally invasive ASDs, they are absolute contraindications because they are guided by TE only. And aortic aneurysm more than 40 millimeters, severe ventricular dysfunction, and severe pulmonary hypertension, they are absolute contraindications for mix. That's why I was wondering where this fits in heart failure, because when a patient is having severe ventricular dysfunction and severe pulmonary hypertension, cardiac collapse may be expected during any cardiac surgery. So managing in mix is maybe a bit difficult. Maybe we can have peripheral venous cannula and arterial cannula like we have in ECMO for going on pump at any time. So that way we can modify our cases for heart failure patients. And morbid obesity like this patient is always, the surgical access will be very difficult. and require additional drainage cannula for maintaining the flow, and placement of DLT also can be tricky, and difficulty in tolerating one lung ventilation also because of the unfavorable physiology of these patients in lung aspect. CT scan of the arterial tree should be done before any mix to assess the size of femoral arteries, aortic dimensions, aortic atheromas, and so on. And evaluate comorbidities like cerebral vascular disease, neuromuscular disease, orthopedic abnormalities, predictors of difficult ventilation, because we are planning to put the DLT in these type of cases. And evaluation of pulmonary function is also very important because we are planning one lung ventilation here. And chronic lung disease, reduced exercise capacity, low FEV1, PaO2 less than 65 millimeters of mercury, PaCO2 more than 50 millimeters of mercury, moderate and severe pulmonary hypertension, all are relative contraindications for one lung ventilation. It is difficult for us to maintain saturation in these type of cases. And coming to monitor, standard monitors as of a cardiac surgery, and TE is very essential for minimally access cases. And the line positions, always we leave one groin for the placement of arterial and venous cannula for the surgeon. And SVC cannulation, if planned, then we go for a left IJV for central catheter, and coronary sinus cardioplegia cannula and SVC cannulation are planned on the right IJV. Then we go for a left femoral CVP catheter. And endoballoon cardioplegia, if planned, we should have both left and right radial arterial lines. And cerebral oximetry monitoring is desirable in mixed cases, especially when endoballoon migration is anticipated, endoballoon cardioplegia is anticipated. It can migrate, which can be identified by cerebral oximetry. Harlequin syndrome, which has been, I thought it would have been already discussed, but Sundar sir has cancelled that topic today. So it is just, anyway, you will know later. And Harlequin syndrome is nothing but differential hypoxemia of upper body tissues. Continuing to ventilate that left lung with 100% oxygen till aortic cross clamping. Avoid this problem of differential hypoxia in mixed setup. And induction and maintenance, we always should have external defib paddles before starting any mixed case. And OLV pneumothorax increases the electrical impedance for the defibrillator paddles. And so we should be careful. And if not working, we can ventilate the lung momentarily at that time. Pediatric internal paddles are desirable if it goes through the small incision. And hemodynamic instability, if it happens, no other go, you have to go on fem bypass, or IABP can be inserted. Femoral arterial, pulmonary artery pressure monitoring and CCO monitoring are desirable in bad cases. And we use for OLV either W-Lumen tubes or bronchial blocker. We prefer in our minimally invasive or robotic minimally invasive cardiac surgeries, EZ blocker, the like one you see on the right side, which is placed through bronchoscopy. And any displacement of bronchial blocker is less likely, as there is no lung manipulation in these type of cases. And one lung ventilation, hypoxemia and hypercarbia may happen during one lung ventilation, which increases pulmonary vascular resistance, which puts additional strain on RV, and RV dysfunction ensues. Hypoxemia and hypercarbia cause arrhythmias, which are poorly tolerated in bad LV. Methods to improve oxygenation are dependent lung PEEP, non-dependent lung CPAP, increased FiO2, intermittent suctioning, recruitment maneuvers to ventilated lungs, increase systemic pressure, and avoid drugs that attenuate hypoxic pulmonary vasoconstriction. Always one should be ready for any emergency sternotomy in mixed cases. We should drape in such a way that emergency sternotomy can be done at any time. Causes, excessive bleeding can happen at any time, which can lead to a mortality of 20%. Poor exposure, adhesions, hypoxia, arrhythmias, and iatrogenic aortic dissections leads to sternotomy in some cases. And hypotension happened during the initial CO2 insufflation, like any laparoscopic surgery. Insufflation pressure, if higher than 10 millimeters of mercury, increase intrathoracic pressure, decrease venous return, low cardiac output, and hypotension. So we have to be ready to handle this while starting the case. And positioning in mix, it's very important. Pressure points should be sufficiently padded. Neck, arms, and legs should be taken care so that they are not hyperflexed or hyperextended. Warming devices and hot air mattresses should be available so that we can wean the patient quickly and fast track it. Cannulation and TE guidance only it is possible. Single two-stage venous cannula is inserted through a femoral vein and is passed up to the proximal part of the SVC. When the right atriotomy is planned like ASD cases, separate IVC and SVC cannula are put, and arterial cannulation is always done from femoral artery in mixed surgery. Bypass and myocardial protection. It is utmost important that surgeon, anesthesiologist, and perfusionist should have excellent communication, and that is crucial. And aortic cross clamp, they can use either Chitwood clamp and endo balloon. Nowadays, Chitwood clamp is preferred more because of endo balloon can migrate during the surgery, which can cause catastrophic complications. And TE can identify LV distension as well during administration of cardioplegia. And if we have endoballoon aortic cross clamp, invasive pressure monitoring should include 4 transducers to encompass 2 arterial lines for right and left radial and CVP, and a transducer for the tip of endoballoon. And while weaning off from CPB, when patient is on OLV, we should ventilate both the lungs while coming off, because it is difficult to maintain oxygenation with one lung while coming off. So temporarily expanding both lungs is useful for weaning of CPB, not only for the oxygenation purpose, even RV performance is better when we do like this. And mandatory points to be addressed by TE in mix or to rule out aortic valve regurgitation, assess size and morphology of aortic root and ascending aorta, advise any atheroma in the aorta, inform the presence of PFO and ASD, verify correct endoballoon positioning and pulmonary artery vents. Postoperative bleeding, hemostasis is very difficult because the incision is very small. So sometimes we may miss something, and repeat TE or TTE may be done to assess any collection. If stable, bleeding can be addressed by mini thoracotomy. If not stable, emergency sternotomy is performed. Postoperative management, since we repair femoral vein, so better to monitor femoral pulse, peripheral pulses post-op, and even anticipate DVT and pulmonary embolism. Arterial catheter navigation may cause debris or thrombi, which can produce neurological liver and kidney dysfunction. Complications of OLB should be anticipated like acute lung injury, air leak, segmental or lobar collapse, re-expansion pulmonary edema. So lung protective strategy for OLB helps to avoid these complications. Analgesia mix, we have more postoperative pain because it's a thoracotomy rather than sternotomy. So intravenous opiates and IV paracetamol are used. On top of it, we always put a erector spinae block with continuous infusion catheters, which is very good in analgesia. At the same time, the complications are low. These are various neuroaxial and local regional techniques for post-op analgesia. Nowadays, we have given away thoracic epidural and paravertebral block for the pain, because they can cause catastrophic complications like neuroaxial hematoma. Erector spinae block under ultrasound guidance helps to avoid this complication, as we are just superficial to the ribs and the transverse process. And fast track protocol mix is claimed to have early extubation and fast tracking. So if there are no major complications, we can proceed with fast track. Generally, we extubate patients 3 hours post surgery. Some people extubate on table also, that is called ultra fast tracking. And to conclude, anesthesia for mix is challenging. Mix require maximum awareness and vigilance from the surgeon and the anesthesiologist equally. There should always be a low threshold for sternotomy to correct the reversible and residual cardiac lesions if it is not possible with mix, as patient's life is paramount. Thank you. These are my references. Thank you.
Oh, thank you, Dr. Ganapathy. Although the topic says is minimally invasive, but we all know the problems is highlighted is maximally invasive from the anesthetist point of view. And you already mentioned about the limitations of applying this technique for a patient with a heart failure. Thank you, Dr.
Thank you.
Thank you so much, sir.
Yeah.
Dr. Suresh Rao sir is unavailable today, but on his behalf, Dr. Ajay sir will be speaking and he'll be giving us some insight on anesthetic considerations prior to LVAD implant. Thank you, sir.
What do you? No, it will show that automatically. I just. It's not coming. You can play from directly then. Okay. No. No. Okay, then we play from the system. It's not playing. It's not playing. No, it's already loaded. The videos will not be not coming. Okay, we'll play it. Can play it. I'm very sorry. Good evening to everybody. I'm speaking on behalf of Suresh Rao sir, and I'm thanking the organizing committee for the opportunity to speak here. I am trying to keep to time, and I have no disclosures. Okay, briefly, I'm talking about the introduction, about a VAD brief idea for especially for junior people, a pre-op and assessment and optimization of a patient presenting for a VAD, and a basic intra-op management. I'm not going to speak on post-op VAD management. Why do we need a VAD, or what is the need? Basically, because of mismatch between available organs and transplant, especially abroad in the Western world. Over the last 2 decades, VADs have become much more common than transplants. It is considered established therapy for end-stage heart failure in patients who are stable or who will benefit from VAD. It's basically a small pump which takes blood out of the LV and gives it back to the aorta. It's controlled by a controller which is outside the body, and the batteries which are basically carried by the patient in a bag or some sort of a pouch, and they have to carry the battery throughout their life as long as the VAD is working. Indication is refractory heart failure in spite of maximal heart medical management. The options are for a transplant. If not fit for a transplant or not wanting a transplant, the VAD is the alternative we can suggest to a patient. Contraindications for a VAD. Absolutely, if you cannot anticoagulate a patient, you can't put on a VAD. Severe biventricular dysfunction, you should consider a BiVAD or not do a VAD. A small LV cavity, some sizes are mentioned in the literature. Extremes of BSA, because the BSA less than 1.4, 1.5, the VAD cannot work. End-stage organ disease, where probably you should not do a VAD at all, and social and psychological reasons, as well as the cost. This is the HeartMate 2 is on the left side, the HeartWare is on the right side. The HeartWare is no longer available, and what we have is a HeartMate 3 now, which is similar to the HeartWare. VADs are used as bridge to recovery, bridge to a permanent VAD, bridge to transplant, or as destination therapy when they are permanently implanted. Okay, coming briefly to the pre-op assessment for patient and optimization. First thing, take a detailed clinical history. The patients mostly will be either they are ischemic, there may be non-ischemic cardiomyopathy, history of cardiac arrhythmias. They make the VAD management difficult. If the rhythm is reasonably stable, you are much better off. Signs of heart failure, the RV failure, pH, what is the pH pressures, reversibility, the echo parameters, basic lab workups. And before you take up a patient for a VAD, you need to have adequate blood arranged the day of surgery or the day prior to that. Okay, basic labs, apart from the blood and CBC, LFT, RFT, because the RV failure will impact your liver and renal function, viral serology, and pro-BNP. X-ray ECG is routine, VO2 max, if the patient needs to be transplanted or VAD, a 6-minute walk test, a detailed echo, ideally multiple echoes done, TEE if required. A right heart cath is mandatory before a VAD is put in. The coagulation parameters to be corrected or at least assessed if there is any coagulopathy. Ultrasound abdomen for any pathologies, a CT chest or an angiogram. If it's a redo surgery, especially if it's a post-CABG VAD, then you need to have an idea of where your grafts are. So surgeons need to know that. Apart from that, pre-operatively, you should optimize nutrition status as much as possible. Whatever vaccinations are required to be done, psychological counseling, clearance from the dental team, ENT team, neurologist opinion if required. If the patient, some of the patients have old strokes and neurological issues, frailty index to be considered, and consult other systems as required. Candidacy for VAD depends on the clinical picture, the echo, and the cath numbers. Okay, and also, of course, the affordability of a patient. This I would like to stress on this one. What we normally do for a right heart cath is most of our caths are done in the ICU by the anesthesia team, or the ICU team basically. We'll do the caths, and if the numbers are high, we start with milrinone, which will progressively increase the doses. So on the left side, we have a CVP of 19, which has come down to 12 with high 0.7. That's almost full dose of milrinone. PA pressures have dropped slightly. The PA mean has come down. The wedge has come down. TPG has changed slightly, and the cardiac output is improved. The PVR has changed. So this is not possible in the cath lab because they're time limited. What we do is we put a PA catheter through the neck, through the IJV, and we keep it in place for a few hours, maybe overnight, to get the readings. And to adjust we adjust with milrinone if required with nitric oxide to get the best numbers possible for a VAD or a possible transplant. And apart from this, just stress on this thing, the CVP is important for a VAD. The idea is that your CVP to wedge should be less than 2:3. If your CVP is 2, wedge should be 3 or more. If your wedge and CVP are almost equal, 1:1, then you probably need a BiVAD, not an RVAD, not an LVAD. Okay, and apart from that, you can also get an idea of your RV function with your RV stroke work index and a PAPI. These numbers, what we normally use is a CCO catheter, and the Edwards, it automatically gives the cardiac output directly. We can also manually calculate the numbers if it's required. Echo guidelines, I'll not go into the echo for RV. It's already been spoken to. The RV shape, strain, the TR, the RV systolic pressure, the tie index, FAC, TAPC. Other thing to look for in a pre-op echo is the LV cavity size and any clots. Clots are important because the surgeons have to know if there are any clots, they have to be evacuated before the VAD is placed. TAPC, easy to do, if not very accurate, I suppose. Less than 16 or 17 is considered of poor RV systolic function. Can be done bedside. Other thing which is easy to do is an RV S prime, which is also used. Values are mentioned less than 10 or 12, depending on the books. Optimization, first thing is to optimize your heart failure medications. Second thing is to optimize your diuretics, aggressive diuresis, to get rate and rhythm under control, get the PA pressure as low as possible. Some patients may benefit from an IABP or already on IABP. If the patients have renal dysfunction and not making urine, it's a problem. You have to consider some sort of hemodialysis or CRRT. The sick patients on ECMO already and convert to a VAD, they are mostly emergency VADs. Sometimes you put a temporary VAD, then go to permanent VAD. Those are the sickest patients. Intraoperatively, what we do is we put a triple lumen on the neck and a PA catheter, the CCO catheter. We monitor CA, CVP, PA pressures, SVR, PVR calculations, and cardiac output. And TE, of course, after induction. At induction, we avoid any insult to contractility and further worsening of PAH. Maintain rhythm if possible, avoid hypotension, avoid hypervolemia, minimize the PVR increases, depth of anesthesia to be monitored. We use an NIRS routinely, and TE is mandatory. You can do a transplant with minimal TE. Without TE, you can't do a VAD. Drug, the literature says that etomilit is a drug of choice. So most people use that. That's what we also prefer, but you can use only midastfentanyl, the relaxants with SIVO or desfluran. Antibiotics, as per the protocol for the unit, you have to give. What do you see pre-bypass after induction when you're putting a VAD in? The RV function, the PFO. You have to look for a PFO and close it if it is there. The cannulation sites, you can make out the LV apex and the aorta cannulation sites. Valves, AR, anything more than mild AR is a problem. Anything more than mild MS or moderate MS is a problem. MR is not really a problem because it comes down. And AS is not a problem as long as it's not very severe. AR worsens with a VAD, so it has to be observed once or pre-op itself, you should know about the AR. Okay, after you look at the TE, you decide about LVAD, and nowadays we have a low threshold for putting an RVAD in. Assess the RV function in total. Look at the numbers from the CAT data, your on-table CAT numbers, basically the same PA numbers, and then look at the aggregate and then get an idea of what is the best thing to do. Okay, other things on echo, we can make out the arrow shows the apical cannulation site. It should be in line with the mitral inflow. This is where we're indenting in a different view. We're indenting with a finger, and that is where you're going to put the cannula, the LV inflow cannula. We're looking at a pre-LVAD. We are looking for a PFO, and there's no PFO here because the contrast is all into the right side. Surgical steps: go on bypass, core the LV, insertion of LV inflow cannula, partial clamping of aorta, the outflow grafting, and driveline tunneling. Usually nowadays, the aortic graft is put first. On echo, again, de-airing of both the cannulae. This is the PFO. Sometimes the PFOs open up when starting the VAD. Look for the PFO again. Of course, get an idea of the RE function. This again is an inflow cannula after it's put. This is an inflow cannula after it's in placed. This is a Doppler flow of the inflow cannula, and this is the outflow graft, 3D. You can see the outward flow. Okay, this is a Doppler of the outflow graft. As you come off, look for de-airing, start the LVAD and reduce your pump flows, assess the clinical status, the numbers and the echo, gradually wean off bypass and slowly increase your RPM on the VAD. Supports, we use as nitric oxide as routine for all transplants and VADs. VADs, they are absolutely mandatory. Inodilators, usually an adrenaline with a touch of noradrenaline, maybe a milrinone. Depending on the patient, you have to adjust accordingly, depending on the heart rate also. You may need to pace the patient also. Target is mean of around 65 to 80. CVP, if possible, under 12, under 15 is also acceptable because usually 12 you will not get the PA. Target is to have adequate RV filling and adequate LV filling, septum in the midline or slightly to the right side with intermittent aortic opening. This is what patient after coming off in the theater with the heart rate is irregular, around 100, mean around 78 pressures, PA pressures are on the higher side, and the CVP is nice. It's 9 of CVP, we are happy. And this is how it looks as you come off. And you increase the RPM, the position of the septum changes, and you can slowly adjust your flows accordingly. What happens if you increase the RPM too much? Okay, something called a suction event. It's essentially a collapse of the LV. So the LVAD inflow will stop. This is secondary to hypervolemia, excessive RPM settings, or tamponade, or severe RV dysfunction where the RV is full, but the LV does not get any flow into the LV. No preload into the LV. Diagnosed by echo. Absolutely, you will get low numbers alarming from the VAD, and you will have low main pressures. You don't know what you're looking for. Have a quick look at the echo. This is what you see. LV is collapsing. It's partially collapsed now. It can completely collapse. VAD cannula is seen. Your RV looks okay here. Not full. Okay. So then you have to reduce your RPM and give some minotrope if required and some volume to the patient. Post-op bleeding is a main issue. We usually wait for 3-4 hours if required to have complete hemostasis, full reversal of protamine before we consider shifting a patient. Post-op maintenance of hemodynamics. If the RV function is reasonably good, your VAD parameters will be stable. If the RV is borderline, you are already planned pre-op that your RV is not great, you are going to have post-op trouble. That depends on your numbers. Your CVP ideally, you should not let it go above 15. We would like to keep it below 15, 12 if possible, with reasonable mean pressures. Okay, same thing. Once you go to the ICU, briefly about post-op, needs continuous echo guidance. In 90% of the cases, the post-op patient, the night T is put back to have a look because some flow equation will be there. Whether flow fluctuations or some suction event happens very commonly. So T is mandatory. If you have good windows on transthoracic, you can manage. Okay, and once this settles down by about 24 to 48 hours, patient is once stable and otherwise doing well, you can wean off the nitric oxide and extubate the patient and optimize the inotropes. Brief about high-risk VADs. There's a difference between a VAD patient who walks in from OPD, who is stable, admitted electively, and a patient who comes on inotropes. Some of them are on balloon, some of them are on ECMO, and some of them are on temporary VADs done elsewhere. These patients are high risk. You expect them to have trouble in the post-op period. And other thing is reduced sternotomies, either a valve surgery done earlier or a CABG done earlier. If it is a CABG, you should make sure that the graft is not touched as much as possible, because the RV blood supply is important. Any damage to the RV graft especially will have problems later on. And the other group of patients are patients with some sort of RV failure or some sort of renal dysfunction who are either on HD or on CRRT. These patients are difficult to manage because post-operative, you can't take out volume. You may require CRRT post-op period.
Can you sum up, Doctor?
Yeah, just a couple of slides. The post-LVAD, air embolism, bypass induced, increased cardiac output from the LV, from the LVAD basically, and alteration of the RV dynamics and pulmonary hypertension causes RV dysfunction. You look at all the numbers and you take a call on what is to be done. Some indices for RV dysfunction. I will not go into detail. It's already been spoken. Optimize your mean arterial pressures. Get your PA pressure down as much as possible. Optimize VAD flows. Adjust your inotropes as required. Dilate to diuretics and CRRT if required. Briefly about mechanical support for the RV. It's either failed medical therapy, echo parameters, and a crashing patient. Options after LVAD are Centrimag, Rotaflow. Okay, we routinely put a femoral venous line at induction. This is used as a VAD line if required. RA candidate to the femoral vein. Actually our surgeons now bring it post to the subacute area and they keep it through a graft so that the temporary RVAD can institute it comfortably this way. Few days, 4 to 5 days, we wean off the RVAD flows, and then we can just pull it out under local. You don't even intubate the patients routinely nowadays. So take home message, VAD implants are increasing worldwide. More and more centers are doing it. And I'm sure all of us, the younger generation at least, will see more VADs. Pre-op optimization and right heart data is crucial. Optimize the patient after right heart cath, repeat cath if it's done earlier or the numbers are not good. Multiple echoes, seen by multiple people, ideally. Discuss the surgical plan, lines under local, review the number tables before induction, avoid the crash as induction. TE is crucial in VAD management. Absolutely, you cannot do a VAD without having TE ability. And early RVAD implantation is better. That's what we have found rather than struggling with inotropes. And RVAD usually, in most cases, can be weaned off in a few days, and then the patient slowly comes out the VAD and goes on with the VAD. That's all. Thank you very much.
Thank you, Dr. Ajay. Just a question to you.
Sir.
How do you manage if there is an associated severe AR or PFO was diagnosed in coming off?
In case there is a PFO diagnosed intraop or that bubble test we do and we get a PFO, we have to close it, sir, before putting the VAD in. It has to be closed, and you cannot have a PFO or a VSD. And AR, the options are either to close the aortic valve completely. I have not seen it being done because in that case, your output depends only on the VAD functioning. You have no native cardiac output. Other option is to put a bioprosthetic valve and then put the VAD in. You can't put a mechanical valve. If it is a mechanical valve, the recommendation is to change it to a bioprosthetic valve to prevent the risk of clotting.
Any other question?
Thank you very much.
Thank you so much, sir. That was very educative. I would now like to call on Dr. Sitaram, sir, to talk about anesthetic considerations in non-transplant cardiac surgery in heart failure. Can I please have you on stage, sir?
Good evening. This is an extensive topic and I'll try to make it as brief as possible.
I will be talking about the anesthetic implications for non-transplant cardiac surgery in heart failure. Patients with a history of heart failure have a very high incidence of major acute cardiovascular events, and proper optimization and evaluation and intra-op management will have a successful outcome. This is a significant comorbidity, can affect up to 20% of the patients in anesthetic practice, and because of rising incidence of cardiac failure and also advancements in therapy, there is this cohort of patients is a growing cohort. Prior history of a cardiac failure in any patient elevates the mortality risk after cardiac surgery, and even this happens even if they are with current normal ejection fraction or they do not have any symptoms. This is mainly because these patients can very quickly decompensate with heart failure in the perioperative setting. In preoperative evaluation, we need to evaluate if the patient is currently in heart failure, and we have to identify which of these heart failure syndromes which are high risk, like if it's an acute history of heart failure or if it's an advanced heart failure or low ejection fraction. If the patient is not in failure, and if he's stable, we have to make sure that he's optimally managed. And in these patients who are optimally managed, we have to identify certain comorbidities which can impact the stability of their heart failure in the perioperative period. There are certain conditions and triggers which can trigger perioperative heart failure in such patients coming for cardiac surgery. And if you have a prior knowledge of these factors, we can initiate aggressively treatment when they're struggling, when we're struggling in the postoperative period. The patients have a history of atrial fibrillation, kidney disease, diabetes, hypertension, history of alcohol abuse, chemotherapy, and if there is a family history of heart failure, these patients will be at a higher risk of postoperative failure. There is a small subset of patients who have LV dysfunction but are completely asymptomatic. These are a difficult subset to identify. In the preoperative evaluation, we should have a very high index of suspicion from the history and physical examination of these patients. History and physical examination constitute a very important part of the pre-anesthetic checkup. We should know the etiology, the duration, and we should review the current therapy and the presence of active failure symptoms. The functional capacity of the patients should be assessed, and the physical examination should place a lot of importance on the hemodynamic status and the volume status. Volume, oxygen saturation, BP, heart rate will complete the assessment. They have to be auscultated, and the abdomens and extremities have also to be assessed for any fluid retention. Investigations, Q waves in the ECG may be there, but the ECG, preoperative ECG mostly serves as a baseline for postoperative comparison. Echo will differentiate between preserved ejection fraction and those with reduced ejection fraction. In these two subsets, the treatment and the prognosis is different. A chest radiograph is done mainly for suspected pulmonary edema to rule out any lung pathology. Cardiac biomarkers are increasingly used. They are very powerful predictors of mortality, but they should never be considered in isolation. BNP and NT-proBNP should never be considered in isolation. And the remaining coagulation parameters and electrolytes also have to be assessed. There are a lot of modifiable and non-modifiable patient-related and technique-related factors which play an eventual role in the eventual outcome of these patients. And there are a lot of risk assessment scores. The commonly used assessment scores in cardiac surgery, the Euroscore 2 and the STS risk score. There are a lot of variables which have been excluded, but ideally they should be calculated. This allows us to identify patients for rigorous preoperative optimization. This is mainly because if we can find out some modifiable factors, small improvements in multiple modifiable factors may eventually benefit the patient. And these risk factors can be used complementary to the NT-proBNP levels. These patients will have a lot of other factors because of the cardiac issue. They'll have other issues as well. These patients also have to be optimized: renal, liver. These patients are frequently catabolic, bowel hypoperfusion may be there. They're malnourished. We have to optimize the volemia, the nutritional state, and the end organ function. Anemia, hemoglobin should be more than 10 grams per deciliter. There is a role for preoperative pulmonary artery catheterization and a goal-directed therapy. Mainly, these patients have very limited reserve, and placing a surgical stress on these patients may compromise them postoperatively. So there is a role for keeping them adequately filled, which can limit the hypoperfusion. These cardiac output studies can be done at regular intervals, and the dilators and diuretics can be titrated. Inotropes can also be considered in certain patients, where the hemodynamic goals would be a CVP, ideal CVP, and a PCWP. Pre-op inotropes are not for routine use. Patients mainly indicated for patients in shock with multiple organ dysfunction and hypoperfusion. A combination, whichever dobutamine, milrinone, or epinephrine can be used. Temporary mechanical support should also be considered. IABP is, as Dr. Murli said, it increases coronary artery perfusion. It can be used. Other types like Impella, tandem heart, they have a higher cardiac output than the IABP. Preoperative consultation with the heart transplant team is necessary to coordinate if the patient will need advanced heart failure therapies like LVAD and transplantation. There are other two aspects of preoperative management, which we have to assess the preoperative medications as well as devices. Patients on AC inhibitors, patients with cardiac failure frequently put in AC inhibitors. These AC inhibitors, angiotensin receptor blockers and angiotensin receptor neprilysin inhibitors are ideally interrupted 3 days before surgery and restarted before home discharge. Beta blockers continued up to say the patient is already receiving, and mineralocorticoid receptor antagonists are interrupted 24 to 48 hours before the surgery. These patients may also be on a permanent pacemaker or an ICD. The preoperative cardiology consult is required. ICDs should be integrated if not been done in the last 6 months. In the low voltage pacemakers, integration should be done if it has not been done in the last 12 months. The surgical options, that is CABG, valve surgery, LV restoration, destination VAD therapy. Cardiac transplantation will not be there in this topic. The last minute checks before anesthesia would be a reassessment of the cardiopulmonary and the airway status, breathing circuits, suction, proximity of the surgeon and the perfusionist, emergency drugs, including anticoagulation for a possible emergency CPB. These in the pre-medication room, we should remember these patients are extremely sensitive to sedation. We should avoid sedation or carefully titrate them in the holding area. They will benefit from supplemental oxygen. Because of delayed gastric emptying, we can consider them as full stomach, and aspiration prophylaxis can be given. In re-sternotomy, external defib paddles and cross-match PRBCs should be available. Monitoring of standard monitors will be applied. Non-invasive monitoring, arterial side, we can choose the side according to convenience. Additional femoral line will be useful for later IABP use or to avoid the post-CPB discrepancy. And also in case the patient crashes, we can use it as a cannulation site for CPB. Central venous cannulation is timing of placement is individual choice. Second line will definitely be useful because they can be used to give volume or for further future hemofiltration use. TE is invaluable in monitoring such patients. When we give anesthetic, they have negative inotropic, chronotropic, and vasodilator action. There is a loss of the sympathetic tone. There is a transition from spontaneous to positive pressure ventilation. And these patients, because of diuretics, they are relatively hypovolemic. So this is more than a simple transition from a sleep to an awake state. They should be adequately pre-oxygenated. The hemodynamic goals will be to maintain heart rate and contractility, avoid changes in preload and afterload, avoid increases in pulmonary vascular resistance. A lot of induction regimens are described: narcotic-based, propofol, midazolam, ketamine. But the most important thing, the choice of the drug is dictated by individual preference. There is no single agent or technique which can guarantee stability. The choice is less important than the management of the hemodynamic parameters, perturbations that follow. So we have to give in conservative drug amounts, slow titration, titrate to the consciousness of the patient. Inotropes and pressors may be frequently needed, and they may have to be continued even after CPB. We should remember that the bolus administration of agents and pressors will take longer to reach because of the slow circulation. Fluids, again, these patients have a very narrow therapeutic index. We should use it conservatively, because it minimizes hemodilution and also reduces PRBC transfusion. Maintenance, again, relaxants, inhalation agents do have negative inotropy in vasodilatation. Low concentrations are well tolerated in these patients. Some patients, some surgeons do prefer to do it in off CABG because it minimizes ischemic time and perioperative myocardial damage. Hemodynamic management of these patients can be really challenging because they have an enlarged heart. The positioning of the patient before grafting will have to be done very patiently. IABP use is optional. When the patient goes on CPB, we should try and minimize the CPB time. Myocardial protection is a very important determinant of outcome. Cardiac pressure can be warm or cold, antegrade, retrograde, crystalloid, colloid. The best would be blood cardiac pressure repeated. Proper venting has to be done to avoid over distension. Hemofiltration has to be done to control hemodilution and remove excess fluid. And separation of CPB, the filling has to be very controlled. Separation from CPB, complex separation is to be anticipated. Age, poor ejection fraction, mitral surgery, CPB duration are independent predictors of complex separation. We can consider preemptive non-pharmacological or pharmacological treatment, whether we have to put a prophylactic IABP or a wait and watch approaches after the surgeon. TEE is a cornerstone of diagnosis for complex separation. These are the scenarios that can happen after coming off when there is difficulty right heart failure. Again, fluid challenge, IABP, ultimately ECMO may be required. If there is a left heart failure, again, IABP, Impella, ECMO may be the last option. These patients are also prone for vasoplegia after the CPB. So vasoactive drugs and factors which can promote like AC inhibitors, anesthetic agents, all of them, if they've been excluded, norepinephrine, vasopressin, and all other steroids may be the ultimately the option that may be available with it. The post-operative course will be stormy in these patients. Ventilation, sepsis, hemodynamic issues will dominate the course in the post-operative period. Early and aggressive intervention will hold the key. A multidisciplinary approach will benefit the patient. If we are well prepared, probably we'll have a very good outcome in these patients. These are a challenging subset of patients, but with preparedness and aggressive early intervention, these people can have a normal recovery. Thank you.
Thank you, Dr. Sitaram. It was a very detailed talk, as you rightly mentioned. The small things before the surgery to matter. Optimizing them will help us a lot, and the detailed family discussion, gradual weaning, these are all very, very important in this. The house is open. Anyone, any questions are welcome.
Thanks, man. I'll just leave it. Thank you.
Thank you, sir, for such an informative talk. I would now like to call on Dr. Balaji, sir, who is going to speak on anesthetic management of donor harvest, including optimization of the same. Thank you.
Good evening, all. As an anesthetist, the essence of managing a brain dead patient is shifting the typical role of being an anesthetist and anesthetizing a patient to be more of a perioperative physician, trying to optimize the donor in order to yield the best organ possible. So the objectives of my today's discussion is about understanding the basic pathophysiology of a brain dead and the adverse outcomes of a brain dead on the various organ systems, and how do we manage the altered donor physiology, and the role of an anesthetist right from the pre-operative assessment till the intraoperative period is being discussed. Some of the common physiological derangements and its incidence in a brain dead donors being discussed here. The foremost thing is the hypothermia, which is invariably present in all the patients if not prevented. That could be explained because of the hypothalamic damage that ensues immediately after a brain death. The intense vasoplegia and hypovolemic state, along with the reduced coronary blood flow, will lead on to an hypotension, which is reported in 97% of the brain dead patients. Posterior pituitary damage following the brain death leads to diabetes insipidus, which is followed by arrhythmia and pulmonary edema. So immediately after a brain death, there is a various and the intense period of an increase in the intracranial pressure is manifested, which is compensated with the systemic hypertension and a bradycardia, as explained by the Cushing's reflex. This is followed by an acute surge in the level of the circulating catecholamines and cytokines and inflammatory mediators in the bloodstream, which leads to an intense sympathetic stimulation leading to a vasoconstriction and a raised SVR and a tachycardia. This, along with an associated central redistribution of the blood volume with an increase in the afterload, leads to a visceral ischemia. The echocardiographic evidence of myocardial dysfunction is noted in 40% of the donors at this period of a catecholamine storm, which is reversible in most of the patients. After the catecholamine storm, there will be an intense sympathetic loss of the sympathetic tone, which leads to a peripheral vasodilatation, which in turn leads to an hypotension and an organ hypoperfusion. The main respiratory changes you could see is a pulmonary edema. This is because of the circulating endogenous norepinephrine levels, which takes a huge surge following a brain death, leading to the capillary endothelial damage and a raised pulmonary hydrostatic pressure. The endocrine changes, as discussed, leads to diabetes insipidus. The euthyroid, there is an acute fall in the level of the circulating thyroid hormone levels, manifest as a sick sinus syndrome, sick euthyroid syndrome, and the decrease in the insulin concentration with an insulin resistance adds to hyperglycemia, hypothalemia, and DIC. The simplified version of a goal of donor management is rule of 100, wherein try to maintain the systolic BP of more than 100, urine output of more than 100 ml per hour, and a PaO2 of more than 100, hemoglobin of more than 100 gram per liter with a tight 100% control of a blood sugar. The standard donor criteria is discussed as a patient characteristics and allograft characteristics. Some of the important allograft characteristics are the donor time should be less than 4 hours and with no significant coronary artery disease, and the ejection fraction of more than 50%, and age of less than 55, ideally it should be less than 40. With the ever expanding the demand for an organ, we just extended our criteria, and the extended criteria it's add a great emphasis on the traditional risk factors such as increased donor age, LV dysfunction, patient with LVH, and a prolonged ischemic time has been considered and has been studied in many single center studies. So the pre-retrieval assessment should start from the ICU, where a detailed handing over must be taken from the pre-existing ICU team in the form of what are the events that have led to the brain death and how it's been diagnosed with a brain death, and you have to concern whether the family consent has been obtained for the organ donation. The hemodynamic assessment includes mean arterial pressure, CVP, heart rate, and echocardiographic assessment. Try to look for the number of the inotropes and the dosage at which it's going. The endocrine in the form of glucose and the temperature should be monitored. Respiratory parameters like a PaO2, FiO2 ratio, and urine output, and ABG and sodium level to be assessed. So maintain a mean arterial pressure between 60 to 110. Any intervention for management of the cardiovascular effects of the catecholamine storm should be easily reversible, which is followed by a period of hypotension, has been told already. It's quite difficult to manage at that time. In order to control the tachycardia and hypotension, a short-acting beta blockers like esmolol could be used. The initial management of an hypotension should include a fluid administration to optimize the circulating volume and aim for a CVP of 4 to 10 millimeter and a capillary wedge pressure of less than 12 millimeter. The isotonic fluids, ringer lactate, 0.9% sodium saline can be used. If the risk of hypernatremia is anticipated, then go for hypotonic solutions. 5% albumin can be used for a rapid volume expansion, but a starch is not recommended. Correct anemia, target and hemoglobin of more than 10 gram per deciliter. Avoid excessive fluid loading in the donor management, as this is shown to be consistently increase the number of transplantable lungs. The pulmonary artery catheter may be a useful monitor, but in general ICU, it's quite results are declining. The central venous pressure monitoring alone is not be a proper guide for fluid resuscitation. So multi-center clinical trials have been underway regarding the usage of a pulse pressure variation to look for the viability of the lungs and other organs. Restrictive fluid regimen does not bring about any adverse effect on various organ systems when it's monitored appropriately. Once the volume status is optimized, then you can go for the inotropic or vasoactive agents to achieve the mean arterial pressure. Vasopressin is a first line of agent because of its V1, V2 mediated vasoconstrictory effect. The low dose dopamine has frequently been preferred as first line of the inotropic or a vasopressor agent because of its additional benefits in the transplant outcomes after the use. It's known to cause a profound induction of hemoxygenase 1 enzyme, which prevents the oxidative injuries in the lung transplant. The treatment of the brain dead donors with a low dose dopamine of 4 mics per kg does not harm any cardiac allograft, but appears to improve the clinical course of the heart recipients. Vasopressin is preferred because of its role in the vasodilatory shock and as also for the diabetes insipidus. The inotropic support should be commenced only after the hypotension has been treated with adequate volume replacement. Prolonged inotropic support may lead to a downregulation of the beta-1 receptors, which leads to an increase in the post-transplantation inotropic requirement. DOPA, ADRI, or NORAD can be used. A little cautious when you use a high-dose alpha-adrenergic agents because of the splanchnic and the peripheral vasoconstriction. The role of hormone replacement therapy, it brings about a reversal of an acutely hypothyroid state, and it also improves the myocardial contractility in a stunned myocardium. In the dosage of 20 mics of T4 followed by 10 mics, and T3 4 mics followed by 3 mics. Steroid administration, our routine is to give a methylpred of 1 gram IV. The emphasis on this tabulation is about the infusing of volume. The infused restrictive fluid therapy is more advisable, and the pulse pressure variation only if it's more than 13% or an IVC collapse is noted on the echo, the liberal fluid could be used. Else, it's better to restrict your fluid and achieve the BP. Also, regarding the sodium, even a serum sodium of more than 155, you should go for a half normal saline or a dextrose for volume replacement. Regarding the heart considerations, the acute surge in the catecholamines along with the acute withdrawal of the hormones, endogenous hormones, lead to the myocardial stunning and the cardiac dysfunction, which is reversible in the initial phases. So the echocardiographic assessment plays an important role. The functional abnormalities identified during the examination, early examination, do not contraindicate a heart transplant in 50% of the cases, but structural abnormalities may preclude the transplant. The goal of the echo assessment should rule out if any structural abnormalities and to assess for the regional and global functions. And the donor hearts with an LVH and the feasibility for a transplant is still unclear and it's been debated. LVH, as we all know, is defined as wall thicker than 11 millimeter in the absence of an underfilling of a ventricle. A recent study demonstrates even a mild to moderate LVH do not increase the morbidity. The image shows a normal heart because of the underfilling might mimic as an LVH, wherein the LV mass as such remains normal. This is the picture of a diastole and a kissing ventricle in the systole is a classical of pseudohypertrophy. Picking up this and volume replacement, then reassessing the echo after an hour, after 6 hours of duration is recommended. Most of the valvular and the congenital abnormalities preclude transplantation, but our extended criteria could include a patient with mild MVP without a severe MR is included. Also, the patients with bicuspid aortic valve when it's normally functioning, and easily repairable ASD is also being included into the extended criteria. Segmental wall motion abnormalities in a donor heart could be because of a coronary artery disease or a myocardial contusion or a ventricular dysfunction after a brain injury. This is an article that enlightens the incidence of a cardiac dysfunction in the donor hearts, its reversible nature, also its outcome in the recipient following the transplant. In this study, 641 potential donors are included, out of which 155 donors had an LV dysfunction. Amongst the 155, 113 donors had regional hypokinesia, out of which 46 patients had a Takotsubo like a circumferential hypokinetic pattern. The remaining had a septal hypokinetic pattern. Among the 155 donors, 45 heart got transplanted. Some of the interesting outcomes of the study is the LV dysfunction is noted in 1 in 4 eligible heart donor candidates. And the LV dysfunction that were initially present recovered after transplant. The intraoperative management, the anesthetist moves to an unfamiliar environment, so it's always better to communicate well, anticipate for the adverse effects. And these patients, the donors still have the spinal reflexes intact, both the motor and the autonomic. It's better to give the neuromuscular blocking agent even before shifting the patient to the ICU in order to avoid the unnecessary concerns among the staff beyond the movement of the patient. The volatile anesthetics are able to attenuate the autonomic spinal reflexes like hypertension and tachycardia. And it also has a role in the ischemic preconditioning, which is favorable in the recipients. Placement of all the invasive lines is recommended, and a large bore line for the rapid volume infusions. Anticipate the large fluid shifts after opening the chest. Warmers are considered. Protective lung ventilatory strategy is advised. Antibiotics and steroids to be given. Then manual palpation of the heart with looking for the CAD will win. That time you should anticipate for the hemodynamic instability. The cardiac arrhythmias are not uncommon among the heart donors. So the cause, as we all know, is multifactorial. Target a heart rate between 60 to 110. If a clinically significant bradycardia is noted during handling, adrenaline, dopamine, or the isoprenaline is a drug of choice. Atropine has no role here. Then just goes with it. This is the ISHTL recommendation and the guidelines regarding the expert consensus on the selection of the donors. This is a class 2A recommend. Class 1 recommendation is even a norepinephrine of less than 0.5 donors can be accepted. And some of the class 2 recommendations is to maintain the mean pressure of more than 60, index of 2.4, and CVP of less than 12, pulmonary pressure of less than 12, and work index of more than 15 gram. The donor metabolism, even abnormal sodium levels are considered here. It's a class 2A recommendation, and with a sodium level of less than 129 and more than 170 should not be included. It's should not be included. It comes under the class 2 recommendation. And regarding the recommendation for LVH, LVH should be assessed by measuring the thickness of the interventricular septum or a posterior wall. It's a class 1 indication, and including more than 13 millimeter of LVH is recommended in the class 2 in the extended donor criteria. These are my references. So expand the donor pool has always been the mantra of the transplant community. So in the recent years, even the hepatitis C heart donors and the technology that supports the donation after the circulatory death have been created a new avenues to increase the donors. Thanking you for giving me the wonderful opportunity.
Thank you, Balaji. Well presented. Although all the problems you highlighted and the actual management for the donor harvest, there are a lot of problems before you reach the hospital. If it is in-house, it is fine. But otherwise, you know, the problems of going to a different hospital and then mixing up with the other team for the liver, kidneys, and heart and lungs separately. So there are a lot of problems apart from the actual donor management. Most important thing is whenever the patient is admitted, they all live with hopes. You know, they expect the relatives expect them to turn around and become this thing. But when you pronounce them as a donor, from there only all this thing starts. So there's a lot of implications of that, how we are going to manage it, and going to a different hospital is a nightmare. Thank you very much. Any other questions?
I mean, like, I try if it could be weaned or if possible to considering the risk of losing if a patient is high risk recipient or the patient who really on a VAD or I mean like if it's really if it's outweighing the benefit risk ratio, I would rather choose than declining the heart. Try to optimize it. If it's not possible, then.
Thank you so much, sir. That concludes our session on anesthesia for heart failure. Now, whenever there is a plan to set up a heart transplant and ECMO unit, there are a lot of challenges we face, mainly because of the need for multidisciplinary team amongst the others. So the next session is basically going to be a summarization of all the difficulties faced and managed to successfully run a heart transplant and an ECMO unit. And I would like to call on Dr. Shivan Raj, sir, and Dr. Madan Kumar, sir, on stage to moderate the next session. The first talk will be on challenges faced in Jaipur by Dr. R.K. Yadav. Can I please have sir on stage, please? Thank you.
Yeah, we have come to the fag end of the today's Congress. And the last topic is out of the box topic, setting up of a heart transplant unit. So may I request Dr. R.K. Yadav to view his thing from Jaipur, the setting up of
Don't
heart
worry,
transplant.
I will not
unit.
take much time. I'll finish it. So, good evening, ladies and gentlemen. I thank organizer, especially Dr. T. Sundar, for giving me a chance to speak here. And my talk will be centered on the transplant program in the government hospitals. So, next first slide. स्लाइड तो बाद में कर देंगे, पहले इस पर। I'm from SMS Medical College Hospital, Jaipur. It is a government hospital, tertiary care center. And all you know that first human heart transplantation in India was done by Dr. P.K. Sen in 1968, just after the first heart transplantation done by Professor Christian Bernard in the world. Unfortunately, his patient didn't survive much, and then in 1968, the brain death definition of brainstem death, which has been considered as a formal death by the committee, ad hoc committee from Harvard Medical School, and that opened the gateway for cadaveric organ transplantation all over the world. But it took now nearly 25 years to adopt the brain death as a formal death by Government of India. And on 1994, the Parliament of India passed the Transplantation of Human Organ and Tissue Act bill. And just few days after that, Professor Venu Gopal, along with a team of 20 surgeons, one of them, Dr. Balram Aarons Bethe, is sitting here. They performed the first successful of heart transplantation in the India. You know that Dr. K.M. Cherian, who had many firsts to his name, he performed the first heart and lung combo transplant in India, first pediatric heart transplantation, and first re-heart transplantation in the Asia. You know, organ donation program is started all over the world, and many countries took it very seriously and actively. But here, we in India, we are lagging behind. You see, in the Spain country, like the Spain has the organ donation rate of 43.7 per million population, and we have only 0.8 per million population. This was data from 2021. In India itself, the Tamil Nadu is leading all the states, and its organ donation rate was very high. It was 6,223 in the up to 2021, and in comparison to that, the Rajasthan is very low. It's 2.4% of the Tamil Nadu only. Other states like Andhra, Telangana, Maharashtra, Kerala, Gujarat, they are coming up with very speedily. In my state, Rajasthan, so far 178 organs were donated. Most of them are kidneys, and 27 of them are the heart, and 4 were the lungs. Of them, we utilize out of 27 heart, we utilize 13 in our Rajasthan. 14 were gone out, and the lungs, 4 out of 4 lungs, we used their 1, and 3 lungs were sent out. So this is the slides approximately. The figures are not exact, actually very difficult to obtain the figures. Approximately in India, for 1,500 hearts so far have been transplanted, and more than 500 lungs, and 135 heart and lungs. So number of hospitals performing heart transplant, government versus private. You know, most of the donors are from the government sector. Brain death patients, neurosurgery ICU, trauma ICU, they are all in the government sector. And most of the donors are from the government sector. But if you see the donation, the organ transplantation, only 15% of the institutions in the India are government. 85% of institutions are private hospital. They are performing the thoracic organ transplantation, especially heart. So what are the issues in the government hospitals? The infrastructure, no, all the city waste department have the transplant units, no well-established advanced labs where all HLA and your tech level or many other specialized investigations are being done. No, all CTUS units have the facilities of the IABP, ECMO, Elevate, artificial hearts, etc. In the government sector, there's hardly any political will. There is no political commitment, different priorities of fund allocation, red tapeism, poor interdepartmental coordination, poor work culture, poor coordination among the administrators. Cost is a big issue. The government hospitals are catering the poor patients, and cost of the transplantation is very high, and it is not in the reach of a common man. So government health schemes like Chiranjeevi in Rajasthan and Ayushman Bharat and many schemes, Transtan here, they covers the treatment part only. But the poor patient need transportation also, attendance, loss of wages and working days. The post-discharge expenses is very important. Some of the patient cannot afford the food, isolation, hygienic food, and frequent travel after the discharge from the hospital by treatment with these Chiranjeevi and Ayushman Bharat Yojanas. So the donors, India has the highest rate of head injury in the world. 1 out of 6 trauma victim dies. But there is a delayed, but still there is the organ is not available, the shortage of organ. Consent is released because of the social divorce, lack of attendance, lack of considering the brain death as a real death, and busy trauma and neurosurgery ICUs have the poor donor management, lack of standardization of intensive care management of donor, infection control, and hemodynamic monitoring are not up to the mark. Recipients also have some problem because of delayed reference from cardiologists and pulmonologists, poor trust in transplantation program, death in waiting period. Then those patients who improved a little after registration with medication, they don't turn up for the surgery on the day of transplant. The bridge to transplant facilities are costly. They are not available everywhere, and they are associated with complications. Manpower in the government sector, this manpower issue is a big issue. Deficiency of manpower is there, lack of standardization of training, no separate cardiac cadre for the paramedical staff and nursing personals. All the personals are in search of comfort zone. Frequent transfer of trained personals, sickness, absenteeism, interpersonal conflicts, private practice of doctors, and poor teamwork. There is some reason of poor enthusiasm in the government sector personals, because persons are on the, they are all salaried and they are on secure job. Their wages are fixed. No extra wages for extra work, no rewards, no punishment, no additional incentives, plenty of government leaves. Workers have the unions fighting for their rights, but not for their duties. Biopsy is the endomyocardial biopsy, transbronchial biopsy. There is a lack of technical expertise, lack of competent pathology. Most of the biopsies are being sent to Chennai, Hyderabad, Mumbai, or Delhi. So what are the solutions? The solution is information, education, communication. Brain death should be considered a real death by the government and by hospitals. The moment the brain dies, patient should not be treated further. There should be chapter for the organ donation and transplantation in primary school, colleges, universities, medical, paramedical education institutions. Awareness program through the newspapers, TV, movies, Nukkad Natak, biopsy, books, and social medias. Dedicated coordinators and NGOs like One Foundation are of vital importance. Inclusion of former recipients in the team of coordinators and NGOs should be practiced. Fund allocation, health insurance should cover the transplant surgery also. Health insurance should cover transplant surgery. So far, there is no insurance, I think, for the transplantation. And government schemes like Chiranjeevi Yojana, Ayushman, Transtan, Mitha Sanjeevani, they should be more and more. And involvement of the non-governmental social organizers in funding, recipients, as well as attendant should be given free transport, stay, food, investigation, treatment, and also cover the in these schemes. Financial support and incentive should be also be given to the donor's family. So interstate, intercity, intracity transport should be provided free of cost. The standardization of training should be mandatory in all the fields. Residents of the concerned department should get rotatory training at the center of excellence. Thank you.
Thank you, sir. Like you have covered the entire spectrum of things like the government setup is especially facing. And it's not only in Jaipur, we are facing the same challenges in Tamil Nadu also, sir.
Yeah, yeah.
And I just want to highlight a few things like the transplant is included in the CM scheme, that is Chief Minister's comprehensive scheme in Tamil Nadu. And for the heart transplant, the scheme is 25 lakhs and combined heart and lung transplant is 35 lakhs. And post surgery, post transplant, the government is providing free of cost the drugs also every month. So that we have in our Tamil Nadu, government is doing
Yeah,
that.
government Rajasthan has also started a Chiranjeevi Yojana in that heart transplant and other transplants are also covered. But there is many issues. Like after transplant, the patient goes home. He don't have the money for the frequent travel, for biopsy, for investigation, this and that. And he can't travel in the common bus or train. He need a separate, so he can't pay for that. What the food chart given to him, the eat this, he can't afford that. So these are the, if we want the transplant for a common man, so far it is limited to the affluent society of, there's certain definite issues for poor patients.
And you rightly said, like most of the donors are from the government setup, but the
Yeah.
organs are utilized in the
Private sector.
private
Yeah,
setup.
yeah.
So that is also a point like
Yeah.
which we are facing here. Sir.
Yeah.
Thank you, sir. Thank you, sir. I'm sharing the view of my state, like I representing Tamil Nadu, and sir is representing Jaipur. Okay, fine. Good, great. Thank you.
Thank you.
May I request Dr. Mariappan, Professor of Cardiothoracic Surgery, Institute of Cardiovascular and Thoracic Surgery, Madras Medical College.
First of all, I thank Dr. Sundar sir, Madan sir, and Paul sir for having given this opportunity, because I troubled them so much. Whenever we mobilize the case for transplantation, I called them, sir, what shall we do? What shall we do? So they realized that I have challenge. I am facing so much of challenge. So they asked me to talk about this. In the year 2009, they have done first heart transplant in GH. It was appreciated by Chief Minister of Tamil Nadu. At the time, what we have, how we have done, and what I have realized. We have CD department, 6 units, 12 assistant professors, 6 postgraduates, and 6 stable CTOT, and 13 bedded CTBO1. Then my chief took recipient blood for cross matching. Both of us went to corporate hospital by ambulance. We couldn't carry adequate number because we don't know. But the corporate people has helped us, and they provided adequate quantity of solution and preserved the heart. And they are also ready to provide the ambulance because our ambulance also not good shape. Anyway, we came with our own ambulance only. Myself and my chief have harvested and implanted. Anyway, my colleagues also opened the chest and kept everything ready. Recipient card, once the understanding is over, recipient card was beating, kept in OT itself. And we kept the OT as an ICU. One pay ward after stabilization, one pay ward room was used as isolated ward. Patient came off well, everyone has appreciated. What I realized, since the patient is receiving immunosuppression and we are handling lung cases also, need separate ICU and OT. We don't have separate team for coordinator. Most of the virology tests, we have to send the sample to private hospitals. OT, when we want to create separate OT and ICU, no cooperation with the administration. With a lot of difficulties, existing OT has been converted into OT, ICU, and dialysis unit. Fix a team, surgeon, requested. Everyone says everyone has to be part of the team. They are ready to cooperate, not to be committed. Who has to lead the team? Dean has changed. HOD of anesthesia has changed, but we couldn't change the rotation to fix a team. Since they are rotated every 3 months, they struggle to start even RTL line, CVP, PA catheterization, and commitment to. Nephrologists, they are supportive, but surgeon approach differ from their approach. And they said not having experience on heart and lung transplantation. So they withdraw their involvements. Microbiology, most of the time they say virologist not available. Blood bank is the best. Pre-op investigation, it's not just to override 1 or 2 days like private hospitals. They have to send some to private labs, especially some radiology, HLA, PR testing. Patient does not have money to pay for these investigations. So the primary surgeon has to spend money from his pocket. Assistants and postgraduates also contribute. In fact, one recipient told, I am in Trichy, I don't have money to come to Chennai. If you give money, I will come as a recipient. Most of the recipients coming with a very bad condition of hepatic or renal failure and need to be stabilized. To assess cycloperin and diclofenac level, the sample sent to private hospital and we have to pay money. One case, heart and lung transplantation, we ourselves went and bought the possible injection. Harvesting. Initially, we could not maintain the temperature of the preservative solution. At present, we have approved cold box, that too also used for transport of donor heart. Harvest time vary and we could not fix the team and time. Implantation, lacking some technical points, somehow we managed with our experienced corporate colleagues. Since they are working in corporate hospital, they couldn't come and help because they have to cancel their entire work and OT list. ICU, here also we don't have any support from anesthetist team. They have to manage the ICU. We are surgeon, not anesthetist. In my observation, not only transplant, any patient who need to ventilator for more than 72 hours, facing the problem of either morbidity or mortality. Our PGs has to manage the case for a few days, more than a week, they are fatigued. Staff nurse also not to be committed and not well trained. Nitric acid, initially suppliers do not cooperate by saying cost of the monitor this much extra, this many lakhs, like that. Once we organized, we could not tell the exact time because various opinion from the centers, whether to start immediately in the ICU or the PKG pulmonary evidence does not come soon, it has to be started. Centers having variable opinion. Preoperative period team challenge. Case 1. We have gone or harvesting at a harvest one case around 1 AM. On table, it was found that the patient has atheromatous plaque in the coronaries. In fact, the fellow is 35 years old male. Otherwise, he is totally fit enough. Case 2. After mobilizing the team, we realized that donor had cellulitis and pustules over the medial aspect of thigh. So the organizers not observed. Hence, the procedure was deferred. These 2 cases were deferred after mobilizing our entire team from different part of the city because we don't have a fixed team. When this happened, more number of times, the entire team gets fed up and does not turn up on time. Case scenarios. One patient, male and female mismatch, same age, same body mass, but somehow by the digital X-ray, we could assess the correct size of the heart. But after opening only, we realized the heart is very small. On the table, once we realized the clamp, once surgery is over and release the cross clamp, developed a thing for the secretion continuously coming through the ET tube. We changed the oxygenator after 6 hours, then organized the ECMO. In fact, that day when I asked, they said no. Then again, I asked, requested Dr. Paul sir, how to organize. He immediately mobilized the ECMO and connected. In fact, the technician has helped us a lot. In fact, we managed the case for nearly 12 days. Patient stabilized. In fact, we weaned off the patient and was also all right. After even of everything, suddenly he collapsed. We couldn't save the patient. ECMO, so many troubleshooting. So my next professor or director will talk, so I don't want to talk about this. Manage the ECMO technician. What I realize is small size mismatch means mismatch. That's all. Post-op assessment. We have separate echo with TE. Some statement like pre-op assessment, the same thing Kadal is saying. Competent people are always coming into the job. Others could not come at all. Endomedical biopsy, they do not have equipment, interest, or experience. Still where we are. In my observation, 1 or 2 cases we can spend money from our pocket. Most of us are ready to contribute. Government, public are appreciating, but are not ready to give monetary benefit. So they don't show their interest. So, totally 13 cases being done in RGGH, including one heart and lung transplantation. This one is recently we have done one heart transplantation. Government has appreciated, but where we are. Even video labs comes. Still where we are. We have enormous donors, recipient also, but very poor people. We don't have coordinators. We ourselves have lack of experience, lab facilities also lacking. Tech level assessment also we couldn't have. When compared to the corporate hospitals, they have fixed team, appointed and paid for it. They are forced, committed to organize and proceed. We are not like that. We handle complex surgeries like aortic aneurysm, VATS, mix, etc. Adult congenital surgery also. Still, transplant is a challenge because it needs interdepartmental cooperation, coordination, and commitment. What to be done? Government has to come forward to create separate team or some incentives or monetary benefit to create interest, make it answerable, auditable, and to be committed.
It was an excellent presentation, and he has said like a lot of lacunas. The list of lacunas is extending to many slides, so cannot be coped up. So we are watching, and we are expecting the government will support us to move this program forward.
A lot of practical points I would appreciate. It was now we can realize how difficult the government set up to form it, and really appreciate your team's effort in proceeding with the transplantation, and also like you have done 13 heart transplants successfully. Thanks and congratulations for that. And thanks.
Thank you, sir.
May I request Dr. K. Damodaran, our director, Institute of Cardiovascular Thoracic Surgery, Madras Medical College, Rajiv Gandhi Government Hospital, to share talk on challenges in setting up of ECMO unit. Over to you, sir.
Good evening to all. My sincere thanks to the organizing team and Dr. Sundar and Dr. Madhur Kumar, and good evening to the chairpersons. The challenges sitting in ECMO in a government setup mainly. I cannot much pull down the government. The ECMO, the extracorporeal oxygenation, the techniques and development recent the white fastly is going on. And everyone know that we know arterial, we know venous, whatever it is. And the history of ECMO in India started way back 2001, and the widespread use of 2004 with various reasons. And 2010, the flying school along with its first airport transfer was done, and 2000 the ECMO started in ICU for a pre and post-operative during the post-operative lung transplant units, and 2013 extended for treatment of specific toxinomies. And the ECMO unit is not a simple unit as you think of that. It's more multidisciplinary. It's mainly the cardiac surgeons, editors, and respiratory therapists and anesthetists all together with the nursing leaders are most important according associated with the administrative leaders. All together only we can able to run the ECMO unit, especially administrative leaders for want of financial assessment, all things most necessary. And the procedure for the initiation is a surgical procedure, requires the CT surgeons and a preoperative team and in-house cardiac surgeons and anesthetist team and cardiologists for echo and TA procedures to be mandatory. And extra imaging also will be required. Respiratory therapists and perfusion technologists, technicians round the clock, and all the team on the in-house and the reservation team or reserve team also required, along with the multidisciplinary specialists also required, with the specialties nurses also required. The challenging will setting the code and awareness of the efficacy and for a right time and for a right indicator is most important, along with the public education, like and ECMO is available and the cost of the ECMO and the patients related for the possible complication, morbidity, mortality, everything should aware along with that. And the travel delay during the transport, whether it is everything is along with all the cost factors available to the financial resource and the importing license, especially with the importing all, because we are getting all the machineries from importing only, but the lack of local manufacturers amount to more cost. And the cost of procedures, I will put in approximately morning, that's nickel said the level is 7 lakhs per day, but I have shown the initial starting it is 1.75 lakhs to 3 lakhs. I don't think it is, but remaining all the factors, it is already mentioned of so many doctors. And setting up in the private sector is entirely governed by cover the cost of initiating treatment with the machine charges and kit disposables and other health worker charges and ICU charges, drugs and blood test monitors, anticoagulation. Everything is covered with majority of the things will go borne by the insurance and of course the patients involved. And when the government sector, majority of the things are borne by the government. Not nowadays we are getting only CMGHS fund only. And with that only we have to get all the drugs and the consumables, entire things, we have to maintain it. Very difficult. And regarding the difficult situation, the patient transfer on road transport or air travel is difficult, along with the machines or towards the machine, the patient with the highest center we are supposed to send. That also difficult. And regarding the transport, this is nosocomial in drug resistant infection and the prolonged ventilation and all other things which lead multiple tubes which lead to the reduction of survival rate about an ECMO is at 20%. When use of multiple coagulation for multiple coagulation for long-term use of ECMO, and we have to maintain it the INR rate, and along with all other factors which leads to the mortality rate, we have reduced the survival rate 8 to 10%. The co-factor like high disposable and higher recurring and maintenance charges per day and increased length of ICU day, higher antibiotics and blood-related product, and the multidisciplinary professionals involved. All put together is a lot of high cost per every day, and the lack of insurance and need to support the cost by the patient relatives, which is miracle. And the need for adequate and skilled machines and maintenance, whether the machines are not in use or during the use also we require biomedical engineer along with that to regularize use regular service for machine. And blood related product always necessary, but otherwise setup of extensive blood bank support is the issue, and blood use of blood product main anticoagulations and correct losses. The transfusion to prevent the complication also is also very difficult to maintain it unless otherwise we have a round the clock blood bank and we can get appropriate blood product also. It's most mandatory. Sometimes very difficult to get a negative report also, negative groups. And the labor management is the most important. This is minimum in-house cardiothoracic surgeon, highly trained staff nurses and internists, perfusionists, at least one round the clock, and the reserve also we require. And CT surgeons on call and anesthetists specialists on call also, which is required. And ventilatory and the round the clock we have to necessary with along with it in standby ventilator also with cost additional cost. The multiple lab tests to maintain the coagulation profiles with additional charges. and the need of adequate drug therapy to maintain iron and anticoagulants also, and trained aware personnel and identify the problems immediately and offer quick resolution for the ECMO to be beneficial. Adequate nutritional support, supplementation to overcome the prolonged ventilation ICU stay. That's also more difficult. But in the government funding, we are wicked, but this little bit we were able to get it, but via and other it's going to be incurred with all manpower, maintenance, but product we have to maintain it. So, but getting in bulk purchase bring down the cost of disposable, and guideline-based data regarding initiation, maintenance of the echocardiograms therapy is most important, and prevent unwarranted ECMO initiation, because the local guidelines most important. Initiate ECMO for the right patient, the right time for a maximum benefit. Integrated ECMO and along with the CB cardiopulmonary bypass unit also reduce a little more effect, because we had a case like that immediate post-operatively with the persistent severe pulmonary hypertension. We had moved the patient to ECMO unit along with the cardiopulmonary bypass, same circuit. Patient was managed overnight, and more trained person was necessary for a specialty ECMO unit, but still we are struggling to get it. But with the government permission, we had to cut down the imported torches and maintaining the local manufacturing units for components and cannulas. Simple machines assembling over the one unit, targeted investigators, more awareness about the timely intervention and more number of cases to avoid unnecessary ECMO runs and prevent consumable misuse, ensure bulk purchase and long-term cost more, all will bring the ECMO unit. And the local training and fellowship certificate course for medical transport personnel, and standardized regulation, monitoring, training programs and delivery, spreading awareness and classes, seminars, summits, CMEs, encourages participation, publication, standardized guidelines for the Indian scenario, we cater to local population and hospital conditions. So this has to be regularly followed to pull up the personnel who are required, mainly required for the ECMO training, including the doctors, staff nurse and paramedicals, most mandated to bring, at least we can initiate ECMO standards. Once again, this all three together only we can able to run the thing. Most issue all this mainly the money matters for this ECMO unit to create. Even the private sector is very difficult to run the show. So widespread use of ECMO about to come means we have to follow certain rules and regulations by government, especially mainly money related. I cannot force much against the government being a government doctor. Thank you so much.
Thank you very much, Dr. Damodaran. That is a very excellent talk and describing each and every details about the difficulties what you find in ECMO in a government setup. Thanks a lot for that. And thanks everybody who has participated and making the Congress successful. Thank you. We'll see you tomorrow morning. Thanks.
Good evening. I'm Dr. Sandeep Bansal. I'm professor and head of cardiology at Vardhaman Mahavir Medical College and Safdarjung Hospital in Delhi. My job this evening is to talk about in-hospital initiation of therapies for heart failure with reduced ejection fraction. I was wondering why I got this article and from where I got this particular topic. And what I came to see was that during the survey of literature, I found that there is an article of the same name, absolutely the same name, which has appeared in the European Heart Journal a couple of months ago. And this talks of dire need to, as far as possible, start the guideline-directed medical therapy prior to the discharge from the hospital for an acute decompensated heart failure. Before we go further, let's have a quick recap of certain facts. Whenever a person presents to us with acute decompensation of heart failure from a phase when he's been stable, there is a pre-acute heart failure stage wherein over a period of a few weeks, the patient becomes sicker and sicker. He ends up in the hospital, is discharged, and he takes another couple of weeks to become stable. So in the run-up to the hospitalization, there are a lot of changes that are taking place, like increased filling pressure, autonomic adaptations, weight changes, symptoms starting to occur before the patient presents with an episode which needs hospitalization. This is the clinical classification of how the heart failure patients may present. They may present with hypoperfusion or hypotension and back pressure changes such as wet lungs. So typically, if there is no hypoperfusion and no wet lungs, you have a patient who is warm and dry, has the best possible prognosis. On the other hand, you have the extreme right bottom corner, as one can see here, the cold and the wet patients who are the worst off because they have hypoperfusion as well as CREPS. These are four basic pillars of guideline-directed medical therapy in the form of RAS inhibitors and ARNI, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. This slide shows, it's a busy slide, but it shows in a nutshell all the drugs that we currently use in the guideline-directed medical therapy of heart failure. And on the right side, we can see what is the relative reduction of mortality risk that each of these drugs produces. Now, people have tried to analyze as to whether this starting of quadruple therapy benefit our patients. What are the parameters that they would benefit? This is an analysis by Vaduganathan in Lancet 2021, end of 2021, which clearly shows that there is a benefit in all-cause mortality, cardiovascular mortality, and both hospitalization for heart failure and composite of these two. So almost all parameters that we look for, there is a benefit if all the four drugs are started. The other thing is that if we start all these fours, what is the numeric benefit that we get? What has been seen is that if we start these on a patient who's 55 years of age, then we add a good 6.5 years to his life. And if we start these patients at the age of 65, then we add about 4.5 years. And if we start at 75, we add about 1.5 years of life to the patient. Why is there a need for speed? Why is there a tearing hurry to start these patients in hospital? And the reason lies in the fact that the benefits accrue very fast. This is from the Paradigm Heart Failure trial, which clearly shows that statistical significance in the difference and the greater degree of benefit of sacubitril valsartan starts to appear as early as 1 month after the patients have been started on these drugs. Similarly, In terms of SGLT2 inhibitors, again, as early as 4 weeks, we start to see divergence of curves, and there is a significant benefit if SGLT2 inhibitors are used. So what we are saying is that guideline-directed medical therapy reduces mortality, improves quality of life, and the benefits accrue within 3 weeks or so. Now, whatever therapies we give are associated with risks and benefits. The risks here are predominantly of hypotension, hyperkalemia, worsening heart and kidney functions, and benefits are very clear. You reduce the risk of hospitalization for heart failure, you decrease the mortality, and also you improve the biomarkers and protect the kidneys. However, what has been seen is that complete guideline-directed medical therapy institution is very low. In fact, as low as 1% of the patients currently receive all the 4 guideline-directed medical therapies together. And this is based on 3 drugs. These are data from the CHAMP heart failure, the US Pinnacle study, and the European Society of Cardiology studies. Now, there are, of course, multifactorial causes for why this is poor. These could include socioeconomic, patient-related factors, and of course, intolerance in some patients. Most important, of course, is that there is a clinical inertia. We know we should we should start these patients on GDMT, but we do not. There has been a paper about a year ago which said that we can start with low doses of all these 4 drugs, as is shown here, continue on to the second week, and titrate, of course, the beta blockers as required. And then over a period of 4 weeks or so, we up-titrate further, and thereafter we continue these drugs in up-titrated doses. Different classes of drugs have been studied in different trials and not together. This shows the various studies in which beta blockers institution at the time of in-hospital stay has been studied. Important being the optimized heart failure registry. It clearly showed that beta blockers do benefit. In fact, if your patients are on beta blockers, do not stop or have a very high threshold for stopping beta blockers because it is associated with adverse effect, and it is clearly beneficial to continue the beta blockers. Also, as soon as your patient is stabilized, start the patients on beta blockers and they will do well. As far as MRAs are concerned, a host of trials can be seen here. But if we really speak of a randomized controlled trial, which has seen the role of in-hospital initiation, then FSS trial comes to our mind, in which eplerenone was studied in post-MI LV dysfunction and was started 3 to 5 days after the acute event. And it was seen that it was associated with a significant reduction in mortality and benefits as early as 30 days. As far as the ACE, ARBs, or ARNI are concerned, at the bottom, we can see this Pioneer Heart Failure study, which is a very important study in which patients were started on ARNI in hospital after they had been stabilized. Now, what does stabilization mean? It means that you have not needed intravenous diuretics in the preceding 6 hours. You have not had an inotrope on board, and the patient is clinically dry and stable. If that is done, then the primary endpoint of reduction in NT-proBNP and hospitalization for heart failure is statistically significantly reduced. So there is a significant reduction with a p-value of 0.001, and this is without increased side effects. It's a drug therapy which is well tolerated. Similarly, in the transition study, if we concentrate here, patients were instituted on the therapy plus minus 3 days from the time of discharge, it was possible to achieve the target doses in majority of the patients quite early, and this was a safe procedure to do. As far as in-hospital SGLT2 inhibitors are concerned, this is the Impulse study in which patients were started on 10 milligrams of empagliflozin in the hospital, and there is a clear benefit with clear clinical benefit with the use of empagliflozin. So whenever the patient comes to us, what we are looking at is some immediate and acute targets, which basically aims at improving hemodynamics, alleviating symptoms, and limiting the damage to different organs, and of course, decongesting the patients. Decongestion continues. The initiation of GDMT starts in the intermediate phase, and of course, thereafter, we think of preventing readmissions, looking at improved quality of life, up titrating the doses of the GDMT, and also thinking of devices therapy if they are needed. Whenever these patients come to us, it comes to our mind, how should I start these patients? Is it safe to start all the 4 drugs in these patients? Will it be safe to discharge these patients from the hospital on all the 4 drugs? And of course, every single trial tells you that you should have a stable patient. The stable patient which should have hemodynamic stability with no symptoms of hypotension or need for intravenous vasopressors. There should be stability of key laboratory parameters, particularly kidney parameters, and there should not have been patients on diuretics in the intravenous diuretics in the preceding 24 hours. Now, there are different ways in which optimization therapies may be achieved. So ideally, we can start these therapies immediately or very early after the hospital admission. In a small percentage, this is possible. As I said, after about 2 weeks, you reassess the beta blocker therapy and the ARNI therapy, increase the doses, continue the SGLT2, and continue the mineralocorticoid. At 4 weeks or so, try and increase the MRA doses if required. If you have a special subset, for example, if you have a patient with low blood pressure, then MRA and SGLT2 inhibitors may be started early on, beta blockers may be added later, and the ARNI may be added even later. If you have poor worsening kidney functions, again, beta blockers and SGLT2 inhibitors may be started, MRAs may be added later. If there's a concern for low cardiac output state, then ARNI, SGLT2, and MRAs may be started, and beta blockers may be added later. There's a seminal paper by John McMurray, which talks of using these therapies in combination, particularly SGLT2 inhibitors and beta blockers they have talked about, and there are different ways to do that. So if this is a very important paper which says that it is safe for the beta blockers to be continued, for the ARNIs to be continued, and for the MRAs to be continued if your patient is on these. If you have to initiate or switch to guideline-directed medical therapy, it is also safe. However, one should not withdraw without a very solid reason. One should not withdraw the beta blocker or ACE-ARNI or MRA in a patient who's been admitted for heart failure. So the strategies include discussing the strategy of all the 4 drugs, start all the 4 drugs, initiate them in the hospital, start on a low dose, keep evaluating your patient, and optimize these. What are the benefits? We have rapid improvement in the health status within 1 to 8 weeks, improvements in the LV ejection fraction within 3 months, and hospitalizations for heart failure are again reduced by 4 weeks. So we get stupendous clinical benefits. What are the other drugs besides these that can be used? These are highlighted here: iron therapy, hydralazine isosorbide dinitrate, ivabradine, and digoxin. And of course, if patient has had more than one admissions for heart failure, then adding the new kid on the block, that's vericiguat, is absolutely in thing. This is my last slide, which says that it is safe to start ARNI in ADHF, particularly if your patient, as I said, is dry and warm. You can start beta blockers. You can start actually with metoprolol tartrate within the hospital and shift over to metoprolol succinate or bisoprolol or carvedilol as per your choice. MRAs again can be started within a few days, 3 to 5 days later, closely monitoring the creatinine and the potassium. And SGLT2 inhibitors also can be started about 2 to 3 days prior to the discharge or at the time of discharge, and these patients be followed up closely. I thank you for your kind attention. Thank you.
Good day, dear friends. This is a pleasure to be here and to deliver a talk on SGLT2 and ARNI, two faces of the coin in management of heart failure. I am thankful to HFAI for giving me this opportunity. So as we all know that heart failure is a major problem in human population and especially for Indians. We are at the receiving end for diabetes, for heart disease, for hypertension. The prevalence is as high as that 8 to 10 million people of heart failure are there in India, almost 1% of adult age group. We have more younger patients. We have more patients of rheumatic heart disease, although gradually now this is replaced by coronary artery disease as rheumatic heart disease is going down. And heart failure mortality is significantly high. We are almost 10 years younger to our American counterparts, and mainly males are predominantly affected. Our CHD burden is almost 25%, and we have hypertension, diabetes, IHD, everything in prevalence in India. And mortality is also formidably high in patients who are having heart failure and who are getting discharged or who are treated. So it's almost twice as more prevalent as compared to US counterparts. And sometimes it is even 9 times more as compared to our European and American counterparts. This is something contributed to low socioeconomic status, decrease in availability of health care system, and definitely to our patient education and availability of drugs and continuation and follow-up of these patients. So as the data says that CHD accounts, coronary arteries account for almost 3/4 of all patients of heart failure with reduced infection. Underlying diabetes is quite common in almost 50% of patients. 1 in 5 patients is dying within 90 days of hospital discharge, which is a quite high number. And 1 in 3 die within 1 year. At hospital discharge, only 1/4 of patients receive full dose of GDMT, which is required at discharge. So the ideal way to treat this patient is to give them proper treatment and proper GDMT, which is not done in most of the patients. 72% lower risk of 90-day mortality with GDMT is reported if we can start it during hospitalization, but it is not done. So this is all Indian data. So heart failure is reaching an epidemic proportion now, and we have to act now. The effect in Indian patient is much more severe. We are dying much more commonly. We are having disease much earlier than our European counterparts. Very limited data is available in Indian patients. Our socioeconomic status is very low. Resources are always an issue. Unaffordability is a major concern. Although now with reduction in the doses, the cost of the important medicines for heart failure has given us some opportunity that we can give these medicines to many more patients. But still there is the issue of availability, issue of awareness, and diagnosis and early intervention, which is much more important, is not as often practiced in India. So if we consider heart failure patients, they are being divided initially into a dichotomized way, that patients with below ejection fraction of 40% were considered reduced ejection fraction and above 40% was considered preserved ejection fraction. Now there is a new class which is added, is mildly reduced ejection fraction, which is between 41 to 49, and patients with preserved ejection fraction are 50. So this is actually a continuum from dichotomized way to trichotomized way of diagnosing these patients, is because it's easy to treat them, but it's actually a continuation. Many of the patients of mid-range infection may go into reduced heart failure, or may go into preserved infection, or may remain in the same state because of certain diseases. So we have to diagnose them at right time and treat them at right time. So this is a very important way to diagnose. The reduced patients, even if they improve, they are coming in the same category and the treatment will remain same. Patient with mid-range ejection infection can go into reduced ejection infection, can go into preserved ejection fraction, or can remain in the same parameter. And patient with preserved ejection fraction also can go into all three varieties. So accordingly, this is a continuum of disease, and some patient may improve, some patient may not improve, and we have to change the medicines accordingly. But it is very important that even after improvement, medicines should be continued. So the mechanisms are quite different for preserved ejection fraction and for reduced ejection fraction, but they have multiple common pathways also. And ultimately, they affect cardiac function, they increase hospital mortality, they increase cardiovascular death, and they cause worsening renal dysfunction, renal function. So ultimately, we have to prevent both of the spectrums of heart failure. Mainly, reduced infection is the one which is the studies much more, and multiple studies are done on this on multiple patients. And in last 20 years, we have seen many drugs like ACE inhibitors, beta blockers, MRAs, ARBs, and ivabradine, which are shown to be having improvement in cardiac function up to significant extent. You can see 33% reduction, 30% reduction, 17%, 19%. Still, 50% of patients are dying within 5 years of diagnosis. So although availability of multiple drugs and devices are there, still many patients are dying. These are the major changes which happen in last few years. Definitely ICD is a major improvement, which is always there. But now there are two new classes of drugs, ARNI and SGLT2 are added. If they are added, they are giving benefit over and above all these benefits which are already there. So we are getting additional benefit over and above the standard treatment, almost in the range of 20% in ARNI and 17% in SGLT2 inhibitors. So these are the two major entrants and are considered two major phases of heart failure. So if we discuss about heart failure with reduced ejection fraction, there are 4 pillars of heart failure management, and in these 4 pillars, along with beta blocker and MRA, 2 major pillars are ARNI and SGLT2 inhibitors, along with all other treatments like ICD, CRT, transplant. But step 1 and class 1 indication is that we have to start these 4 major drugs. This is the crux of heart failure management, that you have to start beta blocker and MRA, and along with that, ARNI and SGLT2 inhibitors. All 4 drugs are to be given to all patients, and they should be started as early as possible. Once we do this, we are acting through multiple mechanisms like angiotensin 2, neprilysin, sympathetic nervous system, mineralocorticoid, and multiple mechanisms which are still not known for SGLT2 inhibitors. And ultimately, by giving these drugs, what we are gaining is we are gaining at least 6 years of physically active life for them. So this is very important, that 6 years of survival added to these patients if we use these drugs in time. And this is one study which showed that if you use these drugs in time, so what is the best time is that we should add these drugs as early as possible and escalate them. So the data says that if we add all 3 or 4 drugs within first 42 days, and then escalate them further to the maximum tolerable dosage, then benefits are much more. You can see 42% further reduction in ARNI, 25% in beta blocker, 37% in MRAs, and 58% in SGLT2 inhibitors. So if we start these early foundational drugs and start them in timely manner, then benefits are much more as compared to starting them very slowly, adding them very slowly, patient coming after 1 month. So these are the 2 new drugs, and there is no way that we can say that now these are the 2 drugs, SGLT2 and ARNI, are the 2 phases of the heart failure, like heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So SGLT2 inhibitors are more effective for preserved ejection fraction, as well as they are equally effective for reduced ejection fraction. ARNI are more effective in reduced ejection fraction, although there's some role of ARNI in heart failure with preserved ejection fraction also, especially in females. So if we have to discuss about the first phase, which is always ARNI, because ARNIs have more robust data in heart failure with reduced ejection fraction. So ARNIs are always considered to be the first phase of the coin for heart failure management. As you can see, multiple trials are done. Pioneer and Transition are the initial trials which have shown that patients who are hospitalized with reduced infection, if we start these drugs, ARNI in them, then they will have significant reduction in NT-proBNP levels. They will have some trend toward decrease in mortality and decrease in the rate of rehospitalization. So these are the admitted patients, and once they are getting discharged, in transition studies, it was found that during discharge, pre-discharge, and post-discharge, they tolerate these drugs well, and incidence of readmission is going significantly down. If we go to the next phase, prove-it study, which is mainly in ambulatory patients who are at home. So you can see that ejection fraction is improving significantly. LV and diastolic volume and systolic volumes are improving. Diastolic indices are also improving. So just one drug can give you additional advantage, almost 10% improvement in ejection fraction over and above the standard treatment, which is very, very significant, because this is one thing which is hard endpoint and which is correlated with the patient's outcomes. And the first study which proved the beneficial is Paramount, which was proven in patients who are having stable heart failure. Already a stable heart failure patient, if you give them this new drug, they are significantly beneficial in terms of improving their outcome. Although in patients with preserved infection, Paragon study, the study was not positive, but in patients with mid-range ejection fraction up to 42%, and especially in females, this was found to be positive. So if we think about it, this is just a continuum of disease that all group of heart failure patients, like patients who are admitted due to acute heart failure, this is very beneficial. If they are discharged, the drugs are well tolerated. On their ambulatory phase also, there is improvement in heart failure and there is reverse remodeling. And even if patient is stable, we can further reduce the hospitalization and death in these patients by giving ARNI. So ARNI covers a complete spectrum of heart failure patient with reduced infection especially, and to some extent in preserved infection also, to improve outcomes. So there is a recent study which was a combined study of Paradigm, HF, and Paragon to cover the all spectrums of ejection fraction. Like Paragon is mainly for above 40% and Paradigm is for below 40% of heart failure. You can see the benefit is there in all group of patients, like in terms of CV death and hospitalization, in terms of CV death alone, in terms of heart failure hospitalization, all cause mortality, first and recurrent hospital admission, emergency room visits, all are significantly benefited in patients who are given ARNI. And this is right for all the group of patients, like even if patient is younger than 75 or older, if patient has ejection fraction below 35 or above 35. So the above 35 patient data is not that robust, but in patient with below 35% ejection fraction data is much more robust. It has no relation with GFR. All patients with all GFRs range are benefited. Patients without hypertension, with the hypertension are benefited. In patient with anti-proBNP is higher, the benefit is much more, but even in patient with lower levels of anti-proBNP, benefit is significant. So we can say that ARNI as one class of drug are so important that they improve all the parameters or biochemical parameters of heart failure, like anti-proBNP, cyclic GMP, troponin, profibrotic signaling, and ST2. All these are markers for chronic and heart failure with progression. It also improves decline in EGFR. So decline in EGFR is slowed. So kidney function will be going down because of heart failure, but they will go down slowly. All the LV indices like LV volume, LA volume, heart, ejection fraction, all will improve. And they will also correct systolic blood pressure. So ultimately, they are improving quality of life also and improvement in function class. So along with longevity of life, quality of life is also improving with these drugs, which is a phenomenal thing, because we want to live an active life, not just live for more years. And if we see this across the spectrum of ejection fraction, as this combined study of two studies, which showed that patients with all spectrum of EF from 15% to 75%, if we see the benefit is much more definitely in poor ejection fraction patient, but there is some trend toward benefit in patient with preserved ejection fraction or mid-range ejection fraction also. You can see in terms of total CV death and hospitalization, in terms of CV and non-CV deaths, in terms of all-cause death and total hospitalization for heart failure. The benefit is much more in patient where ejection fraction is below 30-35%, but still there is some improvement in patients who are having borderline low ejection fraction also. So this says that rate of primary composite outcomes of heart failure, hospitalization, and cardiovascular death and all-cause mortality decrease markedly with increase in ejection fraction due to the use of ARNI. And this rate of decline in event rate is significant in patients with poor LV function. Although the death and hospitalization data is not that robust, but still this says that if you are improving heart function or improving ejection fraction, this will definitely culminate into longer life and longer quality of life. So you can see here that in poor ejection fraction patient, benefit is much more. As the ejection fraction goes up, benefit is not that significant, but improvement in ejection fraction is significant, and that changes many things. Here also you can see that rate of ratio for this, there is gender difference. The benefit is much more in females as compared to males, especially in mid-range ejection fraction patients. But in the poor LV function patient, the benefit is equal. So we have to understand this, that this is a wonderful drug for patients with ejection fraction below 30-35%, but also for patients with mid-range ejection fraction, especially the females. Effect of HbA1c and insulin is also toward a betterment, that patient HbA1c declining is much less. They have improved HbA1c and new insulin use are also going down. So this is helpful in patients with diabetes also in terms of their glycemic control. So now come to the second phase, which is equally important, is SGLT2 inhibitors. So we all know that this is a modern drug and this is as effective as ACE inhibitors in management of heart failure. This has multiple extra advantages, that this is beneficial for diabetic patients also. This is found to be beneficial for CKD disease patients also. And now the data is developing on ASCVD also, like acute cardiac events or acute heart failure. Multiple studies are going on, and there is chance that this will come out to be positive. So the only negative effect of ARNI-R is that we could not find any benefit of ARNI in patients of acute myocardial infarction or ACS. Although corroborative evidence were there which showed that there should be a benefit, but in actual study we could not find any benefit. Now we are relying on SGLT2 inhibitor that they will come out with some robust data for these acute MI or ASCVD patients also. But otherwise, for all heart failure patients, for all diabetic patients, for all CKD patients, this is significantly beneficial. You can see the data of dapagliflozin is much more robust. Multiple studies are done and pooled analysis are done, which showed that there is significant reduction in sudden death, significant reduction in heart failure death, significant reduction in stroke deaths, MI deaths. So all these benefits are seen in patients of all ages and all ejection fraction. Although data is more robust for poor LV function patient, but also for preserved ejection fraction patient also, there is significant benefit in all forms of major cardiovascular endpoints. And this is beneficial in across the range of patients of ejection fraction from 15% to 60-65%. So this is most important thing about SGLT2 inhibitors is that they are the class 1 treatment for patients of reduced infection, but also for a preserved infection. This is a class 2A indication, which is quite powerful indicator that they should be used in all patients of heart failure with preserved infection and all those patients who are at risk of heart failure. So the spectrum is quite wide for the patients of SGLT2 inhibitors. And if we go by the data, there are multiple trials done on this. And if we divide them into two groups, one group is patients who are at risk of heart failure, like who are having no structural heart disease, but having some symptoms of heart failure, like patient of hypertension, patient of atherosclerosis, patient of diabetes, CKD, metabolic syndrome. So this is a whole spectrum of patients, and many patients, most of the patients coming to our OPD are coming into this. And there are multiple trials are done which have shown significant benefits of SGLT2 inhibitors in these patients. If we go to the next group where there is structural heart disease, like patient with acute MI, patient with LV hypertrophy, patient with low ejection fraction, there is significant data by impact MI, DAPA MI is still awaited. So these will give us some idea that in these patients also this is beneficial. But there is enough data for patients with reduced extraction and preserved extraction, deliver, DAPA, HF, Emperor preserve, Emperor reduce. They have shown that patients who have symptomatic heart failure, these drugs are very effective. And patients with recurrent hospitalization also, there is data from Solicit WHF that there is significant benefit in terms of improvement in worsening heart failure in terms of repeat hospitalization. And many more trials are going on in ACS patients. So possibly in that spectrum also, this will found to be beneficial. So this SGLT2 inhibitors are also ineffective in all spectrum of heart failure patient, like patient with high risk, patient with structural heart disease, patient with symptomatic heart failure. So that's why this is discussed that SGLT2 inhibitors and ARNI are the two faces of coin for heart failure management. They are controlling almost all mechanisms for heart failure development, like volume overload, like microvascular inflammation, like cellular and extracellular structural changes, cardiometabolic abnormalities, congestion and diastolic function, and left atrial hypertension, and pulmonary vascular disease and RV dysfunction. So all these mechanisms of heart failure development in preserved and reduced infection, they are being tackled by these two important drugs, SGLT2 inhibitors and ARNI. And this is the data from a very recent publication which showed that SGLT2 inhibitors are considered as round and ARNI are depicted in a square. And these are the different subgroups: diabetic, CKD, patient with reduced infection, patient with preserved infection, MI, and stabilized acute heart failure. You can see that SGLT2 inhibitors are much more beneficial in diabetic patients, even with very low event rates. Patients with slightly high event rate, they are still beneficial, like in preserved infection patients also, this was proven that SGLT2 are beneficial. ARNI are beneficial in patients with reduced infection, but in preserved infection, data is not that robust. Here also you can see in terms of all-cause mortality, DAPA of HF has shown significant benefit and Paradigm has shown significant benefit. So SGLT2 and ARNI are beneficial significantly. Although the data of Emperor Preserve is not that robust in terms of mortality, but we can prevent hospitalization. That is also more important than preventing deaths. Because if we can give them quality of life, they will give better. So that's why the guidelines have changed and multiple changes have happened in this. They have divided them into three groups: patients with reduced infection, patient with mid-range infection, and patient with preserved ejection fraction. So mild reduced infection patients, only the 2A indication is by SGLT2, but all other drugs are given 2B indication. Heart failure with preserved infection, MRAs are given 2B, ARNIs are given 2B, and SGLT2 are given 2A indication. And for reduced infection, all are class 1 indication. So we all know that this is the standard treatment. All these standard treatment are to be given to all the patients. And as we have already discussed, if we summarize whatever treatment is to be given for all group and all stages of patient. So in stage A, when patients are at risk of heart failure, SGLT2 is recommended. A patient with stage B, pre-heart failure stage, SGLT2 is recommended as class 1. ACE inhibitors, ARBs are recommended, and beta blockers are also recommended. So ARNIs are not recommended in this group in pre-heart failure. The role of ARNI comes when there is a data on ejection fraction is available, ejection fraction is less than 40%. They are class 1 indications. Beta blockers, MRAs, SGLT2, all are class 1 indications. Patients with mildly reduced ejection fraction, diuretics have class 1 indication. SGLT2 inhibitors are considered class 2A. All other are class 2B. And patients with preserved ejection fraction, again, diuretics are needed for symptomatic control, and they have class 1 indication. SGLT2 are again 2A, so they are very important. So you can see ARNI and SGLT2, they are the cornerstone of therapy in all range of patients, from, you can see here, from stage 1 to stage B to stage C, and all patients of heart failure. So if we divide how to give this appropriate treatment to all the patients, so this is how it is divided. For reduced infection patients, what is recommended now is that we should start as early as possible ARNI in them, and we should escalate the doses in first 2 weeks and reach to the maximum possible dose in maximum 4 weeks. Similarly, for SGLT2 inhibitors, for stable patients, you can start straightforward together with ARNIs and beta blockers and escalate the doses in next 2 to 4 weeks. Similarly, beta blockers can also be started as early as possible, or maybe after 7 days, and then escalate the doses. Only thing is about MRA is that because ARNI and MRA both have potential for hyperkalemia, so we have to check for hyperkalemia and hypotension. If that is not there, they can be added on second week and they can be escalated. But definitely checking of potassium is very important. Patients of acute heart failure who are admitted in hospital, there is no role of ACE or ARBs nowadays. ARNIs are the one which are to be started once patient is more stable, and the dose is to be increased on 2 to 4 weeks. Similarly, SGLT2 are to be started in hospital and the dose should be increased. Beta blockers should be started on admission even before stabilization, And MRA also can be started once patient is more stable and fluid overload is corrected. And the dose can be increased before discharge. So if we start them very early in hospitalization for ADHO patients, then chances are that they will recover much faster and they will have less chances of rehospitalization and re-death. Patients who are coming with first time de novo injection, reduced infection, in these also, both the ARNI and SGLT2 are indicated, although we prefer to start beta blockers and ARNI first, and then SGLT2 and MRA on second visit after checking for potassium. And definitely we have to achieve the maximum tolerable dosage in first 4 weeks or first month. So the maximum benefit is within first 42 days if we achieve all these doses. So with this, I want to conclude that definitely SGLT2 inhibitors and ARNI are the two phases of heart failure. And we have to start GDMT as early as possible in heart failure with reduced infection patient to give them maximum benefit as early as possible. SGLT2s are given class 2A indication for mid-range and preservation function patients also. So this is a new indication which is very important. And they have a very wide range of spectrum that patients who are at risk of heart failure, who are having no structural heart disease or structural heart disease, or patients with poor ejection fraction, all subgroups SGLT2 inhibitors are to be given. ARNI are to be given in patients with LV ejection fraction below 40%. They are indicated as class 1 indication. And below 40, or between 40 to 49%, they are indicated as class 2B indication. So it is very important that these two drugs, along with all other GDMT drugs, are to be given. And early diagnosis is very important. Early initiation of treatment is very important. And if we give them the GDMT more judiciously, that we can save more life, which is much more important in Indian scenario nowadays, because we are facing this epidemic of heart failure nowadays. So with this, I want to conclude that these are the two important drugs like SGLT2 inhibitors and ARNI, and they are to be used much more judiciously in much more patients to give us maximum benefit. Thank you.
Hello, everyone. I'm Dr. Vivek Chaturvedi. I'm head of cardiology department at Amrita Hospital, Faridabad. And today I would be talking on atrial fibrillation and heart failure, the deadly duo. So atrial fibrillation and heart failure are very often the products of the same soil, means that they are the outcomes of the same risk factors like hypertension, diabetes, structural heart disease like rheumatic disease or valvular heart disease, atherosclerotic disease, obesity, and most importantly, age. Because age is something with which both atrial fibrillation and heart failure incidence dramatically rises. And because we are amongst an epidemiological transition with increasing longevity, so it is expected that both atrial fibrillation and heart failure would rise in India as it is already done in the Western societies. Very frequently, atrial fibrillation and heart failure coexist. And when they do, they complicate and aggravate the course of each other. So I'll begin with a small case vignette of actual case of mine, which is an 80-year-old female with hypertension and normal heart. After a bereavement in 2020, she developed ischemic stroke, which recovered neurologically. But at that point, she was found to be in AF and a diagnosis of a cardioembolic stroke was made. An echo done 1 month later showed EF of 45%. She was put on beta blockers, but the heart rate was not controlled. Subsequently, over the next few months, she developed progressive dyspnea class 2, which progressed to class 3. And the echo showed deterioration to LV function of 25 to 30% only. So now she was in overt heart failure. So she was put on NOACs, amiodarone, beta blockers, and subsequently we went ahead and cardioverted her electrically. With this, she became asymptomatic and her LV function after 6 months was back to normal. This continued for about a year when she had another family tragedy and the AF recurred. And that is known that AF can happen because of emotional as well as other stressors in life. And this was again followed by progressive LV decline and symptoms all over again. So this is a clear case of AF course being complicated by progressive reversible LV dysfunction. The second vignette is the other way around. So this was a 72-year-old male who was diabetic post-bypass, severe LV dysfunction. He has had recurrent VT, paroxysmal AF, couple of episodes of intermittent CHB also recorded, had non-specific IVCD with a QRS of 170 millisecond, and he was class 3, very often requiring admissions for ADHF. So with guarded prognosis, he underwent CRT-D implantation. And with that, his functional class improved to 2, but there was no improvement in LV function. However, after a couple of years, he developed persistent AF with recurrent hospitalization for ADHF, which had been not there for the past couple of years at least. So rate control and attempted rhythm control with amio had no effect. So he underwent AV node ablation with significant improvement because now the AF was still there, but the heart rate was regular. And with that, his ADHF admissions almost stopped completely. And he stayed in this condition in class 2 for 2 years before succumbing to CKD. There are many such cases of different types of heart failure, like restrictive cardiomyopathy, which is often complicated by atrial fibrillation, rheumatic heart disease with mitral stenosis or MR, which are often again complicated by atrial fibrillation, and elderly people with heart failure and preserved ejection fraction. And all these subsets of heart failure typically they can have atrial fibrillation, which complicates the course and leads to recurrent hospitalization and actually even increased mortality too. So why does this happen? So as I said, that heart failure and AF really are the two sides of the same coin, which is degeneration of the heart. So in heart failure, because of increased filling pressures, maybe some atrial cardiomyopathy, neurohormonal activation, and increased LSIs can lead to AF. And then, AF per se can reduce cardiac output. It can cause irregular heart rate and several other mechanisms by which the electrical irregularity couples up to, changes in the calcium load, and that causes progressive fibrosis and altered hemodynamics of LV filling and load. So there are obviously mechanisms involved at hemodynamic, structural, and ultrastructural level. I would not go into the details of these, but there are excellent reviews for this available on the internet. But important to remember as far as our perspective of AF and heart failure is concerned is that this kind of an electropathy, which is the abnormality of the electrical system of the heart, can actually cause heart failure because of several different mechanisms. And with AF, as we can see, that there is an irregulopathy, a tachymyopathy because of increased heart rate, a loss of coupling between the atria and the ventricles, and the dysynchronopathy, which typically does not happen with AF alone. And again, ablation of AF can actually take care of all these three aspects, while if we do a CRT and AV nodal ablation, that only takes care of a tachycardiomyopathy. What is well known, and I will show you probably in the next slides, is that while AF usually can cause heart function to reduce, it can also aggravate or decrease effective treatment of heart failure, which is very often seen in patients who are on CRT devices. And when AF develops, the biventricular pacing reduces and they keep on getting symptomatic heart failure. So how big is the problem of AF and heart failure? Well, if we look at some community-based studies like this one, which was a nationwide Swedish heart registry, then as you can see that the AF prevalence is sizable across different age groups. What is noteworthy is that this prevalence increases with age. And also what is known for the past decade or so now is that the prevalence of atrial fibrillation is actually higher in heart failure with preserved ejection fraction. So you can clearly see that in every age group, the prevalence is higher in heart failure with preserved ejection fraction, which has only begun to come under notice now. And one thing is clear is that irrespective of the cause, whether it is preserved or mid-range or reduced ejection fraction, the prevalence of AF is significant, and approximately half of the patients in the long run actually get AF at any point of time when they have heart failure. Not only that, there is a gradation also been reported with this, which means that as the severity of heart failure increases, the patients who have atrial fibrillation also increase in number. And what impact does it have? So you can clearly see in the same registry from the Swede Heart Failure Registry that as compared to patients with sinus rhythm, in all kinds of heart failure, the mortality and the hospitalization rates are quite adverse in presence of AF. And this is true whether you have preserved ejection fraction or you have reduced ejection fraction when compared to sinus rhythm. With almost about 20% increase in mortality, all-cause mortality because of AF in these patients. What about development of heart failure in new AF? So with this, there is some, while there is no doubt that the heart failure incidence rises in patients of AF as compared to patients who don't have an AF. The exact percentage changes probably because there is some temporal differences. With this registry from US reporting at a development of about 1/5 of the patients getting into heart failure at 5 years amongst patients who had first AF diagnosis, and the mortality had increased by more than 3 times in patients who had heart failure as compared to those with AF who did not have heart failure. Most recent data, which is a global registry, is showing a little bit less development of heart failure, probably because of better treatment aspects. And this is that about 2% per year development of new heart failure in patients who are newly reported to have atrial fibrillation. Again, as was seen earlier, majority of these patients actually have heart failure with preserved ejection fraction, while some also have reduced ejection fraction. And this development of heart failure causes increased mortality as well as higher hospitalization. Typically, the risk factors for heart failure development in AF are traditional heart failure risk factors like diabetes, hypertension, heart disease, obesity, apnea, but also presence of permanent AF as compared to paroxysmal AF and higher ventricular rate at baseline. They are all predictors of development of heart failure in this population of new onset AF. And then, in this, you can clearly see here that in patients who have, as time goes by after years of heart failure, the outcomes are not that different in patients of reduced ejection fraction. But when you look at patients with, as compared to others, then obviously the mortality rate rises after development of AF in presence of both reduced ejection fraction and preserved ejection fraction equally. So essentially, LV function per se does not matter as much as the development of heart failure does, whether it is of preserved ejection fraction or low ejection fraction. Again, looking at this from a different point of view of patients who have hospitalized AF. So this is data for more than 10 million heart failure admissions in US over 10 years. As we saw before with the Swedish data, the prevalence of AF here was 41%. And with increasing time trends, it's being found that it is happening more and more in populations besides whites and also in younger population. And the in-hospital mortality is also increased in those with AF as persistent without AF. And again, as we can see that the percentage of patients who develop AF is higher with preserved ejection fraction. So we know that this problem is enormous, it is significant. So how do we tackle this problem? So I think one commonsensical thing is aggressive control of risk factors common to both. This has a role not only in the primary prevention, but also in the secondary prevention of development of AF or heart failure. So this consists of, good control of hypertension, diabetes, alcohol intake, which is a very common risk factor for development of both obesity, sleep apnea, and then uncorrected heart disease like rheumatic heart disease, ischemic heart disease, or valvular heart disease. Also, as I would show you next, there is some data to suggest that early rhythm control in patients with AF as compared to rate control alone also has good salutary effects on development and worsening of heart failure in this population. On the other hand, patients who have established heart failure, they do very well with the control of risk factors. And once they develop AF, then aggressive control of this AF is very important in these patients. So as I said, that, development of heart failure, though quite bad in patients with AF, is not so problematic as development of AF in heart failure. Because with development of AF in heart failure, I suspect it kind of denotes some degeneration of the substrate. And so control of AF is very important with pulmonary vein isolation by ablation, antiarrhythmic drugs, and if these things are not possible or feasible, then AV node ablation with cardiac resynchronization therapy through different means. So the medical management of AF to prevent heart failure, there is some exciting new data. We are already aware of the East AFNet trial, which was presented in 2020. And this was a sub-study from that trial, which showed that amongst patients with new onset AF developing within the last 1 year, amongst those with heart failure, early rhythm control had significant benefits in amongst the primary outcome of cardiovascular events, hospitalization, and mortality. And this was quite significant. So because of this kind of data now, the latest guidelines for management of AF in heart failure from ESC and from ACC, they always look for good rate control and then rhythm control, and followed by ablation, amiodarone, or AV node ablation. So important thing is do not ignore development of AF in patients with heart failure, because if you do, it's invariably going to be followed by hemodynamic and heart failure worsening. That brings us to the most important and most effective way of controlling AF, and that is amongst those eligible of offering catheter ablation. And there are plenty of trials, all of them being of small to medium size, but together, in this meta-analysis, about more than 2,000 patients with randomized controlled trials. And you can see that there is a clear-cut reduction in all-cause mortality and heart failure hospitalization by about 35%. Not only this, the quality of life also improves. The ejection fraction improves significantly as compared to medical therapy by almost 5 percentage points, and the 6-minute walk test increased by 20%. So I think amongst people who are not getting their AF controlled because of antiarrhythmic drug therapy, they should be offered a pulmonary vein isolation. This is true especially for patients with reduced ejection fraction. With preserved ejection fraction, the data is still being collected. And if this is not possible because of failure or because of patient is too frail or old or not a candidate, then if you do an AV node ablation and put in a CRT device, then the outcome is as good as those with sinus rhythm. And this is indeed very gratifying thing. So amongst these patients, it doesn't matter whether they have narrow QRS or wide QRS, but if they have heart failure, if they have resistant AF, then they do very well with AV node ablation and CRT if they are not a candidate for pulmonary vein isolation. So to conclude, AF and heart failure are outcome of the same circumstances of degeneration which happens in the heart with aging and other risk factors. If you have AF or if you have heart failure, either one of those, it should always alert you to the possibility of the other one lurking around the corner. So one should have enhanced suspicion for this. And there is very interesting study recently reported that amongst patients with unexplained dyspnea with AF, heart failure with preserved ejection fraction is very, very common. In patients of AF, actually heart failure is more common than stroke. So let that sink in.
I don't understand Tamil.
What we are worried about most is stroke, but actually heart failure is actually even more common in AF than stroke, and it increases mortality. While we have always focused on stroke, the time has come now that we also focus on development of heart failure in this population. Presence of atrial fibrillation in heart failure is more sinister and increases the event rates. This is true for heart failure with preserved ejection fraction also. Prognosis of patients admitted with heart failure and AF is, both is grim unless treated aggressively. And rhythm control, preferably with ablation or AV node ablation plus cardiac resynchronization therapy, is the treatment of choice for AF in heart failure. Thank you so much for your patient listening. Thank you.
Hi, Vivek, if you're there, can you please turn your video on? Hi.
Hi. Hello.
I'm Sandeep here.
I know, sir. How are you?
Great talk, actually very exhaustive and very elaborate. And the AF is indeed a very pertinent problem. And you think presence of, heart failure in patients with AF, or I should say presence of AF in heart failure should be a very strong reason to look at rhythm control rather than, upping upon the rate control, because most of the drugs that we use, they don't reduce mortality in patients with atrial fibrillation.
So, yes, Dr. Sandeep, you have pointed out very rightly. So I think it has always made sense that patients with AF should be in sinus rhythm. Up till now, what was happening was that the tools for putting them into sinus rhythm were not of good quality. They had many, off-target effects, a lot of adverse effects, because of which it was still, because of this, they were still not getting the kind of benefit with sinus rhythm as they're supposed to get. Things have changed in the last 4 or 5 years with the release of East AFNet trial and the recent catheter ablation data, which has become progressively more safer also. I think while the jury may still be out there for uncomplicated AF, it is very clear that patients with AF who are in CHF should definitely be offered anti-arrhythmic therapy in terms of medicines or ablation. And if they are not eligible for this therapy or they have failed this therapy, then they should be offered, AV node ablation with the implantation of a left bundle branch area pacing or of a CRT device. This has been shown in several places, in several studies now, to even, give mortality benefit. So it is clear that this should be there. The problem we have in our country is the relative ignorance about AF in these patients. And so I think opportunistic screening of AF in heart failure patients is a low-lying fruit, which can be easily picked.
Yeah, that's a very great point. I accept that. And I'm glad you stressed in your slide the importance of some very important causes like obesity. There's a fair enough data to say that if you take care of obesity, you can actually control or even reverse atrial fibrillation in some patients. What's your thought on that?
So this is very much true. there is a lot of basic science data, experimental data, and then conversion to the clinical way. And Prash Sanders group from Adelaide, Australia has done some phenomenal work on this. And through the various requirements of a causative, they've shown that obesity is almost causative of AF, especially in people who have higher BMI. And that control of obesity or reversal of body weight, it causes reduced AF episodes and increases the efficacy of ablation and antiarrhythmic drugs also. Similarly, I think it has become quite clear that sleep apnea has such a huge role to play both in heart failure and in AF. And I think a lot of these patients with reduced ejection fraction and atrial fibrillation should be subjected to sleep studies, because subjecting them to CPAP, if required, will have a very good effect on both the heart failure quality of life as well as on the occurrence of AF.
Thank you, Vivek. It was great talking to you, and I'm sure the guys who've been watching would have benefited from the 3 talks that were done this night. Thank you, and I think
thank you.
We are well past our allotted time. We'll call it off
Nice
now.
catching up
Thank
with
you
you.
so very
Thank
much.
you. Thank
you. Bye.
The residual risk in heart failure and reduced ejection fraction. If you look into the trajectory of heart failure, it's a chronic progressive disease. After diagnosis of the heart failure, the treatment, improvement, worsening, improvement, worsening, persistent worsening, culminating in death. So this is the usual trajectory of heart failure. So a period when you can see that patients are at risk of development of heart failure, then they develop heart failure, we diagnose the heart failure, start the treatment with guideline recommended medical therapy, then a variable period during which there is a residual heart failure risk despite the initiation and titration of guideline recommended medical therapy. We may use an ICD or CRP as recommended. There is the risk of worsening of heart failure. Patients' heart failure can worsen despite the optimal medical and the device therapy. Finally, the disease progresses and there is an advanced heart failure risk. At this point, the patient is refractory or intolerant to the guideline recommended medical therapy. We may have to consider mechanical cardiac support, LVAD or a BiVAD, heart transplantation, or IV inotropic therapy, or even palliative care. So if you look into the historical development of the guideline recommended medications for heart failure, you can see the SALT trial, enalapril, significant residual risk, even with the use of enalapril, close to 28%. CBIS2, significant residual risk with beta blocker, mineralocorticoid receptor antagonists, along with RAS inhibitors and beta blockers, significant residual risk. And even in the paradigm heart failure, published in 2014, which was considered to be one of the best therapy available for heart failure, there was a 16.5% risk, a 13.3% risk in patients on ARNI regarding the cardiovascular death. So the well-managed patients with heart failure and reduced ejection fraction, they may see an improvement with ARNI, but at risk of cardiovascular death or heart failure hospitalization, and you can see 21.8% of the patients of ARNI died from cardiac causes or had a first hospitalization for a worsening heart failure after a median follow-up of 27 months. Emperor reduced. The RAS inhibitors, beta blockers, MRAs, along with the SGLT2 inhibitor, the residual risk is close to 20% for a death or heart failure hospitalization. DAPA-HF, 16% residual risk. So the current best medical therapy or the quadruple therapy, the 4 pillars of therapy, there is significant residual risk for worsening of heart failure or death. You can see the residual risk in heart failure and reduced ejection fraction remains that despite the use of heart failure medications. 15 to 20% with quadruple therapy. SGLT2 studies, you should understand that ARNI penetration was not full, it was only 11 to 18%. And in these patients, all the patients are not on full guideline recommended drugs.
And those patients on the quadruple therapy, they are not, all of them are not on the full doses. So that is a limitation in the assessment of the residual risk and finding solutions for the residual risk. And I still believe we have to press for full guideline recommended quadruple therapy on full doses to reduce the residual risk. That is the most effective therapy to reduce the effective risk. Despite the guideline recommended medical therapy, there is a residual risk for worsening of heart failure or death, and we have options like drugs, devices, and of course, correctable factors should be identified and tackled. The nitric oxide pathway, there is a relative less availability of nitric oxide in heart failure, which leads to inflammation, fibrosis, and myocardial hypertrophy, endothelial dysfunction, vascular vasoconstriction, and renal fibrosis, and a decreased renal blood flow. If you tackle it by giving a soluble guanyl cyclase simulator and increase the availability of cyclic JMB, it can be anti-inflammatory, anti-fibrotic. It reduces myocardial fibrosis, improves cardiac remodeling. It improves the vasoconstriction. It reduces the endothelial dysfunction. It improves renal fibrosis, improves the renal blood flow, all beneficial in heart failure. Victoria trial with the use of vericiguat. High risk of patients or more sicker group of patients can see 41% had NYHA class 3-4 when compared to around 30% in the SGLT2 inhibitor or ARNI trial. Higher NT-proBNP level, a lower cutoff of EGFR, and the placebo event rate close to 38%, and 100% focus on the worsening of heart failure patients. So sicker group of patients, for 15% on ARNI, 93% on beta blocker, 74% on ACE or ARB, 70% on MRA, close to 30% on ICD, and 15% on biventricular pacing. So well treated with guideline recommended medical therapy, 10.8 months median duration of treatment, a benefit mostly in terms of reduction in heart failure hospitalization, and the number needed to treat for a year is 24, and you can see the curve start separating at around 4 months. 40 to 78% of the benefit of the vericiguat on the primary outcome could be attributed to the early reduction in the NT-proBNP, which tells us that there can be functional or structural or both improvement in the cardiac function. And this is the direct cardiac benefit of the vericiguat. Absolutely nothing we are paying for the benefit. You see the rate of AEs and SAEs were numerically lower with vericiguat when compared with placebo. So it's a drug which is well tolerated. And there is an additional benefit. It is complementary to the use of ARNI. So benefit of this thing was observed irrespective of ARNI use at baseline. A class 2B recommendation for worsening of heart failure on GDMT, AHA, and ESC also, that's a class 2B recommendation for worsening of heart failure despite the guideline recommended medical therapy. A new drug that is coming in, Galactic HF trial, the omecamtiv mecarbil, which reduced the composite of heart failure hospitalization or cardiovascular death. But there was no significant reductions in the component of primary endpoint. We may require a better data with this drug, but it's still it's a glimmer of hope. Iron deficiency. All the other previous iron deficiency trial with the current Ironman trial all have demonstrated benefit in terms of reduction in basically improvement in the quality of life, and some studies showed a reduction in heart failure hospitalization. So iron deficiency diagnostic workup for all newly diagnosed heart failure patients, all patients who have a worsening of heart failure, and if there is iron deficiency, it should be corrected with iron carboxymaltase intravenous. Heart rate targeted therapy in heart failure. Heart rate has got a direct correlation, or it may be a surrogate marker in the drug effect, the benefits offered by drugs in heart failure. You see the beta blocker trials as the magnitude of reduction in the heart rate with beta blocker is correlated to the benefit of the treatment in terms of reduction in heart failure hospitalization and mortality. In heart failure, those patients who have a higher heart rate had a poorer prognosis when compared to those patients whose heart rate is between 58 to 64. So in those patients whose heart rate is above 70 beats per minute, despite maximum tolerated dose of beta blocker, ivabradine is indicated. and it is supported by the data from the SHIFT trial, a 30% relative risk reduction of heart failure, hospitalization or death in 30 days. And it's also predominantly driven by reduction in heart failure hospitalization. You can see the curves start separating quite early. So this is the medical therapy armamentarium available now. Apart from the standard 4 drugs, the quadruple therapy, we have ivabradine, we have the vericiguat, omecamtiv mecarbil, and in selective population, isosorbate dinitrate with hydrolysine may also be useful. Digitalis in certain patients. ICDs and CRP. So patients with non-ischemic DCM or ischemic heart disease, at least 40 days after a post-MI with ejection fraction less than 35%, class 2, class 3 symptoms, who have a reasonable life expectancy of more than 1 year, ICD therapy is recommended for primary prevention, and it provides high economic value. This is a standard indication, but now the concept after the current concept, it is not the ICD and CRP that reduces the sudden cardiac death. These drugs, RAS inhibitors, beta blockers, MRAs, SGLT2 inhibitors, all reduce the sudden cardiac risk death in heart failure and reduced ejection fraction. So it's reasonable to reevaluate the indications for an ICD therapy in patients on contemporary guideline recommended medical therapy for heart failure with reduced ejection fraction. CRP, standard indication, left bundle branch block, QRS more than 150 seconds, NYHA class 2 to 3 or ambulatory class 4 on guideline recommended therapy. It reduces mortality, reduces hospitalization, improves symptoms. So these two are effective therapies to reduce the residual risk of worsening of heart failure or death. And when all these things fail, and all the medicines fails, complementary to medicines, we have a lot of gadgets available right now with the baroreflex activation therapy, LV reconstruction, cardiac contractility modulation, phrenic nerve stimulation, and the mitral clip. So the FDA approved therapies in heart failure and reduced ejection fraction, with ejection fraction less than 35%, between 35 to 50%, NYHA class 2 or NYHA class 3, NYHA class 4 transcatheter edge-to-edge mitral repair. The baroreflex activation therapy in the transcatheter therapy in moderate to severe secondary MR with ejection fraction of 20 to 50% with the LV and systolic dimension of less than 70 millimeters without significant pulmonary hypertension. Other investigational therapy like left ventricular reconstruction, vagal nerve stimulation, interatrial shunt devices, asymptomatic diaphragmatic stimulation, cardiac contractility modulation, a signal applied during the absolute refractory period to the RV septum. Why standard pacing is it is not a mechanistic improvement, rather it improves the contractile efficiency of the cardiomyocyte. So the biological effects seen remotely over time and rapidly in the region of signal application. It reduces it improves the NYHA class, it reduces the heart failure hospitalization. So LVE of 25 to 40%, QRS less than 130 milliseconds, and NYHA class 3 or 4 despite guideline recommended medical therapy, this may be an option. The baroreceptor activation therapy, activating the baroreceptors, reducing the central sympathetic outflow. The BEAT-HF trial showed a reduction, improvement in the quality of life, improved 6 minutes walk, and it reduces the NT-proBNP at 6 months. Again, NYHA class 3 or 4 despite guideline recommended medical therapy with an LV ejection fraction of less than 35% who are not candidates for cardiac resynchronization therapy. Vagal nerve stimulation. Again, the neuromodulation, the sympathetic outflow decreases, the parasympathetic outflow increases. The Anthem HF and the Innovate trial, of course, there is a negative trial also, and newer trials are coming up. There can be a change in the LV end systolic volume, improvement in the 6 minutes walk test, improvement in the quality of life. The phrenic nerve stimulation for tackling the central sleep apnea, which has got a strong association in heart failure patients, especially the severe heart failure patients, highly symptomatic heart failure patients. Without central sleep apnea, also asymptomatic phrenic nerve stimulation of the diaphragm has been found to be beneficial. It may require more studies for the recommendation. Splanchnic nerve block is the new concept coming up. The splanchnic vascular reservoir, the splanchnic vascular system is one of the most important vascular reservoir systems in the body. So even without increasing the total blood volume redistribution plays a role in the congestion. So if you manipulate the splanchnic blood volume, you give the splanchnic nerve block, it decreases the vascular tone, the venous and the arterial tone. So that volume redistribution into the abdominal compartment, which leads to decongestion. This is another therapy that can be offered. Endoarterial shunt devices. This has shown to reduce the pulmonary capillary wedge pressure and pulmonary venous congestion. So my final thoughts on the residual risk in heart failure. There is a significant residual risk in heart failure despite current 4 pillars of therapy. This risk is for risk of worsening heart failure or arrhythmic death. A full dose persistent quadruple therapy, if tolerated, is the primary aim to reduce this residual risk. An ICD or a CRT are as per indications. Correct the iron deficiency. The options of vericiguat and ivabradine should be utilized depending upon the heart rate control and also depending upon the presence or absence of worsening of heart failure. Despite guideline recommended therapy, if there is worsening of heart failure, vericiguat is a definite option. Ivabradine, if the heart rate remains more than 70 beats per minute despite the maximum tolerated dose of beta blocker. The baroreflex activation therapy, cardiac contractility modulation, and mitraclip are upcoming therapeutic options. Thank you so much.
Respected chairperson, respected senior members, and my dear friends. At the outset, I would like to congratulate and thank Dr. Abraham Oman and his team for arranging this excellent conference with jam-packed carry-home message topics. The topic given to me is asymptomatic LV dysfunction. What are the questions for which you will get an answer from my 20 minutes talk? What is the classification of LV dysfunction, staging of heart failure, prevalence of asymptomatic LV dysfunction? What is the prognosis of asymptomatic LV dysfunction? What is the use of detection of asymptomatic LV dysfunction patient? What are the imaging techniques to assess asymptomatic dysfunction patients? Non-imaging techniques to assess the asymptomatic LV dysfunction patients? What are the trials for asymptomatic LV dysfunction? What do the guidelines say? And lastly, most important, how do you translate these trials and guideline recommendations into our day-to-day prescription? Let me start with the staging of heart failure. Stage A is high risk of developing heart failure with the patients having risk factors alone. Stage B is structural heart disease without symptoms of heart failure. Stage C is structural heart disease with symptoms related to heart failure. Stage D is progressive or persistent features of heart failure despite optimal medical treatment. The focus of discussion and the topic given to me is structural heart disease without symptoms of heart failure, that is asymptomatic LV dysfunction. What does the term asymptomatic LV dysfunction mean? The definition of asymptomatic LV dysfunction remains elusive, secondary to the challenges posed by heterogeneity of the descriptions used in the literature, coupled with heterogeneity in the non-invasive techniques used to study the phenomenon. If you want to expand the term asymptomatic LV dysfunction for the benefit of the junior medical officers in this meet, it can be patient may be truly asymptomatic. Second is patient may deny the symptoms. Third is patient may have atypical symptoms which the treating doctor may miss, and the treating doctor may miss to elicit the history. Whatever may be the field, whatever may be the topic, irrespective of whether it's cardiology or LV dysfunction, acute coronary syndrome, gynecology, ophthalmology, or urology, art of the eliciting a proper history is very, very important to clinch the diagnosis and to manage that particular patient. Having seen the staging of heart failure, let us go to the classification of the heart failure. Very simple classification is systolic heart failure and diastolic heart failure. When MI is so interesting to treat, why we should think about heart failure, my dear friends? To answer this question, you need to know about the epidemiology of heart failure. When you take the categories of casualty admissions of heart failure, heart patients, It may be acute coronary syndrome patients, heart failure patients, valvular heart disease patient, arrhythmias patient, myocardial, pericardial disease patient, and lastly, congenital heart disease patient. Having seen the list of cardiac patients admitted in the emergency triage and casualty department, the message is heart failure is the most common cardiac cause of casualty admission in patients more than 65 years. So heart failure outcomes, when you compare the heart failure 5-year death rates, when you compare breast cancer, Hodgkin's lymphoma, non-Hodgkin's lymphoma, colon and rectal cancer, and leukemia, heart failure, if left not well treated, the 5-year death rate is more than breast cancer and Hodgkin's lymphoma. So heart failure outcomes, if it is not well treated, there are certain numbers. 1/3 die during the admission. If discharged, 1/4 die within next 3 months. 1 in 5 patients die within 1 year of diagnosis. 1 in 4 heart failure patients more than 65 years are re-hospitalized within 30 days of discharge if the heart failure patient is not addressed properly. Having seen the staging and the importance of treating the heart failure, let us go to the prevalence of asymptomatic LV dysfunction. ECHO was done in a subset, in a study in 5,649 subjects. 7.3% were classified as asymptomatic LV dysfunction with an ejection fraction less than 50%. It was population-based longitudinal study among adults more than 65 years with history of coronary artery disease and stroke. The study was undertaken in 1989, but advances of risk factor management and pharmacotherapy has changed the clinical profile of cardiovascular patients since then. Nevertheless, this study permitted evaluation of the risk factors in older patients as well as in particular groups that had previously been underrepresented in epidemiological studies such as women, which was accounted for almost 50% in this study. So having seen the prevalence of asymptomatic LV dysfunction, what is the use of detecting asymptomatic LV dysfunction? It can allow early initiation of pharmacological therapy to mitigate the progression of the disease and improve the outcomes in this group of very important subset, asymptomatic patients. So if you want to elaborate and substantiate this treatment, this statement, that is early treatment and addressing the early treatment in the asymptomatic stage, you need to know the prognosis of the asymptomatic LV dysfunction. A population-based sample of 2029 patients aged more than 45 years had a stage B heart failure, that is asymptomatic, characterized by structural or functional abnormalities with an ejection fraction less. Among patients with stage B heart failure, the risk of all-cause mortality was 4-fold greater in men than in women. There was a tendency for a 1.8-fold increased risk of all-cause mortality for those with stage 4 heart failure. So observation from the Framingham study also revealed that the subjects with asymptomatic LV dysfunction had a nearly 4-fold increased risk of death than subjects with a normal LV ejection fraction more than 50%. So having seen the prevalence, prognosis, and the importance of early detection of asymptomatic LV dysfunction, let me go to the next stage of my presentation. How do you investigate a case of asymptomatic LV dysfunction? You can do by imaging modality and non-imaging modality. Imaging techniques assess asymptomatic LV dysfunction can be done by echocardiography, and alternative imaging technique is cardiac MRI. Echocardiography, the most important variable is ejection fraction. So based on the ejection fraction, ACC classification by ejection fraction, heart failure with reduced ejection fraction, LVEF less than 40%. Heart failure with improved ejection fraction, I underline the statement, heart failure with improved ejection fraction is the new terminology included in the latest ACC classification of heart failure based on the ejection fraction. Previous LV ejection fraction is less than 40% in that particular patient, and if there is improvement after the treatment more than 40%, that patient is subgrouped under heart failure with improved ejection fraction. Heart failure with mildly reduced ejection fraction is the next group of classification, where the patient has an ejection fraction between 41% to 49%. Heart failure with preserved ejection fraction, that is ejection fraction more than 50%. So having seen the classification of heart failure based on the ejection fraction, let me go to the next variable, global longitudinal strain in echocardiography. Global longitudinal strain is a more sensitive modality to diagnose early left ventricular dysfunction. GLS is calculated by speckle tracking. Global longitudinal strain is a sum of peak longitudinal strain of 18 LV segments calculated from 3 standard 2D echo views: apical long axis, apical 4-chambered, and apical 2-chambered views. Normal value is 21. Low value is less than 17. So what is the clinical utility of global longitudinal strain in patients with hypertension and normal LV function, independent of LVH and diastolic dysfunction? I underline the statement, independent of LVH and diastolic dysfunction, reduce GLS confers an elevated cardiovascular risk in that particular patient. In asymptomatic diabetic individuals, we have seen hypertensive individuals, we'll go to in asymptomatic diabetic individuals, low global longitudinal strain predicts worst outcomes in individuals with normal LV ejection fraction. Global longitudinal strain has been proposed as the test of choice for monitoring asymptomatic cardiotoxicity related to chemotherapy. A decrease of 10 to 15% GLS is a reliable predictor of cancer chemotherapy-induced cardiotoxicity. So having seen the echocardiography, let us go to the alternating imaging to assess the LV dysfunction, that is cardiac MRI. Cardiac MRI has been regarded as the gold standard to measure left ventricular volumes, mass, using simple acquisition of 2D stacks, contiguous short axis cines with full biventricular coverage. Cardiac MRI is high cost and its limited availability remains a barrier to its widespread expansion. Having seen the imaging techniques, let us go to the next non-imaging tools to assess asymptomatic LV dysfunction. The most important non-imaging tools is NT-proBNP. In St. Vincent screening to prevent heart failure study, that is STOP-HF randomized BNP-based screening strategy among 1,374 participants with cardiovascular risk factors alone. BNP cutoff of less than 50 was associated with reduced combined rates of LV systolic dysfunction, diastolic dysfunction, and clinically overt heart failure among patients with stage A and stage B heart failure, that is asymptomatic LV dysfunction. So another prospective study involving diabetic patients without known structural heart disease, a NT-proBNP cutoff of more than 125, randomized either to intensified treatment, aggressive ARB and beta blocker therapy versus standard diabetic care alone. Those in the intensified group, that is ARB and beta blocker, had a reduced risk of hospitalization and death due to the cardiovascular disease at 2 years. So based on these trials, the ACC, based on the results of these studies and trials, ACC-AHA guidelines for the management of heart failure gave class 2A recommendation for the use of NT-proBNP screening for patients with stage A and stage B heart failure, that is asymptomatic LV dysfunction patients. Class 2A recommendation for the use of NT-proBNP screening for patients with this subsets. So having seen how to investigate, that is echocardiography, global longitudinal strain, ejection fraction, and cardiac MRI, let us go to the next stage of my presentation, management of symptomatic LV dysfunction patient. What are the trials? Identifying heart failure before the onset of symptoms could enable the implementation of therapy at a point along the natural history of the disease that may slow or terminate the progression. That is very, very important. Early treatment will slow or terminate the progression. Having seen this statement, what are the trials? The studies of left ventricular dysfunction, SOLVE prevention trial showed that the use of enalapril in patients with asymptomatic LV dysfunction brings about a significant improvement in mortality and morbidity. Trandraloprid cardiac evaluation trial also showed that the use of trandraloprid reduced the risk of mortality in patients with reduced ejection fraction less than 35% after acute MI. Among patients with the asymptomatic LV dysfunction, both the SOLVE trial and the survival of the ventricular enlargement SAVE trial showed that the administration of beta blockers in addition to the AC inhibitors reduced the mortality and hospitalization. Thus, the SAVE and SOLVE trial both demonstrated that the early pharmacological treatment for asymptomatic LV dysfunction is very, very important and effective. So AC inhibitor are the cornerstone for the treatment of asymptomatic LV dysfunction. SOLVE prevention trial in patients with LV ejection fraction less than 35% had decreased heart failure hospitalization and overt heart failure treated with enalapril as compared to placebo. 5-year follow-up study showed decreased mortality in asymptomatic LV dysfunction patients on enalapril. In the SAVE trial, captopril in patients with asymptomatic LV dysfunction following an acute MI and the TRACE trial following acute MI, asymptomatic LV dysfunction patients on trandraloprid were shown to have reduced cardiovascular events, heart failure, and mortality. I have selected the trials which included only asymptomatic LV dysfunction patients. So angiotensin receptor blockers can be used in ACE intolerant patients as shown in optimal trial with losartan versus captopril. In Valiant trial with Valsartan was found to be non-inferior to captopril in patients with LV dysfunction following acute MI, a subset of whom were asymptomatic. So beta blockers have been shown in the retrospective analysis of solved and saved trials to have synergic benefits when used with AC inhibitor in asymptomatic LV dysfunction patient. In ANS study and Capricorn trial, carvedilol has been shown to benefit post-MI patients with LV ejection fraction less than 40% who are asymptomatic. I underline the statement, asymptomatic. So in River trial, metoprolol has been shown to result in improvement in ejection fraction and ventricular remodeling in LV dysfunction of ischemic and non-ischemic etiology. Hence, beta blockers should be used in asymptomatic LV dysfunction to decrease the sympathetic overactivation and slow the progression of heart failure in both ischemic and non-ischemic subsets. Statin has been shown to reduce heart failure in patients with ischemia in Forest study. Most important subset of diabetic patients, that is cardiovascular adverse outcomes effects in patients with diabetes mellitus may be varied outcomes. That is, it can be atherosclerotic cardiovascular disease, diabetic cardiomyopathy, heart failure, atrial fibrillation, and accelerated sinus node dysfunction. The heart failure in diabetes mellitus is independent of coronary artery disease because of loss of stretch of cardiomyocyte and increase in circulating natriuretic peptides. So the carry-home message is in diabetic patients, the heart failure risk is independent of coronary artery disease. So diabetic patients with asymptomatic LV dysfunction has a higher risk of overt heart failure and heart failure hospitalization. In sub-analysis of SOLVE prevention trial, patients with diabetes mellitus who had developed heart failure had a mortality of 34% versus 29% in patients without diabetes mellitus. So SGLT2 inhibitor is the new class of diabetic drug which prevents heart failure by 23% in meta-analysis even in patients without pre-existing heart failure. So SGLT2 inhibitors have been shown to decrease heart failure, hospitalization, and mortality in EMPEREC, CANVAS, CREDENS, and DAPA-HF trials. The DAPA-HF trial showed benefit in heart failure with reduced ejection fraction with or without diabetes mellitus. So SGLT2 inhibitor added at the stage of A, B, or C shown benefit and should be included for all diabetic patients with LV dysfunction with or without symptoms. So device therapy in asymptomatic LV dysfunction, just 2 slides. ASCD prevents sudden death and decreases mortality in patients with LV ejection fraction less than 30%, irrespective of their symptom status. I underline the statement, irrespective of symptom status. Patients with the ejection fraction less than 30% more than 1 month after acute MI has been shown to have survival benefit as shown in MAD2 trial, which included 40% of asymptomatic patients. So how do you translate these results of the above said trials in asymptomatic patients into the prescription to be used in our day-to-day practice? In general, there are 2 groups of drugs in heart failure, irrespective of whatever may be the disease. There are 2 groups of drugs. One is drugs for quantity of life, that is mortality reducing drug. Another is drugs for quality of life, that is symptom reducing drugs. Mortality reducing drugs in heart failure patient must be in your prescription. The class and art of writing prescription is very, very important. The mortality reducing drugs should be there in your prescription unless there is any contraindication. AC inhibitor, ARB, and ORNI, beta blockers, mineralocorticoid antagonist, spironolactone or eplerenone, and SGLT2 inhibitors are the mortality reducing drugs which should be in your prescription in a heart failure. If associated CAD, antiplatelets, and statins should be included. There are 2 types of prescription writing in a heart failure patient. That is stepladder pattern and comprehensive treatment. What is the stepladder pattern treatment? Stepladder is you add AC inhibitor, ARB or ORNI, subsequently beta blockers, subsequently mineralocorticoid antagonist. It is not recommended. Instead of stepladder pattern, comprehensive treatment for heart failure is recommended. What do I mean by comprehensive treatment? SGLT2 inhibitor, when added to the standard treatment therapy of AC inhibitor, ARB and ORNI, plus beta blockers, plus mineralocorticoid antagonists, reduces the risk of worsening of heart failure, reduces the risk of cardiovascular death, very, very important, prevents the progression. So coming to the final slide, concluding slide, asymptomatic LV dysfunction occurs twice as common as overt heart failure. Asymptomatic LV dysfunction carries a good prognosis until the development of overt heart failure. It presents with a huge window of opportunity to implement therapy and mitigate the progression, adverse consequence of overt heart failure. Yearly screening with echo, global longitudinal strain, and NT-proBNP will help catching the patients early. AC inhibitor or ARB or ORNI, beta blockers, SGLT2 inhibitors, mineralocorticoid antagonists, statins should be initiated early in this stage in patients with coronary artery disease to prevent progression of the heart failure. Thank you for the patient listening.
Maybe it is better.
Good morning, and
Go ahead. Go ahead.
thank you for joining me today. My name is Priyanka Satish. I'm a cardiology fellow at Houston Methodist Hospital. And today I have the honor of presenting in front of you for a topic that I believe is an urgent priority for India, and that is of preventing heart failure. So why do we care about heart failure in India? Estimates in India suggest that there are about 1.3 to 4.6 million patients with heart failure. The disease manifests earlier than in other populations and is associated with a higher in-hospital mortality as well as a higher length of stay. And so this is a disease that has a high morbidity as well as a high mortality, and therefore is of importance to our population. Most of us see patients with heart failure in our clinics and in our hospitals, and that is clinical heart failure, which you see to the right side of your screen. However, recognizing the importance of prevention of heart failure, the ACC-AHA guidelines made two other categories, the stage A and the stage B of heart failure, which recognize patients who are at an elevated risk for heart failure. So stage A patients have a high risk for heart failure, but they do not have any structural heart disease or symptoms of heart failure. They also don't have biomarkers of stretch or injury. On the other hand, stage B patients have structural heart disease, or they have biomarkers of stretch or injury, but without signs and symptoms of clinical heart failure. So what does the patient with stage A heart failure look like? We all see these patients in clinic, and these include patients with hypertension, with diabetes, with coronary artery disease, which is a huge burden in India, as well as rheumatic heart disease, patients with multiple risk factors like physical inactivity, poor diet, obesity. And these are patients that we need to recognize are at a high risk for heart failure, and we need to treat them aggressively. So that brings me to the meat of the topic, which is screening for heart failure. And every time we talk about screening for any disease, be it ASCVD or be it heart failure, the first question is always, why not just treat everyone? Why do we need to screen patients for preclinical disease? And treating everyone is kind of like a utopian reality where we have everybody is hypertension under control in the whole country. While that will be great and we should strive for it, this is what our reality looks like today. And we have to work with the risk, constraints we have, and that's what screening helps us do. Screening helps us identify patients who are at a higher risk for heart failure, and it helps us target the right treatment for the right patient. The other advantage of screening is that, when you see that a patient is at a higher risk and you have objective evidence, that helps overcome both physician inertia and it helps engage and motivate the patient with their own treatment plan. Now let's look at some evidence behind screening for heart failure. So the STOP-HF trial screened around 1,400 adults who had at least one risk factor. So these were all stage A patients, and they randomized them to the intervention arm, which had annual BNP screening, or the control arm, which received usual care. Now, the intervention arm, if the BNP level was greater than 50 picograms per milliliter, these patients were referred to a cardiologist for an echocardiogram, and they received nurse education. So what did the STOP-HF trial find? As you can see in the Kaplan-Meier curves, they found a 31% decrease in major adverse cardiovascular events with this intensive screening approach with a BNP level. And more importantly, a 45% decrease in heart failure as well as asymptomatic LV dysfunction. So what worked? How did they do it? What they found was that the intervention arm had a much more aggressive uptitration of RAS blockade, which includes angiotensin receptor blockers. And these patients had improved lifestyle as well as adherence to therapy. Next, the Pontiac trial looked at 300 patients with type 2 diabetes and an elevated NT-proBNP. And they randomized these patients to either the intervention arm, which had max RAS blockade, as well as highest beta blocker dose, and a cardiology referral. And on the opposite side, the control arm received usual care. So what did they find? They also found that doing an intensive screening and enriching for patients who had a high risk was able to show that they could achieve a reduction in cardiovascular hospitalization, cardiovascular death, as well as heart failure hospitalization. So some pretty significant outcomes. Drawing from these two trials and from other data, the 2022 ACC/AHA HFSA guidelines recommend that patients at risk of heart failure are screened with a natriuretic peptide biomarker. And they also recommend that these patients can receive a multivariable risk scores, which we'll look at. So looking at these biomarker risk scores, this group looked at a bunch of patients with diabetes, and they found that if you had elevated biomarkers, meaning high sensitive troponin T, an elevated NT-proBNP, an elevated hsCRP, and LVH by ECG, the higher you were on this risk score, the better you did when you received an SGLT2 inhibitor. So again, this is another example of using biomarkers to target those that are at a higher risk and the group that has the maximum benefit from our therapeutics. This is another risk calculator, which is fairly commonly used. It's called the PCP-HF calculator. It does not include biomarkers, but it does help identify those patients that are at a higher risk. Going over some echocardiographic markers of risk, these include LV hypertrophy, a reduced LV global longitudinal strain, parameters of LV diastolic function, as well as LA volume and function. And there is evidence that combining a couple of these biomarkers together can offer a better prediction when compared to any individual marker alone. There's also recent data that adding a combination of these markers along with your natriuretic peptides and other blood markers can also offer robust evidence of an increased risk of future heart failure. So now that we've identified these patients who are at an increased risk of heart failure, what can we do about them? And this is where we talk about the best ways to control our chronic diseases like hypertension, like diabetes, like coronary artery disease. Rheumatic heart disease is another big one, but we won't be talking about it in our talk today. Okay, so looking at hypertension, the guidelines recommend a class 1A recommendation for optimal control of blood pressure. And why is that? The SPRINT trial looked at intensive versus more liberal control of blood pressure and found that getting to a systolic blood pressure of 120 can get you a 38% reduction in the risk of heart failure when compared to more liberal control. Similarly, a meta-analysis found that a 10 mm reduction in systolic blood pressure caused a 28% reduction in the risk of heart failure. The government of India has recognized this and has partnered with some private organizations to implement hypertension control across the country. The areas in red that you see are areas where this program is being implemented, and the more widespread we get implementation, the better more steps we take and the better we can achieve hypertension control, which in turn will reduce the risk of heart failure. Talking about type 2 diabetes for a bit, the guidelines now recognize that SGLT2 inhibitors are a class 1 recommendation to lower the risk of heart failure hospitalization. There's now a lot of robust trial data that SGLT2 inhibitors reduce the risk of heart failure, reduce progression of CKD, reduce ASCVD risk, and therefore in patients with type 2 diabetes, there's and more push to get those at a higher risk to get started on an SGLT2 inhibitors so they can enjoy these benefits. A note on the DPP-4 inhibitors, sitagliptin and linagliptin have a neutral effect on risk. However, saxagliptin was associated with a higher risk of heart failure and therefore is not recommended. Similarly, thiazolidinediones like pioglitazone are not recommended because of the increased risk of heart failure. Another important target for India as a country, and specifically with regard to heart failure prevention, is the detection and treatment of atherosclerotic cardiovascular disease. Data from India has shown that up as much as 70% of all heart failure in India has an ischemic heart disease as a cause. And therefore, identification and treatment of ASCVD is paramount. And while we have a lot of strides to take in detection of MIs and treatment of cardiovascular ASCVD as a whole, detection of preclinical ASCVD and treating these patients early with therapy like statins can have the potential to reduce the burden of heart failure. For example, patients with an elevated calcium score are at a higher risk of heart failure. And independent of the baseline CAC, the calcium score progression also predicts the risk of heart failure. So identifying and treating these patients early and treating them aggressively can substantially affect this risk. Not to forget that lifestyle treatment is the cornerstone of a lot of prevention strategies. So maintenance of normal body weight, maintenance of cardiorespiratory fitness are both associated with lower risk of heart failure. Similarly, taking a plant predominant diet, which is a large component of diets like the DASH diet, including lots of fruits and vegetables, legumes, etc., can definitely be associated with a lower risk of heart failure. I do want to pause here and clarify that a plant predominant diet is not the same as a vegetarian diet. So when a patient tells you they're eating a vegetarian diet, we need to clarify are you eating a lot of jalebis or is that healthy food? And that difference does matter. So you can't stop at just the vegetarian diet. And then finally, there are now evidence, although weaker than the others, that mind and body techniques like yoga, like transcendental meditation, Tai Chi example, can all be associated with better outcomes in patients with heart failure. So what does risk factor control achieve? In this study with patients with diabetes type 2, they found that optimally controlling multiple risk factors like A1C, like your blood pressure, like urine albumin-creatinine ratio and waist circumference can be associated with an 8 times lower risk of heart failure. So this is some pretty significant benefits that we can afford to our patients, especially once we identify those at a higher risk who have a better chance of responding to our therapies. I'm going to close with some ongoing efforts in heart failure prevention. So India is taking steps in the right direction with a lot of good registry data on outcomes in our heart failure patients. This has been extremely important. A lot of the data I presented today comes from these registries that go over the prevalence, that also determine what our outcomes are in these patients. So it's definitely a step in the right direction. Globally, there are machine learning models that are being developed that are hopefully going to predict heart failure. This is an example of a machine learning model that looks at echocardiographic phenotypes in asymptomatic individuals, and it classifies echoes into either mostly normal, having predominantly diastolic changes, so for example, a low E prime, or having diastolic changes with structural remodeling, where your LV size, LV mass are increased. And using these machine learning models can predict not only the risk of heart failure, but also different phenotypes where there's predominantly inflammation or predominantly remodeling. And this can help tailor our treatments towards these different phenotypes. And finally, there are trials in biomarker screening that are ongoing. For example, the ADOPT trial in Asia, which also includes some Indian patients, is enrolling 2,400 patients with type 2 diabetes who don't have CVD and an elevated NT-proBNP. And the intervention in this case is RAS inhibition plus beta blocker plus an SGLT2 inhibitor versus the control, which is standard therapy of blood pressure, regular blood pressure lowering. And they want to see if this intervention can improve outcomes. And this will give us some robust data on the benefits of these medications and on the benefits of biomarker screening and enriching our treatment to patients at higher risk. So a lot of exciting new trials out there, but I'll close my talk today with some acknowledgements to some mentor, Dr. Kershaw Patel at Houston Methodist, for going over my slides and for his input. Dr. Nasser, Quinones, and Naga for helping me think about this topic and for helping train me in general. And with that, I thank you for your time.
Thank you, Priyanka, for that excellent talk. The last 3 lectures has been covering the heart failure in toto from class A to class D. Fortunately, I don't see. Fortunately, I said, because we have only 3 minutes left till we finish the time, and you are the only person live. So let me talk to you a couple of questions about the prevention, which is one of the most important things that you absolutely said it right when you said that we need novel prediction model leveraging on the machine learning. And I'm sure about it, we will have more tools for us to for the prevention. You also touched on the SGLT2I has been the statins of heart failure prevention. So what do you think about the probable role of SGLT2? I'm not talking about in diabetes alone, in the non-diabetic population also.
That is a very good question. And I think more and more people are talking about them being the statins, and there are people that are talking about just taking them, putting it in the water. With the robust benefits we've seen in the heart failure patients, even without diabetes, I think there is enough, probability that these drugs will actually help patients even without diabetes in the prevention of heart failure. I think if you look at the DECLARE-TIMI trial, they did have patients who were just at a high CV risk. And even in those patients, CV hospitalizations and I think CV death, if I'm not wrong, was also reduced in this trial with dapagliflozin at high risk. So there's a lot of interest in these drugs for sure in reducing the risk of heart failure.
True. I mean, I also wish that we have a poly pill for CAD prevention. I really wish that we should have another poly pill for heart failure prevention. Another area, maybe the prevention matters is, now we are using so many, the oncology has been prospering with so many drugs and the heart failure with its accompanying complication. What do you think what will be the cardiologist's role in prevention of heart failure in cancer patients?
I do think that collaboration is growing and is very important, especially as the prevalence of cancer increases. I didn't touch upon it in my talk today, but I think it is going to be an important collaboration where we now have cardio-oncology clinics with heart failure or cardiologists who are interested in detecting asymptomatic LV dysfunction. We already have data there on, a decrease in strain, for example, being associated with cancer, chemotherapy cardiotoxicity. And there's a new position statement that came out a couple of years ago on the different cardiotoxicity of different drugs. So that is definitely going to be an important new frontier that we are already at, and a lot of interest has been generated within this topic.
That's right. The last my comment, and you can just respond to it, because hypertension has been our India's problem. One of the and there was even a supposition. We don't have a solid data on that. If we can control hypertension in the entire population of India, possibly we will reduce 4 million heart failure in India. What will be your last piece of advice to the Indian cardiologist, or comment to the Indian cardiologist on management hypertension?
I think you hit the nail on the head, because controlling hypertension just across the country will have a significant effect on the effect of heart failure. And I know that from data that we have, that we still have a long way to go, both in India and outside. And public-private partnerships and working with teams across the globe in helping create systems that will help for early identification and control of hypertension will go a long way. Some of the work that we had done was in using an algorithmic approach to hypertension control that we had published in the Indian Heart Journal a couple of years ago on models that you might be able to use even in a PHC center, where you don't need, if you start with a calcium channel blocker, you don't need routine testing in non-albuminuric patients. And using innovative approaches that are tailored towards the Indian setting, I think that will have a significant impact, recognizing that there are resource limitations that we have to work with. And that, I think, will have a significant impact.
Thank you, Priyanka. Have a great day, and it was a pleasure listening to you.
Great. Thank you so much. This is a great discussion. Appreciate it.
Thank you. Bye, folks. I think that comes to the end of the day.
Hello. Hello. So, but hello. Message started actively looking for amyloid. Personally, I've been talking to other people in the department,